Hello guys, good evening. Good morning. Can you hear me? Hi Savitri. Yeah, chapter is okay. So we will start pathology discussion. I'm Dr. Ranjith, and I hope you're doing good. Your exam prep is going good. How are you guys doing? First of all, am I audible and visible? Do let me know for that. So I hope you have got the workbook that's with you. So we have very crisp 25 pages. That's all for entire pathology. What we'll be doing is we'll be quickly revising, revisiting all the important topics. Vanakkam Gautam. I'll be asking you questions. Please do answer. And I want you to answer more so that this session is not just for you to compile the points, is to revise whatever important previous year topics is already required. Fine. Okay. Okay. Great. If so, there's a schedule just to have a start with. Good morning, Cool Medico. Good morning, Rishabh. And let's start pathology. Okay. So first, before starting test, for FMGE exam, the importance of pathology has to be more for general pathology. I'll say more or less equal to hemat, and definitely the importance of systemic pathology is a little bit less, because I'm sure you will read systemic pathology in surgery, you'll read systemic pathology in medicine, OBG and everything, right? Thank you, Cool Medico. I hope it's going good for you as well. Fine. So that we'll be starting and having more emphasis on general path. We will touch on all the important topics for hemat. The most thing in hemat is they are scenario based question. We'll go to important keywords. If you look at these words, I want to say this is a diagnosis. Very important keywords with anemia, with leukemia, with lymphoma, everything. Systemic pathology, few topics have been repeatedly asked, like emphysema has been repeatedly asked, few glomerulonephritis, right? Those things will be our concentration. Fine. So that note, let's start discussing what is required for us. Fine. Okay, I want more answers. Let's make it more interactive so that it becomes easy for you, not a boring monotonous session, right? So first topic, as you can see, we're going to talk about necrosis, right? So necrosis, is it physiological, pathological? Is it physiological, pathological? Any type of necrosis. Good morning, Medico. It is obviously pathological, right? Necrosis is almost always pathological. Apoptosis can be both physiological and pathological, right? Necrosis, will there be pain and inflammation associated? Yes or no? Because these are simple one-liners. You will have pain and you will have inflammation. In both necrosis, in every necrosis here, you'll have both pain as well as inflammation. That's something which is very important, right? Great. Okay. Come on, guys, you have to answer. I know it's starting of the day. You have a very long day to go ahead. You have orthopedics and anesthesia coming behind. So let's answer. What's the most common type of necrosis? Thank you, Gautam. What's the most common type of necrosis? It is undoubtedly coagulative necrosis. This is the most common subtype of necrosis. Where do you see coagulative necrosis? Coagulative necrosis is seen in every solid organ infarct except which infarct? It is seen in every solid organ infarct except one organ, which is brain infarct, right? In brain infarct, you see liquefactor necrosis, right? Brain liquefies. That's what is very important. It's fat, like fat, it liquefies. Brain also liquefies, liquefactor necrosis, right? The mechanism of action of coagulative necrosis, this was asked in one exam. It is destruction of the protein, or protein degradation is a main mechanism of action. Fine. So once protein is destroyed, I'll have coagulative necrosis. Protein coagulates. Protein forms coagulum, right? That's all. So liquefactor necrosis is from enzymatic, right? So the mechanism of action for any liquefactor necrosis is enzymatic degradation or enzyme related destruction. That's why you have acute pancreatitis, enzymatic problem, right? You have your wet gangrene, lots of inflammation, lots of enzymes in the WBCs, abscess cavity, same, right? And brain, I release lipases so that I can liquefy the brain infarct, right? So since it's a protein degradation, I'm destroying the protein, I am not destroying the architecture. You have maintained architecture. This in microscopy is called as a ghost cell. There will be shape, the outline will be preserved, but I won't have life inside, right? A classical ghost cell is seen in a coagulative necrosis, right? Can you guys give me any one clinical example for coagulative necrosis? We know that it's a solid organ infarct, right? I'll give you one example. One example I'll say is myocardial infarction. If I say one example of coagulative necrosis in kidney, anyone? One example of coagulative necrosis in kidney. We go for? Perfect. A disease called as an ATN, acute tubular necrosis, or an AKI, acute kidney injury. Any solid organ infarct has to be that. So which means if you remember medicine, you must have read that acute kidney injury, the most common cause is pre-renal failure, and it is hypovolemia, shock, because no blood supply. That's all. Everything is same. Everything is related. Fine. Okay. Now liquefactor necrosis. By default, we know that a brain infarct or a stroke is liquefactor necrosis, right? Liquefactor necrosis, since it's liquefied, everything is destroyed. Can I say ghost cells will not be there? Obviously, there'll be no ghost cells, right? Perfect. Okay. Just one more thing before we move on to the next one. Liquefactor necrosis, there's a disease of acute pancreatitis. What is the type of necrosis seen in omentum in case of acute pancreatitis? It's a very commonly repeated question, has always been a confusion. In acute pancreatitis, in omentum, the type of necrosis, fat necrosis. In acute pancreatitis, in the substance of pancreas, the type of necrosis, liquefactor necrosis, right? Always remember them. In acute pancreatitis, the question, what type of necrosis is decided on what organ I'm talking about. If I'm talking about an omentum or a peripancreatic fat, I call it a fat necrosis. If we talk about pancreas, in pancreas, I'll have liquefactor necrosis, because pancreas does not have fat. Pancreas has acini, right? So in acute pancreatitis, pancreas gets disturbed by liquefactor necrosis and omentum gets disturbed by fat necrosis, right? Perfect. Caseous necrosis. Very old days, caseous was a type of coagulated necrosis, but here caseous in microscopy is a little bit more granular than a coagulated necrosis. Almost always they look a little bit more granular, right? There's only one thing I want you to remember with respect to caseous necrosis, which is tuberculosis. Wherever you see caseous necrosis, now FMG, NEET PG, INICT, or in real life, there's only one person, TB, right? If at all you write an exam like an USMLE or PLAB, you want to go outside, there are few rare conditions of histoplasma, not very common in our country, and coccidiomycosis. You had microbiology over, you must have read that the desert fever and valley fevers, right? So that is a little bit common in foreign countries, not as much common in India. For us, it's only tuberculosis, almost always tuberculosis, until it's ruled out. Fine. Okay, let's go next guy, fibrinoid. Cheesy in appearance, in gross, right? Let's add to it whatever Gautam said. Caseous necroscopis, gross, it will be cheesy. Cheesy white, caseous, right? It will be whitish in color because of the TB and the destruction of the tissues there, right? Great. Fibrinoid. I'm sure if you have listened to my lecture, what does oid mean? Oid means like, right? Oid means like. Fibrinoid means fibrin-like necrosis. That's all. Okay. Fibrinoid means it's a fibrin-like necrosis. See, terms help us a lot. When I say fibrin-like necrosis, I will see fibrin or fibrin only when there is a blood clot. That's all. So that's why anything with respect to a vessel, a blood clot will happen only when a vessel is cut, right? So anything with respect to vessel can be vasculitis. I'm sure everyone will answer one thing, right? You'll always answer PAN, because PAN is a PYQ, polyarteritis nodosa. Not PAN, but any vasculitis like what Cool Medico said. That's very important. PAN is an exact PYQ. But I won't ask the same PYQ. I might say that, okay, it is an Shrug-Strauss syndrome. I'll have vasculitis. Any vasculitis, PAN will have it. You will have it in SLE, because SLE is a type 3 hypersensitivity type of vasculitis. Can anyone tell me? You must have read this for sure. I'll give you a clue also. Kidney, patient having flea-bitten appearance. What is it? In kidney, a patient having a flea-bitten appearance. That's a classical case of malignant hypertension. Extremely high levels of blood pressure, like 200 or 190 millimeter of mercury, blood vessel will rupture. Blood vessel dead, it's obviously a fibrinoid necrosis. That's what I want you guys to remember, right? So these are the three things with respect to fibrinoid necrosis, fibrin-like necrosis. And an extra point, in microscopy, fibrinoid necrosis is PAS positive. You do remember that alone. PAS positive will be for fibrinoid necrosis, right? Perfect, great. Now, let's go to the next guy. Fat necrosis. We already know about fat necrosis. Just microscopy of fat necrosis. What is the normal microscopy of fat? Normal color of fat in microscopy. Normal fat is always clear. It's colorless, right? It's always clear. Microscopy of fat necrosis. Any necrotic tissue will be pink in color, including fat necrosis, right? Normally it will be a clear fat. When it becomes necrosed, it becomes pink in color. Fat necrosis also becomes pink in color, right? So I have two things with fat necrosis. One is an enzymatic fat necrosis. Okay, other one is traumatic fat necrosis. We already read about enzymatic, acute pancreatitis in the omentum or the peripancreatic tissue or the fat, right? The best example for is it acute pancreatitis, but not in the fat. Traumatic fat necrosis, example, any organ rich in fatty parenchyma, breast, gluteal region, anything. You got an IM injection? Yes. Normal intramuscular injection. They prick a needle. Obviously, it will cause fat necrosis. It will heal. By default, your body will heal, right? But that also can cause fat necrosis. Any trauma to any fat structure will cause fat necrosis. And enzymatic tissue also, your acute pancreatitis can cause fat necrosis, right? So these are five very important things which to start with respect to necrosis. I hope at least one question related to necrosis might come in an exam, right? So there are few applied questions of necrosis. See, application is where we are struggling a little bit, right? Let's apply that. Now, we'll read a few facts. In necrosis, will there be a loss of cell membrane? Yes or no? What do you think? Necrosis has loss of cell membrane. I want everyone online here to answer. It's fine if you're wrong. Necrosis, cell membrane damage will be there. Yes or no? Answer is a big yes. Right? That's why the intracellular contents come outside. I'll have inflammation and I'll have pain, right? It doesn't matter if you make mistakes. Everyone here do answer. It's completely fine. You will have cell membrane damage. Obviously, you'll have, right? Now, if this is true, can I say cardiac myocyte, once it dies, all the intracardiac structure will come outside? Yes. Same with liver. Same with pancreas. Same with any cell in the body. Yes. So this is the basis for using tests in LFT, in liver failure, to diagnose. The best example, when it's an MI, you do CKMB, troponin 3, troponin I, right? Liver function test, you have AST, ALT, SGOT, SGPT, right? Pancreas, amylase, all these are based on this, right? So I can create a clinical scenario saying that a patient came with an acute pancreatitis, history of alcohol or a gallstone, amylase was elevated. What is the reason? The reason is necrosis because of cell membrane damage, right? Any test I'm going to use to diagnose, example, amylase in acute pancreatitis, or you can have a trop T, trop I level in case of an MI. All these are related to necrosis event only. So I can just ask a one-liner or I can have an applied scenario-based question as well. Fine. Okay. Let's go to the next guy. Apoptosis. Physiological, pathological, both. I'll ask simple questions so that you guys will answer. I want you guys to answer. Come on. It'll be very boring if you don't answer, right? It is both physiological and pathological, right? I asked you a simple question because it's there in the screen itself, right? It's both physiological and pathological. Apoptosis is an programmed cell death, right? It's definitely a programmed cell death. We do have two phases of apoptosis. One, we have an initiator phase and we have an execution phase, right? Great. So the initiator phase, like Gautam said, there will be no inflammation. All those are true. Initiator phase have two pathways. Have an extrinsic pathway and then we have an intrinsic pathway. Which of these do you think is mitochondrial mediated? Comment on it. I'll go forward, right? Which of these two do you think is mitochondrial mediated? Intrinsic, inside the cell, mitochondrial mediated, right? All these apoptotic genes are for the intrinsic pathway. Extrinsic, outside the cell, is cell membrane mediated, right? This is based on your FAS ligand and FAS interaction, or the CD95 or the death receptor. These are questions, right? So CD95 mediated, cell membrane mediated, that's my extrinsic pathway, and mitochondrial mediated is my intrinsic pathway, right? Both of them will join to the execution pathway, and all these are mediated by only one enzyme, caspases. Okay, caspase is going to cause apoptosis by default, right? So now we'll come to the number of caspases soon after we quickly go into the pro-apoptotic and anti-apoptotic genes, right? Pro as well as anti-apoptotic genes, these are seen in the mitochondrial membrane. To be very specific, the inner mitochondrial membrane is where we see the pro as well as anti-apoptotic proteins, and the genes will be obviously there in the nucleus, right? Easier way to remember, anti-apoptotic, no death, so longer life, right? So longer life. Anything with L, remember anti-apoptotic. L is equal to a long life. My senior told me this, I am telling you that. But only one problem, if L is there here, that might be confusion. Going with a mnemonic or a shortcut is, I might fall somewhere. Here I have S. Maybe remember it for shorter. Okay. Most of the thing with L is a longer life, is an anti-apoptotic thing, but backs and bad, right? So the only two important pro-apoptotic genes are here, backs and bad. BCL excess, just because you might wait. Yeah, because you might make a mistake. So I'm just keeping it as BCL excess, also as pro-apoptotic. Backs and back are the most important pro-apoptotic genes for me, right? Apart from this, I have a group of genes called as BIM, BID, and BAD. BIM, BID, and BAD are called as sensors of cell stress. They sense cell stress, but they are also pro-apoptotic in a way. Fine. Okay. Sure, Gautam, do it. Okay. So these are sensors of cell stress. They sense the cell stress. They also push or activate the backs and back, so it becomes pro-apoptotic. That's all, right? So these are just few information which I want you to remember. Again, like I said, caspase is something which has been very important. Even in the last INACT also, you had a question with respect to caspase. All the questions are going to be similar only. There's no distinction of FMG. There's no distinction of NEET PG. There's no distinction of INACT. Pathology doesn't change, so things don't change, right? So let's look at caspases. So there are multiple named caspases for us. Okay, caspase is a protease. That's all. It destroys protein. So we have caspases 8, 10. We have caspase 9. We have caspase 3, 6. We have caspase 1, 4, 5. All these caspases are involved in different phases of apoptosis. Some are not even involved in apoptosis, right? Let's start with the last one. Where do you think caspase 1, caspase 4, caspase 5 is involved? Is it necrosis, apoptosis, necroptosis, pyroptosis? This came in the last INACT. It's involved in pyroptosis, right? It's involved in pyroptosis. Caspase 1 along with caspase 4 and 5 is involved in a mechanism of cell death called as pyroptosis. Pyro means heat or fire or fever. So pyroptosis will always be also to do with interleukin 1, which causes fever. So fever induced cell death, I'm going to call it as pyroptosis, in which caspase 1 is involved. That's also one caspase dependent cell death. 3 and 6, is it initiator caspase or an execution caspase? These are execution caspase. They cause the cell death. At the final part of apoptosis, they make sure the cell dies, right? It's an execution caspase. 8 and 10 are your extrinsic pathways caspases. 9 is your intrinsic pathway caspase, and in this 10 is called as an human caspase, because rest everything are studied in tiny bugs, because we cannot do so much experiment in human beings. 10 is something which is in human caspase, right? So caspases do come in an exam. Do remember about caspases. If it gets repeated, I don't want you to miss it, right? So few areas it's not good to miss because it's already been asked. Newer questions, if we make mistake, it's fine. So that's in short about apoptosis. We know about necrotosis, we know about necrosis, we know about apoptosis, and a little bit about the caspase and pyroptosis, right? Let's go to stains. Stains are something which keeps coming not only as in one-liner, it also comes as a scenario-based question. I can easily ask a question on melanoma using this stain. Hemochromatosis using Perspection blue. Barrett's esophagus using PAS. Stains are very important in pathology, right? The logical thing is, if I cannot differentiate something on a light microscopy, I use stain. That's all, right? So which means, what are the rules for light microscopy? In a HNE, there are very few rules. I have pink color, we have blue color, and we have clear. These are only 3 colors we have in HNE. Clear, you guys already said, it's fat. Anything fat in microscopy will be clear. That's why macrophage is clear, foamy macrophage, because it's completely made of fat there, right? So HNE has only 3 things. What is blue color in HNE? Anyone? I'll tell pink, you tell what is blue. Blue is for nucleic acid. That's all. Hematoxin is for nucleic acid. Anything which is nucleic acid, be it a DNA or be it an RNA, in simple words, nucleus. Nucleus is blue for me in microscopy. That's why if you remember in hematology, those basophilic stippling, blue in color, right? All these bodies are DNA and RNA condensed, they are blue in color, right? Pink, rest everything in nucleus or cell is pink. Be it a cytoplasm, glycogen, be it your, protein, everything will be pink in color in case of an H&E. These are 3 thumb rules, never ever forget. If you have an image, you don't know what to look for blue, pink and clear. Only blue, most likely the answer is cancer. Because all the cancers will have high NC ratio, very big nucleus. That's why they can divide very, very fast, right? These are few clues if you get stuck, right? So now I have the pigment here, I have the stain here, and I have the image here. So what you're going to do is, I want you guys to tell what will be the color of it in a normal H&E. And then we have many stains, we'll see which is commonly used, which is better. And also one scenario where you can apply this, right? So now let's start. So again, I want every guys to comment here. It's okay, please open up, right? What is the normal color of melanin in a microscopy? The normal color of melanin in a microscopy. Whatever comes to your mind, it's fine. What do you think? It is brown. Melanin is not black. Melanin is brown in color, right? When it's condensed, it becomes black like your hair, right? It's condensed melanin. Melanin is normally brown in color. Melanin is not black. Hemosiderin. Can anyone tell me what is the normal color of hemosiderin in microscopy? Hemosiderin is also brown in color. That's why I need stain to differentiate them. Everything here is brown in color for me. Hemosiderin, copper, melanin, everything is brown color. So I need different stains for me to identify them, right? Melanin stain has mesenfantana. That's a commonly used stain, and Schmorl stain as well. Okay. And here, this is skin biopsy, where you can see melanocytes in this corner, in the basal layer. In the basal layer, you have melanocytes. That's what has been highlighted by this stain. Fine. Okay. So last INACT, I think they had a question, which is a bit new application of mesenfantana. In your microbiology, have you read about demeticious fungi or fungi which can produce pigment? Have you read them? You have read them, right? So do remember, mesenfantana will be positive for definitely melanin, and also will be positive for pigmented fungi. Not for every fungus. Not every fungus will be positive. Only fungus which can produce pigment. There is a condition called as pheohyphomycosis, pigmented fungi. That will be positive. There's an application which is asked in the INACT. If it gets repeated, don't forget it. Pigmented fungi can also be positive for mesenfantana. Clear? Then let's come to hemosiderin. Hemosiderin is positive for perspiration blue. Generally, ferritin is not. Generally, ferritin is not positive. Only hemosiderin is positive because ferritin is physiological, hemosiderin is pathological, right? It's perspiration blue. As the name says, microscopy is going to be blue in color, right? So there's a liver biopsy with pearls positive. So again, this is a fact. How can I apply and ask in a scenario-based question? I can ask a simple thing. What's a stain for iron? Very simple. Every one of you will answer. Where it might trouble is, I put a scenario here. Let's say I'm having a patient with a liver failure. Okay, I want you guys to be very, very active. I'll ask questions. I want you to answer. Fine. So that I can revise not just perspiration blue. I can revise one more concept of liver pathology. Fine. Liver failure. There's a patient. In addition to that, the patient's skin is brown in color. And the patient's blood sugar level is, let's say, 250 milligram. Okay, and liver biopsy is pearls positive. Can anyone tell me what's the diagnosis? Whatever comes to your mind, but I want you guys to attempt. See, if you fail after attempting, I'll respect you. Amazing. If you don't attempt, I don't respect you. I'll be very honest. Attempt, fail, come back. Attempt, fail, come back. Diagnosis. Come on. Rishabh, Gautam, cool Medico, come on. I want you guys to answer so that everyone else who's subtly watching also will answer. Liver failure, skin brown, bronze diabetes, super hemochromatosis. Great, amazing, right? It's hemochromatosis. Actually, I wanted you guys to remember the bronze diabetes. Bronze diabetes you must have read in medicine. Yes? skin becomes brown in color. Why does the skin become brown in color? Because of same guy, hemosiderin deposit and melanin also. The skin becomes brown because of increased melanin and hemosiderin, because inflammation causes pigment, right? Classical hemochromatosis, and it'll be blue color. So I can create a scenario based question, put this image and ask you what's the diagnosis. This came in NEET PG 2019 or 2020. Exams are simple. What happens is, I'm scared. Like, you guys are not scared here to comment on it. Maximum will go wrong, right? Make mistakes here so that you won't make in the exam. Fine. That's how I'm going to apply it. Fine. I'll ask you one more question. Then let's go to the next one. Right. Same. Let's take, it's a patient with a lung biopsy. I won't give you the exact clue here. Let's make it slightly difficult. A lung biopsy, and the patient had interstitial lung disease, ILD for interstitial lung disease, and the microscopy of the biopsy showed elongated pulse positive structure. What do you think is the diagnosis? It's a bit difficult, but attempt. If you want a clue, ask me. You want a clue, I'll give you a clue so that you can nail the diagnosis. Lung biopsy, interstitial lung disease, elongated structures which are pulse positive. If you want a clue, please ask. Please comment clue. I'll give you a clue. But I want you guys to open up. Come on. Amazing, right? You can diagnose even without the clue. A cool medico, heart failure cells. You are right in one aspect. That will be pulse positive in the lung biopsy. But it's a cell. It won't be elongated, right? So can I say the clue here is the patient was working in a shipwreck or in a cement factory. So can I link it to asbestos fiber? You can, right? In a NEET PG exam or an FMG exam, you will have the clue there. Because it's an occupational lung disease. Occupation is the most important clue. I hid it so that it can make it difficult. That's all. Whatever cool medico said, that also is possible. Then my history would have been a patient with a heart failure and then lung biopsy showing this. Then I'll talk about an interstitial heart failure, so, right? Perfect. Let's go to next guy. Lipid. Same routine. What's a microscopic color of lipid? Idiopathic pulmonary fibrosis, interstitial lung disease are same. Idiopathic pulmonary fibrosis is the microscopic terminology. Interstitial lung disease is a clinical terminology, right? Okay. Microscopy is going to be clear in color. Why it's clear? It's clear because it is washed away. It's washed away during processing. So actually it is empty. When I process a tissue, it's been washed away, right? So when it's washed away, I cannot actually do the stain, right? There's nothing there. What will you stain? There's nothing to stain. So for me to do a fat stain, that is Sudan black and Iodado, what is a fixative? This came in a NEET PG exam. What is a fixative for me to do a fat stain? Because when I use a normal fixative of formalin, it will be washed away. So what's a fixative here? The fixative is great. It is a frozen section. You cannot do a oil redo or a Sudan black in a normal processing. I need a frozen section. Only when I freeze it, when you freeze fat, what will happen? Will it be washed away? Real life. In colder temperature, what happens to ghee? It will become solid. It's fat, no? It becomes solidified. When I freeze, I cannot wash it. It becomes very solid. So I can easily stain it, right? And this is your oil redo. And this is your Sudan black. Black for black color, red for red color, right? I'll give you one application here. Frozen section, never forget. Frozen section is used for fat stains. I cannot use it in. I cannot use in a normal stain, right? Okay, I'll make it a little bit difficult. Let's see if you guys are able to pick it up, right? Ovarian mass. Okay. A clue might be the patient had hyperestrogenism. And in microscopy, the mass was oil red O positive. Though it's not the normal thing, but what do you think is the diagnosis here? Ovarian mass, hyperestrogenism is actually a clue. Oil red O positive. There's only one ovarian mass which can present with hyperestrogenism. What do you think? That is granulosa cell tumor. See, these are application questions. I know it's a bit difficult. It's okay if you missed it. The reason is granulosa cell tumor is a hormone producing tumor. Granulosa cell produces estrogen. Estrogen is a steroidal hormone, so it will obviously be positive, right? I can create a difficult question also with simple facts, right? Okay, perfect. Let's go to the next guy, glycogen. Okay, can anyone tell me same routine? What's a normal color of microscopy of glycogen? The normal microscopic color of glycogen, anyone? Glycogen has two colors, right? Glycogen can be clear or it can be light pink. Okay, both are the colors of glycogen. See, glycogen is a sugar. Sugar can be opaque, normal sugar, or if you have seen misery or kalkandi, right? That's condensed sugar, becomes clear, right? So sugar can be both opaque as well as clear based on the amount or the quantity present. So glycogen is also can be clear as well as light pink. That's why if you remember in your glycogen storage disorder or von Gierk's disease, have you read this? Plant cell like? Because it's very clear. Plant cell like appearance in glycogen storage disease, right? But glycogen is also pink in color. I can prove that also. It's normal liver biopsy is filled with glycogen. Liver biopsy is pink in color, right? And glycogen is PAS positive. And the most important thing, they are diastase sensitive. Anywhere you see PAS positive diastase sensitive substance, it is glycogen. That's all. In liver, child, glycogen storage disorder, von Gierk's disease. Let's make one more scenario out of it. A patient with a 15-year-old kid, a mass in left femur. Biopsy showed small cells or small round cells which are glycogen or PAS positive. Anyone diagnosis is a very classical diagnosis. 15-year-old, I'll give you one more clue. The mass in the femur is in the shaft or the diaphysis. Diaphyseal mass, if you want one more clue, the X-ray of this mass has an onion peel appearance. I cannot give more clues. Hi, Ella, I'm good, doing good. Hope you're doing good. It is? Great. It is Ewing sarcoma. So Ewing sarcoma biopsy lesions are also PAS positive. So I can apply it in multiple places. It can be a von Gierk's disease, a simple normal glycogen storage disorder, up to Ewing sarcoma. There are many places where I can apply glycogen. This is one of the applications. That's all right. Next, what do you think is the color of protein? We have become very soft, right? We have to comment more often. Come on, only Gautam and Medico is commenting. Only both of you want to clear the exam, or everyone who's watching wants to clear the exam? Everyone, right? So comment. You have to take it up, right? If you want to be on the top, you guys have to comment on it, right? Okay, protein color is obviously same pink color. It's PSD. PAS positive, diastase resistant. It will not be washed away with your diastase. It's a PAS positive structure. It's a diastase resistant structure, right? Two places where I'll be using PSD with respect to an undergraduate. One, if it's a liver biopsy, it is alpha-1 antitrypsin deficiency. Remember this. Alpha-1 antitrypsin deficiency, the protein deposit in the liver biopsy will be PAS positive, diastase resistant. Here, what will be the clue is the patient also will have one more disorder in the lung. Can anyone tell me what will be the disease in the lung for this patient? Medico, Khanam, Allah, Cool Medico, Rishabh, Gautam. What will be the problem in the lung for this patient? That's great. That's pan-acinar emphysema. That's a clue. A lung pan-acinar emphysema and a liver failure. Think of alpha-1 antitrypsin deficiency and the patient will be PAS positive, diastase resistant. Okay. One more place where I'll be using this. This will be an integration between microbiology, medicine, and pathology. I am giving you a clue upfront. Okay. It's an intestinal infection. In this intestinal infection, the patient also has a joint problem, has a cardiac conduction defects, and also an eye problem. Okay. And here in the biopsy of the intestine, you see PAS positive, diastase resistant macrophages. Because this macrophage has organisms inside that. Can anyone tell me what organism? Presence with diarrhea, has a problem in the joint, in the heart conduction, in the eye, and the biopsy shows PS positive diastase sensitive macrophages which are filled with the organism, that is Whipple's disease. Triforema whippleyi is other place where PS positive diastase resistance is useful, right? So these are the two places for an undergraduate you have to remember the use case of PS positive diastase resistance, right? Last but not least, again there's a mnemonic which keeps on going in generations, right? Calcium, K for Koza, AL for alizarin. Easy way to remember, right? Calcium, the most commonly done stain is 𝐌𝐞𝐝𝐿. Alizarin is a very specific stain. It's a better stain but not used because it's expensive. Alizarin is silver based. Silver is expensive, you won't be using it, right? 𝐌𝐞𝐝𝐿 is a cheaper one, cheaper alternative, right? So this is 𝐌𝐞𝐝𝐿. 𝐌𝐞𝐝𝐿 will be black in color, blackish brown in color of the calcium deposit, and this alizarin red, obviously red color, right? Is alizarin, that's how an alizarin red looks like, right? Okay. You know where you have calcium is seen in case of where? Every place where you have dystrophic calcification, metastatic calcification, some of my bodies I can use everywhere, and it's a common finding which you see them, right? We don't require microscopy for this. Most of the time we'll pick it up on normal light microscopy. Blue color is for calcium, that's all, fine. Let's go to copper. Copper, I want you to make sure rhodamine can be right or rhodonine can be right. Both are fine, right? So please don't confuse this rhodamine and auramine rhodamine. Auramine rhodamine is used in tuberculosis, not just rhodamine. Fine. That's a fluorescent stain in TB. Rhodonine or rhodamine stain in liver means copper only, because one is a stain, one is a procedure. That's all. Rhodonine, rubionic acid, orsine. I would prefer orsine stain. This is actually an orsine stain because it's much clear, much easier. Copper has only one use case. Normal light microscopic color of copper is same, brown. This I want everyone to answer. Can anyone tell me what will be the only use case or application of copper? There's only one application of copper. What is that? What's the only application of copper? 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 Only one application. I can use copper in case of... Come on, this is very simple. In case of a liver failure. Perfect. Wilson's disease, right? In Wilson's disease, liver failure, tremors, and you have the problems of the KF ring in the eye, all points to Wilson's disease. That's only one use case of copper in case of diagnostic pathology, right? Great. Let's go to mucin then. There are lots of mucin. Mucin can come from salivary gland. Mucin can come from lower end of esophagus, stomach, the entire colon. All these are mucins only, right? So mucin, the 𝐒𝐿-𝐶 is a mucin which is used for salivary glands. If the question is on a salivary gland mucin, they are 𝐒𝐿 positive. PAS is a neutral mucin positive for most of the mucins with PAS positive. Alcian blue is for acidic mucin. Maybe remember A for A. This is an old INICT question. One of the stains which can stain acidic mucin is Alcian blue. PAS stains both neutral as well as acidic mucin, and one use case is PAS and Alcian blue. Both are positive in case of your Barrett's esophagus. Both are positive for Barrett's esophagus. Do remember them, right? PAS, the color is magenta color, a dark pink color. Alcian blue, as the name says, it's blue in color. I'll zoom this image. Not able to zoom it. Okay. This is PAS, the magenta color, and this color is your Alcian blue. Okay. That's your bluish color, right? Alcian blue, PAS, both are mucin stain. If it's a specific acidic mucin, go for Alcian blue. But a history of Barrett's esophagus, it's possible for both PAS as well as Alcian blue. If it's a salivary gland mucin, like mucoepidermoid carcinoma, you go for 𝐒𝐿. Can anyone tell me, since your microbiology is over, there's one organism which is positive for 𝐒𝐿. I'll give you clues if required. One organism which can cause meningitis in immunocompromised people, has a India ink positive structure in the dark field microscopy. That structure is what is positive for musicarmine as well. Anyone? What is the organism? Musicarmine is also positive for Cryptococcus. Okay, they're also positive in case of a cryptococcal meningitis. If it's an organism, go for Cryptococcus. If it's a mucoepidermoid carcinoma and salivary gland, go for salivary gland tumors, right? Cryptococcus, the neoformans, right? The capsulated structure is positive for musicarmine as well. Yes, perfect. Okay. Last but not the least, we'll go to amyloid. Amazing. Fine. So microscopy, again, normal H&E, normal light microscopy, it's pink in color. When you do the stain Congo red, again in microscopy, the color becomes salmon pink. And in case of polarized light is what you see in this image. It becomes apple green birefringence. Okay, apple green color in polarized microscopy. After Congo red, if I do a normal microscope, it will be same pink but orange pink color. That's called as salmon pink color, right? There are few more older stains for amyloid. I don't use them anymore. Amyloid is PAS positive also. Amyloid is proteinaceous deposit, right? It's also PAS positive. Thioflavin, which is positive for amyloid, right? Lots and lots of stains for amyloid. We don't use anything. The only stain which is used in diagnostic pathology is Congo red. Normal microscopy, salmon pink, and in a polarized light microscopy, you have the apple green birefringence here. Fine. Okay, that's about stains of pathology. We know quite a few stains. So what you have seen in the first chapter is few important things. I have touched on necrosis, the different types, the apoptosis, and we have looked at few of the stains here. Okay, I'll quickly go through whatever you have seen right now if you guys want it. I want at least 5-6 people saying yes so that we can quickly go through whatever you have seen. I'll read it faster. Close your notes, maybe close your eyes, just listen to it. Do you want it? Not. I want you guys to answer. Only when you're answering, you're going to the next chapter. Otherwise, no. Only one person wants yes. Gautam, I want your friends to say yes. Only when all your friends say yes, I'm going up, right? 2. Come on, be more proactive. It's fine if we lose it. What to lose, right? 4 of you. Last guy, 5. Done. Okay. Close your eyes. Just listen to me. Close your eyes. I'll just read through fastly and then let's go to the next one. So we started with necrosis. Necrosis is pathological. It will be as with pain as well as inflammation. The membrane will be damaged and the intracellular contents leak outside. That's the reason we use the troponin I, troponin T, AST, ALT levels for diagnosis. We have multiple types of necrosis. The most common is coagulative, every solid organ infarct. Mechanism of action is protein degradation, and you will have architecture maintained and ghost cells will be there. In liquefactor, mechanism is enzyme degradation, architecture will be lost, there will be no ghost cells. Brain infarct, and you have wet gangrene abscess or any suppurative inflammation, you'll have liquefactor. In acute pancreatitis, in pancreas liquefactor, in omentum fat. Caseous, more granular, cheesy white appearance in gross. TB, histococcidiomycosis if you rule out TB. Fibrinoid, fibrin-like seen in vessels. Any vasculitis, SLE and malignant hypertension, they are PAS positive, right? And it came to fat necrosis. Microscopy of normal fat is clear, but necrotic fat is always pink in color. Enzymatic, we saw an example, trauma. Any trauma to any fat-rich structure will have traumatic necrosis, right? Apoptosis can be both physiological and pathological. We have 2 phases, intrinsic and initiator and execution. Under initiator, we have intrinsic, mitochondrial mediated, extrinsic, cell membrane mediated, fast ligand. Intrinsic is based on the anti-apoptotic, pro-apoptotic, right? Anti-S-L, longer life, BCL2, MCL-XL, or BCL-XL or MCL1 or anti-apoptotic, backs and back or pro-apoptotic. There's one problem, BCL-XS, shorter life, pro-apoptotic, right? And we had caspases. We had multiple named caspases, 1, 4, 5 for pyroptosis. Pyro is fever, so that type of apoptosis will be involving interleukin 1. 8 and 10 for extrinsic pathway, 9 for intrinsic pathway, and 3 and 6 for execution caspases. Caspase is nothing but a protease. Then we saw stains of pathology. Melanin, Massenfontana, small stain. Always in melanoma, new application is pigmented fungi. Hemocyanin, brown in color normally, and we use Pearl's Prussian blue. I can see then hemochromatosis, heart failure cells, and asbestosis. Lipid normally clear, but fat stains of oil red on Sudan black needs frozen section. Otherwise, I cannot use the stain. PAS positive diastase resistant is glycogen. PAS positive diastase sensitive is glycogen, and resistant is protein. Every glycogen storage disorder, I can use them. Ewing sarcoma, I can use them. I can even use them in diabetes mellitus because again sugar related, right? Diastase resistance of protein, only two use cases. Alpha-1 antitrypsin deficiency, lung and liver. Lung emphysema, liver failure. An intestinal problem, infection, you have problems in the heart, problems in the joint, think of Whipple's disease, that also is PS positive, diastase resistant. Calcium, 𝐒𝐿, and azanrate. 𝐒𝐿 is more common, Lewis, azanrate is more specific. Copper, water is rhodonine, rubionic acid, orcine stain, microscopy brown in color, only one use case is Wilson's disease. Mucin have multiple use cases. Salivary gland mucin and cryptococcus is mucicarmine positive. Everything acidic mucin is Alcian blue positive. PS magenta color positive for both neutral and acidic. Barrett's, which in application is both Alcian blue as well as PS positive. Last but not least is amyloid. Amyloid normally is pink in color because of the protein, and obviously amyloid in microscopy will have salmon pink in color after congruent. When you use a polarized light, it becomes apple green in color, right? Okay, now let's go to second topic of inflammation. Okay, next 30 minutes we'll talk about inflammation, and let's quickly go through. Fine. Okay, I want more interaction so that it becomes more easy for you. 3-4 hours we'll just be done with 20-25 pages, so you can read it at last. Fine. So we have two types of inflammation. One is acute and one is chronic. Acute inflammation happens in minutes to hours. Please remember, two cells in acute inflammation, not only neutrophil. Allergy is also acute, yes, predominantly neutrophil, but eosinophil also. Please don't forget this. Eosinophil also will be a component of some amount of acute inflammation, right? Chronic is days to months. This is the cell of chronic inflammation, not lymphocytes. Macrophage is cell of chronic inflammation. Lymphocytes also in case of autoimmune disorder. AI is for autoimmune disorder and also for virus. Any viral disorder, obviously you'll have lymphocytes involvement in there, right? The classical hallmark of acute inflammation is TDHF. Vasodilation and increased vascular permeability. Remember a mosquito bite. When mosquito bites, you have a swelling. Vascular permeability, that's all. That's the most important thing. And for chronic inflammation, TDHF. Remember TB. TB, the sign in the X-ray is fibrocavity tuberculosis. Destruction, cavity surrounding by fibrosis. TDHF is classical for your chronic inflammation, right? Then we have few important steps of inflammation. Close your eyes. I have a problem in my skin. So the neutrophil from the vessel should come to the skin. So what first they do is, from the center, they go to the corner, margination. They keep on rolling. Till a point, they found a door. They will stop there. And then they will slowly sneak outside, right? Margination, rolling, adhesion, diapedesis, chemotaxis. That's what inflammation is. So they go to the part and they remove the organism, which is the role of neutrophil there, right? So margination is a vascular event. It's due to vasodilation. So since the vessel dilates, my laminar flow will be disturbed. Like a stream, you have a river, branches, you'll have swirls. Like that, it goes to the corner. But a molecule called as selectin helps. This came in an exam. Selectin helps margination. Selectin CD marker number is CD62. They will always write PCAM number, CD31. There's double of it, CD62. Fine. Rolling is always due to selectin only. So selectin mediated rolling, right? Rolling is the link between selectin and CLL-Lewis X receptor. CLL-Lewis X receptor is on the WBC and the selectin here is on the endothelium. Endothelium selectin and WBC CLL-Lewis receptor binds and is a very, very, very weak bond. Because of the weak bond is what? It attaches, right? Addition obviously has to be a strong bond. What molecules are involved in addition? Anyone? I told about rolling. You have to tell me about addition. What molecules are involved in addition? What are the molecules involved in addition? Molecules, you have integrin and you have CAMs, cell addition molecules, right? Integrin is on the WBC and cell addition molecules on the endothelium. I'll tell you why I'm mentioning that what is on the WBC, because it's a very, very important for me to understand the abnormality. I have CLL-Lewis X receptor in the WBC and I have integrins in the WBC here, right? Diapedesis is the exit. Exit outside of the cell blood vessel is diapedesis, and you have CD31 or PECAM1 helping it. It's a molecule which helps in diapedesis, right? That helps in diapedesis along with action of little bit of non-specific collagenases. So generally not mentioned in your books, but this also is required for me for diabetes. Okay, it's required for diabetes, right? Next is chemotaxis. It is reached outside, but I have to go to the site of inflammation. We divide chemotactic mediators into two major groups, exogenous and endogenous. See, it's very simple to remember it. An organism came, along with that I'll have the lipopolysaccharide cell wall of the bacteria. I'll have flagellar proteins. I'll have pilin, right? The pili proteins. All these of them are exogenous. They will come and attract me, my WBC, to go there and eat it. That's all, right? The invading organisms will give me clues. I'm there here. Please come and destroy me. Endogenous are my body's response. Can anyone give me one example of endogenous chemotactic mediator? One is interleukin 8, an important one. Complement factor, complement protein C5 is an important one, and also LTB4. All these three you should never forget. All these three are very, very important chemotactic mediators. I want you guys to remember. Okay, all these three are endogenous chemotactic mediators. Because of these chemotactic mediators, from a vessel, the WBC exists and goes to the site of inflammation. Okay, that's the role. With the rolling adhesion diabetes and chemotactics, it reaches there. Once it reaches there, it will destroy. Destruction is always by a respiratory burst. So respiratory burst is a mechanism by which the phagocytosome formation happens and it destroys. Interleukin 8, yes, Gautam. Okay, you must have definitely read about these two. Interleukin 8 is also a very important chemotactic factor. That's where it's involved more in sepsis, and you have interleukin 8 inhibitors, which are in research, which is very useful in sepsis, right? Okay. Now, this is not important for us. Our goal is to understand normal and to apply for abnormality. That's more important, right? So now let's apply the abnormality in terms of diseases. What if something is not present? Inflammation will not be happening properly, right? So all these are not good signs for us, right? What does LAD stand for? Anyone? I'm sure you know the expansion of LAD. LAD stands for, I just want you to comment the LAD so that you will never ever make a mistake here. LAD stands for leukocyte adhesion deficiency, right? Please remember, it's a leukocyte adhesion deficiency. The problem is with the leukocyte or the WBC. It's not a problem of the endothelium, it's a problem of the WBC, right? So LAD1, one is like integrin, right? One is like I. So we have integrin defect. One is like I. Again, all these are mnemonics going on for years together, right? One is like an I, so an integrin defect. There's an autosomal recessive inheritance. Okay. Two is not selectin. Please don't write that. It is CLL-Lewis X. Okay. Two is not selectin because selectin is in the endothelium. It's not in the WBC. CLL-Lewis X in the WBC. CLL-Lewis X with this is also the autosomal recessive inheritance. Okay. So how do I remember the additional inflammation? There are two additional inflammations for both of these diseases, both LAD1 and LAD2, right? LAD1, that's integrin, is also, the other role is it helps in wound healing. Okay. This can also be an MCQ. Integrin is a molecule which helps in wound healing. So can I say in this patient, healing will be delayed because integrin is not there properly? Yes. That's why you have a delayed separation of umbilical cord. Because umbilicus is a scar tissue. That's the first injury all of us got, right? The umbilical cord stump is a scar tissue and it will be delayed because it will not heal properly. There will be delayed healing. That's classical for LAD1, right? CLL-Lewis X, can anyone tell me what's a classical finding for CLL-Lewis X defect? CLL-Lewis X is also involved in blood grouping. So when the CLL-Lewis is absent, perfect, you'll not forget this, right? You'll have Bombay group. A Bombay group for Ciala-Lewis X defect, right? One more important information which is common for both. I'll erase this leukocyte here. That's just for understanding. Common for both of them are problems of WBC not able to go outside. Problem in rolling, problem in addition, right? So both of them will have neutrophilia. Always remember this. Though it's an immunodeficiency disorder, both will have more WBC count because the problem is not the production of WBC, the exit of WBC. They can't go outside, so they are neutrophilia here, right? Okay. Then you come to chronic granulomatous disease, CGD. Both autosomal recessive and X-linked recessive. The problem is in an enzyme. It's an NADPH oxidase defect. Twice this exam question was asked. I want you guys to answer for this. Which infection will be more common in case of a chronic granulomatous disease? You'll have recurrent infection with catalase positive organism or recurrent infection with catalase negative organism, or both. This is asked twice, once in a NEET and once in a INICT. You'll have recurrent infections with, come on, answer. With catalase positive, catalase negative, or both? With catalase positive organism. That's important. A recurrent infection with catalase positive organism, catalase positive bacteria, think of a chronic granulomatous disease, right? That's a very important clue for you to think. This has been asked previously, remember it, right? And there are multiple investigation of choices. Nitroblue tetrasodium test, NBT test is something I want you to remember as basics, right? There are DHR test. There's nitroblue tetrasodium. We start with DHR and we have enzyme analysis to end with, right? That's something which I want you to remember. Fine. 𝐒𝐿-𝐄𝐝 syndrome, again, it's an autosomal recessive defect, mutation in LYST gene. Here there'll be a reduced formation of phagolysosome. Okay, great. LYST stands for lysosomal transporter. So lysosome will not move, so it will not merge with phagolysosome. That's all. So how do you identify 𝐒𝐿-𝐄𝐝 defect? Is a combination. Infections plus, here there'll be a problem in the melanin movement, so albinism, and most important clue is giant granules in WBC. This is a very, very specific thing to diagnose. Giant granules in WBC, diagnostic of an 𝐒𝐿-𝐄𝐝 syndrome, right? Okay, giant granules, albinism infection, think of a 𝐒𝐿-𝐄𝐝 syndrome, right? Perfect. Okay. Last but not least, just to complete NPO deficiency, is an autosomal recessive inheritance, both catalase positive and catalase negative organism. Infection will be seen. An easier way to diagnose is enzyme analysis. That's all. Fine. Okay. So these are the different problems will happen when the molecules involved in rolling addition diabetes is not proper, or the respiratory burst is not properly functioning, right? This table, definitely one question might come. A good source, this or this. If I'm going to ask something in inflammation, I'll be more inclined towards asking these scenarios because it's very easy to create a scenario here, right? Or a one-liner for that matter. Fine. Let's go to chronic. Chronic inflammation. What is the microscopic finding of every chronic inflammation? That's what is being displayed here. Yes, Gautam. Except for one additional thing, chronic granulomatous disease has two inheritance, autosomal recessive and X-linked recessive. What's the finding here? That's a classic granuloma. Granuloma, you have to remember, right? TDHF is obviously there. I'm not leaving it. TDHF is your hallmark. Microscopy is granuloma, right? So a granuloma, in the center of this is what you have your epithelioid macrophages or your activated macrophages. They are the most important or the principal cell of a granuloma. Okay, they are the principal cell of a granuloma, not giant cell. Actually, this image does not have a giant cell. I can have a granuloma without giant cell also, right? Epithelioid macrophage or an activated macrophage is the principal cell of granuloma, and the periphery what you have is lymphocytes. Lymphocytes will be there in the periphery of the granuloma, that also is there, right? So for me, to form an epithelial macrophage, I need a inflammatory mediator. What is a mediator? Because that inflammatory mediator is the principal mediator for granuloma formation, right? To form epithelial macrophages, you need interferon gamma. Okay, don't forget this. We'll apply this very superbly in TB diagnosis. Interferon gamma is must for a granuloma formation. And for my lymphocytes, I need interleukin 2, interleukin 1, 2, and 12. Okay, these are required. In TB diagnosis, have you read about something called an quantiferon assay? Quantiferon assay is a way by which TB can be picked up very early. Quantiferon assay is nothing but an extrapolation of interferon gamma here. Fine. Okay. Interferon gamma is very, very important because that's what quantiferon assay is based on, and that helps me to produce the principal cell of granuloma. That's why it's very, very important for diagnosing of TB. Fine. Okay. So how we divide granuloma is we divide granuloma into two major types: necrotizing, non-necrotizing. Easy way to remember. Here you can kill. Here you can't kill. No need to memorize at all. Non-necrotizing or non-caseating, I am not able to kill. Necrosis is killing, right? Something I am able to kill, that's all. Which means TB I can kill. 𝐒𝐂𝐈𝐀 I can kill. Histoplasmosis I can kill. Leprosy, especially pure neuritic leprosy, I can kill. All these are caseating granulomas. If you can kill, they are caseating granulomas. I want you to answer one thing so that we can fill in non-caseating very easily. Is there a possibility if a person's immunity is not that great, I can't kill TB? Is that right statement? My immunity is not that great. Will I be able to kill TB? I'll not be able to kill TB, right? So here also the first guy is TB. If my immunity is not good, any person's immunity is not good, they will not be able to kill the TB bacteria. So that's the most important thing. TB can be both necrotizing and non-necrotizing, caseating and non-caseating. Please remember this, never forget this. No one can kill a foreign body. Foreign body is a non-living thing. Foreign body granuloma, non-caseating. Okay. No one in the world can kill sarcoid. There's nothing to kill in sarcoid, non-caseating. No one in the world can kill Hodgkin's lymphoma. Nothing to kill in Hodgkin's lymphoma, non-caseating. If I can't kill, non-caseating, that's all. There's nothing to kill in case of your occupational lung disease. That also is non-caseating. Silicosis produces non-caseating granulomas or non-necrotizing granulomas, right? Nothing to kill there. I cannot kill a silica. It's already dead. Can't kill non-caseating, can kill caseating. That's it, fine. So please do remember this so that you will never ever forget the difference between non-caseating and caseating granuloma, right? Perfect. Let's go to the next guy. Few important images which has been asked in around with granulomas, right? I want you to guys to answer this in the order which I'm marking. 3, let's go with 4, 5, 6. What's the first one? What's the first one? All these are repeatedly seen images. You should not make a mistake. So tell me, what's the first one? That's a Harsh. Yes, you're right. If it's with respect to omentum, I will think of an fat necrosis. Fine. That's a great. That's a Langhans type of giant cell, which is seen in TB, where I have horseshoe-shaped arrangement of the nuclei. It's like a horseshoe or a U-shaped arrangement of nuclei, right? What's number 2? The nucleus is having a circular arrangement. The nucleus is circular. What's 2? Circular nucleus is seen in Xanthoma xanthalismas, wreath-like arrangement or circular arrangement. Great. It's two-tone giant cell. Okay, since we are in giant cell, Let's look at one more giant cell. Extremely multinucleated here, right? It's multinucleated. And actually, I'll zoom it a little bit more, if you can appreciate that. You do have tiny pink inclusion inside the nucleus and also pink substance outside the nucleus, right? So you have both intranuclear and intracytoplasmic pink or eosinophilic inclusion. This is seen in a condition of measles. This is asked once in NEET exam as well. Measles, intranuclear intracytoplasmic inclusion, we call it Warthin-Finkelday giant cell. Okay, so in Warthin-Finkelday giant cell, measles pneumonia is a classical place where you can see this giant cell, right? Okay, let's go to the next guy. This also is a multinucleated giant cell. I hope you can appreciate that. Let's zoom in here. One nucleus, one nucleus, one nucleus. If you see, these three nuclei are sitting very close to each other. That's molding. You can see it is molded, right? So this is a classical thing. You have three M's here: molding, margination, multinucleation. I'm sure you know the answer by now. What's the answer here? Seen in case of herpes, right? Herpes simplex. I'm not saying just sang smear. Sang smear is a finding where I see this, but I can see that in herpes simplex 1, in the oral cavity, I can use a jam smear, or I can see also this in a pap smear, because herpes simplex 2 involves external genitalia, right? So pap smear or sang smear, 3M, herpes simplex, right? This you guys have to say. What's this one? Fifth one. What's the fifth one? What's the fifth one? It's classical outside, right? It's a classical outside. The most important thing is the outside is basophilic. It's blue in color. That's your cytomegalovirus. Okay, cytomegalovirus. Perfect. Right? If the same outside is pink in color, what's the thing? The same outside is pink in color. This also is an outside, right? But it's an outside, but has a pink color eye. That's your classical RS cell, right? So one is in classical RS cell, pink color nucleoli, right? And I have a blue color nucleoli, so blue color inclusion, that's your cytomegalovirus, fine? All these are giant cell. RS cell, Hodgkin's lymphoma is also a giant cell. It's a tumor giant cell, that's all, fine? Okay, so all these are different types of giant cell. Langhans, two-tone, Warthin-Finkelday, you have your herpes, you have a CMV, and you have RS cells. This will cover most of the giant cell which can come in an IBQ, fine? Okay, few different types of granulomas. What is the shape of this? We have a donut shape or a duffnet shape, however you want to call it. Donut shaped granuloma is commonly seen in liver and bone marrow. Allopurinol is a problem. Allopurinol toxicity. It's a place where I can see a donut shaped granuloma. And any other place? It's also seen in one infection. Which infection? You can see them in Q fever. Coxiella burnet infection. I can see a donut shaped granuloma, right? Perfect. Okay. This guy is a irregular granuloma or a star shaped granuloma or a stellate granuloma. Where do you see stellate granuloma? Stellate, star shaped. Which infection? Which infection you will see stellate granulomas? There are actually two infections. Stellate granuloma, in microscopy, you'll have neutrophils also. That's a unique thing of this granuloma, not the shape. Neutrophils plus granuloma, I have a stellate granuloma, right? Yes, I left the cerebral malaria. I've come to the niche one. Like, let's go to cerebral malaria soon. PC7, perfect. Cat scratch disease, Bartonella-Hinsley infection, and also remember LGV. Lymphogranuloma venereum, chlamydia. That also you'll see stellate granuloma. Generally not much discussed. Fine. Okay. This you're seen in cerebral malaria. not exactly granuloma, but it's been named as drugs granuloma, just for us to complete it, that's all. Okay, last but not least, on this side I have something called microgranuloma, where you have less than 25 epithelioid cells and there'll be no giant cells. That's the when I call it a microgranuloma, seen in case of an toxoplasma. Toxoplasma lymphadenitis, you see a microgranuloma. Fine. Yes, ninja star appearance in case of an cardiomyopathy, right? Titin mutation. If this remembers ninja star for you, Titin mutation in case of a dilated cardiomyopathy as a ninja star nuclei, if that's what you're asking. Fine. Okay. Done. Okay. So we know almost everything required for a chronic inflammation, the images and the caseating, non-caseating granulomas. Okay. Now, I want again 5 yeses so that we can quickly redo whatever 3 pages what we saw with respect to chronic inflammation. Yes, no. I want yes. Come on, I want you guys to answer. Let's quickly redo everything then and there so that at the end of the day, you'll be happily done with whatever time spent here should be useful, right? Can we go through it? Just 3 pages. Okay, perfect. Close your eyes, just listen. Don't do anything, don't write anything, right? Just listen. Fine. Inflammation, we divided inflammation to acute and chronic. Acute inflammation happens very quickly. There are 2 cells of acute inflammation, neutrophils and eosinophils. Please remember, allergy is also acute, right? Increased vascular permeability is the hallmark. Chronic inflammation, cell of inflammation, macrophages. It is lymphocytes if it's autoimmune or viral disease. And hallmark is TDHF, tissue destruction, healing by fibrosis. We saw both the events of acute inflammation. Margination because of vasodilation and selectin helps. Once it goes to the corner, it has to roll on the endothelium. For that, you have selectin on the endothelium and Cialis-Lewis receptor on the WBC. It's a weak bond, so it rolls. It has to stop at a point where there is an exit possible, right? Stopping happens due to addition. Addition is due to integrin on the WBC and CAM, cell adhesion molecules on the endothelium. It stops. Exits outside via diaperesis is the mechanism, and we have CD31 or PCAM1. Selectin's other name is CD62 if they ask, right? And also non-specific collagenase helps. Goes outside, goes to the site of inflammation with chemotactic movement. Both endogenous and exogenous factors. Exogenous are bacterial products. Endogenous, interleukin 8, C5a or C5, and your leukotriene B4. All 3 are superb endogenous chemotactic materials. Goes to the place, each destroys via respiratory burst. This is not important for us. What is important for us is the diseases. We have group of diseases which are immunodeficiency diseases because of problems in these steps of inflammation. LAD 1 and 2. LAD is leukocyte adhesion deficiency. The problem is the WBC. All of these are autosomal recessive except one. CGD is both autosomal as well as X-linked recessive, right? So LAD1 is like an eye, integrin defect. Integrin also helps in wound healing, so umbilical cord healing is delayed. LAD2 is your Cialis-Lewis X defect, not selectin, Cialis-Lewis X. And Cialis-Lewis is also involved in blood grouping, so I have Bombay blood group. CGD is an NADPH oxidase defect, both autosomal and X-linked recessive. The classical clue is catalase positive infection. NBD test is a very good test for us to identify it. It's negative. Then we have celiac syndrome, autosomal recessive, LYST defect, lysosomal transporter defect. Transport of lysosome is defective, so it will not merge and there will be no phagolysosome formation. Infection plus albinism, think of this. And Jane granules in WBC a very specific finding for celiac syndrome. MPO deficiency, just to complete autosomal recessive, you have both catalase positive and negative infection. Then we get to granuloma. Granuloma center part will have necrosis and plus epithelial cells. Epithelial cells is the hallmark of a granuloma. Interferon gamma helps in the formation of epithelial cells. Then you have interleukin 12, 1 and 2 helps to bring the lymphocytes to the corner. That's the peripheral cuffing of granuloma. We divide granuloma into necrotizing and non-necrotizing. Necrotizing, I can kill TB, histoplasma, coccidio, pure neurotic leprosy. Non-necrotizing, I cannot kill. Still first is TB. When immunity is not great, I cannot kill TB. Or you have your foreign body, sarcoid, Hodgkin's, or your occupational lung disorder, right? Then we have images. All these are classical images for us. Langhans, horseshoe-shaped, two-tone, circular, extremely chaotic, intracytoplasmic, pink and pink inclusion, Watson-Finkeley measles. Margination, molding and multinucleation, Zank smear or in pap smear herpes simplex. Outside blue, CMV, outside pink, RSL. Donut in liver and your bone marrow, drugs in cerebral malaria, slate microscopy lab also have neutrophils, catch-crash and LGV, and microgranuloma is something which is seen in toxoplasmosis. Fine, done. Okay. Leprosy is necrotizing granuloma if it is pure neurotic leprosy, right? Other types of leprosy might not show classical granuloma, so let's not have it for now. Fine. Okay, done. Let's go to genetics. Clear? So genetics, I'm not going to take many things here, right? We are just going to cover very few things in genetics. The most important thing here is the pedigree. Pedigree as a rule. Please follow this rule. The first time you see every pedigree, rule out mitochondrial. The only way to rule out mitochondrial. Can anyone tell me mitochondrial is paternal or maternal inheritance? Paternal or maternal? Mitochondrial is maternal inheritance, right? It's maternal. So if a mom is affected, how many kids will be affected? 100% kids will be affected. If a dad is affected, none will be affected. Okay, mom is affected 100% and dad is affected, none of the being affected. That's a clue for mitochondrial inheritance, right? Then you have two flow charts. I have one flowchart for autosomal recessive, one flowchart for autosomal dominant. Very simple to identify them. If you can identify them, that's nothing like that. It's very, very simple. We can extrapolate. But please look for the same order. Don't miss mitochondrial. If you miss mitochondrial first, your entire pedigree goes wrong, right? Few symbols for me to remember. Male, female, okay. Affected male. Can anyone tell me what is this finding? Or what is the symbol? This is for carrier state or a trait. Generally, you won't see this marking in pedigree because carrier is not mentioned in pedigree. It's either affected or normal, right? Okay. If it's like this, what does it mean? Because these symbols are also come in the exam. This is consanguineous marriage. Sanguineous is blood. Consanguineous marriage is blood relatives. That's all, right? Marrying within family, right? If you have a symbol like this, neither a square nor a circle, a diamond, that is gender unknown. Gender unknown is not always intersex or hermaphrodites, not always. Gender unknown can also be a fetus. As per our Indian law, I cannot draw, even with pedigree, that's a male or a female. I have to put a gender unknown for a fetus, right? That's one. Last symbol, if you've seen something like this, babies, but it's bifurcated. That's your twins. This is dizygotic twins. If you see the same way, but it's been connected by a single line in the center, that is monozygotic twins. Okay, the monozygotic twins image was asked once in exam. Remember, they are genetically connected. Don't write them as conjoined twins. They are monozygotic twins, right? There are a few symbols for you to remember. Fine. Now let's go to two flowcharts. Very simple flowcharts. The day before the exam, I want you to definitely go through these flowcharts. It's very, very important here. Fine. Okay. So first thing is, whenever I see a particular ask whether all generations are affected or not, which means at least one every generation. Write this also here. This means at least one per generation to be affected. Not everyone, at least one, right? If the answer is no, I'm talking about recessive. If it's only men involved, it's X-linked recessive. Both men and women involved, it's autosomal recessive. It's very, very simple. See a pedigree. If all generations are not affected, it's a recessive disorder. Only men involved, X-linked recessive. Both men and women involved, autosomal recessive. That's all. Dominant is little bit complicated. One more extra layer will be there in dominant. Fine. It will start the same. All generations affected. I'll think of a dominant disorder. Next question is dad to son. I'm a dad. If I give birth to a son, I'll give my Y chromosome or X chromosome to the son. I'll give a Y chromosome. Only when I give Y chromosome, the zygote will become a son, right? So can I ever transmit my X-linked problems to my son? Never, because I don't give my X chromosome to my son, I'll give my Y chromosome to my son, right? So if the dad to son transmission is not there, I think of an X-link. If the dad to son transmission is there, it's not an X-linked problem. It's an autosomal dominant problem. Then I have one more question. I said there are two questions, right? All the daughters are affected of the affected dad. Again, same example. I'm a dad. Assuming my X chromosome is abnormal, I'm going to give birth to a girl child. What chromosome should I give to the zygote so that it becomes a girl child? X. Because from the mother only X comes. From me, if the X goes to the zygote, it becomes a girl. I have a problematic X. So how many ever girl child I produce, I'll produce a problematic girl child. Because then the answer is, if 100% the daughters are affected, then it is X-linked dominant. If the answer is no, not 100%, it's an autosomal dominant, right? These two flowcharts, the day before the exam, I want you to read it. Just once, enough. You can solve any pedigree which comes in the exam. Pedigree is a pure science. It's not by luck. And if a pedigree is not fitting into this flowcharts, the pedigree is wrong. People don't know to draw pedigree, that's all, right? Okay, let's go through it. I want you guys to comment. This is purely on commenting, right? All generation affected or not here. Because if you don't practice what you read, it's useless. Everyone watching here, tell me, all generation affected or not? Yes, no. No, because this generation is not affected. Dominant or recessive? If all generation are not affected, I'm going to talk about recessive, the first flow chart. In the first flow chart, there's only one question I asked it. Both men and women or only men, right? Not all generation affected, right? Come on. It's no, right? The first generation is not affected. Don't miss this generation. This generation is not affected here, right? So it's recessive. If it's recessive, then I think of only one thing. Only men or both men and women here? Women is affected, man is affected. It's both. So can anyone tell me what's the pedigree? It is autosomal recessive inheritance. It'll take 10 seconds maximum. All generation not affected, I think of recessive. If it's recessive, I look at genders. Both the genders are affected. If it is, so it's autosomal recessive. That's it. Never ever worry. It will be easy for sure. Okay. Let's look at one more pedigree. Again here, same rule. All generation affected or not? Yes, no. No. Again, please don't miss this. Generation not affected. The answer is no. Then again, I think of recessive disorder only. When I think of recessive disorder, the next question is whether only one gender is affected or both genders affected. Only males are affected here, right? Only males affected here. So what will be the inheritance? Perfect. It is X-linked recessive. I don't want you to memorize anything. Just remember the flowcharts. It's X-linked recessive. It will take 10 seconds. If you cannot find the answer in less than 10 seconds, the pedigree is wrong. All the generation affected or not? It is not affected. So it's recessive, right? Only men or both men and women are affected. It is both men and women. So it is autosomal recessive, right? That's all. You just apply the flowcharts. If you apply it like this, and if you come to an autosomal recessive, I want you to do one thing. Hold your hand like this, right? And give a nice hit on your head. Can you guys do it for me? Everyone who follow the same thing, can you guys do it for me? Yash, Rishabh, including me. Can you give it? Because I told you the most important thing in solving is follow the rules. What's the first rule? The first rule is always rule out mitochondrial. You miss rules, you miss everything. You miss rules, you miss a mark. Anytime you see a pedigree, the first thing, please make sure whether it's mitochondrial or not. Mom affected. How many kids are affected? 100%. Mom affected. How many kids are affected? 100%. Dad affected. How many kids are affected? None. Can I say it's mitochondrial? It is. It's very, very, very important to rule out mitochondrial first. Mother is the most important in the world. Remember that. Perfect, cool, medico. Why mitochondrial will not fit into my rule is mitochondrial is non-Mendelian. It's not Mendelian inheritance. And the rules are laid down by Gregor Mendel. Right? Please make sure the first time you see any pedigree, rule out mitochondrial. Once you rule out mitochondrial, it's fine. Then 2 flowcharts only. It will fit there. Fine? Okay? Don't worry, Rishabh. You made a mistake here. You will not make that in the main exam. That's our ultimate goal. This is not an exam. I am not going to give you pass or fail, right? Simple. Mitochondrial first, mitochondrial always. Rule that out. Then these 2 flowcharts are enough. Whatever pedigree comes to you, it's enough for you to solve it. Fine? The day before the exam, read it. Don't forget these rules. Memorize it. Write the correct answer. Forget it after the day of the exam. Not useful for real life. Fine? Okay. So we know how to solve a pedigree, right? Then I have one more easy clue or logic. These are pure concepts. It's not clue, it's not mnemonic. To remember which disease can be dominant and which disease can be recessive. Because I have seen mnemonics for this. I sometimes hate it. You have a mnemonic, right? A, B, C, D, E, F, G, H. Right? That's not mnemonic. That's very, very sad. It's very difficult to remember mnemonics like that, right? Let's go with pure logic. Now, there are few clues for dominant disorders. If it's a cancer syndrome, it has to be dominant. Can anyone name one cancer syndrome? Any one cancer syndrome? Can I tell familial adenomatous polyposis as a cancer syndrome? Yes. Cowden syndrome, you must have heard. Peutz-Jeghers syndrome, yes. Von Hippel-Lindau syndrome. Neurofibromatosis. All the cancer syndromes has to be dominant. Structural protein errors has to be dominant. Collagen, fibrillin has to be dominant because they are structural protein. Your spectrin ankyrin, spherocytosis, structural protein. Presence late in life, mostly adults or adolescents. In other words, it will not present at birth. If a syndrome follows these 3, it has to be dominant. I'm saying dominant can be autosomal or X-linked. X-linked dominance are very less, so mostly autosomal dominant. Clear? This is an image from Robbins, a table from Robbins. We'll just use this, that's all. Okay? ADPKD. Will you accept? Just comment Y or yes, that's enough. Will you accept when I say ADPKD presents around 40-50 years of life? Yes. Late in life presentation. FAP, cancer syndrome. Structural protein or late in life. Von Willebrand disease presents late in life. It presents around puberty most often, right? Marfan syndrome, structural protein. Ehlers-Danlos, structural protein. Osteogenesis, structural protein. It will fit into it. If it's not fitting, it's not science, that's all. Fine. I have 3 rules for dominant disorder. Remember these 3 rules. Apply that. Don't apply in the exam. You have multiple subjects. Wherever you see a syndrome, apply this. It will fit into it. If it's not fitting into it, remember that alone because that's an exception. That's all. Fine. Let's go to recessive. Recessive also has rule sets. Early life presentation, or I can call them congenital. If something presents at birth, I call it recessive. Again, recessive can be both autosomal recessive and X-linked recessive. But it's recessive, that's all. Enzyme errors, inborn errors of metabolism, all are recessive. Okay. In inborn errors of metabolism, in mucopolysaccharidosis, you have a big table, right? Don't memorize them. Your Hunter Fabry X-linked, rest everything autosomal recessive. You can rule out and write it because it cannot never be dominant. If a disease has carrier state, it is recessive. Sickle cell anemia has a carrier. Thalassemia has a carrier, is recessive. It has to be recessive only, right? Now, with this just three simple rule, let's go to the table of Robbins. You don't want A, B, C, D, E, F, G, H, right? Cystic fibrosis, presents meconium ileus, early in life. Enzymes, early in life, right? All are inborn errors of metabolism. Trait, enzyme, will fit into it. If it's not fitting into it, medicine is not logical, medicine is not conceptual. But medicine is logical and conceptual. It should always fit into the rules. There are few exceptions. That I'll memorize. I won't memorize what is required logically, right? So easier way to remember dominant recessive is these two things. Just memorize it. That's enough for me. Then obviously you can apply it and come to a conclusion, right? As simple as that. There are only two places in genetics where is more emphasis. One is pedigree. Other is I can ask them whether the syndrome is a dominant or the syndrome is a recessive. We have rule sets for both of them, right? Pure logical rules for both of them, right? Last but not least, let's go with few investigation of choices, because it's been common to ask give a disease and rarely ask an investigation of choice. Fine. Thank you, Yash. All thanks to the big guys who discovered science and left it for us. Fine. It's our job to take it forward. Okay. Any chromosomal disorder or any chromosomal, when I say chromosomal disorder, Down syndrome is a chromosomal disorder, right? You will agree? You will. Can I say Philadelphia translocation is a chromosomal disorder? It is. So when I say chromosomal disorder, aneuploidy. Last exam asked, what is aneuploidy? It's very simple. Aneuploidy. You means true. True ploidy is 46 chromosome. You have 46, I have 46, right? Aneuploidy, not 46 chromosome, that's all. If a person does not have 46 chromosome, it's aneuploidy. No confusion. Downs is aneuploidy. Turner is aneuploidy. Klinefelter is aneuploidy. Patho, Edward is aneuploidy. Not 46 chromosome is aneuploidy. And every translocation, right? Perfect. Like Harsh said, I have two things here. Generally, I go for fish, then karyotype. Harsh, I want to little bit change. Fish is more important than karyotyping. If it's a known disease, I'll tell you what do I mean by this. How do I apply it in the exam? If I have a patient with a chronic myeloid leukemia, I want to do a genetic test. I'll always prefer fish, then I'll prefer karyotyping. I'll not prefer the other way because fish is more specific. But at the same time, you will also accept that one of the most common cause of abortion is trisomy 16. You must have read in OBG, right? Trisomy 16 is one of the causes of abortion where I don't know what I'm looking for. It could be even trisomy 12. It could be even trisomy 10. In abortion, I go for karyotyping first, right? Because fish is a very, very, very specific test. Karyotyping is a very, very, very sensitive test. If I want to diagnose a clue amongst multiple options, I go for sensitive. I know it is CML. I have to hit the bullseye. I go for specific. For any disease, fish is better. Fine. For any disease, fish is better than karyotyping. If I don't know what it is, karyotyping is better than fish. Fine. Yes, Robertsonian translocation is a translocation seen in case of a Down syndrome. It's seen in the mother for Down syndrome. That's a Robertsonian translocation. Fine. Translocation between any two acrocentric chromosomes is Robertsonian. It can be translocation between 21, 22. The most common Robertsonian is translocation between 14 and 21. Okay, this is the most common Robertsonian translocation, which might result in Down syndrome. Fine. Okay, let's come to the next. Chromosome arm deletion or an exon deletion. We have a test called as an MLPA. Just remember this test name, and the only use case I want you to remember is Duchenne's muscular dystrophy, Becker's muscular dystrophy. Remember that Gover sign, standing on yourself. Duchenne's and Becker muscular dystrophy, we use MLPA. Point mutation, like sickle cell anemia. Right, sickle cell anemia is a point mutation. Fine. In sickle cell anemia, you will have investigation of choices PCR, or I can use any variant of PCR. Could be a real-time PCR, could be a reverse transcriptase PCR, any PCR. Fine. I'm just writing PCR and its variants. Gold standard for sickle or point mutation is sequencing. The sequencing is named after the person who discovered sequencing. We call them Sanger sequencing. That's a gold standard for any point mutation, Sanger sequencing. Fine. Okay. If I have to measure, quantitative is if I have to measure a mutation, quantitate, I use qPCR. qPCR is quantitative PCR, or otherwise called as real-time PCR. Okay. The most common mistake done is this. RT-PCR is not real-time PCR. What does RT stand for, anyone? RT is reverse transcriptase. Remember this. RT stands for reverse transcriptase PCR. RT is not real time. Real time is Q. If you have to measure, I use qPCR. Fine. Now there's a question which is asked a couple of years back. Where do you use RT-PCR? The answer is very simple. The only problem, no, I'm not looking into the concepts and logic. I'm looking into only memorizing facts. Reverse transcriptase. Yes, sure, I'm not going into that. Yes, let's ignore it. It's too complicated. I'm not going into it for now. What does reverse transcription means? Reverse transcription is from an RNA, from a DNA, I form an RNA, that's transcription. What does reverse transcription means? From a RNA, I form a DNA, that is reverse transcription, right? That's all? Perfect. So what is reverse transcriptase PCR is used is, that's all, it is used in RNA products. If you have to measure RNA, could be an RNA virus, could be a protein product. If you have to measure a protein product, because protein again is reverse, right? It's reverse. If you have to measure a protein or an RNA product, it is reverse transcriptase PCR. That's all. COVID-19 is an RNA virus. Reverse transcriptase. Clear? Don't forget, don't memorize. Reverse transcription is RNA to DNA. Wherever I want that, I use reverse transcriptase PCR. Fine? Okay. So these are few things which you want to memorize, remember with respect to investigation of choices. Fine? Okay. Apply with relevant clinical scenarios which comes in an exam. Alright, so let's go to the amyloid. We'll complete amyloid and then let's go to the quick revision of complete genetics and the immunology. Immunology, I'm taking only amyloid because I know that hypersensitivity you must have read with respect to microbiology. Stick to that. Fine. Amyloid is non-branching beta-pleated sheets. It's a protein. It's a non-branching beta-pleated sheet. That's a classical one. Fine. Lots and lots of types of amyloid here. Always A stands for amyloid. The next one stands for the protein which is getting deposited there, right? The most common amyloid is AL, and you see them in myeloma, and mostly involves kidney. It can involve multiple places, but mostly involves kidney. What does AA stand for? AA stands for, here A stands for serum amyloid A protein. That's what the AA stands for. Okay, it's an amyloid A protein. It is seen in any chronic inflammation induced amyloid. The chronic inflammation could be anything. Could be a rheumatoid arthritis, could be a tuberculosis, could be any chronic inflammation. I'll have amyloid deposit here. Fine. Okay, that's your A amyloid. Okay, perfect. Where do you see A beta 2 microglobin? Beta 2 M stands for beta 2 microglobin. This has been repeatedly asked. The seen in chronic hemodialysis. See, there's a very logical explanation for that. A hemodialysis machine is not perfect like a kidney. They cannot remove beta 2 microglobin, which stores and causes amyloidosis. That's all. Fine. ATTR. TTR stands for transthyretin. Okay. Normal ATTR is seen in senile amyloidosis, senile systemic amyloidosis. It's normal ATTR. I also have mutated ATTR. Mutated ATTR is seen in an inherited condition called an amyloidotic polyneuropathy. It causes nerve disturbances. It causes an amyloidotic polyneuropathy. Have you read in carpal tunnel syndrome in your anatomy? Amyloidosis is a cause. I can have an inherited problem, amyloidotic polyneuropathy, which is a mutated ATTR. Fine. Cal stands for calcitonin. I am sure you know the answer. Where do you see them? Calcitonin is in your parafollicular seizures. We see them in medullary carcinoma thyroid. That's where we see calcitonin. It's in medullary carcinoma thyroid. Fine. Okay. BA beta or A beta 42 to be very specific. Where do you see A beta 42? CNS, Alzheimer's. See them in Alzheimer's disease, right? Last one, this I want you guys to answer. Because I've answered everything, I want you to answer at least one. The difficult one, I'll give it to you, right? IAAP stands for islet amyloid polypeptide. Okay. I just want you to answer which organ will you see this islet amyloid polypeptide. The next I'll come to which condition. First tell me which organ. Organ is very simple, right? Which organ? Which organ? Pancreas. Islets is in pancreas, right? In pancreas, in case of a greater, in case of type 2 diabetes mellitus. Please remember this. Type 2 diabetes mellitus. Okay, not type 1. I'll give you a logic to explain and remember why it's type 2. Amyloid is excess deposition, right? Yes. In type 1 diabetes, insulin is reduced or insulin is increased? In type 1, insulin is reduced, so it cannot deposit. In type 2, because of insulin resistance, insulin production is increased. More protein production, more deposit results in amyloidosis. Clear? IAPP is in pancreas in type 2 diabetes. Fine? Okay. So few other one-liners with respect to amyloid. The most common organ involved is renal or kidney. The most common cause of death is cardiac amyloidosis. Because once amyloid is involving heart, can't do anything. The patient will die by default. Okay, because the only way to get out of it is cardiac transplant. Not that easily possible, right? Abdomen fat pad is a very sensitive test to pick up in case of an generalized amyloidosis. Tongue, yes, I can take. Rectum, I can take, but abdomen fat pad is the best. And we already know that stain is congruent, what will be the color in light microscopy after congruent? It will be salmon pink. Okay, this salmon pink after congruent is H&E. In normal microscopy, it will be normal pink in color. We have all the three colors here. This is amyloid, H&E, pink. Pink extracellular acellular proteinaceous area. Congruent, pink, salmon pink. The orange shade of pink is salmon pink. Salmon pink. Same congruent in polarized light, you have apple green. Okay, that's classical. Fine. I think someone told in the start fibrillar protein. It is a fibrillar protein. I'm not denying that at all. In electron microscopy, it's seen as fibrillar non-branching proteins or non-branching fibrils. They're non-branching, seen as elongated structures. What's the best thing to demonstrate structure of amyloid? This is related to biochemistry actually. I have to tell this amyloid by telling it's a beta pleated sheet. What's the test? The best test to demonstrate amyloidosis is X-ray crystallography. Because X-ray crystallography tells me it's a beta pleated sheet. Nothing else will tell me it's a beta pleated sheet. It tells fibril. It tells the color. Nothing tells me it's a beta pleated sheet. The only test which says beta pleated sheet is X-ray crystallography, right? All these are with respect to amyloid, right? So we have covered mostly the important things with respect to amyloidosis. Okay. Clear? If clear, can we quickly go through genetics and amyloid soon before we move on to little bit of neoplasia? If you're ready, I'm ready. Ready? Okay, come on. I want more louder yes. Yeses are very silent. We just saw very few logical things, just 3 more pages with respect to genetics and your amyloid, right? Same rule, we'll recap for sure, Gautam. That's my job. Your job is to study, my job is to teach, right? Let's close your eyes. I want you to close your eyes. Let's recap quickly and let's go to the next one soon. So in genetics, we saw only 2 topics. One is for pedigree, rules for pedigree, few images or the what is the pedigree symbols mean, and also we saw about the dominant recessive inheritance, how to remember it, right? So rule of pedigree, first and foremost, please don't forget mitochondrial. Mom infected 100 affected 100%, dad affected 0% affected. Then we have few images, right? Completely shaded is going to be deceased, half shaded or dot is going to be your carrier or trait. Double line is a consanguineous marriage. Diamond is a gender unknown, could be a fetus or a hermaphrodite. You have a kid and then it branches, it's a twin, and the branch has been connected, it's a monozygotic twin. They are connected genetically, not physically, fine? So there are two rules or two flow charts. All generations affected, no, recessive. Only men, X-linked, both men and women, autosomal. All generation affected, yes, dominant. Then I ask a question, dad to son. If there's no dad to son, X-linked, yes, autosomal. Then I ask one more question. If all 100% of the girls are affected from the dad, definitely X-linked. If it's no, again, goes to autosomal dominant. These two flowcharts, read before the exam, has to. Then obviously you apply, but please don't forget the first rule. First rule is always rule of mitochondrial, and mitochondrial is a non-Mendelian inheritance, right? Then again to rules of how to know it's dominant or recessive. Cancer syndromes, structural protein errors, later in life presentation is dominant. Early life, congenital, inborn errors, enzyme deficiency, carriers. Your sickle cell thalassemia, all are recessive, right? This can be both for X-linked and autosomal recessive. Same way this can be both for X-linked and autosomal dominant, right? A simple way, these are two tables of Robbins. Both can be solved with just three rules, that's all. Remember these rules, you need not remember mnemonics. And apply these rules whenever you go and read exams. Whenever you read any syndromes in any subject, fine? Chromosomal problem, aneuploidy or translocation. Aneuploidy is not 46 chromosome. The best choice is fish. Then karyotyping if I know the disease. If I don't know the disease, I go for karyotyping, then I go for fish. Chromosome arm deletion, exon deletion, MLPA, disease is DMD or BMD. Point mutation, any point mutation, like sickle cell anemia also. Investigation choices, PCR and its variants. Gold standard is by default sequencing. If you have to measure the quantity of the thing, I go for real-time PCR. Reverse transcription is RT-PCR. If I want to deal with a protein product or a virus product, reverse transcription, I do an RNA PCR, fine? Okay. Then it came to amyloid. Non-branching beta-plated sheets, fibrils is what is getting deposited. AL is for myeloma, AA for amyloid in chronic inflammation, beta to microglobin in hemodialysis, A beta in Alzheimer's, ATTR, two condition, senile systemic and mutated amyloid polyneuropathy, right? ACAL, calcitonin, medullary carcinoma thyroid, AIAPP is in your pancreas, type 2 diabetes because more protein production. Most common organ is in kidney, most common cause of death is cardiac. Sensitive investigations, abdomen fat pride in case of a generalized amyloidosis. Microscopy of pink color, salmon pink of congruent after congruent in light microscopy. After congruent in polarized microscopy becomes apple green beneficiaries, right? The best test to identify the beta plated chip is X-ray crystallography, and EM electron microscopy can give you non-branching fibril appearance, right? That's with respect to amyloidosis. Okay, perfect. Now let's go and have a quick look about few things in neoplasia. Just give me a second. Okay, ready? See, neoplasia is a very complicated topic and a very big topic. There are few genes. I'll just mention the genes which are required for you to remember the last code. That's one. Second thing which I will be focusing on is this and this. This page one question is coming. Paraneoplastic syndrome, you will definitely have a question, or in a tumor marker, you'll have a question. Not directly related, indirectly. Last FMG also had a question on CA125 in an ovarian tumor. You'll have questions by default, because for me to, if you have to ask like 4 or 5 questions in cancer in an exam, it will not be there without these two, right? Okay, so first we'll go to few important genes which I want you to remember, because many genes are there, right? Just few important genes. First, remember the last go with respect to cancers, right? Let's go to it. EGFR receptor family. So we have ERB1. The other name for this is EGFR. Just remember one thing, lung adenocarcinoma. I'm just going to say one. Few which you should never forget. ERB B2. This is the other name for HER2/neu. And that will be seen in breast cancer. Right? ALK. Again in lung adenocarcinoma. And one more tumor, don't forget, anaplastic large cell lymphoma. Okay? Is an anaplastic large cell lymphoma. Just remember that ALCL, because ALK stands for anaplastic lymphoma kinase. That's where it originated from, right? KRAS. The most common proto-oncogene mutated. Very, very, very worst prognosis wherever KRAS is involved. 3 cancers: lung, colon, pancreas. There are many more cancers where KRAS, but as on date, if I want to diagnose and start the treatment for all these 3, KRAS has to be done. If the patient is affordable, I have to do KRAS by default, right? ABL is the BCR ABL. I'm sure you know which guy. CML, Philadelphia chromosome, right? Tyrosine kinase. JAK2. You see them in polycythemia vera. If I have to call one, just remember this. That's more than enough. Right? 𝐒𝐬𝐶. 𝐒𝐬𝐶 almost equal to CD117. Wherever 𝐒𝐬𝐶 is positive, CD117 will be positive there. Fine. 𝐒𝐬𝐶. Can anyone tell me where all you have heard about 𝐒𝐬𝐶? Just is 𝐒𝐬𝐶 positive. Seminoma, dysgeminoma is 𝐒𝐬𝐶 positive. And also a disease of systemic mastocytosis is 𝐒𝐬𝐶 positive. Okay. Burkitt's is not 𝐒𝐬𝐶. Burkitt's is 𝐶-MYC. Hush. There's a difference, right? Burkitt's is right, but it's 𝐶-MYC. Fine. Okay. These 3 are 𝐒𝐬𝐶 positive. The one important thing for 𝐒𝐬𝐶 is 𝐒𝐬𝐶 and this both are tyrosine kinase. Both ABL and 𝐒𝐬𝐶 are tyrosine kinase. So can anyone tell me what drug I can use in both? What drug can we use in both? You can? Perfect. Both I can use imatinib. That's why you must have read in GIST also, it's imatinib responsive. Because 𝐒𝐬𝐶 is a tyrosine kinase. Systemic mastocytosis, I can give imatinib. CML, I can give imatinib by default. Fine? Okay. All those are proto-oncogenes. Rest are tumor suppressor genes. Retinoblastoma, okay, it's also called as an governor of cell division or cell proliferation. Retinoblastoma, you see them in obviously in retinoblastoma. Also, you see them in osteosarcoma. Fine. 2 things, have to remember these 2, right? Yes, 𝐒𝐬𝐶 inhibitor, that's tyrosine kinase inhibitor, that's your imatinib. Okay. P53 is the guardian angel of the genome. One chromosome, if I want you to remember this, chromosome 17p13. Why I'm asking you to remember is, there's a most common gene mutated in cancers, across all the cancers, and whenever P53 is gone, they have a very bad or a worse prognosis. Okay, they have worse prognosis whenever P53 is gone, whenever P53 is mutated, right? And the syndrome where you have congenital loss is called as an Li-Fraumeni syndrome. It's a P53's congenital loss. We use the Li-Fraumeni syndrome, right? CDH1, it codes for a protein 𝐒𝐻. 𝐒𝐻's function is, normal function is cell addition. It's like a desmosome, hemidesmosome. It causes addition. If 𝐒𝐻 is not having addition, it's lost. No cell addition. 2 classical cancers. Lobular carcinoma of breast. Okay. Other one is diffuse gastric carcinoma. This also will not have cell addition. These are 2 classical ones which will not have cell addition. Lobular carcinoma of breast and diffuse gastric carcinoma. Always remember that, right? VHL, 1 hepalindu, chromosome 3. One thing at least don't forget, it's involved in clear cell RCC and also cerebellar hemangioblastomas. Okay. Next, I want you to tell. Can anyone tell me, comment like, since we are more or less reading facts, can anyone comment me where do you see APC? That's a very simple thing. I'm sure you know that. APC is in which condition? APC in adenomatous polyposis coriae in familial adenomatous polyposis condition and chromosome 5. With respect to APC, obviously you should have minimum 100 polyps. to call it APC. And there are two changes of APC, which is Gardner's or variance and Turcot. Turcot is colon polyp plus CNS tumor like glioma, medulloblastoma. Gardner can have pricks in my fingers, right? So skin, bone tumors, musculoskeletal skin plus polyps. Fine. Here are polyps plus osteomas and skin lesions. I call it Gardner. All three are related to APC only. You have polyps and CNS, and you have this, right? Perfect. Colon carcinoma will also be there, right? STK11, it's seen in Peutz-Jeghers syndrome. Okay. One important thing which most of your seniors or missed during the last exam was Peutz-Jeghers syndrome. Yes, colon polyp for sure. Colon cancer for sure. That's not the thing. Peutz-Jeghers syndrome increases the risk of many other cancer, especially pancreatic cancer. The risk of pancreatic cancer in Peutz-Jeghers patients is 50 times than a normal population. 50. Never forget that. It also increases the risk of breast cancer also. Not just the colon, it also increases other risk of cancer as well. Obviously, one more important thing, oral hyperpigmentation. You must have seen the image, right? Lots of black dots in and around the lips, right? Oral hyperpigmentation is a classical condition for image for Peutz-Jeghers syndrome. Fine. Okay. So these are all classical genes and its syndromes you should not miss. The last day, there are lots of genes you must have compiled and read during the course of your prep. But last day, if I don't want to miss, I don't want to miss these things. Just a single page. All the important things have been repeated quite a few times in the past few years, right? Just for you. Okay, perfect. Now let's have a quick look at next page. Paraneoplastic syndrome, tumor markers. I don't bet on the gene, but I will definitely bet on paraneoplastic syndrome and tumor markers. There's a possibility questions can come. You can easily have a scenario-based question. Unrelated symptom, lung cancer, what could be the problem? Very, very unrelated, right? Paraneoplastic syndrome means I cannot explain the symptom because of the location of the tumor or the physiology of the tumor. That's what is paraneoplastic, right? So the most common paraneoplastic syndrome is Cushing's. The most common endocrinopathy. Overall, the most common is hypercalcemia. If you have to take problems in endocrine, the most common is Cushing, right? Can anyone comment where do you see all these classical paraneoplastic syndrome? Because these are multiple repeated things, right? Where do you see Cushing syndrome? Which tumor? Which tumor comes to your mind when you think of Cushing syndrome? Cushing? Cushing is due to ectopic ACTH production. That's a reason for Cushing's. Will be produced. Don't forget this guy. Small cell carcinoma of lung. Small cell carcinoma of lung. Two things can be there. One is Cushing. The other one is your SIADH. Syndrome of inappropriate ADH secretion, right? Great everyone. Basdev, Cool, Medican, Gautam. You'll have classical small cell carcinoma of lung. These both can be classical paraneoplastic syndrome, right? Hypercalcemia, you will see them in squamous cell carcinoma of lung. You can see them in breast cancers. You can see them in myelomas. Hypercalcemia, there'll be a product called PTH-RP being secreted. PTH, parathormone related peptide, RP. That causes hypercalcemia, right? Polycythemia vera, clear cell RCC, and cerebellar hemangioblastomas. In other words, whichever has one hippolyndo problem will have polycythemia vera, because that's related. Okay. Acanthus nigricans. What is acanthus nigricans? What will be the first thought? Non-paraneoplastic, I'll always think of insulin resistance. If you see black color or blackish discoloration in the nape of the neck or in the axilla, you think of acanthus nigricans, right? In the neck and the axilla. Obviously, you think of insulin resistance, diabetes, or patient with PCOD and others, right? If it's a tumor, I think of GI cancers and uterine cancers. Leiomyosarcoma, very classical acanthosis nigricans. Fine. Trocheus phenomenon. Trocheus sign is different. Trocheus phenomenon is different. You must have seen Trocheus sign in hypocalcemia, tetany, right? Trocheus phenomenon is migrating thrombophlebitis. It's lots and lots of clots in the superficial veins of the limbs. That's migrating thrombophlebitis, right? You see them in pancreatic cancer. See, the older repeat is a classical finding of pancreatic cancer. But what we understood later was not only pancreas, any mucin secreting cancer, not just pancreas. Now it's like any mucin secreting carcinoma can have it. Colon, lung, breast, stomach, anything. Because mucin can trigger the coagulation cascade, right? Maybe is right. Initially pancreatic cancer, but now any mucin secreting adenocarcinoma, I can have migrating thrombophlebitis because mucin will activate factor 10. If it activates factor 10, won't I have thrombus? That's all. Activates the coagulation cascade. So any mucin secreting adenocarcinoma can have this, right? Red cell aplasia as well as one more disease, myasthenia gravis. Both are actually autoimmune problem, right? Myasthenia gravis is an autoimmune problem, same as red cell aplasia. Both are classically seen in thymoma. Okay, because both are autoimmune diseases. Okay, so gist of all the asked paraneoplastic syndrome till now, right? There's a very high possibility you will get at least one of them in either of these two tables in this time. Fine. Okay. Got it. Last but not least, before the lunch, we'll complete this. After lunch, we'll go to hematology. Fine. Okay. We'll have a 5-10 minutes break. They'll come back. Not big lunch break. Fine. Okay. So we have, first of all, understand tumor markers are not going to help in diagnose. Tumor markers are adjuvant. They are not it's an adjunct in diagnosis. I cannot diagnose tumor only by tumor marker. I need other findings also. Or it's useful follow-up. Let's say you had a hydatiform mole, removed it. After 5 months, HCG became high again. Something is retained back. That's what the useful for use of tumor marker. Follow and it helps in the diagnosis. That's all right. Human chorionic gonadotrophin, anything in molar pregnancy, and also if it's a cancer, choriocarcinoma. Okay, come on. Before going for a break, I want you guys to comment. Let's have a Josh before the break, right? Calcitonin, which tumor? Which tumor will have calcitonin? Which tumor will have calcitonin? Come on, it's simple. Calcitonin, perfect, right? 𝐒𝐿, medullary carcinoma, thyroid. Right. Catecholamine and its metabolites, or metabolites means metanephrines. Where do you see catecholamines? Catecholamines are produced by adrenal medulla, right? Can anyone tell me one adrenal medullary tumor or one tumor from sympathetic ganglia? Perfect. What is that? You see them in pheochromocytoma. You can see them in neuroblastoma, right? Or an extraadrenal pheochromocytoma, I can see them, right? Perfect. Ectopic hormones is the heading, so only I struck it off. Alpha fetoprotein or AFP, where do you see them? Two places you can see them. One, alpha fetoprotein of 1000 or above. Always diagnostic of only one guy, liver cancer, HCC. Okay. And also I can see them in your yolk sac tumor. Non-seminomatous germ cell tumor. Also I can see alpha fetoprotein, right? Okay, Harsh, GFAP is different. I think you got confused between GFAP and alpha fetoprotein. GFAP, I can see them in gliomas, fine? Okay. Carcinoembryonic antigen is CEA. CEA is a mucin's product. That's all. Again, you see them in any mucin secreting tumor. That's why CEA is very, very non-specific. CEA can be seen in gastric carcinoma, ovarian carcinoma, pancreatic carcinoma, because anywhere I can have mucin production, I'll have CA. Any mucin secreting tumor, CA will be elevated, right? PSA as a straightforward thing, prostate. Okay, these are very important for you to remember. CA 125, CA 19.9, and CA 15.3. All these are very classical findings, right? 125, this was asked in the last exam. Please remember, 125 is a classical finding for epithelial ovarian tumor. Very, very specific. Not any ovarian tumor, it should be an epithelial ovarian tumor. Which I mean, dysgerminoma is a germ cell tumor, will not have. Granulosa cell tumor, sex-cord stromal tumor will not have. Mucinous adenocarcinoma, serous adenocarcinoma will have it. Very important, epithelial ovarian tumors, not any other tumors of ovary, right? Do you guys follow a guy called as Med School Bro in Instagram? Many things are crap there, but few things stays for a long time, right? This is from him, so thanks to him. 9 looks like pancreas, right? This from him, pancreatic cancer. Okay. 3, he said it looks like breast parenchyma, so I call it then breast cancer. Very stupid mnemonics, but it helps us to retain for a longer time, right? If you've seen that video of his, you will never forget it. Don't go for everything with mnemonics. Few things, yes, tricks are important because there's no logic behind why I named it 15.3 and why I named it 19.9. Doesn't matter, right? So I obviously have to remember them, right? So there are just 4 tables what I've covered in neoplasia. Genes, 2 tables for proto-oncogene and 1 for your tumor suppressor gene, and paraneoplastic syndrome and your tumor markers. Possibly at least one or couple of questions may come in this exam, fine? Okay, it's 1:07. Can we start by 1:12? Just 5 minutes? Possible? Let's go for a quick break and come back again. Yes. Okay, guys. Okay. Let's take a quick break. I'm not going to shut this link. I'm just going to turn off my audio and video. I'll come back soon. Fine. Hey guys, welcome back. Can you see me? Can you hear me? I hope you had a tiny break. Yes, Gautam. Yes, Rishabh. Let's recap for sure. So you guys are there. Comment hello, hi, and let's start a quick recap and then let's go to hemat. Okay. The most easiest thing for us hematology, we can easily read it, conceptualize it, and you can easily extrapolate it as well. Okay, first let's quickly recap whatever we saw with respect to neoplasia. Just 4 tables for neoplasia. First 2 tables are consisting of genes, proto-oncogenes and tumor suppressor genes, and the rest 2 is for paraneoplastic syndrome and tumor markers. Fine. So, as usual, close your eyes, just listen to me. Fine. All these genes are very, very important diagnostic or prognostic used in current day practice. Right. ERBB1 is the other name for EGFR, seen in lung adenocarcinoma. B2 is the other name for HER2/neu. You might make a mistake because everyone knows HER2/neu. If I change the name to ERBB2, seen in breast cancer, remember them. ALK, anaplastic lymphoma kinase, seen in anaplastic large cell lymphoma and lung adenocarcinoma. KRAS, the most common proto-oncogene mutated. Lung, pancreas, and colon is something which you don't forget. I can see them in many other tumors as well. BCR-ABL, Anio, 𝐒𝐿. Both are tyrosine kinase. I can use imatinib, BCR-ABL for CML, and 𝐒𝐿 for GIST, systemic mastocytosis, and seminomas. JAK2, seen primarily in polycythemia vera. I can also see them in myelofibrosis, essential thrombocythemia, and other myeloproliferative disorders also, right? RB gene is called as governor of cell proliferation, seen in retinoblastoma and osteosarcoma. P53 is important. Most common gene mutated overall and has the worst prognosis whenever it's mutated, called as an guardian angel of the genome, and seen in chromosome 7q13. Okay, fine. And Lee-Fromley syndrome is where it is associated, right? CDH1 is an E-cadherin. It codes for E-cadherin. Normally, it's functional cell addition. It's lost in case of lobular carcinoma of breast and diffuse gastric carcinoma. 1-hippolyndo. Remember, these two are the things where you see polycythemia, because 1-hippolyndo gene has something to do with RBC proliferation. So, clay cell renal cell carcinoma and cerebral hemangioblastomas you have in 1-hippolyndo syndrome. APC is seen in familial adenomatous polyposis, Gardner syndrome, and Burkott syndrome. All these two are variations. I need minimum 100 polyps to call as APC or FAP, familial adenomatous polyposis. Polyps plus osteomas and skin tumors, Gardner. Polyps plus CNS tumor, Turcot, right? And STK11 is Pujiger, oral hyperpigmentation, colonic polyp, everyone remember. Please don't forget, they also increase risk of pancreatic and breast cancer as well, right? Paraneoplastic syndromes are symptoms and signs which are not related to the primary tumor. Like lung cancer can present as inappropriate radiation secretion or Cushing syndrome, paraneoplastic by default, right? Hypercalcemia produced by PTH-RP related peptide in case of squamous cell carcinoma and breast and myeloma. Polycythemia vera, like I said, related to 1-hippolyndo. Acanthosis nigricans is a black coloration in the neck and the axilla, seen in GI cancers and uterine malignancy. Process from is due to any mucin secreting tumor because it activates factor 10 directly, causes thrombophlebitis, right? Aplastic red cell aplasia and myasthenia gravis are autoimmune disorders seen in case of thymoma. Tumor markers role is adjuvant to diagnosis and also helps in follow-up. Very classical tumor markers of HCG, your hydatidiform mole and choriocarcinomas, calcitonin parafollicular C cells, medullary carcinoma thyroid. You guys only said that pheochromocytoma, you'll have catecholamines, metanephrines, neuroblastomas, AFP, HCC, and yolk sac tumor. See, do remember this. Hepatoma is the older name for HCC. We have ruled it out now because hepatoma looks like a benign tumor, right? Name wise. But if a question comes on hepatoma, very, very old terminology, which means they are talking about hepatocellular carcinoma only, right? And CA is same mucin, colon, pancreas, they can have elevated thing. PSA for prostate. 3 CA markers, 124 for epithelial ovarian tumor, not for your sex cord stromal tumor or germ cell tumor, only epithelial ovarian tumor. And 9 looks like pancreas and 3 looks like a breast parenchyma, so it's a breast cancer, fine. Okay, that's a gist of whatever we read with respect to neoplasia. Okay, so let's go to hematology. See, hematology is very, very simple. RBC disorder, first we'll start with the normal RBC. What's the shape of normal RBC? What do you think is the shape of normal RBC? Biconcave, right? It's a biconcave shape structure. So biconcave disc means the center will be compressed, right? So the hemoglobin will be here. So if I look in a microscope from the top, how it looks is, it looks like this. The central part of a normal RBC will be pale. central 1/3 will be pale. That is how normally RBC looks like. That's all. Fine. That you should never forget. If you forget normal, you forget everything. You have to remember normal, right? And the lifespan of normal RBC is 120 days. This also we have to remember. If I know this, it's very simple for me to extrapolate and identify the abnormality. Okay. So now, if you see this image, can I say that you can see paler here, central paler, central paler, central paler. Yes, all the marked ones you have a central pale structure, which means it's a normal RBC. Compare that to this RBC which I'm drawing in circling in black color. Is that smaller than the normal? Yes, it is, right. They are smaller than the normal, no central pallor, and darker than the normal. These are three characteristic features of one cell: smaller, darker, no central pallor. Whenever you see this, what's the diagnosis? There's a classical spherocyte. Okay, I won't go with whatever we said, not spherocytosis, right? Let's change it. Spherocyte, that's all. Because spherocyte is seen in, like you said, in hereditary spherocytosis, absolutely right, and also in acquired conditions. Which is more common, acquired or hereditary? Acquired is more common, right? The most common cause of hereditary spherocyte is autoimmune hemolytic anemia, not spherocytosis. Acquired is most common. That's the most common cause. So that brought us to the next question. If you see a spherocytic anemia, what's the next step? Next step is very simple. I have to do a 𝐒𝐿𝐵's test. I have to do a 𝐒𝐿𝐵's test. That's all. To rule out autoimmune hemolytic anemia. I see a spherocyte in microscopy, do a 𝐒𝐿𝐵's test to rule out autoimmune hemolytic anemia. But our NEET PG exam question came. A 5-year-old with a family history and microscopy shows spherocyte. What is the diagnosis here? Autoimmune condition or an hereditary condition? Family history 5-year-old, obviously I think of an. Here I'll do an osmotic fragility test, or I might do an flow cytometry to diagnose hereditary spherocytosis. A family history makes it hereditary, right? That's why I go for hereditary spherocytosis, and flow cytometry is the investigation of choice for hereditary spherocytosis. Remember them, not your osmotic fragility. Undoubtedly, flow cytometry is the investigation of choice, right? 𝐒𝐿𝐵's is positive in case of an autoimmune hemolytic anemia. Fine. If it's positive, I call it autoimmune. If it's negative, I call it an hereditary spherocytosis. Okay, got it? Fine. So when I say it's hereditary, obviously you need to know the mutation. The most common mutation is 𝐒𝐿𝐴NK. 𝐒𝐿𝐴NK gene mutation is the most common mutation, and it's also an autosomal dominant inheritance. Like I said, structural protein mutation has to be autosomal dominant by default. Fine. Okay. So this is with respect to spherocytes, whatever has come till now. What's the treatment for spherocytosis? The treatment is we can remove the spleen, because spleen is where they get destroyed. So removal of spleen by default is a treatment what we can do for spherocytosis, and here also I can do that. So treatment for spherocytosis, if at all asked, treatment is splenectomy. Okay, but even after removing the spleen, spherocytes will not disappear. You will see spherocytes in the microscopy by default. Fine. Okay, now let's go to the next image. We're just going to discuss entire question based on images. What is this? Can anyone tell what's the diagnosis? What's a cell? Don't answer this. We'll go with normal ones. We'll go as per order. What is this cell? The double arrowed black one? That's a normal RBC, right? Perfect, perfect, perfect. What is this cell? The red one? Double arrowed one is a normal RBC. The red one is a spherocyte, smaller, darker, no central pallor. Right now, let's go to the. I'll use a different color, maybe brown color. This is a white cell like 𝐒𝐿𝐵 cell, right? We have normal RBC, a spherocyte and a bite cell, right? Perfect. Great. So if it's a bite cell, if you're comfortable in calling it a bite cell, can anyone tell me the diagnosis so that we can discuss something about the disease? Bite cells are classically seen in G6PD deficiency. Okay. The first thing with respect to G6PD deficiency is it is a X-linked recessive inheritance, right? It's absolutely an X-linked recessive inheritance. Okay, it's an X-linked recessive inheritance. G6PD affects your HMP pathway. Okay, it's an enzyme seen in HMP, hexose monophosphate pathway, the X-linked recessive inheritance. X-linked recessive means more commonly involving men, that's all. So G6PD, how do I diagnose clinically is, clinically the patients will have a trigger. It's a trigger-induced hemolysis. That's very classical. Patients have a trigger, then a urine becoming red in color. Classical for G6PD deficiency. The trigger could be an infection. I am sure you know one trigger. Do you remember fava beans? Which is not useful, we'll remember, right? Infection, then drugs. At least one drug, few drugs. Primaquine. Remember at least primaquine. The anti-malarial drug, right? Primaquine induced hemolysis and also fava bean. The patient has an infection or takes drugs or fava beans, consumption of fava beans. After that, there's a hemolysis, G6PD by default. There's no doubt in that. Two findings in G6PD in microscopy. One which is started with bite cell. Okay. The other one is this corner. Dapson also, yes, Gautam. And just since it's last, I'm just wanting you to at least remember one. Fine. What stain is this? Is this stain and this stain same? Definitely no, right? In this, the RBC looks blue in color. So this is a new methylene blue stain. Okay, it's a new methylene blue stain. New methylene blue is a supravital stain. Okay, that also came once in an exam. Supravital means it does not have a fixative, that's all. So these dots in new methylene blue stain is also diagnostic, called as an Heinz body. Heinz body is nothing but denatured or destroyed globin. In the hemoglobin, the denatured globin is Heinz body. That's classical for it. Fine. So in microscopy, you'll see bite cells, Heinz body, diagnostic of G6PD deficiency, and if at all I need investigation choice, it's an enzyme assay. It's an enzyme deficiency, right? So enzyme assay should be the best for me to investigate G6PD deficiency, right? That's all. Bite cell, I know it's a G6PD deficiency by default. Okay. Trigger, mostly in men because of X-linked recessive inheritance. Trigger should be there. After that, you have hematuria, intravascular hemolysis, two findings, bite cell and Heinz body. Obviously, you diagnose G6PD deficiency. Fine. Okay. Next image. Again, a very classical image. What is this? What's that? That's a sickle cell, right? You will not find it difficult to identify sickle cell. So sickle cell, see what happens is, of late, all of you know every cell. Sickle cell you'll identify, target cell you'll identify, teardrop cell you'll identify. The only problem for me is, as an examiner, I have to make it a bit more difficult. So I asked a different name of it. Sickle cell are also known as drepanocyte. Okay. Drepano is boat. It's looking like a boat. Fine. Next. I'll add this also. Bite cell is also known as degmacyte. Okay. Again, it's a different term here, that's all, but it means the same. Drepanocyte, degmacyte, right? Sickle cell anemia, right? So we'll take two things with sickle cell anemia. Sickle cell anemia is first of all, sickle cell anemia is an autosomal recessive inheritance. So obviously I'll have both carrier and trait. The patients, how they will present with sickle cell anemia, they generally don't present with anemia. They present with pain crisis. Because the most common presentation of sickle cell anemia is vaso-occlusive crisis, tactylitis. That's how they present. Anemia will be there. Unexplained abdomen pain, recurrent pain crisis, recurrent dactylitis, recurrent pains. Unexplained abdomen pain is due to autosplenectomy. Slowly spleen is dying. Every time there's a necrosis, you'll have pain, right? Salmonella osteomyelitis also. Recurrent pain crisis in a young person, think of sickle cell anemia. Plus, obviously, you'll have anemia as well. Okay, so if I know a sickle cell anemia, obviously I'm going to do a microscopy. You can see sickle cells in microscopy. So for me, if I have to confirm investigation of choice, I go for HPLC, which is better than hemoglobin electrophoresis. HPLC is any day better than hemoglobin electrophoresis. Okay, that's one. Next, if I say it's a treat might not have features. Carriers are incidentally diagnosed, right? It might look like a sickled RBC, but not exactly sickle. So what we do in treat is, we have a test called as a sickling test. I am forcing sickles. So what you do in sickling test is, you take blood and you take sodium thiosulfate. Okay, take blood and add a little bit of sodium thiosulfate, right? This will make it deoxygenated. It'll remove oxygen and it causes sickles. It predisposed sickle, that's a sickle test, fine. You will get it. It'll be there in the PW Telegram group, fine. Okay. I'll ask them to upload as soon as possible because I'll send them the copy as soon as possible, fine. It's a screening test. It's not a diagnostic set. I just add a little bit of sodium thiosulfate. It'll consume every oxygen there and automatically make it deoxygenated and looks like a sickle, fine. Okay. Perfect. Okay, great. So treatment for sickle cell anemia, just a word about it. So you have a drug which will increase the hemoglobin F, because if hemoglobin F is increased, you'll have more oxygen which will be retained here, right? So which anyone know what this is a drug for sickle cell anemia? The mechanism of action is to increase the hemoglobin F so that all this crisis and everything and the sickling can become reversible. The drug is hydroxyurea. Obviously, the best treatment is bone marrow transplant, but at least to alleviate the symptoms, we can use hydroxyurea. Fine. Okay. Next image. What is this? What is this? What is this? What is this? I'm going to say the easiest name. I'll call it target cell. I want you to tell the other name of target cell. Telling target cell is not difficult, right? You have an exam in 10-15 days. You should be able to identify target cell by default, right? Name here is podocytes. Target cell is the other name for podocytes. So where all I can see target cell, obviously I can see them in thalassemia. That's the first diagnosis I wanted to think of. I can see them in sickle cell anemia also. I can see them in IDA. Severe forms of IDA also will have target cells. The other name for target cells is podocytes, because in electron microscopy, target cells looks like a hat. Podo means hat, fine. It's a target cell, okay, or a bullseye. Okay, now again, so when I read about thalassemia is again an autosomal recessive disorder, which makes me a thalassemia major and a thalassemia minor, right? The most common by default is beta thal compared to alpha thal. Beta globin is in chromosome 11, alpha globin is in chromosome 16. So it's autosomal chromosome and it's an autosomal recessive inheritance, fine. Beta thal major. How do I identify its beta thal major? From history and from microscopy. From history, presents after 6 months of life. You'll have very severe anemia. Baby will not grow properly. There'll be failure to thrive. Will not grow properly at all because nonsense mutation is what the beta 0 is, which is major thalassemia major, your right scavenger, fine. And in microscopy, obviously target cells will be there, right? So target cell is common. When you see target cells, along with the finding as an NRBC, please remember this. NRBC is nucleated RBC. Wherever you see nucleated RBC, they are severe anemia. They are not less severe anemia, fine. Okay. So minor, they are generally incidentally diagnosed. I screen a patient for some other disease. I find target cells in microscopy. I think of it, right? So microscopy, they'll have only target cells. Okay. Thal minor is a very, very important differential diagnosis for iron deficiency anemia. Okay, that's where the two MCQs becomes very important here. RDW and Menster's index. They are very, very important here. RDW in case of thalassemia, since we are in the last aspect, I'm not going purely into concepts. It's a bit easier to remember it, right? RDW, thalassemia will be lesser, right? Less. Okay, it'll be narrow RDW, and in iron deficiency anemia, it'll be wider RDW, right? And with Menster's index, Menster's index is fine. CRISPR is approved, and there are for sickle it's approved, Gautam, fine. For Menster's index, it is RB's, it is mean corpuscular volume. The formula is MCV divided by RBC count. Okay. Again, the same thallus will help me here. RBC count is very high in thalassemia because of hemolysis. So Menster's index becomes less than 13. Remember, RDW is less, narrow in thalassemia. Menster's is less than 13 in case of thalassemia, right? Because that's an easy way to remember. It's either normal or narrow. I use the term narrow because less, you can easily compare both of them, fine? Okay, that's with respect to thal minor. Again, how do I diagnose thalassemia? Investigator choice is same. HPLC is better than hemoglobin electrophoresis. Okay. Which hemoglobin will be elevated in HPLC? Is it hemoglobin A, B, C, D, or is there any particular hemoglobin? It's hemoglobin A2. Whenever you see elevated HbA2 in a question, think of thalassemia. Fine. One more question came in INICET. If it's an alpha thalassemia, the investigation of choice should be globin gene study. HPLC might not help. Always go for globin gene study. Fine. Sure, Allah, we'll see you back soon. HbA2 is a classical finding. Okay. Perfect, right? That's with respect to thalassemia. See, all the important things with respect to thalassemia is here. There's a classical X-ray finding for thalassemia also. Anyone? X-ray finding for thal major especially, we call it an hair on end appearance. It looks like very spiky things on the skull X-ray. Hair on end appearance is a very classical finding for thalassemia. Fine. Okay, perfect. Okay, next image. So we'll go to classifying anemia based on the MCVs, because MCV is something which is a very basic classification use: microcytic, normocytic, and macrocytic, right? We call something as microcytic when it's less than 80 femtoliters. We call something as macrocytic when it's more than 100 femtoliters. In between, we use the term normocytic anemias. Fine. Okay. Perfect. So how do I call it in microscopy is if RBCs are small than nucleus of small lymphocyte, then I'll call it a microcytic anemia with microscopy. But MCV values less than 80 only, right? I am sure you know the mnemonic Sita. I don't like the mnemonic Sita because Sita makes you remember sideroblastic first. Sideroblastic is the last I want you to remember, right? There are only two things for an undergraduate: IDA, thalassemia. In the Sita, that's anemia of chronic disease, which is not actually a microcytic anemia, it's a normocytic anemia. That's also wrong, right? And sideroblastic. Sideroblastic is last. Sideroblastic, one of the easier way to identify treatable sideroblastic anemia is pyridoxine deficiency. Treatment is also pyridoxine, right? So let's ignore Sita, or at least remember I first and add whatever you want. But IDA should be the first thing I want you to remember. That's the most common anemia worldwide. In India, it's be like 90% of anemia will be IDA only. Rest every 10% is the rest of the entire Robbins. Right? Normocytic anemia, I'll want you to remember two anemias. Anemia of chronic disease, that's one. Next is anemia and CKD. Anemia and chronic kidney disease is also due to normocytic anemia only, right? Anemia CKD, the way to treat is aplastic might be a little bit scavenger, normo to macro, but I can put into normo also if required, right? Treatment here is erythropoietin, because in chronic kidney disease, there's no erythropoietin because erythropoietin is produced by the kidney. So I inject it, automatically it will work, fine. Macrocytic are two things. One is megaloblastic. The other one is macrocytic pure. Megaloblastic, you know, it's B12 folate. That's a different pathogenesis totally, right? When I take pure macrocytic, I have liver failure, I have alcohol, right? Hypothyroid. These are all pure macrocytic anemia where there will be no problem in the bone marrow. Bone marrow is completely fine. The RBC alone is a problem. But in megaloblastic, blast, bone marrow is a problem here, right? That's how we classify macrocytic and megaloblastic anemias, fine? Okay. I'm not going to go detailed about IDA because I'm sure you know about IDA. IDA was, I read about lots of things about iron metabolism, the 𝐒𝐿, the way to diagnose. What I'm going to concentrate is your serum iron studies, because iron studies is something which you try to memorize always, right? Let's use a very logical statement to understand and to remember iron studies forever, not just for exam. These are the only 4 parameters which is must to know in iron studies. Though there are more, this is something which is very important for me to know. We'll take these 4 parameters, we'll find a link between the parameters so that we need not memorize which is increased, which is reduced. If I know the link between the parameters, I can easily identify that, right? Put your pens down and just listen to me and answer whenever I ask. Because once you answer, you will understand a little bit more than just being a silent observer, fine? Okay. So here, serum iron. Let's assume you are sitting in a room. It has 5 chairs. Let's assume the room is transparent and the chairs are iron binding sites of transferrin. Okay, there are 5 chairs. 10 people or 10 iron come inside. Will there be enough space to sit? No, because there are only 5 chairs. So it will be over flooded. Only 2 people or 2 iron come. Will there be enough space? Yes. It will not be saturated at all. So in other words, whenever more iron comes or more iron is there in the body, the chairs or the binding sites are being saturated. Yes? Yes. Whenever less iron is there in the body, the chairs or the binding sites are not saturated. Yes? Very simple. Perfect. In other words, can I call that serum iron and transferrin saturation are directly proportional? Can I call this? Can I make this statement? Just answer yes or no. Yes or no? Both are directly proportional, which means one increases, other also will increase. One reduces, other also will reduce. Yes? I gave an analogy. More iron, binding sites will be saturated. Less iron, binding sites will not be saturated. That's the first one. The second one is TABC and ferritin. I'm going to convert TABC as affinity of binding iron. Though it's not exactly the same, I want us to easily understand, that's all. Okay? TABC I'm converting to affinity of binding iron, right? Have you had your lunch? Yes, no, maybe? Lunch done? Not it? Okay. Can I say ferritin is a storage form of iron? Yes, ferritin is a storage form of iron, right? Okay. So now, let's assume if you have not had your lunch, are you hungry? Extremely hungry, right? My tummy, which is storage form of food, is empty. My affinity to eat food is very, very high, right? If you have had your lunch, my tummy is full, my stores are full. What will be affinity to eat food? If you're a normal human being, it will be less, right? When you're hungry, you will even eat a hostile food. When you're not hungry, you're like, okay, if it's an amazing food, you'll say, I'm full, right? In other words, can I compare it to whenever my stores are full, my affinity to bind to iron will be less? Yes. Whenever ferritin is full or high, my affinity to bind to iron will be less. Whenever my stores are empty, my affinity to bind to something will be more. Yes? So can I say this is a store and that's affinity? These both are inversely proportional. Can we make that statement? Yes. We took time to understand the parameters. Then disease are very simple. Iron and transference saturation are directly proportional. Ferritin and TIBC are inversely proportional, right? Or inverse relation like what 𝐒𝐿 said, right? Perfect. Now tell me, what will happen to serum iron in case of an iron deficiency anemia? Everyone knows that it will be reduced. Now tell me, what will happen to ferritin or storage form of iron in iron deficiency anemia? Will be reduced. That's a most sensitive test, right? It's a most earliest done test. It's a most sensitive test as well, right? This everyone knows. So if iron is reduced, saturation will be reduced. If ferritin is reduced, TIBC will be elevated. Done. That's all is required. I already have an existing knowledge. We'll make logical assessment to fill in the blanks. These two, everyone knows, right? Iron should be reduced in IDA. Ferritin should be reduced in IDA. So ferritin reduced, TIBC elevated, iron reduced, saturation reduced. That's all. Let's apply to one more disease. Anemia of chronic disease. So here there's a question of where to start. Put a star mark here. You'll have to start from here. During COVID, did we do ferritin as a blood test? Yes, no, maybe. We did ferritin, right? Ferritin as a blood test we did, right? Yes? Sorry. We did ferritin? We did. Because ferritin is an acute phase reactant, right? So if ferritin is an acute phase reactant, will it be elevated in chronic inflammation also? Yes. So I'm saying ferritin will be more in any inflammation or in any chronic disease because ferritin is an acute phase reactant. Acute phase reactant will be elevated in chronic inflammation also. I'm going to start with that. If ferritin is elevated, what has happened to TIBC? Reduced. Right? Simple. Ferritin is more. Storage is more. I will store all the iron. What will happen to free iron? Less. I can relate it. If free iron is less, what will happen to saturation? Less. Right? So we will put an arrow mark here so that I can relate. I am storing every iron. So freely available iron is less. So that saturation will obviously be less, right? So that's how you read iron studies. Remember this and remember this. You will never have a doubt. Whatever disease you want, you can apply this. The funda is simple. Once you understand the funda, rest everything can be taken care of. Let's take hemochromatosis. More iron, TSAT more ferritin, TIBC more, TIBC less. That's all. If you know this and you know a little bit about the disease, it's enough, right? And this can be easily solved in an exam. You can easily quickly go through the exam and you'll never have a doubt in the exam, fine? That's how you solve iron studies, fine? Okay. Now let's go to few more images. We saw a beautiful concept. Let's go to images again. This you guys will jump to the diagnosis, right? What is this? What do you think this is? This is a classical, perfect, hypersegmented neutrophil, right? Classical hypersegmented neutrophil, more than 5 lobes in 5% of the neutrophils, or more than 6 lobes, even in one neutrophil, I can call it an hypersegmented neutrophil, right? Where do you see hypersegmented neutrophil? You see them in megaloblastic anemia. Both B12 and folate deficiency will show megaloblastic anemia. Few things with respect to megaloblastic anemia. Megaloblastic anemia will present pancytopenia. It's not just anemia. You'll have all 3 cell lines reduced in case of megaloblastic anemia, right? In addition to that, there's a requirement for me to differentiate whether it's due to B12 deficiency or due to folate deficiency. Okay, this is required. I need to say it's B12 or folate. How do I say? Vegan diet, B12. Okay, less fruits and greens, folate. As a clinical history, right? Diet wise, neurological deficit, present, folate, no neurological deficit in B12. Okay, these are easy ways for me to differentiate clinically. Obviously, the final one is by default your B12 and folate levels, right? Why do I need to differentiate them as treatment? So treatment is very classical in case of B12 deficiency alone. The treatment is B12 replacement only. If you have studied that you replace both B12 and folate, that's wrong. That's a very old concept. If it's a B12 deficiency, replace B12 only. Don't give folate. Right? That's a new concept. That's the latest concept. Don't give folate. I have to only give B12 for a B12 deficient person, not B12 as well as folate. Right? Remember that. Fine. Okay. Okay, there's a few things I want to remember with respect to megaloblastic anemia. Hypersegmented neutrophil, classical, pancytopenia, vegan diet, and also you have the red beefy tongue, the hyperpigmented knuckles. Those are clinical symptoms for megaloblastic anemia. So you have a red flat tongue or a red beef-like tongue. Okay, and you have a hyperpigmentation in the knuckles are classical for an B12 deficiency, fine, or a folate deficiency. Okay. Okay. Can anyone tell me what this is? The spikes are regular or irregular spikes? What do you think? Regular or irregular? The spikes are irregular, right? Perfect. When you have an irregular spikes, okay, irregular spikes on the surface of an RBC, we call it an acanthocyte. Acanthocyte's other name is spur cell. Again, always remember the other name. It might pull our legs, right? Two conditions of acanthocytes. First is liver failure. Obviously, you will remember the other one, A beta lipoproteinemia. We always remember the other one because that has come in an exam, right? But liver failure is definitely much more common than A beta lipoproteinemia. Fine. Harsh, dacrocyte if I have, I'll show it. Dacrocyte is like a teardrop, right? Dacrocyte looks like this, like a teardrop, right? Here, the cells are a bit irregular, and irregular production is an acanthocyte, right? Now, if you remember this, compare with this one. Can I say this image is more regular spikes? Yes, they are more regular spikes. Regular spikes, we call it an echinocyte or an Burr cell. Echino is like a porcupine, a sea porcupine, right? It's echinocytes. Okay, let's not go into that, Rishabh. We'll stick to this. That's more than enough, right? Echinocyte is a very common finding seen in CKD, uremia. It's very common seen in CKD as well as uremia, fine. Burr cell or an echinocyte where you have regular spikes, right? Great. Harsh, tell me what these are, and everyone else as well. What are these? Classical, looking like a teardrop. So teardrop cells, the other name is, like I said, dacro. Dacro is tear. You must have read, right? Dacrosis rhinitis. Dacrosis rhinectomia, all those things, right? Dacros teardrop, right? Why is a water coming? Why is a cell becoming like a teardrop? Because the bone marrow is like a mesh, not able to come out properly, so only squeezing and coming out, right? So classically seen in myelofibrosis. Myelofibrosis, you have a dacrocyte or a teardrop cell because the RBC should squeeze inside and come outside. So when they squeeze and come, they become like a teardrop, so called as teardrop cells. Fine. Okay. Okay. So a few things with respect to RBC disorder, we have to quickly look at it, right? So can we quickly recap RBC disorder? Again, if we have 4-5 SS, I'll go for a quick revision. Otherwise, no. I want SS. Comment on it. Yes, no, maybe. Yes, no, maybe. Only one yes. Two. Okay. Three. Before I start revision, I think I will have the fourth and fifth one. So we have only 3 pages for RBC disorders. All the information just been required for is compiled in the 3 pages, right? Again, as usual, close your eyes. I want you to just listen to it, not write, not watch the video, just listen so that you can imagine and create a network so that you will never forget it again. Fine. Okay, let's start. So we started with RBC being a biconcave shape structure so that you'll have a central pallor. Central pallor is normal in any normal RBC. 1/3 central pallor is normal, right? And it's a 120 days of lifespan. So when a cell has smaller than a normal RBC, darker than a normal RBC, and no central pallor, I call it a spherocyte. Spherocyte, the most common cause of autoimmune hemolytic anemia. That makes sense. Whenever I see spherocyte, the next step I do is Coombs test. It's positive, autoimmune hemolytic anemia, right? But a NEET PG question came, 5-year-old with a family history, microscopy showing spherocytes, I'll think of hereditary condition because of the family history. Then osmotic flow test, flow cytometry is the investigation of choice. Do a hereditary spherocytosis as a diagnosis, right? Most common mutation in hereditary spherocytosis is 𝐒𝐿, and treatment for that is splenectomy. Fine. So when you have a spherocyte and also a cell which look like a bitten off, that's a bite cell. GSPD deficiency, X-linked recessive inheritance, important has been asked before. The mutation is in an enzyme involving HMP pathway. The most important clue is a trigger, an infection or a drug like primaquine, dapsone or a fevabine. After that, having an intravascular hemolysis and hematuria, think of a GSPD. Bite cell and Heinz bodies in a new methylene blue stain. Heinz body are nothing but they are condensed or denaturated hemoglobin chains. Fine. And investigation of choices, enzyme as a treatment is supportive. Then we saw on sickle cell, drepanocyte, right? Autosomal recessive inheritance, pain crisis or the dactylitis or the recurrent abdomen pain is the most common symptom. Along with that, you'll have anemia. Microscopy in a full-blown case, homozygous UC sickle cell, investigation is HPLC and the hemoglobin erythropoiesis, treatment hydroxyurea. If it's a recessive condition, if it's a trait, and not a full-blown one, trait, sickling test required. So we have sodium thiosulfate, add on to the blood, make it deoxygenated, and ends up having a sickle cell, right? Then we saw podocytes or target cells. Think of thalassemia, again autosomal recessive, beta thalassemia being more common, beta globin chain is in chromosome 11 and alpha is in chromosome 16. Thal major, very early presentation, very severe problem. Classical hemolytic phase called as chipmunk phases. X-ray will have hair on end appearance. Very severe anemia will be there. Target cell and NRBC. Wherever you see this NRBC, it's a severe anemia. Remember, investigation is HPLC better than hemoglobin erythropoiesis. You'll have elevated HbA2. That's a very important level to think of Thal trait, right? Minor is an incidental diagnosis. Microscopy will have only target cell, no NRBCs. How do I differentiate minor from an iron deficiency anemia? It's a very close DD. Thallus, narrow RDW and less than 13 menstrual index means thalassemia. If it's a wider RDW, IDA. More than 13, IDA. Easy to remember like that, right? Always thallus. Okay. Alpha thalassemia investigation choice your globin gene study. Then it came to dividing anemia based on the MCV, microcytic, normocytic, and macrocytic. We know the finding how to differentiate. If small nucleus small and we call it microcytic. IDA, Thal, enough. Required add sideroblastic, pyridoxine deficiency, and treatment also pyridoxine, right? Chronic disease and CKD is a for normocytic. CKD treatment is erythropoietin, give erythropoietin. Megaloblastic, B12 and folate, liver alcohol and hypothyroidism are macrocytic, not megaloblastic. And then we came to iron studies. Easy way to correlate. Serum iron and transfer are directly proportional. Ferritin and TABs are inversely proportional. So that you can draw permutation combination of any disease whatever you come across. Few more images. Hypersegmented neutrophil for megaloblastic. Megaloblastic have pancytopenia, red beefy tongue, and hyperpigmented knuckles as well. B12 is veganism, not vegetarian, veganism. Folate, no fruits and greens. Neurological deficit B12, no neurological deficit folate, right? Treatment for B12 deficiency only give B12, don't give please B12 as well as folate, right? Irregular spice, acanthocytes or spur cell, liver disease, A beta lipoproteinemia, regular spice, echinocytes or burst cells, CKD and uremia, teardrop shape, dacrocytes in myelofibrosis, right? So that's what we have seen till now. Okay, great. Now let's quickly go into WBC disorders. See, my goal for WBC disorders is to give keywords to diagnose, one of few important points to identify in images, and few very characteristic IHC and genetics. One, that's all. I'm not going to tell that, okay, Burkitt's lymphoma is positive for 10 markers. You know that. I want to say one marker. This marker seen, it's Burkitt. This marker seen, it's Mantle. This finding seen, it's CLL. That's all, fine? Okay. Now, first let's go to leukemia, then we'll go to lymphoma, okay? First and the foremost thing, how will I identify something as a blast? Because you need to know there's a blast or a lymphocyte. If you don't know that, there's a problem, right? Blast, simple clue is 2 to 3 times of RBC. I'll call it a blast. RBC, blast. Easily 3 times of an RBC, right? Very high NC ratio. These are common for every blast. For me to say it's a lymphoblast, it's coming from lymphoid thing. There will be no granules, no OR rods. No granules, no OR rods, I call it a lymphoblast. This is a lymphoblast. And this appearance. Many of the HODs like this appearance. I don't know why. This calls an hand mirror appearance. You must have seen lenses, right? Holding the mirror, right? So it's a hand mirror appearance. This also is to be seen in ALL, acute lymphoid leukemia, right? So we know how to identify from a microscope. Bigger cells, no granules, no OR rod. Think of an ALL, right? So how to identify? This page is for acute lymphoid leukemia. How to identify it clinically? The clue is age, children. Only leukemia seen in child, ALL. Only lymphoma seen in child, Burkitt's. Whenever I say Burkitt, child African jaw swelling. Hits, right? Child. That's enough. That's the most important clue for me, right? Child with lymphadenopathy. I'll think of an B subtype of ALL. That's the most common variant. 85% is B type. Child with mediastinal enlargement. Mediastinum is widened, which indirectly implicates there is thymus involvement. Thymus will be in B or T type. I want you guys to comment. Thymus is B or T? T cell, right? T means thymus dependent, right? TALL, which is rare. Only 15% are TLL, but they have worse prognosis, right? They have worse prognosis. Okay. Children with lymphadenopathy, blast, I think of BALL. Child with a mediastinal widening, TALL, and also they'll have the same blast, right? Now, I have to confirm how it is an ALL. Why not is an AML? I might have a problem, right? Not always OR rods and granules will be easy, right? So then comes my markers. ALL blasts are PAS positive, something called as a dot or a block-like positivity. A dot-like positivity for PAS is classical for ALL blast, right? They are positive for CD34. CD34 is positive for any blast, right? This is CD34 is a stem cell marker. Both ALL and AML blast is positive for that, right? But to say it's a lymphoid blast, I need a marker called as TDT. If TDT is positive, has to be ALL. Doesn't require my history, doesn't require my microscopy. TDT positive is ALL, that's all, right? Now, can you guys at least help me with this? What is the marker for T cell? What is the marker for B cell? Very basic markers. What is the CD marker for T cell? This marker positive, I'll call it a T cell. B cell is CD 1920. T cell? CD 3. Okay. These are never to forget. So I'll tell you how a question will come. 3-year-old child with bleeding from the gums, recurrent infections. Microscopy shows, CBC shows maybe the increased WBC count. Microscopy, there'll be an image there. And these cells are positive for TDT, CD3. What's the diagnosis? It's a compilation, right? These are all informations. Very important informations. You can compile and come to a diagnosis. The history, what I told, is classical for TALL because CD3 was positive in my case. That's what tells me what ALL it is, right? 34 will tell it's a blast. TDT will tell it's a lymphoblast. 3 will tell it's a T lymphoblast. 19 will tell it's a B lymphoblast, right? It's a stepwise approach, stepwise diagnosis, right? So please be strong in everything. I can pick it up with this. If I miss, I can pick it up by this. If I miss, I can nail it with this. There are 3 categories for ALL diagnosis, same way. 3 categories for AML, same way. 3 categories for any lymphoma. Clinical, microscopy, marker. If I am in your place, I will read this a lot because this is specific. Others can change a lot. Fine. Let's go to AML. Okay, this is for acute myeloid leukemia. Can anyone tell me what this is? What is the structure? You guys have to open up. Come on, come on, come on. We're not moving here if you don't say what this is. It's a very simple one, no? It's a classical one, is a spot. What's it? It's a or rod, right? Perfect. Blast. I'll have the same thing. 2 to 3 times of an RBC. Yes, the cell is very, very, very big. Right? High NC ratio, yes. I'll call it an AML blast when you see granules or rod. Or rods are also granules only, but in the form of a rod, that's all. Right? Perfect. That's a classical or rod, right? Or rod. Okay. Whenever you see an or rod, I'll think of an acute myeloid leukemia. So I know it's a myeloid blast. So I know how it looks in microscopy. There are few variations of this myeloid blast because AML has multiple subtypes. I like AML M0 to AML M7. So many AML is there, right? So now I'll just erase this here. I'll give you a few variations of this blast. AML M3 will have buttock-shaped nuclei. It'll be a cleaved or a bent nuclei. Has multiple OR rods. We call it a faggot cell. Faggot cell has extremely high OR rods. Okay, we have many OR rods. I call it a faggot cell, buttock-shaped nuclei, classically seen in M3, APML or an AML M3. M4 will have, M4 is monocyte, right? M4, M5 will have kidney-shaped nuclei. Because normal monocyte is also kidney-shaped. M4, M5 has that. Okay. M6, erythroleukemia as a blue cytoplasm. Extremely blue cytoplasm because normal RBC is also blue cytoplasm. Fine. M7 will have tiny blebs on the surface. Cytoplasmic blebs. So AML is not one like ALL. I have multiple things. So OR rod present AML. Multiple ORs M3. Kidney shaped with tiny OR rods in the background M4, M5. Completely blue cytoplasm M6. Blebs M7. Fine. That's my microscopy. Let's see if we can nail down that clinically. So unfortunately, AML does not have a very classical clinical history. Most of the AML will present with fever, anemia, bleeding from the gums like that. But there are few places where I can nail down the classical clinical history, right? Clinically, AML M3 or APML will present with DIC. Only leukemia presenting with disseminated intravascular coagulation is APML. Okay. M4, M5. When you see a question saying gum hyperplasia, see it's hyperplasia, not bleeding. Bleeding is common for every leukemia. Gum has become thicker, hyperplasia, or a proptosis, or a leukemia cutis. I have blebs in the skin. All these are called as chloroma. Okay, chloroma I think of AML M4, M5, M2 also, incidentally M2 also, right? But I'll only think of M4, M5, right? When you see AML in a child and Down syndrome, I think of AML M7. Okay, these are few clues for this particular AML clinically, right? So I know clinically, I know microscopy. Let's nail down the marker as well. Okay, marker is one person. Myeloid marker is only one guy, MPO. MPO is the classical myeloid marker. CD34 I have already told. CD34 will be positive for any leukemia, which is a stem cell marker. Right? So MPO, if it's positive, it's acute myeloid leukemia. That's a specific stain for any acute myeloid leukemia. But I do have variations, right? M6 is erythroleukemia. I want you guys to comment at least now, right? Tell me what protein comes to your mind when you think of an RBC or erythroid. One protein which you have been reading which is present in RBC from 6th, 7th standard. What is that? What's the protein? Hemoglobin, that's all. Marker is hemoglobin A. Right? M7 is megakaryocytic. So yeah, CD. That's all, right? Hemoglobin, that's it. So M7 is the GP1B9 2B3A. You remember? Glycoprotein 1B9 2B3 which is seen in platelets. The same thing will be seen in megakaryocytes because it's a platelet precursor, right? So CD41, CD61 is my GP2, glycoprotein 2B3A. Okay. M4, M5, we have NSC as a marker and 1464 as a marker. Fine. Okay. So these are markers for specific lineage, but this is the most important thing for me. If we have this, by default, I'll call it an AML, right? And 3 genetics is important. Genetics for acute myeloid leukemia, don't forget these 3. Translocation 821, translocation 1517. Actually, 1517 is what's seen in APML or AML M3, and inversion 16. Inversion 16 is seen in M4 with eosinophils. Just 3 things which I want you not to forget anytime, right? Okay, perfect. So 1 page for, not in 1 page, half a page we have compiled everything with respect to AML. How do I identify AML? Blast is bigger, OR rods is present. Many OR rods cleave nuclei like a buttock, M3. OR rods with a kidney-shaped nuclei are M4, M5. Bluish cytoplasm, M6. Cytoplasmic black, I go for M7. Clinically, most of the AMLs are non-specific, but yeah, DIC M3, gum hyperplasia chloroma M4, M5, sometimes M2 also. Down syndrome was child M7. Every leukemia will be positive of 34, but if MPO is positive, I call it an AML M3, any AML. M4 is NSC and 1416. M6 is erythroid, hemoglobin A, normal hemoglobin. M7 is your glycoproteins, 2B3A, 4161, right? And 3 genetics for me to remember in case of an AML, fine? Okay. Now, let's go to the next leukemia. Just simple. What is this finding? What do you see here? Many cells, few cells. We know acute lymphoid, we saw acute myeloid. Now I'm just going to chronic, that's all. This? Many cells, right? All the cells are looking the same or are they looking different? If you tell that, I can relate it to whatever useless finding we have always been reading. All the cells look different. They don't look same, right? Like people in a party, they don't look same. Like people in a college, they don't look same. Garden party appearance, college girl appearance, right? So here, what I have is leukocytosis, right? There is increase in number of WBC showing various stage of maturation. They don't look same, right, Harsh? When I say various stage of maturation, I'll have blast, or in other words, I use a different term. I'll come to that soon. I'll have blast, I'll have myelocyte, I'll have band form, I'll have neutrophil. Okay, I have all of them, right? So they have all of them. I call it a with various stages of maturation. Fine. Okay. So now we call this a CML. This is a term which you guys said, a college girl appearance or an garden party appearance. We call it a CML, chronic myeloid leukemia, right? Perfect. So how do I know it's chronic myeloid leukemia? Same 3 characters: microscopy, clinical, if required, marker, right? But we'll see whether marker is required or not. Okay, just give me a second. Okay, CML, elderly, splenomegaly, massive splenomegaly. When you go to CBC, leukocytosis with left shift. Okay, leukocytosis is shift to left. That's a very classical finding. That's what varying stage of maturation mean. Classical for CML. This is enough. So CML, you don't have marker. You don't need bone marrow for CML. So once I have this, the next step for CML is genetics. Flow cytometry does not help in CML. Bone marrow does not help in CML. Markers does not help in CML. Suspect CML. Whenever you suspect CML, the next step I want you to do is go with genetics. It's very simple and go with genetics. Fine. Okay. So CML, the best is FISH, PCR, than karyotyping. This has been asked multiple times. Always prefer FISH or the real-time PCR. If it's not there, go for karyotyping because FISH and PCR are very, very specific. Karyotyping is not specific. Ultimately, I'm going to look at the translocation 922, the Philadelphia chromosome. That's a classical for CML. Fine. Okay. Please remember, CML does not require flow cytometry. Fine. Since we are in CML, we'll have a count of all the leukemias: ALL, AML, CLL. Investigation of choice is flow cytometry and markers. Based on whatever marker is positive, I can diagnose ALL, CLL or CML, right? And CML is the only place investigation of choice is genetics. Okay, the only place I'm going to go for genetic diagnosis. Fine. Okay. Next, also remember, I'll call something as an acute leukemia if blast are more than or equal to 20% in bone marrow or in peripheral smear. BM is for bone marrow, P is for peripheral smear. Otherwise, I use the chronic leukemia. If immature cells are more than or equal to 20%, I call it an acute leukemia. Fine. Okay. So this half of the page is for CML. Microscopy, we know I have lots of cells. All of them are different maturation. That's what is a shift to left means. Clinically, I know that's an elderly person, massive splenomegaly, left hypochondrial dragging sensation pain. That's one. Then I have CBC. You have then investigation choices, FISH or karyotyping, right? Genetics only. Treatment is imatinib. We already know that. Fine. Okay. Let's go to lymphomas. Okay. So we know for leukemia, ALL, AML, CLL, CML. Now let's go for lymphomas. Fine. So lymphomas. The thing about lymphoma is we have a different group of HL and non-Hodgkin's lymphoma. Both of them symptomatology more or less is generalized lymphadenopathy. That will not change. Be it Hodgkin's, non-Hodgkin's, generalized lymphadenopathy is a classical symptom. But there are few clues like jaw swelling. What do you think of? Burkitt's. But Burkitt's also can present with lymphadenopathy. So clinically, I do not have much help except for few places I'll have help. So what are things I want to treat in lymphoma? We'll enumerate every lymphoma here. 1 points for everything. If I have a classical translocation, I want you to remember. Classical microscopic finding like an RS cell or a smut cell or a starry sky, I want you to remember. One marker, one CD marker I want you to remember. And if required, if there's any probability in the treatment, let's remember that as well. Fine. That's what we're going to do because symptom for every lymphoma is generalized lymphadenopathy. Fine. Okay. But look at this. If there's an alcohol-induced pain, it's a very unique symptom. Think of a Hodgkin's lymphoma. Hodgkin's lymphoma is a very unique symptom of an alcohol-induced pain. When the person consumes alcohol, the lymph nodes will start paining. That's a very unique symptom for a Hodgkin's lymphoma. Fine. Let's look at images and let's tick all the required points, whatever we saw. Fine. What is this? It's actually written there. That's a smut cell. Okay. CLL, Chronic lymphoid leukemia, smut cell is diagnostic. Right? That's classically diagnostic. Okay. CLL, the cell of origin. This came in exam. It comes from naive B cell. Okay. CLL can have the classical symptom. Apart from that, one unique symptom is CLL can have autoimmune hemolytic anemia and ITP along with lymphadenopathies and everything. Okay, this is a very unique symptom. If you have a lymphoma with autoimmune hemolytic anemia and ITP, I want to think of CLL, chronic lymphoid leukemia. It's a very, very classical symptom here. Fine. Okay. CLL marker wise, it does not have a very classical marker, but it's a combination. Okay, it's a CD5 positive, 23 positive tumor. Okay, CD5 positive, CD23 positive tumor, and also a new flow cytometry marker is CD200. It's a new marker. If possible, remember them. Right. And one complication of CLL can become DLBCL, and that syndrome is called as Richter's transformation or Richter's syndrome. Okay. These are the points which is required with respect to CML. Again, one finding, any unique history, marker, complication or treatment. Fine. Okay. What is this finding? If you don't say this image, no, it's tough. What is this image? Is it classical? What is this? Come on. You know this finding. And obviously I missed that in CLL is as a college girl appearance. We people want to understand all this weird names, right? Lymphocytes look similar. Sorry, not a college girl. It's a convent girl. Lymphocytes look similar like a convent girl. So we got a convent girl appearance. Fine. Okay, that's a starry sky, right? Book 8. Please use start writing this like this, Buck 8, because I want you to remember the 8th chromosome. 8th chromosome is very, very classical here. It's Buck 8 lymphoma. Fine. Okay. Translocation 814, translocation 28, translocation 822. These are 3 things seen in Burkitt's lymphoma, Burkitt's lymphoma. Like I said, clues, children, jaw, right? Very classical, children with jaw swelling for Burkitt's lymphoma. 8th chromosome. The chromosome 8 has a gene called as CMYC, right? That's why it's getting translocated. So which means marker is also CMYC. That's very, very important for me there, right? So I know the history. Microscopy, like you can see, you have a classical starry sky appearance. So here there are white spots here, right? Those are the stars in the sky. These stars are nothing but macrophages. The sky, the blue part, is the tumor cells. The tumor cells are extremely proliferative. So all the dead tumor cells, this macrophage will consume, becomes like a star. That's a starry sky appearance, right? Marker, CD markers. There are many CD markers, but like I said, I want you to remember 1 or 2 maximum. Remember the same thing, 𝐒𝐿. 𝐒𝐿 positive, it is Burkitt's. And one more thing called as Ki67. Ki67 is 100% in case of Burkitt's. Okay, it's very, very, very high. It's one of the most highly proliferative tumor. Ki67 is a proliferative index. Okay, it's a proliferative index. It has a very high proliferation, which is diagnostic of an Burkitt's lymphoma. Fine. Okay. Okay, this is about Burkitt's lymphoma. Again, it's just what is required for us. Okay. Now, let's go to the next guy. I'm sure you'll identify this. What is this? Because you must have seen this image multiple times. Anyone? What is this image? That's your classical. Okay, let's try to draw that a little bit. Does it look like a popcorn now at least? Yeah, right. Harsh said it's a popcorn shaped RS cells, right? So let's go and have a quick look at Hodgkin's lymphoma. So we have two types of Hodgkin's lymphoma: classical Hodgkin's lymphoma and NLPHL, nodular lymphocyte predominant Hodgkin's lymphoma. That's a two different variants of Hodgkin's lymphoma, right? Where do you see popcorn cell? Classical or nodular lymphocyte predominant? Classical RSL will have your classical Hodgkin's lymphoma will have your classical RSL, which is your owl's eye, like we saw in the morning. And the marker for classical RS cells are CD15 positive, CD30 positive, and PAX5 being weak. Okay, it should be weak. If it's strong, it is not classical RS cell. NLPHL is where we'll have the popcorn shaped RS cell or the popcorn cell, and this will be CD20 positive, CD45 positive, and PAX5 will be strong. Okay, and obviously this will be CD15 and 30 negative. Right? This marker differentiation is very, very important. 15 positive, 30 positive here. That is 20 positive and 45 positive there, right? Classical and NLPHL. Fine. Okay. Now, there are different types of classical Hodgkin's, like nodular sclerosis. Nodular sclerosis is the most common variant of Hodgkin's lymphoma. This is EBV negative. Epstein-Barr virus, it will not be there, it will be negative. Nodular sclerosis, the type of RSL, along with the classical RSL, I have a cell called as lacunar variant of an RSL. Okay, then I have mixed cellularity. Mixed cellularity is supposed to be EBV positive, common in developing countries, at least with respect to this, India is developed, right? Okay, it's common in developing nations where infections are a little bit more common. Then I have lymphocyte rich. The only thing is the background lymphocytes will be very high in this. Apart from that, not much of a difference here. Or more, the last one is lymphocyte depleted. Lymphocyte depleted is unique. Very less lymphocytes. Which virus kills lymphocytes? HIV, right? So this is HIV positive, obviously EBV positive as well. Very rare variant of Hodgkin's, but the worst prognosis. Because if HIV is there, it's very, very difficult for the patient to mount an immune response or destroy the condition. It will definitely keep on progressing and it will die, right? Patient will die. And these are all four classical variants of Hodgkin's. Whatever RSL you see in this will be 15 positive, 30 positive, PAX5 weak, right? Okay. So if you look at the prognosis as such, this came once in an exam. The best of the lot is NLPHL. Then is nodular sclerosis. Then is mixed cellularity. Then is lymphocyte rich. The last is lymphocyte depleted. Okay, these are classical things required for Hodgkin's lymphoma, right? Again, half a page. What was required for us for the last day to go through? We have already seen classical RSL in the first half of inflammation chapter, so I'm not repeating it here. That's all, right? So what we know with respect to lymphomas and leukemias is whatever is required. We saw about ALL, we saw about AML, we saw about CML, we saw about CLL, and few lymphoma, non-Hodgkin's lymphoma and Hodgkin's lymphomas, fine? Okay, can we quickly go through it before going on to little bit of systemic pathology? Yes. Can I quickly go through WBC disorders? If you guys say yes, I'm ready to go through it. Okay. See, I'm compiling lots of information into tiny space so that 20 pages should not be a mental barrier for you. If it's 100 pages to revise pathology, tough. Just 20 pages, no? Let's quickly go through it. Maybe you'll be able to click few things and maybe it'll help in your exam, fine? As usual, close your eyes, just listen to me. ALL flow. Let's call it our flashcard, right? ALL flashcard. Blast 2 to 3 times of an RBC, no granules, no or rods, hand-married appearance. Children with lymphadenopathy BALL, children with mediastinum TALL. If it's 3 positive TALL, 1920 BALL, TDT positive will be therefore any ALL. And ALL is also PS positive dot-like. Came to AML, microscopy wise you should have an or rod, extreme or rod and cleaved nuclei, we call it an AML M3. M4, M5 will have a kidney shape. M6 will have a blue cytoplasm. M7 will have cytoplasmic blips. Clinically, M3 will be your DIC. M4, M5 gum hyperplasia, not gum bleeding, gum hyperplasia, gum hypertrophy, right? And your M7 will have children with Down syndrome, right? Marker, MP was positive for every AML, NSC 14, 16, 64 for your M4, hemoglobin A for M6, and your 41, 61 for your M7. Three genetics, don't forget, 821, 15, 17, and your inversion 16, right? Came with CML, leukocytosis, lots of maturing stages, looking like a college girl or a garden party, left shift CML. Elderly with massive splenomegaly is a clinical finding, 922 chromosome positive in fish, PCR important than karyotyping, right? Leukemia always flow cytometry except for one leukemia, which is CML, with investigator choice is genetics. And every acute leukemia should have more than 20% blast in the peripheral smear or in the bone marrow, right? Then came to lymphoma. Lymphoma, CLL, smut cell lymphocytosis, origin is naive B cell. Symptomatology is autoimmune hemolytic anemia, and ITP will also be there in this, in addition to the routine symptoms. And your IHC is 5 positive, 23 positive, 200 positive. CLL can become DLB cell, which is Richter's transformation, right? Then BUC8, 814, 28, 822. 8 is CMYC, that's a marker as well for me. Children with jaw, African, microscopy starry sky. Blue color is the tumor cells, and the white color is the macrophage, or the star is the macrophage, right? Marker is CMYC, and extremely high proliferation index of KS of close to 100. Then it came to classical RSL, outside, pink eosinophilic nucleoli, 15 positive, 30 positive, PAX5 weak. NLPHL popcorn cell, 20 positive, 45 positive, PAX5 strong. I have different variants of Hodgkin's, nodular sclerosis being the most common amongst them. Lacunar variant of RS will be seen there, and it's EBV negative. Rest almost everything is EBV positive. Your NLPHL is also EBV negative. Remember them, right? Okay. The best prognosis or something of EBV negative only. NLPHL is the best. Then nodular sclerosis. Worst becomes your lymphocyte depleted because of the HIV positivity, right? Okay. Great check. So that completes our lymphomas and leukemias and hematology. Okay. Great. Perfect. So now let's quickly go through whatever is required from systemic point of view. Right? I'm not going to go in detail because systemic pathology is a combination of multiple things. You need to have knowledge of medicine, surgery, OBG, pediatrics, and obviously you'll be able to sail through systemic pathology properly, right? So what you're going to see is few classical vegetations. This definitely was I've seen has come in exams previously, right? Vegetations are nothing but irregularities on the surface of the valves. That's all. They are irregularities on the valve surface. Okay. So just for us to remember, recap our anatomy, you have your chorda tendineae, you have your valve. If you look at the edge of the valve, it's irregular. It's not proper, right? It's irregular. That's what we call it as in vegetation. We have 4 different types of vegetation: rheumatic heart disease, NBTE, infective endocarditis, Lippmann-Sachs. As the name says, right? NBT stands for non-bacterial thrombotic endocarditis, right? IE for infective endocarditis, right? So what all the parameters I have to look for is where I see the vegetation. Is there any specific name? Are they infective? Are they destructive? When I say destructive, are they destroying the valve, right? RHD is seen along the edges of the valve. They are very, very tiny, less than 0.5 centimeter. They're also called as verrucae because they are looking like tiny warts. They are sterile, non-infective. Okay, they are non-destructive. And we see them in rheumatic heart disease. That's all. Okay, these are just the 4 informations. Same 4 information we'll see for every vegetation. NBT, they are also seen in the edges of the valve. They are also smaller. They are seen in, previously we thought it's seen in marasmus. Now it's seen in any condition. See, it's thrombus, right? Basically, microscopically what they are made of is thrombus. So it's primarily seen in any prothrombotic state. Any disease which will cause thrombus, I can see them. As simple as Appler syndrome, DIC. We saw Trossier's phenomenon, right? Migrating thrombophlebitis, I can see them. APML, I can see them. Any prothrombotic state, I can see them, right? Since it's thrombus, obviously it's sterile. This also is non-destructive. They won't destroy. The only thing which is an outlier in this entire group is infective endocarditis. They are infective. They are extremely large. They are very, very, very fragile. Because of this, they can form an embolus, and they are also destructive. And obviously, you know about infective endocarditis in your medicine and micro. You can definitely know the symptoms of that, right? Liebman-Sachs. Can anyone tell me where do you see Liebman-Sachs? Which condition? Liebman-Sachs is seen in SLE. It's seen on the valve surface, not in the edge of the valve, both the atrial and ventricular surface of the valve. So Liebman-Sachs primarily is an antigen-antibody complex. Okay, it's an antigen-antibody complex because of SLE. SLE is circulating immune complex which is getting deposited, which makes it sterile. This also is non-destructive. Okay, these are 4 vegetations, very high probability of them being asked in the exam. Fine, clear? Okay, I'm not going to take much with regards with systemic pathology. Like I said at the start, we'll cover whatever has been asked before. Can anyone tell me what is this? 3 images here. All 3 are classical images. 2 of them has been asked before in exams. These are lung, right? So let's go with the easiest one, what you already know here. This is bullous emphysema. Okay, so bullous emphysema, where you can see the bulla in the corners of the lung, right? Bullous emphysema are just generally in microscopy, they are distal acinar type. Why bullous emphysema is very important? The only reason bullous emphysema is important is because of they can rupture and can cause tension pneumothorax. Okay, a rupture of them will cause tension pneumothorax, and I can easily relate with an emergency medicine or medicine question where you have to treat with an intercostal tube drainage. It can spontaneously rupture, and also I can have a rupture after a trauma, right? Harsh is exactly right. Second is panacinar. Okay, so how do I know it's panacinar? See, if you see, this part of the lung is normal. It's not dilated. This part of the lung is dilated, right? Okay. So let's say this is how we draw acini in your anatomy. Acini is like this, right? So if certain part of the acini is dilated and a certain part of the acini is normal, we call it centriacinar emphysema. Okay, it's centriacinar. If you look at this part is dilated. It's bigger, right? Centriacinar is the most common subtype, seen in smokers, seen in upper lobes. Okay, it's a type of COPD, that's all. How do I see in panacinar emphysema is everything is dilated. That's why if you zoom in, there's no normal part at all. Look here, I have normal lung and dilated lung. Here only dilated or distended alveoli, right? That's panacinar. We already saw panacinar. It is seen in which condition? Great, alpha-1 antitrypsin deficiency. More commonly seen in lower lobes of the lung. You will have a family history of emphysema. And also here you'll have both lung and liver involvement. So these are clues for me to call it panacinar, and the gross image is there. That also will help us, right? Perfect. See, systemic path is always a combination of many things. It's not only one system. It's always a combination of multiple things. Liver history, microscopy, maybe a CT MRI finding, and also the clinical symptom. Fine. Okay. These again are very classical things. We'll go with bottom up, right? Because the bottom ones are much easier. This you must have seen multiple times. What's the finding? What's the finding here? That's your asbestos body, right? Classical, right? So this is for occupational lung disease flashcards. All the things required for occupational lung disease. The most common occupational lung disease is silicosis. The clue for every occupational lung disease is occupation, right? involving glass manufacturing industry, glass blowers. Right? That's where silicose, or the hardware manufacturing. So the chips what they manufacture that has silica in it, right? So silicoses will have there's a big silica nodule. There's a fibrotic nodule which is classical of silica. It's commonly seen in upper lobes of the lung. Okay, silicosis, the particle which is extremely fibrogenic is something called as quartz. Quartz an extremely fibrogenic silica. Not can't do anything. It's an end stage. It's fibrous. That's all. Beyond that, we cannot bring the life back. The entire lung is damaged, right? Okay, and asbestosis you can have in the cement manufacturing. You can have in the insulation. You can have in the ship manufacturing. All these will have asbestos particle. Okay, asbestosis microscope. You have the, just zoom this brown color structure. Kind of, it's not exactly dumbbell, but you can call it dumbbell shape or like a filament. That's all. This part looks like a dumbbell. Not everything looks like a dumbbell, right? Brownish. If you want to make it dumbbell, yes, they look like a dumbbell shape structure, which are Pearl's positive. Okay. Ferruginous bodies or your asbestos bodies. The most important thing in asbestosis, which has been repeated multiple times for you, is the cancers. Asbestos can cause cancers, lung carcinoma. The most common is by default lung adenocarcinoma. And the most specific is, what's the most specific asbestos related tumor? You're going to fill it up. I'm not going to tell you, right? Same way, silica also can increase the risk of lung cancer or the lung adenocarcinoma, right? And also remember, silica in X-ray has a very classical finding called an eggshell calcification. Okay, but one most important thing, since you have to complete the entire occupational lung disease or pneumoconiosis here, coal workers pneumoconiosis, this does not increase the risk of cancer. Coal does not increase the risk of lung cancer, right? Yes, you'll have fibrosis in lower lobe. The most common cancer, like Cool Medico said, and most specific cancer is mesothelioma. Fine. Except for coal, others will increase the risk of lung cancer, but coal does not increase the risk of lung cancer. Half a page required important points for the final revision of pneumoconiosis. Okay. Okay. Few pointers with respect to GI tumors. Because GI tumors, unfortunately, is important for us, right? It's a classical image of leather bottle, right? Or we call it an Rhinitis plastica. When we read in neoplasia, we read about a tumor called diffuse gastric carcinoma. Can anyone tell me what's a gene mutated? Diffuse gastric carcinoma had CDH1 mutation, right? So CDH1 mutation or a CDH1 loss, right? CDH1 loss results in tumor cells will be separated. They won't be adhered together. They'll be separated. That's why the tumor cell goes throughout the stomach and involves the entire stomach wall. It's not involving in one place. It's entire, right? 𝐒𝐶ADN loss, right? CDH mutation or loss of 𝐒𝐶ADN, right? That's the reason we have Rhinitis plastica. The same reason here in microscopy, though it's an adenocarcinoma, there'll be no glands because there's loss of cell adhesion, right? Glands cannot be there. So what I'll see is, you'll see individual cells filled with mucin because the stomach tumor, right? The individual cells filled with mucin gives a very unique appearance here. That's shown in the image. The cells look like this. Mucin pushes the nucleus to the corner. We call it an Signet ring cells or a Signet ring carcinoma. I'll zoom this. I'm sure you can appreciate the Signet ring here. where the nucleus is towards the corner and the entire cytoplasm is filled with mucin, right? That's a classical signating appearance of your linitis plastica or diffuse gastric asthma. Probably, see, visually, these are some things which can be easily asked in image-based question, fine? Okay. Few things about your GI polyps. When you take polyps of intestine, we divide them into tubular adenoma. Tubular are very good polyps, right? So microscopically, I'll see very tiny glands there. They are mostly benign. Recurrence is very, very, very less. Tubular adenoma, very, very decent polyps, will not trouble much. If you look at this part, can I say it's finger-like projection? That's your villus adenoma. Villus adenoma is one of the worst. Right? Villus adenoma should have more than 75% villi in the microscopy, called a villus adenoma. Malignant transformation is very high. The malignancy risk is high. And recurrence is also high. Okay. That also is high in case of a villus adenoma. Fine. This one, it's a spotter with Peutz-Jeghers polyp. So Peutz-Jeghers polyp, the most common location is in jejunum. They look like a tree. If you can draw this pink structure, it exactly looks like a tree. It's an arborescing polyp, right? Like a tree. Peutz-Jeghers polyp, most of them are pedunculated polyp. Pedunculated in the sense, they'll have a stalk. So normally polyps is nothing but projection, right? So they'll have a stalk. That's your peduncle. It will not be flat from the surface. They'll have a stalk. That's a peduncle, pedunculated polyp, right? It's a type of an hematomatous polyp. That's how a Peutz-Jeghers polyp looks like. Peutz-Jeghers polyp is a spotter, which has been asked before. Like I said, and we discussed before also, STK11 mutation. Syndrome is different. Polyp is different. Syndrome might have the problems in the oral hyperpigmentation. Polyp might not have, right? Last but not least is juvenile polyp. See, juvenile polyp, age is the clue. Children. Location is rectum. Okay. It's a type of mucus retention polyp. Okay, so what I'll have in microscope is lots of glands which are dilated with mucin. Very big glands filled with mucin. As the name says, it's a mucus retention polyp. The mucus retains inside the gland and makes it much more bigger, right? What 𝐒𝐿 said is right. If it's a juvenile polyposis syndrome, I do have a syndrome called juvenile polyposis syndrome where I have SMAD4 mutation. In a polyp, I will not have a mutation. In a syndrome, I'll have the mutation. Same with Peutz-Jeghers syndrome, congenital mutation of your STK11. Fine. Syndrome is different, polyp is different. Fine. Okay. That's a few things about GI malignancy which I want to cover. The last bit, I won't take most of your time. I'll complete it before my speculated time, is renal. Okay. See, kidney is something which has to be read. At least we give a little bit of more importance with respect to pathology and physiology than nephrology. Because if you know pathology, it's very simple to treat syndromes, all the nephrotic syndrome. Simple. Steroids, cyclophosphamide, end of story, right? But clues clinically is very important for me to categorize nephrotic and nephrotic, right? It's simple. Nephrotic, you know, classic. I'm just going to touch on the classical parts only. Nephrotic syndrome, massive selective proteinuria. Okay, massive selective proteinuria is nephrotic syndrome. You'll have lipiduria also. And definitely lipiduria also. There'll be a massive and a selective proteinuria, right? You'll have antithrombin 3 loss in the urine. This increases the risk of thrombosis. Okay. In nephritic syndrome, two classical findings: hematuria, hypertension. See, nephritic syndrome will also have proteinuria, but there'll be non-selective proteinuria and not massive. Little bit like 1-2 grams per day will be lost, right? Here also proteinuria will be present. I'm not saying it will not be present. Proteinuria will be present and not severe, and they are non-selective proteinuria and not very massive like nephrotic syndrome, right? These are two classical ways by which we can differentiate nephrotic and nephritic syndrome, right? Clinically, nephrotic syndrome will have puffiness of face because the selective proteinuria is primarily albumin loss. Because of albumin loss, oncotic pressure will reduce and edema will happen, which results in puffiness of face, fine? So now I'm going to show you few images and classical clues for you to diagnose them, right? This is a normal glomerulus. I need to know normal glomerulus to identify or to compare and call it an abnormal. You tell me, what's the difference between these two? In other words, which are the glomeruli? These are my capillaries, okay? Which are the glomerular capillaries thick? I'll mark it as 1, I'll mark it as 2. Which glomerular capillary do you think is thick? It's a very simple question, right? Which do you think is thicker? Not difficult. Everyone will say, obviously, second one is thicker, right? So thicker glomerular capillary loop, we use the term membranous glomerulonephritis. That's what you will see them, right? It's a normal glomeruli, and this is what you see in membranous glomerulonephritis or membranous glomerulopathy. It's a membrane, it's a thick membrane, that's it. Not wire loop. See, wire loop will not be thick uniform. This is thick uniform, right? I'll talk about wire loop soon. It's membranous glomerulopathy, right? So the etiology of membranous glomerulopathy, they are multiple, but the most common etiology which I want you to remember is you'll have antibodies against a protein called as PLA2R. Predominant of the membranous glomerulopathy present with nephrotic range proteinuria or nephrotic syndrome. Okay. So HNE, like you saw, you'll have thick capillary loop. And once it was asked in a NEET PG exam, I can do a silver stain, though we don't do it always. Silver stain will have spike and dome appearance. And immunofluorescence, the direct immunofluorescence, will have granular positivity for IgG. That's a very classical finding. It's IgG only. Antibodies also IgG. Yes, that's what we see in the immunofluorescence as well, right? Sure. Okay. Okay, these are, and electron microscopy if required, we have a sub-epithelial deposit. Okay, that's how a classical membranous glomerulonephritis will look like. The same thick capillary loop will also be there for Goodpasture syndrome, right? So for Goodpasture syndrome, where you have antibodies against collagen 4, also will have the same light microscopy. The only difference here is IF. Please never forget this. This is the only place you'll have linear positivity for IgG. There's no other glomerulonephritis will have linear positivity. Everything is granular. Only one which is linear is Goodpasture syndrome. Same capillary loop but linear positivity. Fine. Okay. There's a classical image. I'll just zoom this image. I want you to identify one cell. If you identify that cell, that's enough for me. Can anyone tell me what inflammatory cell does this look like? I'm circling a few classical ones. Will you agree that these cells look like neutrophils, especially this one? Does it look like a lobe of neutrophil, like a bent nuclei? It does. Whenever I have neutrophil, can I say it could be an acute inflammation? Yes, that's all. That's all is required for me, right? Acute bacterial infection, that's all, right? So when you have in microscopy neutrophils in the glomeruli, or in other word, we call it an endocapillary hypercellularity. Increase in cells inside the capillary. That's all, right? Endocapillary hypercellularity, right? We call it more neutrophils. That's it, right? So this is how your PSGN or PIGN will look like. Classical history is skin infection or an URI. After that, 2 weeks. After that, hematuria. It's classical for PSGN. Same skin infection or URI, generally not skin infection, URI. Second day, hematuria, this is IgA nephropathy. You can differentiate them just based on history. That's enough. PSGN, the bacteria deposits in the kidney, consumes all the complements. So C3 levels will be reduced in the serum. That's also a very important clue. Yes, Rishabh. If C3 levels are reduced in the serum, what will happen? I'll have in immunofluorescence positivity for IgG, C3 granular, right? And in electron microscopy, like you can see in the image, you have here also subepithelial deposit, but this subepithelial deposit will be like an hump-like deposit. It will be like a hump. So if you can see this, I'll just zoom this image. Can anyone tell me what structure is this? A finger-like projection. Can I call it podocytes? Right? And see here. So I have the red one is your basement membrane. Normal podocytes, suddenly there is a hump, right? That's your subepithelial hump-like deposit, right? It looks like a hump of an ox, right? So you call it a subepithelial hump. That's classical for PSGN, okay? And the clue, IgA nephropathy is a bit different from this, okay? Perfect, great. So let's have a quick look at IgA nephropathy also. So in IgA nephropathy, or the other name is Berger's disease, history we already know. Any mucosal inflammation, you'll have immediate hematuria or the second day hematuria. It's obviously nephritic syndrome, right? It's a mucosal inflammation triggered problem. So you might have had at least 2-3 episodes of URI in the past 1 year. So IgA will be recurrent or once in a while? It has to be recurrent. A recurrent hematuria, think of IgA nephropathy. PSGN is not as that recurrent, but IgA is very recurrent. Because it's not only one URI alone, UTI, diarrhea, any mucosal problem will have this. Recurrent hematuria is one of the important clues, and immediate hematuria during the infection is one of the important clues, right? Okay. Microscopy, what I'll have is mesangial expansion. The mesangium becomes bigger. This is mesangium. The capillary is completely fine, but the mesangium becomes bigger. Capillary loop is completely fine, right? The mesangium becomes bigger because of the deposit. So the immunofluorescence or direct immunofluorescence is also IgA positive in mesangium. See, everything here goes to the mesangium. Okay. Even in electron microscopy, I'll have mesangial deposit. It's not a problem of the capillary, it's a problem of the mesangium, and it causes your nephritic syndrome, nephritic range proteinuria, hematuria, and hypertension, right? Because it's recurrent, the only problem is it can kill the kidney over the period of time. CKD will happen, and you'll have to replace the kidney at some point of time. Fine. Okay. Last few images. We have many glomerulonephritis. The end point is these two. One is FSGS. If you can see, this entire part is pink in color, or sclerosed or fibrosed. This is the most common cause of nephrotic syndrome in adults. Okay, this is the end stage. Any glomerulonephritis in end stage will end up in this only, right? This is, you can see an appearance here, that's your crescent. Okay, crescentic glomerulonephritis or RPGN, rapidly progressive glomerulonephritis. History is very, very classical. Patient with creatinine of 2 milligram percentage. Within 12 to 24 hours. See, it should be very, very rapid onset. I should not say that 3 months back, creatinine was 2. Now, creatinine is 8, RPGN. No, it's immediate. 12 to 24 hours, if creatinine becomes, let's say, 8 milligram percentage. The rapid progression is important for me. It's rapidly progressive glomerulonephritis. That's very, very important. The reason why it's a rapid progression is the pathogenesis. The pathogenesis here is, as you can see in this image, break in the GBM. GBM is glomerular basement membrane. Capillary is ruptured. It will not take months to destroy the kidney. If capillary is gone, entire glomerulus is capillary. Entire glomerulus is gone, right? So you can see it's broken here. The broken capillary has a very fast progression. The only treatment for it is immediate dialysis. Do immediate dialysis. Try to salvage the kidney. If it recovers fast, great, right? So that's the end stage. One is RPGN, one is FSGS here. Fine. Okay. Few more spotters. All these three are spotters here. Okay. Let's start with the easiest one. What do you guys know? What is this? I think this is my last slide. Yeah, last slide. Tell me, what is this? That's your onion skinning appearance or an hyperplastic arteriolosclerosis. Okay, that is seen in malignant hypertension. It's onion skinning. Looks like an onion skinning. You will definitely remember that, right? Perfect. So this is a completely pink wall of the arteriole, which is hyaline arteriolosclerosis seen in benign or a chronic hypertension. When you have a hypertensive patient for, let's say, 20 years, 130, 140, or 120, that's chronic hypertension, right? And here in benign hypertensive, the gross appearance of the kidney will be malignant hypertensive and benign hypertension. Gross appearance here will be shrunken granular contracted kidney, right? You'll have here granular and contracted kidney, and in malignant you'll have the flea-bitten appearance. We saw in the first half the flea-bitten appearance of the kidney. Fine. Okay. The last one, last microscopic image, nodules in the glomeruli. It's a classical seen in diabetes mellitus, KW nodules or the Clemmenstein-Wilson nodules. These are the glomerular finding. The same diabetes, one more lesion in the PCT. These are glycogen stored in the PCT as clear vacuoles, which is called as an Armani-Epstein lesion. Armani-Epstein lesion as well as Clemmenstein-Wilson lesions are classical for diabetes, though we don't diagnose diabetes with this, but these are few classical findings which you have to remember in case of a diabetes mellitus. Fine. Okay. The last two images. ADPKD, ARPKD, that's all. So ADPKD, ARPKD. If age is given, very easy to differentiate. It's seen in adults, it's seen in children or at birth. It's very easy to differentiate if age is given. If age is not given, right, ADPKD generally will have cyst on both outer and cut surface in both cortex and medulla. ARPKD cyst will be there only on the cut surface. Outer surface will be smooth in case of an ARPKD. If you look at this, it's very smooth. I am not having a cyst when you don't cut it. But when you cut it, you can see multiple tiny cysts here, right? That's how ARPKD looks like. But ADPKD, this is not a cut kidney. This is an outer surface. That itself has a cyst, right? Okay, that's classical here, fine. And the protein is being damaged here is, you have mutations in polycystin 1 and 2, and here you have mutations in fibrocystin. Okay, one of the common association here, obviously cyst will be there in multiple organs, cyst in other organs, and also one classical association in the brain, which is berry aneurysm. Okay, here the association, you'll have liver fibrosis, hepatic fibrosis, and a damaged, destroyed kidney obviously has a very, very, very poor outcome here. Fine. Okay, those are few things with respect to nephrology. Okay, that's all for my time. I have tried to complete exactly on time. If you're not had your lunch, go and have your lunch. See you back. I think next is orthopedics, I suppose. So by 3:30, Dr. Alekhya will come and she'll be completing orthopedics. I have had only 25 pages, 24 pages to be exact. 24 pages of required things for the final go. This is not going to give you concepts, it's more of compiling the information. Don't worry, I'm not going to give a big pep talk. Just remember that you can do it. That's it. Just do it. 4 hours. Quite a few of you have been very, very consistent from the moment we started to the moment we ended, right? That is required in the exam. That's it. If you can show this consistency, you will obviously do very well. So all the very best for exams. Hopefully we'll see you when we complete exam, and let's celebrate it together and party together. Fine. Thank you guys. See you soon. Bye bye.
So now let us start orthopedics. Hope you have done. Hope you're done with the pathology and have come back for ortho. Yes. So quickly, not waste the time because we are running on marathon now. So no wasting of any time. So everything clear from my side, audio, video. Should we start? Okay then. So you guys keep coming and start following. Meanwhile, I'll keep starting the class so that we'll not run short of time later. Okay? Is that clear? Yes. So now guys, we have given a good workbook. So worked around all the PYQs and important topics and compiled into a workbook. So this workbook is basically, yes, good evening, Rishabh. So this workbook basically has everything you need to read about orthopedics. Okay. If you complete this workbook at least twice before, I mean, revision twice before your exam, I think it would be an excellent source of preparation. Okay, so first this workbook, as I have compiled, the first and important foremost thing, I have put up few tables first. Okay, I have put up all the tables. So this is the table of fractures, and later we have tables like that. So important x-rays and everything. So even just before, the day before the exams, you can just mug up, or you can just, go through all these tables, which give you, first they will give you good confidence so that you can attend your exam peacefully, and later it will be a good revision for you. Okay, you need not search for various resources, everything compiled into these tables, you can just have a look before going to the exam as well. Okay, so now for ease of the completion of the class, because we have only 2 hours and we need to complete almost 60 pages of this workbook, what I've done is I've already written answers for this. So few tables I've already completed writing answers. These are just, you can just, these are very easy and you keep repeating them. So I have completed them, and later we will revise these tables. Okay. Okay, now let us start the class. Okay, now let us start the class with this images. We'll complete the images and we'll complete the topics first, and then we'll come back to the tables at the end. Okay, is that good? Okay, so now first and foremost and most important thing. So this is a very, very important splint, which you all know. Yes. Can somebody answer for me? So this is nothing but your Thomas splint. So how do they ask you, and what are the questions regarding this Thomas splint? So Thomas splint is nothing but, it was initially discovered for treating tuberculosis, but now they are meant only for treating your femur fractures and mainly for immobilization and remember, there are certain parts of this Thomas splint where you have to name them. This is the ring of the Thomas splint, and there are two rods, which is the inner rod and the outer rod, right? And the outer rod has a bump over the proximal part to accommodate the greater trochanter, right? So proximal part of the outer rod, you will have a slight deviation like this. This is called as the accommodation for the GT, and this is the inner ring which makes an angle of 120 degrees, right? And this is connected, these two rods are connected by a W-shaped structure at the bottom. So remember, this is Thomas splint, and these are the parts, and mainly used for fracture femur, and it is mainly for immobilization of the patient, right? That's it of the Thomas splint. And then once we are done with the Thomas splint, there is one more Thomas which is used for testing. So this is called the Thomas test. In this Thomas test, what we have, why do we use this? We use this for testing the fixed flexion deformity of hip, which is called as the FFD of hip. Okay? Yes? So this is the FFD. So few diseases, like if the patient is having osteoarthritis or if the patient is having tuberculous arthritis, the hip goes into flexion. Okay, why it goes into flexion? Because of the pathology, the iliopsoas gets contracted and the hip goes into flexion. But this flexion deformity cannot be seen outside because the body compensates it, right? Imagine you are having a flexion of the hip. Can you walk with the flexion of the hip? You can't walk, right? You can't walk. So now what does the body do? The body will come into, that spine will come into rescue. Now the spine undergoes lordosis, so it will increase its curvature so that the patient walks. So this FFD is usually not visible outside. So to identify this FFD, we have a test which is called as the Thomas test. So here what is happening? Patient is lying supine, right? Flexion of the normal hip. So there is a flexion of the normal hip. We are flexing. This is the normal hip. They are flexing the normal hip, right? And now if you see, now the spine is straight, right? Now the lordosis is lost and spine becomes straight. When the spine becomes straight, you can see that this is your fixed flexion deformity of the hip. And how do you measure it? You measure a line along the femur like this, a longitudinal line which is along the femur, another line along the couch. So this is your FFD, that is your fixed flexion deformity of hip, right? So whenever you do this, you will identify. So this is a quantitative test. Quantitative test to identify your FFD. Okay? Is this clear? This much is enough for FFD. So this is the Thomas test. Patient is lying supine. You will flex the normal hip. So the lordosis is lost, right? And then you will check for the normal FFD, right? Any doubts? This is called the quantitative test, which is done for fixed flexion deformity of the hip. So this is the Thomas test and this is the Thomas splint. And one more Thomas we have. What is that? That is your Thomas collar we have, right? Thomas collar. Okay. So these are certain Thomas was invented these things, and this is the attribution of Thomas to orthopedics. Okay. And now identify this particular image. You have to be very quick because ortho, we need to complete it in 2 hours, and I want everybody to be very, very active. If you know the answer, type the comment so that I will not wait. Okay. So this is, if you see guys, if you see, you can see a lucency, right? In the humerus, it is not as normal. So this is the normal one. Here you don't see that normal. So what is that lucency? So this lucency is nothing but it is some pathology which is having, and because of this pathology or weakness of the bone, we can see the fracture of the humerus, which is called as pathological fracture. So pathological fracture, 2 important points. One is there is an abnormal bone. So bone is abnormal here, but the what is there? So bone is abnormal, but forces, the force which is creating this fracture is usually minimal. So force is minimal. So what you have to remember, whenever a fracture to be happened, so it is usually happening because of the abnormal forces on the bone, right? So whenever you break the bone, Vidushi, what is that, ma'am, please? What do you want me to tell? IT fracture? Okay, we will tell. Okay, I will tell you IT fracture management. Don't worry, it is there in the workbook. We will complete that. Don't worry about that. Okay. Now concentrate on the pathological fractures, guys. So pathological fracture, what you have to remember, it is mainly occurring in the abnormal bone, but the forces are minimal. So the patient will come only with the trivial trauma, and when you take up the X-ray, you will find the bone is abnormal. So one of the most important pathological fracture where we see is mainly in the tumors. So there are tumors, and then we have the metabolic disorders. So tumors and the metabolic disorders are the two important areas where we see this pathological fractures. Okay. Then what is this? What type of fracture is this? Yes. So this is a type of fracture where you can see this particular area, right? This is abnormal, right? This is abnormal. Yeah. Okay, pathological fractures, we have a scoring system which is called as Merrill's score. So Merrill's score is basically for identifying whether we want to operate that particular area or not, right? For example, if a fracture is occurring in the trochanteric area, if it is occurring in the trochanteric area, it is a high stressful area, right? So then the patient has to be operated, right? Then the patient has to be operated. So that is about the Merrill's score, and usually upper limb upper limb fractures are treated conservatively. Lower limb fractures are treated with the surgery. Okay. And then there are limb areas, and then there is a pain management. So if the patient is having severe pain, then we are going to operate it like that. Okay, this is Merrill's score. There are three criteria in it. First, depending upon the pain, and then depending upon the location. Okay, so that is about the Merrill score. And then the third one is about the lesion, whether it is osteolytic, osteoblastic, or mixed lesions. Okay, that is about the Merrill's score. And then yes, this is the stress fracture. Yes, very good. This is the stress fracture. But what is the thing you have to remember here? What you have to remember here is the bone is normal. There the bone was abnormal. Here the bone is normal, but there are repetitive forces acting on particular area. So there are repetitive forces acting on one particular area which is causing this particular fracture. Usually what we see on the X-ray, we see callus on the X-ray, right? And this is called as the march fracture, which is usually seen in the shoulders, right? Which is usually seen in the soldiers who are marching regularly. They put repetitive forces on that particular area, but the bone is normal. Here the forces are very, very minimal, but the bone is abnormal, hence resulting in the pathological fractures. And the Merrill score is one criteria where we can use to know whether we can operate the fracture or not. And then what is this? Yes. Yes, what is this? This is a type of non-union, right? You can see that bone is not united. So this is a non-union. This is a non-union. So what type of non-union it is? So remember, there are two types of non-union. One is hypertrophic non-union. The second one is atrophic non-union, right? So for the bone to unite, so union occurring, there should be good immobilization of the bone and good vascular supply to the bone. So these two are very, very important for the bone to unite. So one is good immobilization and good vascular supply. And remember, this good immobilization can be of two types. It can be by surgical or it can be by conservative methods also. So you have to immobilize that particular area and you have to give good vascular supply, that is blood supply, then the bone unites. If the bone is not uniting, this is called as non-union, and there can be two important things which can occur there. So in case of hypertrophic non-union, what happens is there is good blood supply, poor support to the bone. That means no proper stabilization, right? No proper stabilization given to that particular bone. Whereas atrophic, you have to remember, that is mainly because of poor blood supply. So there is no blood supply, even though the stabilization can be proper or improper, but because of the poor blood supply, it goes into an atrophic non-union. So what is this? So this is a malunion, right? So this is a malunion where union is present, but there is a malalignment. There is a malalignment of the fragments. Okay, so whenever the bone has to unite, we have to see three important things. One is length, second one is alignment, the third one is rotations. So the length has to be stabilized, the alignment has to be corrected, and there should not be any rotations in between the fragment. Then only the what we say, where then only the mechanics will happen good, and then you will see there is a good union of the bone and complete restoration of the function will happen. But in case of malunion, what happens is there is a union which is occurring at the fragments, but this is not aligned. So you can see there is no length which is gained. There is a shortening of that particular humerus, if you can observe, and then there is no proper alignment. If you see, if you draw a line like this, so there is no proper alignment of the bone, right? So the bone has to be straight like this. So this is called the proper alignment. So there is no proper alignment, and rotations are also disturbed. So whenever there is a disturbance in all the three, it results in what is called as malunion. But if the bone itself is not uniting, then this is called as non-union. And there are two types which you have to remember. One is hypertrophic and atrophic non-union. In hypertrophic, that means there is a good supply, so the bone is formed nicely, but because there is no proper stabilization, no proper support to it, it is not uniting. In atrophic, this is atrophic, means there is completely no blood supply, that is why the bone is not uniting. Okay, so these two are important complications of the fracture which you have to remember. These two are important types of fracture. So one is pathological fracture, the second one is the stress fracture. Okay, yes. And then what is this? Yes, what is this? This is a casing, right? You can see the casing of the tibia. So this is called the PTP. This is the patellar tendon bracing, right? So mainly used for fractures of tibial shafts. So whenever there is a fracture of the tibial shaft and still the patient wants to bear weight, you're going to give this. This is not a below knee cast. Don't write that. Yes, Harsh, please repeat. This is not a cast below knee. Dharamveer, this is not a cast below knee. Please be careful. The only thing I want you all to see is, see the extension of this. Like this. Right, this is a patellar tendon bracing cast, which is mainly for fractures tibia. If it is a below knee cast, it will start somewhere here. So this is the area where the below knee cast starts like this. So this is a below knee cast. So whenever it is going above the knee only on the anterior side, only on the anterior side, this is called a PTB, patellar tendon bracing, and it is mainly used for fractured tibial shaft. And why is this called bracing? Because patient can bear weight. So you can walk with the help of this brace, right? Usually what we do, if you put a cast, below knee cast, patient is not supposed to bear weight, right? So PTB is mainly for bearing weight. Okay. Now Dharamveer and Harsh, is this clear? This is not a below knee cast. It is a PTB, patellar tendon bracing cast. Okay. Yes. Then what is this? So two important cast for shoulders which you have to remember. For the shoulder joint and the humerus. So there is a hanging cast, and then you have a U slab. This both are used for humerus fractures. This is mainly for humerus fractures. So hanging cast and U slab is for humerus fractures. So you see the difference. One is cast, the second one is slab. So what is the difference between cast and slab? Slab, you see, this is in the shape of U. And it is not completely surrounding the limb. Here if you see, completely surrounding the limb, right? So this is a cast and this is the slab. You have to identify. This is a very important image based question here. So both is used for humerus fracture. So just remember it as for the humerus fracture. Okay. right? Okay, then what is this? Yes. So if you see, you can see something outside, right? So external fixation. So this is an external fixation. So this is mainly for this external fixation is mainly done in open fractures, and mainly you can see this in case of tibia. And this external fixation is of two types, right? The first one is rods and clamps. You have rods and clamps. The second one is ring type of external fixator, right? What you're seeing here is a rod and clamp. So the pins which are used here are the Schanz pins. This you have to remember. So these are the Schanz pins and these are the rods, and now these two pins and rods are connected by clamps. So these are the clamps, right? So these are the clamps. So yes, this is an external fixator. So you can see rods, clamps and the pins, right? And if you keep on adding the rods, so if you add one more rod here, the stability increases. So putting two rods this way, this is called as uniplanar fixation. If you put one more rod to this side, two rods on two sides, this is called as biplanar fixation. So sometimes they will ask you which one is more stable. Is it uniplanar or biplanar? Which is most stable? Is it uniplanar or biplanar? What do you think? Yes, Rishabh, which one is stable? Uni or bi? Yes, very good, Nishu. Uniplanar and biplanar, very good. Which one do you think is most stable? No, biplanar is most stable. Yes, very good, Harsh. Biplanar is the most stable one. Then is uniplanar, right? And then what do you think? Is the rods and clamps more stable or ring fixation is the most stable one? Which one is more stable? Bi, uni, then ring fixation. Yes, faster. This was asked in the previous year. That is why I'm putting a little bit of stress on it. No, the ring fixation is supposed to be the most stable, right? Most stable. Why ring fixation? Because it is giving 360 degrees stability. So it is giving 360 degrees stability. So this is your ring fixation. And what is the name of this ring fixation? It is called as the Ilizarov ring fixator. So this gives 360 degrees stability to the fracture, and it is mainly used with the olive wires, right? You will have olive wires. Okay. Yes, ring is first. Yes, ring is first. Okay. So this is an external fixator too, but this is called the Ilizarov ring fixation. And that one is rods and clamps, mainly used for your open fractures. And this Ilizarov can also be used for treating non-unions as well, especially the infective non-unions, right? And they can also be used for deformity correction, right? They can also use it for the deformity corrections, right? Non-union, deformity corrections, all these things we can even use the Ilizarov, that is ring fixation. And external fixation we usually use for the open fractures. Okay, this is the most important difference between the two. Is that clear, guys? Okay, now this was asked in the FMGE, last FMGE. Okay, Jan probably. This was put up and this was asked. Okay, now what is this? Yes, this is a Bowler Brown splint, right? So this is a BB splint or Bowler Brown splint. And now where it is used and why it is used, it is mainly used for fracture femur. Say whenever there is a fracture femur shaft or IT fractures, also this can be used, right? If you see, there are three pulleys here. So first, second and third pulley, right? Usually the first one is mainly for foot drop. So there, whenever there is a foot drop, you can put for first pulley, and then the second pulley is for your, you can see that the femur, usually it is like this, no, the longitudinal axis of the femur. So the second pulley is mainly for the femur, right? And the third one you can use for the tibia. Okay, so these are the various pulleys which are present, and this is called the BB splint. And for using this BB splint, what you have to do, you have to put a skeletal traction. So first you will put a pin. So this is the skeletal traction. And in the skeletal traction, what you use, which pin you use? You use either a Siemens pin or a Dunham's pin and a stirrup. Okay, so what are the things which we use in skeletal traction? So you put a pin. So this is a pin here, and then they're putting the stirrup, and then it is tied to the weight. Okay, so that is about the BB splint. So because they have asked last year, they might put up what are the things they can be used here. So this is not the K wire, but we use the pins here. This is the Dunham's pin or the Siemens pin. And remember, in the external fixator, what pins we use? We use the Schwan's pin. So 3 pins we have learned. One is the Schwan's pins, which we use in the external fixator, and in the Alekhya we use the olive wires, right? And then in the skeletal traction for the BB splint, what we use is the Siemens pin or Dunham's pin. And what is the difference between these three? So they can put these images as well. So Schwan's pins, there is nothing to remember, just it is a straight pin and with little sharpness in it. So this sharp edge will go into the bone. That is the Schwan's pin. So this is the Schwan's pin. And then you have your Siemens pin, and this Schwan's pin, the threads are there here. So this is the threaded part which is at the end. And Siemens pin is very, very straight, right? This is the Siemens pin. There are no threads in the Siemens pin. And the Dunham's pin, you will have threads in the middle. Okay, so this is your Dunham's pin where the threads are there. Nothing is there Siemens pin. And then if there are threads at the end, this is called your Schwan's pin. So whenever they give in the image, identify the image basing on the threads. No threads, simply plain Schwan's pin. Siemens pin. If the threads are at the end, which is going into the bone, that is the Schwan's pin. Threads in the center, that is your Dunham's pin. Okay, clear everybody? Any doubts? Then what is this? Yes, clear? Okay, done. Then what is this? This is, once we are finished, this is the skeletal traction I have told you. So this is the skeletal traction where pins are used. And then what is this? This is a skin traction. This is a skin traction. No, this is not used for foot drop, my boy. Not clo. Nanna. What is that? I'm unable to pronounce your this thing only. ID. So this is the skin traction. So this is a skeletal traction and this is a skin traction, right? So this the skin traction we mainly use for IT fractures, but usually we are not using it now because our patients are being shifted for surgery early, right? So before days where there were long patients and the patients has to be put in the waiting area for the treatment, then we used to use this skin traction. This is also called as the bucks traction. This is also called as the bucks traction. And if you see, there are no pins, nothing. There are two straps like this. So there are two straps like this and they are connected by another strap, the larger strap here. And now what we do this, we wrap these two straps with the crepe bandage and then we add weights here. Right, so then we add the weights here. So this is called as skin traction or the bucks traction. You can use up to 3 kgs of weight for this, right? And for skeletal traction, you can weight up to 10% of the body weight. You can weigh up to 10% of the body weight, right? So here only we use up to 3 kgs, maximum of 3 kgs. So this is a skin traction and this is the skeletal traction. So what are all the things which are used in skeletal traction? They use the pin, the stirrup and the BB splint. So these are the setup which is required. Whereas skin traction, this is a skin traction apparatus we get directly. There are two the straps, and then they are covered by the crepe bandage, right? So that is about the tractions. And what is this? Yes. This is mainly for fracture femur shaft in pediatrics. Yes. What traction is this? You can see the knees are slightly flexed, and what is main thing is this buttock should be cleared off the bed. Then only this will work. In mainly the pediatric population, we use this. Yes, I'm waiting for your answer. What type of fracture, splint, fraction is this? Yes? Yes, this is called as the gallows traction, right? It is called the gallows traction, or also called as Bryan's traction, and it is mainly used for the femur shaft fractures in case of children. And then you see both the limbs are tied up, and you see the buttocks has to clear off the ground. Then only the counter traction will happen, and this will result in union of the femur shaft in case of kids, right? Yes. Yes. Then what is this? Now we are dealing with the tractions are done. So these are the important tractions which you have to remember. The BB splint, the skin traction, and this is the gallows traction. And then we are heading towards the most important image-based questions, implants and instruments. Nowadays, they're asking at least one question from this particular area. So I want you all to concentrate and even answer. So what is this? Yes, quick. Nishu Rishab, Harsh, Dharamveer. Public harness? Rishabh, this is not public harness, this is gallows traction. That is done long back. Is there any lag? Is the video lagging somewhere? Yeah. Okay. You have answered for this DHS? Okay. This is not DHS. Probably your D is right. This is DCP. So this is a plate. So whenever somebody is talking about implants, just remember, I will make this easy. So implants, you have to. Okay. So implants, there are two types. One are the plates. The second one are the nails. Right? These are the implants. And then we have instruments. So there are variety of the instruments where we can use them to put these implants inside. So one such important plate which you have to remember is the DCP. This is called the dynamic condylar plate. Dynamic condylar plate, right? Right. And now this is, sorry, not condylar, compressive, dynamic compressive plate. Okay, dynamic compression plate. DCP is dynamic compression plate. And how do you identify the dynamic compression plate? See, the first thing what you have to look is there is a gap here. And the second thing what you have to look here is the oval shape. Right, so this is the oval shaped structures, and there are no threads anywhere. So if you see, there are very clean, there are no threads. So this is a DCP, used to stabilize bone by applying compression. You will not apply any compression, the bone will heal by compression. Okay, so what happens is, why the name compression is given to it is, so now just this is a fracture and this is a fracture, imagine, and now we are putting this DCP like this, right? So there are holes here. So these are the oval holes, as I've told you, and there is a gap. So this gap will sit on the fracture exactly, right? And now what you do is you put these screws here. So whenever these screws are tightening, the mechanism of the DCP is such a way that whenever you tighten the screw, this plate moves. And now because of the movement of the plate, the bones are also moving towards each other and they get compressed at the fracture site. Okay, so that is why it is called as dynamic compression plate. So we are tightening the screws, which gives the dynamic, that is the movement, and because of this movement it causes compression at the fracture side, so the both the fragments come and unite. So this is called as the dynamic compression plate. Okay, is this clear? So this is the dynamic compression plate. So whenever you see this plate, first you have to see for the gap, and then you will see the oval shaped round holes, oval shaped holes, and then there are no threads in it. Now, why I'm telling so much about this? Because there is one more plate, the contrary, which is called as locking compression plate, which is called as the locking compression plate. So why there is locking compression plate? So the same meaning of this, but here what happens is there are threads in this combi hole. So if you see a combi hole, that means what is the combi hole? There are threads at one part of the hole and there is an oval shaped in other part of the hole. So just zoom in and see. So if you can see, this is a combi hole. It is something like this. So there is a hole and there is one more hole like this. So this is called as a combination of hole or a combi hole. And now why I'm telling you threads? So one part of this is threaded. Yes, cortical screws are used in DCP. Okay. So this is an LCP and you have to identify the threads. So whenever you see there are threads in the hole, this is called as an LCP. And now we use the screws. So this is the screw which we use, and these screws also have threads in the head. So in the head, the screws is threaded. So the threads in the plate, the threads in the screws, they get locked. And this is called as the locking compression plate. This is called as the locking compression plate. Nishu, the 3.5 mm and 4.5, that depends upon the fracture which you're fixing. Okay, no need to go into that detail. So just remember identification, that is DCP and LCP. LCP is mainly used for locking compression plate and dynamic compression plate. So now why do you think that LCP has been invented? So we are happy with the DCP. So DCP might have been, we are putting the holes and now it is causing compression, so we have to be happy with that, right? So why did the evolution of LCP had happened? Okay, Nishu, can you answer this? Why do you think LCP is superior to DCP? Now I'm telling LCP is a new invention, it is superior to DCP. So why do you think is that? Yes, yes, answer. Quicker, quicker. So mainly what you have to remember is this LCP is mainly used for osteoporotic bones. So in case of osteoporotic bones where the bones are already weak, हाँ, डिजाइन एंड मैकेनिज्म का वजह से ही हुआ था, बट व्हाट इज दैट डिजाइन एंड मैकेनिज्म? आई एम आस्किंग यू. So in case of the osteoporotic, so in case of DCP, what I have told you, that the screw will get into the bone, and now because of that movement of the screw into the bone, there is a compression. Now if the bone itself is weak, it cannot hold the screw, right? If the bone itself is weak, it cannot hold the screw. So now what happened is, the screw which is there, which gets locked with the plate. Now the movement is between the screw and the plate, not with the bone. So now the bone has no role in holding the screw. So hence we treat these osteoporotic bones with LCP. And if you see, the periarticular also used with the LCP. The periarticular fractures, the cancellous bone especially, they are present in the periarticular areas. So that also is treated with the LCP, right? Okay. Then what is this? Now, can you tell me, is this an LCP or DCP? Okay, Harsh, don't know, they'll present stability and strength. It is nothing that like that. I hope you all understood the difference between DCP and LCP. Okay, so that is the main difference. Now, identify this particular plate. Do you think is this an DCP plate or an LCP plate? Yes, quicker. Yes, yes, yes. Is this an LCP plate or DCP plate? Yes, this is an LCP. Very good. And for your information, this is even customized plate. So this is specially designed for the wrist. So this is the wrist locking plates, right? And these are distal radius locking plates. You can see that this distal radius we can treat with this locking plates, where this locking screws are put into the cancellous bone. So if you remember the cancellous bone, the distal radius fracture, right? So these are the cancellous bones. So we need the AO plate. Yeah, very good, because already it is mentioned here, the AO. Okay, fine. So this is the distal radius locking plate. So you have to identify that way. And this is mainly used for treating the fractures. Okay. Okay, then what is this? It's not AO plate. It is a distal radius locking plate. AO has helped in designing it. Yeah, this is important. This has been asked in the FMG for a longer, I mean, like various times. So what is this? So this is the tension band wiring, TBW, tension band wiring. And where do we use this? This is mainly used in fracture patella, and especially the transverse fractures. We use this transverse fractures of the patella. We use this. And what is the principle behind it? Principle behind the patella tension band wiring. It's okay. It is based on AO principle. It is not an AO plate. Yes, it is a tension band wiring. The principle is converting the compressive forces converting the tensile forces into the compressive forces. Okay, that is about the TBW. Okay, why I'm telling you this clear is, yes, they might ask again where it is again used in. So this has been used in patella, as we all know, and this is also used in olecranon, and then it is also used in medial malleolus, right? So these are the areas where the tension band wiring is used. And second, third, last one where it can be used is your greater trochanter or greater tuberosity of the humerus. So these are the areas where this tension band wiring principle is used. Yes, it is converting the tensile forces into your compressive forces. So how is that? So this is the fracture, and now these are the tendons. So if you see the patella, there are two important areas, right? So the upper one is the quadriceps tendon, right? The lower one is the patellar tendon, right? So here what happens is, whenever there is a fracture, the two fragments are pulled on the opposite side because of the tendons. So one tendon is attached above, one tendon is attached below. So whenever there is a fracture, the two tendons pull the two fragments towards like this. So there's a lot of gap in between them. So now what we do is we bring these two together and we put KYS, and now these are tied in shape of SSYS. So these two are the K wires, and this is called the SS wire, which is nothing but a stainless steel wire, and it is in the figure of 8. It is in the figure of 8. So whenever we put this into figure of 8, what will happen is it will not allow the fragments to move because of the compression. All the forces which you're putting it will cause compression of the fracture. So this is mainly the tensile forces are converting into compressive forces. And if you see whatever site we are taking, there is a tendon attached to that particular bone. So it is olecranon where the triceps is attached, the medial malleolus, and the greater trochanter. So these are the areas where we use this tension band principle. So they have asked patella for a longer time. Now they may shift asking where the other uses of TBW, where you have to remember olecranon, medial malleolus, and your greater trochanter. Okay, now identify this implant. What is this implant? Yes, faster. This is intramedullary interlocking nail, and this is being used in tibia, if you see, and there is a plate which is done for fibula. So these are mainly done in the ankle fractures. So you have to identify intramedullary interlocking nails and the plate. So what is this intramedullary interlocking nails? So if you see, the locking nails are in the bone itself. So here there is a nail, and now there are screws above and screws below, but everything in a single bone like this. But if you see the femur, if you see the femur, you see there is a nail here and then the screws goes into the head. So this is called the cephalomedullary. So this is the head in the screw and the nail in the medulla, which is called as cephalomedullary. This is intramedullary. Right? So this is the difference you have to remember. So this intramedullary nails are used for the long bones. These are used for long bones, mainly weight-bearing bones such as femur and tibia. And the cephalomedullary are mainly used for the fractures of the hip, especially your PFN, right? So that is the difference. So this is about the implant. So this is the IL intramedullary interlocking. So you see this is the locking mechanism which is happening here. So this is intramedullary inside the medulla and locking above and below. This is called interlocking. So these intramedullary nails are mainly used for your long bones such as femur and tibia. So if they ask you what is the treatment of femur shaft, what is the treatment of the tibia shaft, you can happily answer the nails. But if they ask you what is the treatment of IT fractures, you have to go for cephalomedullary nails, which are called this PFN, that is proximal femoral nailing system. Okay. Yes, that is about the implants. So we are done with the implants here. So this is what I was talking about, the intramedullary interlocking nail. So here clearly I've given. So these are the screws which are used. So these are the screws or bolts we call, which are being used to lock the nails with the bone. So why are we locking it above and below? So if they ask you why there is a locking system in the nail, this is because to prevent the rotation. So again, going back to basics. So for the union, we need length, alignment and rotation. So length and alignment we get because of the putting the nail, right? We put the nail and we can attain the length, and it is aligned because we are passing the nail to the two fragments. But the rotations are further prevented by this locking mechanism. So you're locking the fragment above and below so that it is not rotated. So this is called the intramedullary interlocking nail. Yes. Okay. And now what is this? This has been again asked in the FMG. What is this? Identify this image. Yes, quicker. Yes, Rishabh, what is this implant? This is nothing but your dynamic hip screw. The before one you answered no, that DHS, that is DCP, and this is DHS. This is dynamic hip screw. So this was initially used for treatment of your IT fractures. So IT fractures were initially treated. So you can see this is the screw and this is the barrel. And now these two are fixed to a plate, right? This is a plate. And these are the cortical screws. So this is complete system which is called as the dynamic hip screw. Okay. So dynamic hip screw is mainly used for what type of fractures? Mainly used for your IT fractures. But now the system has been shifted. So IT fractures are now they are treating it with PFN, the proximal femoral nailing, as I've explained, the cephalomedullary nails. But previously it was treated with this dynamic hip screw. Okay, is this clear? Yes, I want everybody to answer yes if you're following, or else if you want me to repeat, comment repeat. But comment something so that I will understand. Yes, okay then. So the same image I have put it down so that you will not get confused even in the exam. If they give this image also, you're not going to get confused. So that is the screw which goes into the head, and this is the barrel which is attached to the screw, and this is on the femur. This plate is on the femur, and just Observe this. This particular is called the derotation screw, again to prevent rotation of the femoral head, right? So this is called the derotation screw. Done. So that is it. So this is the DHS. Please, this is very, very important. This has been asked. This is a PYQ. And now what is this? So once we are done with DHS, so is Vidushi present still or she left? She was the one, no, who asked about the IT fracture. Okay, Vidushi. So now what is this? Identify this. Yes, so this is the proximal femoral nail, what I was telling about. So if you can see, this is a cephalomedullary nail. So the screws are going into the head and the second screw into the femur, right? Like this. So this is the proximal femur, yes, PFN or proximal femur, and this is mainly used for treatment of the IT fractures as well and the subtrochanteric fractures. So trochanteric fractures. So this is the IT fracture. So PFN is this is the PFN. So you were asking the treatment of IT fracture, right? So IT fracture can be treated with two ways. So one, it could be treated with your DHS or with the PFN. DHS or the PFN. So this is the treatment of the IT fracture. Okay. So what are these screws? Is this clear? So this is the proximal femoral nail. So this is the nail. And these are the head screws. Mainly for your, if you see, this is IT fracture. Okay. Yes. And then what are these? These are screws. So simply they can put these images and they can ask you what are these screws, right? So this is a CC screw. Cannulated cancellous screws, right? So where they are used in multiple ways. Say this can be used in case of your tension band wiring also. Sometimes instead of KYS you can use the CC screws, right? Even for fixing of any small fractures also you can use this CC screws. But most importantly, it can also be used in the IC fractures. If you remember inverted triangle shape, right? So there also the CC screws are used. So if you see, the threads are only to some point, that is at the end which goes into the bone, and this is the head, this is the shaft, and these are the threads. And why cannulated? So there is a hollow surface in it, so you can pass a guide wire through it, and over that guide wire you will put this screw and you will tighten it. So this is called, yes, neck of the femur. Yes, neck of the femur, IC fracture also the CC screws can be used. Okay. And then what are these screws? Yes, I have not put the, which one is cortical, which one is cancellous? So usually the difference between these two and the locking screw also same like this, but what you see is there are threads in this head. So these are the locking screws. So whenever you see the threads in the head, this is called as the locking screw. And this is your cortical screw. And this is your cancellous screw. The cancellous screws can also be single threaded or half threaded. No idea about screws. That's fine. So there are only three type of screws which you have to remember. So these are CC screws, and then you have cortical screws and cancellous screws. So there are two important things. It is simple. So cortical bone and cancellous bone, right? So cortical bone is a strong bone, right? It is well behaved, it is organized, whereas cancellous is a weak bone. So it is not that organized, it is not so strong. So it is a weak bone. For example, your distal radius cortico-cancellous junction, they'll tell. So the ends of the bone are usually cancellous. So that is, yeah, how to identify cortical and cancellous? You can see this is the pitch, the difference between the two threads. This is the pitch. Two threads, this is lesser in case of cortical and this is more in case of cancellous. Okay. Okay, cancellous is mainly used for bones which are weak. I mean osteoporotic bones, you can use this cancellous. Okay. Just a second. So that is about cortical and cancellous. Then your locking screws. Then this is the above one is cannulated cancellous screws. Okay. Okay, now then what is this? Yes, even I am thinking the same thing. I will increase the speed from now. Okay, now what is this? So this is Workman's ischemic contracture. So this is the Workman's ischemic contracture. So where it is usually occurring, it is mainly seen in case of your compartment syndrome if not treated. And then you can see in case of your brachial artery injury. Right, in brachial artery injury, in your supracondylar fractures, right? So this is the, no, this is not claw hand, this is not wrist drop, don't get confused. So a wrist drop, you can see only there will be a drop in the wrist, but you have to see the deformity in the hands as well. Don't get into conclusions as fast. So this is about the Workman's ischemic contractures. And what is this sign called? This sign is called the Workman's sign. So this sign is called the Workman's sign. So what is actually Workman's ischemic contracture? So what happens because of the compartment syndrome or because of the brachial artery injury or some damage, the flexor compartment is completely dead. Whenever it is dead, the muscles here are replaced by fibrous tissue. So these fibrous tissue are not supposed to be dynamic and they don't move, right? So they just pull all the fingers like this. So this is called the Workman's ischemic contracture. So whenever you flex the wrist, because of that dynamics, what happens is there will be extension of the fingers. And whenever you extend the wrist, again because of the pull of the tendons, they will cause flexion of the finger. So this is called the Workman's sign. So this is the Workman's sign, right? So this is Workman's ischemic contracture and this is the Workman's sign. Okay, done. And then what is this? This image. So you can see something here which is not very clear. What have to be there? The radial head, they have been replaced. So now you can see there is a formation of the bone. So this is called as the myositis ossificans. So this is called as the myositis ossificans, right? So what is myositis ossificans? So myositis ossificans is a condition where this muscle is being replaced by bone. So the muscle is being replaced by the bone. By because of the massages they do. So they usually seen around the elbow. The first joint where you see is around the elbow. The second one is at the hip joint. So elbow and the hip are most important things where you see this myositis ossificans. And in the elbow, which muscle you see? This is the brachialis muscle which usually undergoes this ossifications, right? So this is the brachialis muscles. And one drug which can prevent this is indomethacin. So whenever there is a risk of developing this myositis ossificans, you can give this drug which is called as indomethacin. Is that clear, guys? So this is Workman's ischemic contracture, VIC, Workman's sign, and then this is myositis ossificans, right? So ossificans is nothing but myositis. Myo means muscle, right? Where there is inflammation of the muscle and this is converting into the bone because of the differentiation of that muscle cells into osteoblast. And why this is actually occurring? Because of the stimulation. They stimulate by the massages and now this brachialis muscle has been turning into your bone, right? So the drug which can prevent is the indomethacin, right? Treatment, you have to do excision. No physiotherapy works, and the complaints, usually the patients have restriction, and the treatment is excision. You have to remove that particular bone. Okay, yes, done. And then what is this? So this is again a very important topic which you have to remember. So this is about the scaphoid. So very important topic. So first one is, they will ask you how to identify it. You identify based upon the anatomical snuff box. The position of the scaphoid is related to your anatomical snuff box. So whenever there is a tenderness in the snuff box, you can suspect a scaphoid fracture, which is usually missed by many of the surgeons. So why it is very, very important? Because scaphoid has a precarious blood supply and it is risk for proning into non-union. So there are certain bones which are at risk for non-union. So what are those? So first is the femoral head, very, very important, femoral head, which will result in femoral AVN. The second one is scaphoid, which will again result in AVN. The third one is talus. So these three are very, very much at risk of developing non-union. So whenever you see fractures of femoral head, that is IC fracture, scaphoid fracture, talus fracture, you have to be very much prepared that they might land in non-union. So what is the investigation of choice of AVN or non-union? So investigation of choice is MRI, right? So investigation of the choice is MRI. Is that clear, guys? So first, this is scaphoid, anatomical snuff box, where the tenderness you feel, and then, yes, usually the proximal part of the femur. So that is about the AVN. This is the AVN, avascular necrosis of the scaphoid. And the three other structures where we see AVN is femoral head, scaphoid, and the talus, right? So they have been asked, this anatomical snuff box is an important question, okay? Then coming to this, what is this? What is a Bankhart's lesion? What is a Bankhart's lesion? So here, in case of recurrent shoulder dislocation, so what happens is, because of recurrent shoulder dislocation, there will be tear in the labrum. So this tear is mainly in the anterior and the inferior part. So inferior and the anterior, you see there is a tear in the labrum, and this tear in the labrum is called as the Bankhart's lesion. So this is your Bankhart's lesion. Where there is a tear in the anterior and inferior part of the labrum. So what is actually the labrum? Yeah, this is one of the complication of the anterior shoulder dislocation. That is why I mentioned this is a recurrent shoulder dislocation, right? That you have to be clear. And what do you mean by labrum? Labrum is nothing but a cover on the glenoid. So if you remember, this is a glenoid and this is the humeral head, right? So this glenoid has an extra covering which is called as the labrum. This glenoid has the extra covering. So this is the glenoid. You think there is an extra covering to accommodate the humerus into it. So, right, so whenever there is a recurrent shoulder dislocation, so the head is constantly coming out. So what will happen? There is a tear in this labrum, especially on the anterior aspect and the inferior aspect. So this is called as the Bankhart's lesion. And similarly, this is the problem of the glenoid, right? So Bankhart's is the problem of the glenoid, that is labrum. And the problem of the humeral head is also there, because head is also coming outside. But this humeral head problem is mainly on the posterior aspect. So it is the posterior superior defect which you see. And what is that called? That is called the Hill-Sachs lesion. Right? It's called the Hill-Sachs lesion. So remember, H for hedge, humeral head for Hill-Sachs lesion, and glenoid labrum, that is for your Bankhart's lesion. So these two are important complications of the shoulder dislocation. And what are the important tests which you have to remember for shoulder dislocation? Yes, Dugas test. What is Dugas test? So Dugas test is touching the opposite side of the shoulder. So whenever somebody is coming with the shoulder dislocation, how do you test them? You ask to touch the opposite shoulder. So now I'm having some problem in the right shoulder. So there is some dislocation. If I'm suspecting, you have to ask the patient to touch the opposite shoulder with the right hand. So if he's able to touch the opposite shoulder, that means there is no dislocation present. So that is your Dugas test, right? And now here Hill-Sachs is posterior and lateral. Yes, posterior and lateral aspect. And this is anterior and inferior. That is your glenoid labrum. Okay. Now what is this? Yes, quick. Yes, inability to touch the opposite shoulder. Very good. And then these are two types of splints which you are seeing. One is the static and second one is the dynamic. So these two are your 𝐒𝐄𝐝 splint. So these two are your 𝐒𝐄𝐝 splint. So one splint, this is called the static 𝐒𝐄𝐝 splint and this is called the dynamic 𝐒𝐄𝐝 splint, right? So static and dynamic. How do I identify dynamic? Again, any movement is dynamic, right? So there are springs here. The springs are attached and they will do the movement of the fingers. So this is the dynamic 𝐒𝐄𝐝 splint. This is the static 𝐒𝐄𝐝 splint. Both are used for which? Radial nerve injury. So both are used for your radial nerve palsy, right? So they are used for the radial nerve palsy. Okay. And then what is this? Yes, now you have to identify. You have to identify. Before you told me it was Workman's ischemic contraction, right? You can see the fingers are flexed here. So please be careful and you have to identify the fingers as well here. So here if you see the wrist drop, the fingers are not flexing. Only the wrist is in flexion. So this is your wrist drop. So this is your wrist drop. So which important fracture you have to remember? Which is causing the wrist drop? This is called the Holstein-Lewis fracture. This is called the Holstein-Lewis fracture. That is fracture humeral shaft, right? Fractures humeral shaft, especially in the distal part. Especially in the distal part, you will see the fracture humerus. And there will be radial nerve injury. Yes, radial nerve injury. And this radial nerve injury will result in the wrist drop. Okay. And next, what is this? This is cubitus varus, right? So this is cubitus varus. Where we have often see this, this is usually seen in the supracondylar fracture humerus. So whenever it is neglected or not treated properly, this will develop in a condition which is called as cubitus varus, also called as your gun stock deformity. This is called as gun stock deformity. Cubitus varus and gun stock deformity. Treatment, again you have to go for osteotomy. It is osteotomy. And now this is a complication which is causing the malunion, right? This is nothing but malunion, right? So what are the areas where we see for malunion? It is a supracondylar humerus. And then you have your intertrochanteric region, IT. So IC is for non-union and this is intertrochanteric is for your malunion. Then you have your distal radius. And then you have your clavicle. So these are the areas where you will look for your malunions, like your supracondylar fracture humerus, your intertrochanteric fractures, your distal radius fractures, and your clavicle fractures. So this is malunion, and that was your non-union. Non-union, femoral head, scaphoid, and talus. So this is non-union, cubitus varus, mainly because of the supracondylar fracture humerus. It is also called as gun stock deformity. The treatment is osteotomy. And very good, cubital valgus is for lateral condyle. And what is the one complication you see in cubitus valgus? Cubitus valgus, yes, it is lateral condyle. What is the important complication which you have to remember? The important complication is tardy ulnar nerve palsy. Tardy ulnar nerve palsy, right? So any patient who is presenting with claw hand and you see there is some abnormality in the elbow, this is nothing but a tardy ulnar nerve palsy. So over a period of time, it goes into valgus, right? So what happens is the medial side, the lateral side is not increasing in size, but the medial side is increasing in size. It causes stretch over the ulnar nerve on the medial side. It will result in a palsy which is called as a tardy ulnar nerve palsy. And how do patient present with ulnar nerve palsy? So he will present with a claw hand. So you will see a patient with the claw hand, right? So that is it. Okay. And then what is this? So once we are done with the scaphoid fracture, we know there is a complication of the non-union. You have to check for the anatomical snuff box. So one more important thing for scaphoid is how do you take the x-ray views? So I have ordered for x-ray wrist, but I'm not seeing any fracture there. But what is the next view you ask for scaphoid fractures? What is the next view you ask for the scaphoid fractures? So you ask for the oblique view. So you ask for the oblique view. So oblique view is one important view which is used for identifying the scaphoid fractures. And what is the treatment of the scaphoid fracture? This is called the scaphoid cast. So how do you identify the scaphoid cast from the Colles cast? Yes. So here what you see is the thumb is included. The thumb is included in the scaphoid cast, where the thumb is free in case of your Colles cast, and this is called as glass holding fashion. So this is a glass holding fashion. So this is the scaphoid cast. It is below elbow cast, but whenever there is inclusion of the thumb, it is for scaphoid. Whenever there is no inclusion of thumb, it is a Colles cast. Okay, that is the main important thing which you have to remember. And then what is this? Yes, this is an attitude of the limb where you can see and identify. Very, very important again. What is this attitude? What is this attitude? This attitude is called flexion, abduction, adduction, and internal rotation, right? Flexion, adduction, and internal rotation. It is farther. Flexion has, yes, it is a posterior dislocation of the hip. Very, very right. And this is the attitude. And looking at this attitude only, you can tell that this belongs to posterior dislocation of hip. And what is the complication of this? What is the complication of posterior dislocation of the hip? It can result in what is called as the sciatic nerve, that will present as a foot drop. So what is the important thing which you have to do here? Immediate reduction. So you have to always go for the immediate reduction, and this reduction is mainly done under anesthesia. Right? So this is about the posterior dislocation of the hip. The attitude is very important. It is the flexion, adduction, internal rotation. And what is the attitude of anterior dislocation of hip then? If it was an anterior dislocation, what is the attitude? The attitude is Faber, flexion, abduction, and external rotation, right? So this is important, Faber and Faber. Faber is for your posterior hip dislocation, Faber is for your anterior hip dislocation. And now what is this? Identify the prosthesis. Which prosthesis is this? Yes, quicker. Yes, very good, Faber. Faber for anterior dislocation of the hip. Okay, now so this is not Thompson, this is a bipolar prosthesis. Why did I tell it is a bipolar prosthesis? I will show the two. Sorry, I did not get Thompson's for you. So this is a Moore's prosthesis here. So Moore's, how do you remember? There are two holes. There are two holes, and the two holes, this is Thompson's. And whenever you want to tell it as a Thompson, you will see a collar type like this. So if this is your head, and you can see something like this. So this is your Thompson. So whenever you find a collar, then that is your Thompson. Thompson is always with the collar. But what is this? This is a bipolar prosthesis. This is a bipolar prosthesis. You can see the thin stem. The thin stem is there, and this is the bipolar prosthesis. And now let us discuss in detail about your very, very important question where everybody get confused. Your IC fractures, that is neck or femur fractures, and what is the age for it. So here, if the fracture is less than 40 years, okay, to maybe up to 60 years also. This is above 65 years. So here what we do is the treatment. Yes, anybody 40 to 60 years, the treatment is CC screws, right? So CC screws, cannulated cancellous screw, which is called as osteosynthesis, And the next one is above 65 years. What you do? You treat the patient with hemiarthroplasty. So what is hemiarthroplasty? Hemi is half. Arthroplasty means replacement. So you're replacing half joint. So what is that half joint? That is your femoral head. How are you replacing it? You're replacing with the prosthesis. We are replacing it with the prosthesis, right? What is that prosthesis? That prosthesis is nothing but your bipolar prosthesis. So there are types of prosthesis. One is Thompson, the second one is Moore, the third one is bipolar. But nowadays there is a shift of using only bipolar because it is easy for the patient to recover, and this processes is doing really well because there is a movement between acetabulum and the head and the neck. Hence it is called the bipolar. So movement between acetabulum here and the head and the neck. So there are two movements, hence it is called the bipolar. So this is called the hemiarthroplasty for more than 65 years of age. Below 40 to up to 60 you can go with CC screws, and if you remember we have dealt that cannulated cancellous screws, and they are put in the inverted triangle fashion like this, inverted triangle fashion. So this is called as the osteosynthesis and mainly used for your neck of the femur fractures. Is that clear? Yes. And what is this now? What is this? So now once you identify the bipolar prosthesis, so this is a bipolar prosthesis again, but if you see there is a difference between this bipolar prosthesis and this bipolar prosthesis. You can see there is a cup which is also replaced. So this acetabulum cup is also replaced, hence replacing both acetabulum and the femoral head. So it is a complete joint, right? So femoral head and acetabulum forms the hip joint. You're replacing the complete hip joint. So you're calling this as total hip replacement. So this is nothing but your THR, the total hip replacement. So this is your total hip replacement. So that was your hemiarthroplasty, where you can see, you can identify the cup is not present. So this is the head which you're seeing. But here you can see, you can put both images together and see there is a cup which is replaced here. So this is called as your total hip replacement, where the complete hip joint is replaced, the acetabulum and the femoral head, right? And now, so this is your what? This is your CC screw. So if you see again, for age below 45 to 50 years, whenever there is an IC fracture, we can treat with these three screws which are called as the cannulated cancellous screws. So these are called the CC screws, and this is your CC screws fixation. Okay, so this has been clear. So this is your inverted triangle fashion. So this is what I was talking about. Inverted, these are also three screws. The one is here, the second one is here. You can't see on the AP view. On the lateral view, it shows your inverted shape of triangle like this. And if you see, I've told you the cancellous threads are there. No, this threads has to cross the fracture. Hence, these threads will cross and hold the bone, and now because you're tightening it, the fracture gets compressed. That is why it is important for the threads. There are only half threads which we use here, not complete threads. So half threads which we use, and the threads has to cross the fracture. So this is the cannulated cancellous screws, right? Is this clear? I think implants are very much clear now. So we have dealt with the wide variety of implants: DCP, LCP, external fixators and prosthesis. Your hemiarthroplasty, we have dealt with Moore's, Thompson's and bipolar. Okay. Yes, then what is this? This is angles which we are talking about. So there are two important angles. One is your Bohr's angle. So this is the Bowler's angle. This is your Ghissane angle, or angle of Ghissane, the Bowler's and the Ghissane angle. So what is Bowler's and what is Ghissane? Yes. What is Bowler's and what is Ghissane? So here if you see, this is the posterior facet, right? So this is the tip of the calcaneal tuberosity here. This is the anterior facet and this is the posterior facet. So once you draw a line which is touching these two and another line along this one, and that there is an angle which is forming there, that is called the Bowler's angle. And along the facets, if you draw a line, this is called as angle of Ghissane. So what you have to remember, only one thing, that is the Bowler's decreases and Ghissane increases in case of your calcaneum fractures, right? So calcaneum fractures, first you remember these two angles are used for calcaneum fractures, right? In the calcaneum we use, and whenever there is a decrease in the Bowler's or there is an increase in the Ghissanes, then there is a calcaneum fracture which is not fixed properly. So usually we see it post-operatively. So usually what we do, we measure these angles pre-operatively, and then post-operatively we measure. Usually these angles should be restored whenever you're treating the calcaneal fractures. So very, very important, the Bowler's angle and the Gissen's angle, right? So Bowler's is, I've told you that it is drawn along the this is the calcaneal tuberosity here, the tip of the calcaneal tuberosity, upper one, and the line is drawn along it. And here, if you see, this is the anterior facet. So proximal part of the anterior facet, and this is the posterior facet, and touching these two, you draw one more line. And this is along the facets like this, and this is called the angle of Gissen. Okay? Yes, we are done with the angles. And then what is this? This image is about, this is nothing but your straight leg raising test. So what do you mean by straight leg raising test? So he's the surgeon who is trying to lift the patient's leg, but it is put straight. That means putting completely straight. How do you do that? You do that by extending the knee. So knee in extension, passively the patient's leg is lifted. And now if the patient winces with the pain, it means that there is a stretch in the sciatic nerve. So there is a stretch in the sciatic nerve, and this stretch in the sciatic nerve is because of prolapse intervertebral disc. So this is the PIVD which we identify by doing this test, which is called as a straight leg raising test. Is that clear, guys? So straight leg raising test is done for PIVD. This is the passive. This is passive. Then what is active straight leg raising test? There is one more thing which is called as active SLRT. So what is this active SLRT? Active SLRT is patient is advised to do the test. So this is for testing the hip joint. If the hip joint is stable, if there are no fractures in the hip joint, then the patient will stably lift the leg up. That is called as active SLRT. So what this surgeon is doing, he is doing a passive SLRT. So passive SLRT is mainly for testing your proximal. Yeah, that is the test. So this is straight leg raising test mainly for the PIVD, prolapse intervertebral disc. So let us see what is actually a prolapse intervertebral disc. So this is the vertebra, this is the vertebral body, right? And hence we have this disc in between. And why this disc is very, very important for us? Because this disc contains annulus fibrosis, and in the center you have the small structure which is called as nucleus pulposus. So this nucleus pulposus is always under tension. That means it wants to escape from annulus fibrosis. Okay, so when does it occurs? It occurs whenever there are annular tears. So these annular tears whenever are there. Why this annular tears occurs? This occurs because maybe some mechanical problem or some stenosis. So there is some mechanical problem, some stress over the vertebral body. So ultimately there will be some tear, right? So there is some tear in this annulus fibrosis. So now this NP escapes from the tear and it will not keep quiet, right? Especially on the posterior aspect, what you see is this will irritate the nerves which are present on the posterior aspect. So this nucleus pulposus will come out of the annulus fibrosis, that is the disc, and now it irritates this nerve fibers. So whenever there is an irritation of this nerves, what will happen is it will result in a condition which is called as sciatica. It is called as sciatica. So posteriorly there is only one important big nerve from the proximal to the distal, one important nerve which is called as the sciatic nerve, and now this nerve gets disturbed, right? And depending upon the disc level, which, so we are having multiple levels like L4, L5, S1. So the vertebral bodies are named accordingly. So vertebrae are named accordingly. So whenever there is a prolapse in particular disc, then they will ask you which nerve is getting affected, right? So then how do you do that? So here what happens is whenever there is an L4, L5 disc prolapse, so just imagine taking this as example. So this is an L4 body, this is an L5 body, and this is an L4, L5 disc. So if there is an L4, L5 disc prolapse, so there is disc prolapse happening here, usually the L4 nerve root will exit below the vertebra, but the L5 will traverse. That means it will go along the disc to the below level, right? It has to exit from here. It has to exit from here. So it goes below that level. So whenever there is a disc prolapse, the traversing nerve root gets affected. Okay, this traversing nerve root is, so L4 L5 disc prolapse, there is a problem in the L5 nerve root, right? So this is what the question will be. If there is a L4 L5 disc prolapse, which nerve gets involved? Is it L4 or L5? So the answer is L5. So if it is an L5 S1 disc prolapse, so this is the disc prolapse which is happening here. So which nerve is getting affected? So this is the S1 nerve which is getting affected, right? Is that clear? If you don't understand anything, just mark the below level. So L5 S1, S1 will get affected. L4 L4 L5, L5 will get affected. Is this clear? Yes, I want a yes. Yes, yes, clear. Very good. Okay, now moving on to the next one. So what is this? So there are three important conditions in the spine which you have to remember. The first one is prolapse intervertebral disc. For that we have learned about the SLRT, and then we have learned which nerve is getting affected. These are the two important questions they would usually ask. And now what is this? They will put this X-ray and ask you what is this. So here you have to identify that if you draw a line along this, so this is the problem here. And if you draw the line along the posterior aspect, again there is a problem. So that means there is a forward protrusion of this vertebra over this vertebrae, right? And assuming this as your S1 vertebra, this is your L5 vertebra, this is your L4 vertebra, right? So what is the answer? The answer is L4 L5 spondylolisthesis. Spondylolisthesis. So what do you mean by listhesis? It is nothing but your protrusion of the vertebra. Protrusion of the vertebra. And why actually this occurs? Why actually this occurs? This occurs because of spondylo. This occurs because of spondylolysis. What is lysis? Lysis is break. Where is that break occurring? The break is occurring in the pars interarticularis. Pars interarticularis. So what is this pars interarticularis? It is a particular area which is usually connecting the posterior part of the vertebra to the vertebral body. You go back to the anatomy and identify the pars interarticularis. So there is a break in this pars interarticularis, and then because of the break, it will result in spondylolysis. So this can also be identified on the X-ray. But if the patient further neglects this spondylolysis, it will result in what is called as spondylolisthesis. It will result in what is called as spondylolisthesis. So here, this is the spondylolisthesis. How do you identify? You have to draw a posterior line along the posterior border of the vertebra, and you can see there is a step here. So this is called as pars spondylolisthesis. And on clinical examination also, if this is very prominent and the patient is very thin, you can identify the step sign. So you will palpate all the posterior facets. This is the spinal processes, posterior spinal processes you will identify. So one will not be there, and identifying the other one, you will feel a step there. So that is called a step sign on clinical examination, right? And this spondylolisthesis, usually they present with Scottish dog sign. Scottish dog sign. There are various signs which you have to remember. The ears of the dog, okay, and the body of the dog, the eyes of the dog. The most important one is the eyes of the dog are nothing but your pedicle, right? So that is the Scottish dog sign, which is usually seen in spondylolisthesis. Clear? Yes? Okay. Now we have completed two important things. So one is the PIVD I have done. The next one I have done is spondylolisthesis. I have told you there are three important conditions in this spine, chronic conditions. So the third one I'm talking about is lumbar canal stenosis. So this is very important, lumbar canal stenosis. That means there is some problem in the canal, right? So canal is becoming slightly closer, that is the area is becoming narrower, that is called as stenosis. And what is the what is this? This is called the shopping cart sign. This is called the shopping cart sign. So why actually this stenosis is occurring? So this stenosis can be because of prolapse intervertebral disc. It could be a disc problem, or it could be a mechanical problem, or it could be a fluorosis. So there are multiple reasons for lumbar canal stenosis, right? So canal is where the nerves travel through. So this canal is closing. That means there is a problem in the canal. It could be because of the calcification of ligamentum flavum. So there are multiple problems which is causing this stenosis. But what is important for us is, so these symptoms, the patients present with backache, right? And most important thing, what they present with is neurological claudication. So they present with neurological claudication. So what is that neurological claudication? So they will have pain on walking, and then with paresthesias. Okay, they will have pain on walking and paresthesias. So neurological claudication is nothing but, what is paresthesias? Paresthesias is nothing but tingling and numbness. It is tingling and numbness. So if a patient is having pain in the back with the tingling and numbness, it could be a prolapse intervertebral disc, or this disc can further present as a lumbar canal stenosis. It can further present as lumbar canal stenosis. So what happens in this lumbar canal stenosis is, whenever the spine goes into flexion, pain is relieved, right? And whenever spine is in extension, pain is increased. Right, so exaggerated pain in spine extension, on flexion this pain get relieved. So whenever you are using a shopping cart in case of your supermarkets, so if you remember, you will pull the cart like this. No, whenever you're pushing the cart, you will slightly flex. So on this flexion the pain is relieved. So this is called as the shopping cart sign. So this is seen in the lumbar canal stenosis. This is seen in the lumbar canal stenosis. Okay, and what are the symptoms of stenosis? You will see backache with the neurological claudication. Okay, so that is it for three important spine cases. And the fourth and most important one, PYQ, this is the 𝐒𝐄𝐝's angle. So this is the 𝐒𝐄𝐝's angle, and where you measure or identify this angle is mainly seen in case of your scoliosis. So scoliosis is nothing but a deformity in spine. So this is a deformity in spine, and this S for S, that is a sideward deformity. Right, forward deformity is kyphosis, and a side deformity is a scoliosis. So here, how do you draw a 𝐒𝐿P's angle? So first you identify the vertebra here. So from this vertebrae to this vertebrae there is a deformity, right? So you will identify the first apex vertebra. So this is the apex vertebra, this is the apex vertebra, right? And then what you do is you draw a line along the superior end of one and the inferior end of the other, right? And then you draw a perpendicular lines for this. So this angle or this angle is the 𝐒𝐿P's angle. They don't push. So this is the angle. So these are the angles which you have to identify. So this angle and this angles are same. This is called as the 𝐒𝐿P's angle. So why you have to identify? So normally they should be less than 20 degrees. Okay, 20 to 40 degrees and more than 40 degrees. Right, so this is the 𝐒𝐿P's angle you identify, and if it is less than 20 degrees, you do nothing. You tell the patient that he has to be under observation. And if it is 20 to 40 degrees, you tell the patient has to wear the braces. There are two important braces which can be used, the Milwaukee brace and the Boston brace. So the Milwaukee brace and the Boston brace are the two important braces which you have to use. So for this scoliosis. Okay. And then we have more than 40 degrees. More than 40 degrees, you have to undergo surgeries. For more than 40 degrees, the patient has to undergo surgery. Fine. So that is about the 𝐒𝐿P's angle. Yes, Adams forward bending test is mainly to identify between a pathological scoliosis, right? So sometimes what happens is whenever there is a problem in the hip, the spine goes into the spine. The spine will compensate it for the hip problem. So that is called as physiological scoliosis. So it is some basic rescue for the hip joint. So to rescue the hip joint, the spine goes into this scoliosis, right? So whenever you do this Adams forward bending, on bending, if the scoliosis disappear, it is a normal. That means it is just a physiological phenomena, right? And if on bending still it is present, then that is a pathological scoliosis. That is the Adams forward bending test. That is for doing your identifying between a functional and a pathological scoliosis. Okay. Yes. Then these are the two important braces I was talking about to treat the scoliosis. Whenever the angle is 20 to 40 degrees, you have this Milwaukee brace. The second one is your Boston brace. So how do you identify? The Boston is mainly for thoracic region. If you see, Boston is for thoracic and Milwaukee is usually up to this mandible. Okay, the neck is also involved. So whenever there is a cervical scoliosis, you go for this Milwaukee, and thoracic scoliosis, you go for your Boston's brace. Okay, so that is about the spine chapter. Any doubts? Yes, then we are going to arthritis. So there are certain joint disorders which you have to remember. One is arthritis, the osteoarthritis. The second one is rheumatoid arthritis. So rheumatoid is very, very important. So what is the importance of this rheumatoid? The first thing, it is usually seen in the young individuals, and this is an inflammatory condition, right? So there are various things which are involved. The most important one is the RA factor, which is increased, right? So there you see there is an increase in the RA factor and its inflammatory conditions, and there are various joints which are involved, and especially what you have to remember is the involvement of the MCP joint, right? So very, very important, the MCP joint are involved, then involvement of the PIP joint, right? Then comes your DIP, and then comes your wrist joint, and then comes your knee joint. So usually what happens is the DIPs are spared in case of your rheumatoid arthritis, or less involved. So MCP and PIP is most involved, then comes your wrist and the knee joint, right? Okay, so and what you have to remember about the rheumatoid arthritis is various disorders. So one is the Botinius deformity, the next is the swan neck deformity. So these two are very, very important. So how do I identify Botinius and swan neck? Swan neck, you see BP. Botinius is, so this is this. So you will first decide which one you want to remember, whether you want to remember a Botinius deformity or your swan neck deformity. I recommend remember the swan neck deformity because you can put like this. This is an important thing. I mean, you will not get confused. So whenever there is a swan neck deformity, there is a flexion in the DIP. So this is a flexion in the DIP. Remember FD, flexion in the DIP, right? And then there is an opposite, that is extension in the PIP. Whereas BP, if you want to remember Botinius is flexion in the proximal, extension in the distal, right? So this is up to you, whatever you want to remember, but only remember one thing. If you want to remember FT, that is flexion in the DIP, it is the swan neck, that is FT. BP is Botinius, that is flexion in the PIP and extension in the DIP, okay? And there is ulnar drift, as Rishabh has mentioned. Yes, there is a drift. That is usually what happens is all the joints involved and then just move like this to one side. So moving towards the one side, that is called the ulnar drift. And there are various deformities. Z deformity, which is seen in case of thumb. So this is a Z deformity. So one deformity in the MCP, the other deformity in the IP. This is called the Z deformity. Okay, so these are the important deformities. Please remember Botinius and swan neck, and you remember the involvement of the joint. So MCP is the one important joint which is very, very important, and usually they are associated with the morning stiffness. So Jumble Studio, are you talking about the rheumatic fever and the rheumatoid arthritis? So one is rheumatic fever that is dealt separately, and this is rheumatoid arthritis. This is inflammatory arthritis of the joints. Okay. So that is about the rheumatoid arthritis. Okay. And then what is this? I think this is all your favorite topic. Yes, this is your favorite and most important topic. This is your ankylosing spondylitis. So what all you have to remember about ankylosing spondylitis? So first you remember it is again seen in the young because this is also an inflammation, and it is seen in the males, and it is related to HLA-B27, which is an important gene. HLA-B27, right? And then you see it is related with enthesitis. So the ligaments and tendons are involved, and it is also involvement of other systemic, that is pulmonary, where patient present with breathlessness and patient present with uveitis, right? Eye involvement or cardiac complications. So these all you can see in case of ankylosing spondylitis, and this is called the calcification of the posterior longitudinal ligament, and this can be seen as the dagger sign. So this is seen as the dagger sign in case of your ankylosing spondylitis. So these all you have to remember: HLA-B27, enthesitis. So they will put this question associated with involvement of tendons. That is, mainly they'll ask you, maybe patient have bilateral heel pain, or patient is having pulmonary problems, such there is a complication in breathing, right? And this is a Schobers test which you have to do. That is decrease in the flexion of the spine. Okay, decrease in flexion of the spine, that is Schobers test, which is done for your ankylosing spondylitis. Okay, and then what is this? This is the formation of the syndesmophytes. So formation of the syndesmophytes, where everything fuses. Fusion of entire spine. Okay, fusion of entire spine, right? And this is called as the bamboo spine. So this is called as the bamboo spine. And what is the most important thing? So ankylosing spondylitis is involvement of the axial skeleton. That means there is an involvement of the SI joints and your spine. So appendicular skeleton is not involved, axial skeleton is involved. So SI joints plus spine which is involved, and this is called as fusion of entire spine, bamboo spine, and calcification of the PLL, which is called as the dagger sign. And this is all about the ankylosing spondylitis. So first you identify the SI joints involvement, and then you confirm your ankylosing spondylitis. And then coming about the metabolic disorders, there are two important metabolic disorders which you have to remember. One is your rickets. The second one is your scurvy. So what usually they ask is about the X-ray findings. So X-ray, if you see, this is seen at the growth plate, where we see, because rickets is decrease of calcium and phosphorus, so the minerals are absent, right? So whenever the minerals are absent, it means there is a lucency. So lucency is, you can see in terms of cupping and fraying, so absence of that lines, and then you have playing, right? So cupping is nothing but it is a cup shaped, right, like this, and fraying is something like this, and splaying is extension of this. So this is cupping, fraying, and splaying which you see in rickets. And the scurvy, this is because of defect in collagen. So there is a defect in collagen cross-linking because of vitamin C deficiency, right? So this will result in what? This will result in, again, you see calcification is normal here. So you can see everything in white color. White. So it is right, white line of Frankel, right? And the ring epiphysis, which is surrounded by a white line around the epiphysis. So this is about the scurvy. So scurvy, you see there is a provisional zone of calcification, which is called as a white line of Frankel. So this is the white line of Frankel, again white line. And ring epiphysis, these two are important, which are surrounding the epiphysis, a thin line, again a calcification, that is again a sclerotic, right? And then just below it, you see there is a subperiosteal hemorrhage because of the weakness of collagen, and then you see this corbatic zone where there is an absence of collagen formation, hence you can see a lucency again in case of your scurvy, right? So these are the two important things. One is your rickets, the second one is your scurvy in case of your pediatrics. And how do you treat them? This you treat with vitamin D, and this you treat with vitamin C, right? Okay, then what is Barlow's disease? What is Barlow's disease? Barlow's disease is a combination of both vitamins, vitamin D plus vitamin C deficiency together, right? Yes, next one. Yes, this, identify the next one. So this is nothing but hyperparathyroidism. So this is hyperparathyroidism. So what is that? So there is an increase of parathyroid hormone where this will cause increase in calcium and decrease in the phosphorus. So this is an example of a Brown's tumor where you can see a lytic area which is similar tumor-like presentation, right? It is tumor-like presentation. This is nothing but fibrosis, osteitis cystica. So there is a fibrous tissue which is present as a cyst, and this is present in brown in color. This is not a soap bubble or this is not a GCT. Please Harsh, this is not GCT. This is Brown's tumor, fibrosis or osteitis cystica. In soap bubble appearance, you see everything like a bubble, like it is lytic, right? And it is seen as encroaching on the bone. It sees an encroaching on the bone. This is an example of the Brown's tumor. But sometimes usually we can get confused between GCT and hyperparathyroidism, but this particular x-ray is very, very specific. You have to see, and once we come to the GCT, I will tell you the difference, right? Okay. And GCT, if you see, it is seen in the epiphysis. Here the epiphysis is almost clear. Okay. Okay, then what is this? The second one. This is an example of ivory vertebrae. Ivory vertebrae, picture frame vertebrae, ivory vertebrae and picture frame vertebrae. These two are examples of what? These two are examples of your Paget's disease. So what is a Paget's disease? Paget's disease is a condition again seen in elderly people, mostly about more than 60 years, because of the defective. What is defective here? What is defective here? So usually what happens is the dynamicity of the bone. So bone will form, again it will resorb, again it will form, again it will resorb. So that is how the bone functions. But in case of your Paget's disease, what happened because of any virus, it is mainly the parvovirus or some mutations, what will happen is this resorption is not present. This resorption is not present in this. So it becomes defective. Hence you can see the sclerosis. Hence, you can see this sclerosis. So this is an example of the Paget's disease, usually seen in elderly people. And only one thing which you have to remember is there is an increase in the alkaline phosphatase. Rest, everything is normal. Only the alkaline phosphatase is increased here, right? And patient sometimes may present with the increase in the hat size. That is what they say, because the head grows. Because of the head grows, and they will again present with deafness, right? So this is deafness and increase because of the sclerosis. Autosclerosis also occurs and they will present with deafness. And because of the increase in the head size, that is, there is increase in the head size, right? So that is how we identify the Paget's disease. So one is the ivory vertebra, the second one is picture frame vertebra, because there is a first there will be resorption, and then there will be formation, and again resorption. So this is the phases where they undergrow, and this will result in what is called as your picture frame vertebrae. Picture frame vertebrae. And then what is these two? These two are examples of osteopetrosis. So what is osteopetrosis? It is also called marble bone disease. Yes. And this is a genetic disorder, right, where there is a osteoclast deficiency. So there is a defect in the osteoclast. Hence, again, the resorption is a problem. Because osteoclast is mainly involved in resorption, right? So because of the resorption is problem, again, it is resulting in sclerosis, complete sclerosis. And the medulla is completely occupied. So patient might present with pancytopenia. And again, because of the sclerosis, again, there will be deafness. Right? So these are the this is called the marble bone disease. It is called the osteopetrosis. And this is a rugged jersey spine. You can see in osteopetrosis. And it is also seen in hyperparathyroidism as well. So rugged jersey appearance is seen in both hyperparathyroidism, sometimes in Paget's, and also in your osteopetrosis. It is nothing but striations. It is nothing but striations. So one area of resorption, one area of absorption, resorption, absorption, resorption, absorption. So this is called as the rugged jersey appearance. Okay, so please be clear. So here the Paget's and the osteopetrosis and the thing is same, that is resorption is problem, but this is usually occurring in the elderly, and osteopetrosis can be seen genetically from the childhood. So congenital osteopetrosis is also present. So this is a complete sclerotic, that is marble bone disease, and this is an example of more minimal form where there is a resorption and problem in the absorption. Yeah. Yeah, osteoclast is mainly the defect is mainly in the proton pump and the acidity. So there should be an acid environment for the resorption. So that problem is there in the osteoclast. So there is a defect in the osteoclast where the resorption is a problem. So that is the osteopetrosis. Okay, then what is this? This is one more interesting thing. This is osteogenesis imperfecta. So again, it is a defect in a genetic deformity. So where there is a weak in the collagen because of COL-A1 and A2 gene. So these are the two genes where there is a problem. Hence, they will result in osteogenesis imperfecta. Because of a collagen, the bone breaks, right? The bone breaks and result in fractures. And one thing what you have to remember is healing is normal. The healing is normal. So you will see multiple stages here. So here one stage of healing, one stage of healing. So again, because of this, they get deformed because the bones are again weak because of the collagen. So this is because of the osteogenesis imperfecta. This is not fibrous dysplasia. Fibrous dysplasia is usually seen in one part, that is a proximal femur. This is, you can see the multiple fractures here. So this is fracture, this is one fracture, right? And this is usually seen in the, see, this is the, mainly, even if you see the x-ray, the first thing is you have to know the history. It is not that you will jump into conclusion. First, you will know the history. So in the exam also, they will put up this x-ray and they will tell you this particular patient had so and so fractures, or this patient has a blue sclera, right? Or this patient has a hearing problem. So now all these are related to your osteogenesis imperfecta. Okay, this is not fibrous dysplasia. This is osteogenesis imperfecta. Okay, multiple fractures are seen, but the healing is normal. This is because of the collagen, and there is a classification which is called as the silence classification. There are 6 types of osteogenesis imperfecta. Okay. Yes. Next. Okay. Now this is about the infections. So what you have to know about the infections, there are 2 types of infections. One is acute infection. Second one is chronic infection. And the third one is subacute infection. Right? So whenever I say acute, it is acute osteomyelitis, and this is about bacteria. So bacterial infection. So this is acute osteomyelitis, then we have chronic osteomyelitis, then we have subacute osteomyelitis. In acute osteomyelitis, what you see is less than 24 hours, the patient will come with pain and severe pain and fever and all acute conditions. So they will come with fever, they will come with pain, there will be increased WBC, right? So this is all there in acute osteomyelitis, right? And usually X-ray changes will be normal. and you treat them with the 2 weeks of antibiotics, right? But what is important for us is chronic osteomyelitis. So in case of chronic osteomyelitis, what you see is the most important thing, that is your sequestrum. Sequestrum is a dead bone which is present. So sequestrum is a dead bone which is present, and this sequestrum, whenever is present, it will not help, or it will not help, or it will not allow the bone to heal. So this is that dead sequestrum. So this is that sequestrum, right? So this is that sequestrum what I was talking about, which is very dense in structure. Because it is dead, there is no resorption. So whenever there is no resorption, the bone appears dense. So hence this sequestrum is dense but is surrounded by lucency. So this lucency is nothing but your granulation tissue. So this lucency is nothing but your granulation tissue, right? So whenever there is a dead bone surrounding by lucency, this is called as sequestrum. There are types of sequestra based upon the infections, and there is a table which is given, friend. You can read about types of sequestrum in that. Okay. Now what you have to remember is this is treatment is sequestrectomy. So you have to remove the sequestrum. So treatment is sequestrectomy. And here when it appears acute, acute is whenever the host is weak and the organism is virulent. Here host is very weak, virulent organism, you will result in this. But subacute, host is strong. Okay, so whenever the host is strong, and that results in what is called as subacute osteomyelitis. Host is little strong here. So then you will see this is Gary's hyperostosis. So where you see there is a multiple, you can see that there is an increased calcification at that area. So there is Gary's sclerosing osteomyelitis. Sclerosing means there is increase in the bone formation. So there is a Gary's sclerosing osteomyelitis is again a subacute condition. This subacute condition is where the host is fighting with the bacteria. So the host is fighting with the bacteria, hence the bacteria can be, put up at a place and it can be treated well. So the bacteria is not able to spread. So in chronic osteomyelitis, what happens is the bacteria spreads from the bone, it goes into the soft tissues, then it goes into the skin. So on the skin, you will find what is called as sinus. So this sinus tract is formed. So the host is not able to control the bacteria. But here in subacute, what is happening, the host is able to control the bacteria, and this is called as Gary's sclerosing osteomyelitis, and this is called as the Brodie's abscess. So here what is happening, the host is able to put the bacteria into one particular area which is called as Brodie's abscess. So this is a lucency which is seen again in the metaphyseal region. Usually the infections occurs in the metaphyseal region, right? So here the bacteria is weak, the host is strong, hence you can localize that bacteria. So this is called as Brodie's abscess, and this is called as Gary's sclerosing osteomyelitis, right? So these two are important subacute conditions. And then we are dealing with the tuberculosis. This was again asked in the knee exam. So tuberculosis is mainly disc is involved, and the most common form is your paradiscal. The most common form is your paradiscal, where the disc is involved above the vertebra, below the vertebra, and you can see this is nothing but knuckle, kyphosis, and gibbous. Knuckle is only one vertebra, gibbous is two vertebra, kyphosis is three vertebra. Knuckle 1, gibbous is two vertebra involved, kyphosis is more than three vertebra involved, right? So this will result in what is called as a complete formation of the pus. So this is seen as bird nest appearance on X-ray, right? Bird nest appearance. This pus is seen as bird nest appearance on the X-ray, and you see this is the MRI. So the investigation of choice is always MRI. Investigation of choice is always MRI in case of your tuberculosis spine. So tuberculosis spine is also called as the Pott's spine. Is also called as the Pott's spine. So what is the treatment? It is middle path regime. The treatment is the middle path regime, and usually what happens in this middle path regime is they try to treat it conservatively. They try to treat it conservatively. And whenever the patient is not responding properly, then we go for a surgical treatment. So remember, tuberculosis caused by Mycobacterium tuberculosis, port spine, and most common area involved is your dorsolumbar area. DL spine is the most common one which is involved. And what you will see decrease in weight, a decrease in appetite, right? So these are the things which you see, and the patient will present with the other symptoms also, like weakness and movements, decreased movements in the spine. So whenever there is only one vertebra involved, the deformity is knuckle. Two vertebra involved, the deformity is gibbous. Three vertebra is kyphosis. The most common form is paradiscal, and the treatment of pot spine, which you have to remember, is middle path regime. So this was not asked till now, so they might ask you the middle path regime. The middle path regime is nothing but a conservative approach to treatment of the TB spine, right? And what is the brace which we used? We used the Taylor's brace. This is very important. So Taylor's brace is used for treating your tuberculosis spine. Okay. Then this. Okay, what is this? This is a form of DDH where the head is completely absent, right? Okay, DDH is a condition which is called as developmental dysplasia of hip, and it has a neonatal or newborn screening protocol. So this screening protocol has two important tests. One is your Barlow's. The second one is your Otterlony. So Barlow's and Otterlony are two important tests which can be done to identify your DDH, right? And then what is this splint? This is called as DB splint or Dennis Brown splint. It is mainly used for your CTEV procedure, right? CTEV, once you treat with the casing, after casing, the maintenance period is with your DB splint. So DB splint is mainly used for your casing. After casing, you will put the patient on this CTV for about 3 months. Okay, first initially for 24 hours, next for 12 hours, right? So this is the DB splint. And what is this? CTEV shoes. So once the patient start walking, so your CTEV patient starts walking, what happens is the patient will go into CTEV shoes, right? So CTEV shoes has three important features. First, there should be a straight inner border. So to prevent what? Cavus. And outer should be raised, right? The second outer border should be raised. So again, it will not go into adduction. And again, it should not go into plantar flexion. So there is no heel. So these three important features you have to remember. The straight inner border, that means it should be straight. It should not go again into cavus or inversion. And outer is raised. So it will not go into adduction. And then it should not go into plantar flexion, right? So this is no heel technique. And remember CTEV, there is a mnemonic that is cave. So this is the deformities. One is the cavus, adduction, varus, equinus, right? So this is the order of the deformity which should be corrected, and this technique is called as your Ponseti's technique. This technique is called as the Ponseti's technique, and as soon as possible you have to start the treatment. Treatment is started as soon as possible, and the treatment is nothing but your casing. So weekly we change the casing, and this is the order which we correct, and this is called your Ponseti technique. After correction of that, then we put them in DB splint. After that, we put them in your CTEV shoes. Okay, and these are the two tests which I was talking about, your Barlow's maneuver and Otterlony's maneuver, and this is mainly used for screening of your DDH. And what is this? Treatment of DDH. Treatment of DDH is, what is this? This is called as your Pavlik harness. This is called your Pavlik harness. This is a splint which is used for putting the limbs in abduction. Limbs are put in abduction. So this is an image based question. Again, they will give and identify. So this is the chest strap, and this is the abduction strap here. This is the abduction strap, and this is your flexion strap. So this is the flexion strap and abduction straps. These are used to put the limbs in abduction, and this is the treatment for your DDH less than 6 months of age. So whenever the patient is less than 6 months of age, you will treat it with the Pavlik harness. If it is more than 6 months, you have to go for your hip spica. You go for your hip spica. Okay. And then what is this? This is nothing but your Perthes disease. It is nothing but your Perthes disease. Okay, we are past time. So this is Perthes disease, usually seen in 4 to 8 years of age group, and this is nothing but your avascular necrosis of the femoral head. It is avascular necrosis of the femoral head, and the treatment is nothing but containment surgery. So you have to put the head inside the acetabulum. That's it. So this is called as the containment surgery. So putting the head back into the acetabulum is the only treatment which we give for the Perthes disease, and it is a self-limiting disease. So this is a self-limiting disease, right? And then this is Salter-Harris classification. So Salter-Harris, as the name goes, Salter. So there are 5 types: 1, 2, 3, 4, and last one is 5. So ER is nothing but your crush injuries, right? So crush injury completely damaged. But Salter for S, it is growth plate. So straight through the growth plate. So these are the injuries whenever there is involvement of the growth plate. We use this classification which is called as Salter-Harris classification. So it goes straight. This is stage of hypertrophy, right? So there is a various levels in the growth plate, various areas. So there is a hypertrophic zone which is present. So this hypertrophic zone, you will see the fracture which is happening, because that is the zone of hypertrophy, is the weakest area. So this fractures occurs through zone of hypertrophy, right? And then it is above the growth plate. Above the growth plate is metaphysis, right? So it occurs to the metaphysis, and this is lower. Lower is below the metaphysis, that means involving the epiphysis. This is through, that means it is going all three. That is your metaphysis, that is your physis, which is growth plate, metaphysis, epiphysis, and finally complete injury, that is your crush injury. So this is a Salter-Harris. So what you have to remember is, first question they'll ask you which is the weakest zone, that is zone of hypertrophy. Then the second question is, involvement of metaphysis is seen in case of your Salter-Harris type 2. Involvement of epiphysis is seen in Salter-Harris type 3. Involvement of all the three is seen in Salter-Harris type 4. And one more important question is Thurston-Holland fragment. Thurston-Holland fragment. This fragment is seen in which type? So this is seen in type 2. So type 2, whenever the metaphysis is involved, there is a small fragment which is present. So this fragment is called as Thurston-Holland fragment, right? So these are the questions. And what is this? This is an example of a pediatric fracture which is called as the torus fracture. So buckling of cortex is called as torus fracture, usually seen in toddlers, okay? And what is this? This is a green stick fracture. Green stick fracture is nothing but the pediatric bone is increased in water content. So the water is more. And whenever you try to break where something which is very wet, so take a stick which is wet and you try to break, it will not break easily, right? So there is a break in one cortex and bend in other cortex. So other one will only bend. So one is break, second one is bend. Here there is only bend or buckling in only one cortex. If you see, this is a buckling, right? So this is the buckling. So this is a torus fracture, right? And here this is a green stick, where you see there is a break in this cortex, bend is the other cortex. So this is called the green stick fracture. Green stick fracture is nothing but a certain thing where the water content is very high. Because of that, you can't break it easily. So one part will bend, the other part will break. So that is called as green stick fracture, seen in pediatric population, right? And now nerve injuries. So this is your claw hand, and we have dealt with it. It is mainly the ulnar nerve palsy which is showing this. And this has been asked in the exam again, ulnar nerve palsy, where you see claw hand, right? And dab and pad, that is for your IGAWA test and the card test. And one important thing which you have to remember is adductor pollicis. Adductor pollicis, though it is pollicis, though it is a thinner muscle which is applied by the ulnar nerve, and this is involved in the book test. And this book test, whenever is positive, you can see the Fromen's sign. You can see the Fromen's sign. Okay, so that is it about the ulnar nerve, very, very important. And then the radial nerve, we have already dealt with it, radial nerve. So it is nothing but supplies all the extensor. So there are no specific test for it. So it supplies the extensor. You can do the thumbs up. You can ask the patient to do thumbs up. That is again the radial nerve. The treatment we already learned, that is 𝐒𝐄𝐝 splint, where you have dynamic and the static 𝐒𝐄𝐝 splint, right? So the radial nerve, this is called the Saturday nerve palsy. So why I'm talking about Saturday night palsy? This palsy is mainly because of the neuropraxia. This is mainly because of the neuropraxia. That means there is no problem in the nerve, only there is a physiological block in the conduction. This can be rectified by using the splint, right? So this is about the radial nerve, and this is the pointing index. This pointing index is mainly because of the median nerve. So this pointing index is because of the median nerve, right? So median nerve supplies the flexors, right? And these flexors, whenever they're not functioning properly, will present as this pointing index. This is also called as Ochsner's clasp deformity. This is called as Ochsner's clasp deformity. And then you can see the pen test in case of your median nerve. Again, the pen test is in case of your median nerve, the pointing index, and the O sign or the OK sign. This is the branch of median nerve which is called as the anterior interosseous nerve. Okay, that is about the nerves, all the three important nerves. Okay, and then what is this? Yes, 5 more minutes. Okay, this is Dupuytren's contracture, right? What is a Dupuytren's contracture? So you can see there is a thickened nodule here. So this is the thickened nodule. So the palmar fascia gets contracted or fibrosed, and this will present as a thickened cord. So this is called as a Dupuytren's contracture. Usually the treatment is instillation of the steroid. This could be a self Peyronie's fascia, or usually the penile fascia also gets contracted, right? So similarly like that, it is a Dupuytren's contracture, which you see the thickened cord you can see there. So that is your Dupuytren's contracture. And what is this? This is torticollis. Torticollis is nothing but bending of or wry neck, where you see the sternocleidomastoid muscle. The sternocleidomastoid muscle is contracted again, and it causes pulling to one side. So head to one side, chin to the opposite side. So this is called as torticollis or the wry neck. And what is this? This is scapula elevation. So there is scapula at one level. It is called as the Springel's deformity. So this is just an identification of the things. So this is Springel's deformity, where there is an absent of scapular descent. So the scapula has to come down, but it is not coming down. This is called as the Springel's deformity. Okay, and then this is it is self-explanatory. It is called Klippel-Feil syndrome. What you have to remember is three things. So because three things are there, very, very important for the exam, because the fourth one will be the option, right? Fourth one will be the wrong option or the right option. So the patient will have fused vertebrae. So the vertebrae will give fuse. So what you have to remember in Klippel-Feil syndrome is there is a fused vertebrae. Because of the fused vertebrae, you will have low hairline, you will have short neck, and there is a fused cervical vertebrae. That is main thing you have to remember. The fusion of the mainly in the cervical vertebrae. So cervical vertebrae, there is a short neck and low hairline. Okay, and Springel's deformity is scapula. So the scapula is not coming down. So this is the Springel's deformity. So there is a weakness in the shoulder because the shoulder movements is associated with the scapula as well. Okay. And then we have important instruments to identify. This is the periosteal elevator. So you can see the periosteum of the bone is a tough structure. So you have to remove the periosteum to deal with the bone fractures. So this is the periosteum elevator, and these are the bone spikes. So once you remove the periosteum, you have to put this spike so that you can stabilize the bone and work on that particular bone. So this is the narrow spike, and this is the broad spike, and this is also broad, heavy duty broad spike, and this is mainly used for femur. This is used for your forearm. Okay, this can be used for your humerus. And this is what? This is an osteotome. Osteotome is a sharp structure. You have a straight osteotome and you have a curved osteotome as well. Straight and curved, you have both, and you can break the bone with the help of your osteotome. So break the bone or break the osteoclasis. So whenever there is an excessive formation of the bone in case of fracture, you want to break the bone or remove the bone for bone graft, you can use this osteotome. And this is the curettage. So this is curettage, mainly used for tumors. You can remove everything, curate the cavity with the help of curettage. So this is the curettage. And what is this? This is a bone holding forceps. So once you use the periosteal elevator to remove the periosteum, then you will put this spike, right? So to identify the bone, then you will put this bone holding forceps for working with the bone again, right? And this is plate holding forceps. So plate holding forceps is, again, you will put the plate and then you will put the forceps on it so that it will hold the plate. So this plate holding forceps, the plate is nothing but your DCP or LCP plate, and then you will hold with it. So this is bone curettage. Okay. Then we have two important orthosis footwears here. So this is called the Satch footwear, right? So solid ankle cushioned heel, that is Satch footwear. And this is your Jaipur foot. So Jaipur foot, as you all know, Jaipur is from India, and this has been developed by our famous surgeon. This is P.K. Sethi, and this is an Indian version of your Satch foot. This is an Indian version. Just remember, whenever we do Indian version, that means everything can be done easily by us. So we do squatting, so squatting is easily done by this. We can do barefoot walking, so this is barefoot walking possible with this, right? So squatting, barefoot walking, and movement at the ankle is possible with this. So PK Sethi has done an extensive work, because this solid ankle cushion, they cannot walk, no barefoot walking and no squatting. So what happened is, he has used a wooden keel. So this wooden keel has been used so that you can just place your foot inside. Nothing can be done. But what Sethi sir has done is, he has used the vulcanized rubber. So this rubber will bend as you like. So you can squat with it, you can walk barefoot with it, and you can have the movement at your ankle with it. So this is called as the Jaipur foot. So this is the difference of the Jaipur foot, and this is your Satch foot. So Satch foot was originally used, but most of our people were not using Satch foot. So they have done a modification, and now we are using this Jaipur foot, okay, which is functional and economical as well. By this, we have completed the orthopedics. I think most of the part I have completed, and we have left with the tables. So these tables, I will send it as a PDF. I will write the answers and send the PDF. You can just go through the tables, because it is just a revision of all these things. Okay. So now we have done with the angles, right? So Q angle, 𝐒𝐿𝐾𝐝's angle we have done. So 𝐒𝐿𝐾𝐝's angle is talus and calcaneum. So CTV, Bowlers and Gisen is again seen in calcaneum, and alpha beta angles in DDH. So like this. So these are certain tables which you can, so these are the sequestra. So we have done about sequestrum. So these are types of sequestra. There's nothing to explain, right? So tubular sequestra is seen in pyogenic, ring sequestrum is seen in amputation, feathery sequestrum is seen in syphilis, coarse sandy in tuberculosis, like that, Bombay and black in actinomycosis. So this is just, you have to revise it. And this is again simple bone cyst. What is the most common site of adamantinomas? So they will ask, what is the most common site? So the most common site is tibia, and chordoma is most commonly seen in sacrum. So this is a table telling you that. And this is again entrapment syndromes, right? So this is carpal tunnel syndrome. So you all know carpal tunnel syndrome, and there is a median nerve entrapment, and the one important test is your Durkan's test. And thoracic outlet syndrome, you know, the lower trunk is involved, that is C8, and T1 is usually involved, right? So these are the, again, you have to just understand and you have to remember. So carpal tunnel, median nerve; pronator syndrome, median nerve; and if it is tarsal tunnel, it is posterior tibial nerve. So you can just revise it. And again, we have dealt with Dennis Brown splint, Bowler Brown splint, Thomas splint. So again, this is table, you can just revise. So Thomas splint in fracture femur, Bowler Brown fracture femur, Dennis Brown CTV, cock-up, radial nerve, knuckle bender splint, ulnar nerve, Workman's splint in Workman ischemic contracture, and aeroplane splint in brachial plexus, right? And Taylor's brace, I have told you, the dorsal lumbar tuberculosis, right? Okay, you can use in dorsal lumbar tuberculosis. And Milwaukee and Boston, we have already read, it is in your scoliosis. Tumors IBQ. Tumors is mainly Okay, tumors is not covered here. Tumors is mainly important. IBQs of tumors is you have to remember. So first is the giant cell tumor. Again, it is a soap bubble appearance, right? And then osteoid osteoma. Yeah, tumors why I have not put is usually it will be taken up in the radiology as well. No, that is why I have concentrated much on others. Okay. Tumors, they will usually be taught by the radiology people also. So osteoid osteoma, what you have to remember is there will be a central nidus which you have to identify, and the thing is they will be asking you that the night pains, and this is relieved by NSAIDs. This is relieved by NSAIDs. That is osteoid osteoma. So GCT, osteoid osteoma is very, very important, and then comes your fibrous dysplasia. Right? So the important syndrome which is associated with this, the McCune-Albright syndrome. So the McCune-Albright syndrome is the one which is associated with your fibrous dysplasia. So these are the important things which they will ask you in case of tumors. And the second one is osteosarcoma. So osteosarcoma again. So here again there is a tabular form for appearances. So sun ray appearance is seen in osteosarcoma, right? Codman's triangle in osteosarcoma. So bubble in GCT. Onion peel appearance is seen in Ewing's sarcoma, right? Onion peels is seen in Ewing's sarcoma. And ground glass appearance or fibrous dysplasia. Shepherd-Crook deformity is fibrous dysplasia. Okay, and then we have patchy calcification is chondroblastoma, right? And then we have popcorn is again chondro. So anything calcification is related to chondroblastoma, that is cartilage tumors. And homogeneous calcification, this is osteosarcoma. So bone forming tumor is osteosarcoma, right? So homogeneous calcification is again your osteosarcoma. Chicken wire is again, this is on biopsy. These two are on biopsy. So you see this on chondroblastoma, chicken wire appearance, right? Fallen fragment or simple bone cyst, double density with septa, aneurysmal bone cyst, winking oval sign. So winking oval sign where you see in metastasis, moth beaten appearance in multiple myeloma, and polka dot in hemangioma. Right, so this is it, and these are all the various features of tumors. And tumors IBQ I have wantedly not put because it is usually taken up by radiology, so we have many more to discuss also, right? So that is why I have not taken up that. Okay, so I hope we have covered enough. So osteoarthritis and rheumatoid arthritis, the thing is in osteoarthritis you see this is degenerative, this is inflammatory, right? So we have already discussed there is various deformities which are present, and this is usually associated with the early morning stiffness, right? And this is at the end of the day. And degeneration is about wear and tear. This is inflammatory products such as RA factor. And what is the most important thing you have to remember is presence of osteophytes. So there is a presence of osteophytes, right? Here you see periarticular erosions. This is an X-ray finding. So periarticular erosions, this is X-ray. And syndesmophyte. Decreased joint space is seen in both. So decreased joint space and all the features are usually seen on both, but what is main thing is osteophytes and loose bodies are usually seen in case of osteoarthritis, whereas you see periarticular erosions, and it is symmetrical. It is bilateral and symmetrical. Bilateral and symmetrical is seen in rheumatoid arthritis. So this is usually low, it is only one side. Osteoarthritis is mainly to not that symmetrical, but here it is symmetrical and there is an involvement of MCP joint, PIP joint, right? And here there is an involvement of DIP and there is a presence of nodes. Forbidden nodes, Bouchard nodes are involved in osteoarthritis, and most commonly thumb MCP is also involved in case of your osteoarthritis. Okay, so this is a difference, basic difference between osteoarthritis and rheumatoid arthritis. Okay, you have to remember there is an involvement of DIP in osteoarthritis, no DIP in case of your rheumatoid arthritis. Okay, is that clear? So this is, we have completed most of them. This again you can write on your own, the table, and the other tables, this is important again. So this is sports medicine. So various tests I have covered here. So your ACL, MCL, PCL and all are covered here. So this table will help you there. And this is again complications. And this is names of the fractures. So recently they have asked you what is the fracture of talus classification. So this was asked. So this is your Hawkins classification. So that was asked. And the second one they have asked you, Beddoes classification is used for Montigia. Okay, and third most important is your Gardens and Powell's classification is used for IC fractures. So this all you have to just read so that you will understand. Okay, and this is avascular necrosis, again various things. So Kienbock's is called lunate avian, and Perthes femoral head, Kohler's is navicular, Blount's is tibia. So again you have to remember all this. These as we have done, the U slab and hanging cast. And these are certain fractures. So I think you are very well versed with these eponyms of the fractures. Okay, I'll just fill up and send the entire PDF. Okay, because we are already running 20 minutes more. We have already taken 20 minutes more of the time. Sorry for that. Any doubts you have? Anything you want me to explain? Tumors IBQ, don't worry. That Dr. Rishabh will teach you. Don't worry about that. It will be covered in the radiology. Yes. So this will give you the entire drift, because in 2 hours we can't complete the entire portion, right? So usually this is being read by the students, right? All this you will be keep reading. So I have taken the other areas where you usually neglect. So anything else, guys? We'll just wind it up. So Dr. Vinish will be waiting for you all. Okay, then that's it. So this PDF, I will fill up this fracture eponyms and I will send it to you. You just keep reading. If you have any doubts, guys, if you have any doubts, this is not the end of our meet. So we are available on the Telegram as well. So you can ask your doubts there. We will clear it at any time you can ask. So that is it. Keep reading. Don't lose your hope. And you have to clear this exam. As SAP, I will send. Don't worry. Okay, but you have to promise me that you're going to clear the exam this time. Okay, no more meeting us again. We are going to end this for this time. Okay, okay, everything I will send. Don't worry. If you have any questions also, you can ask in the Telegram. All the best. Do well. Keep us posted. How was your paper? Tell us how was the preparation going on at the end also. Okay, bye. See you all.
ये लाइव हो गया, मैं स्ट्रीमिंग कर रहा हूँ। हेलो हेलो, हाँ मैं लाइव कर चुका हूँ, मैं दिखने का। हेलो, ये आ नहीं रहा एक्चुअली, मैं देख। हेलो, ये अभी तक स्ट्रीमिंग शुरू नहीं हुआ, मैंने लाइव कर दिया है। कर दिया है। हम्म। आया नहीं अभी तक, दिख नहीं रहा मेरे को। गुड इवनिंग गाइस, इफ आई एम विजिबल एंड ऑडिबल प्लीज गिव मी a thumbs up. Yeah, okay. Good evening guys, if I'm visible and audible please give me a thumbs up everyone. I can see everyone, all of you messaging. Dr. Rishabh, चलो ठीक है, लेट्स शुरू करते हैं, लेट्स स्टार्ट। सर मेरे को दिख नहीं रहा यूट्यूब पे। हेलो, हाँ मतलब लाइव कर दिया, मेरे को दिख नहीं रहा है, कांट सी। बफरिंग आ रही है। नहीं नहीं, इसमें तो ग्रीन है। हेलो, अब ठीक है। हेलो हेलो, good evening everyone, if I'm visible and audible please give me a thumbs up, so we'll start with the session. ओके डॉक्टर जॉन, चलो आ गया, मैसेजेस तो आ गए, मेरे को सुनाई भी दे दिया। लेट मी स्टार्ट विदाउट वेस्टिंग एनी मोर टाइम। फाइन फाइन फाइन, डॉक्टर क्रेजी फिजिशियन डॉक्टर जॉन, ठीक है, गुड नेम्स, सबके नाम्स अच्छे हैं। लेट्स स्टार्ट विदाउट वेस्टिंग एनी मोर टाइम। ओके, गुड, ठीक है। एनी क्वेश्चंस और डाउट्स यू कैन आस्क मी, आई कैन सी देम ऑन द चैट बॉक्स, अदरवाइज आई जस्ट स्टार्ट विद द सेशन गाइस। So we'll try to revise anesthesia as fast as we can. Straight away going to the point without wasting any more time. All right. The first thing that you people need to know in anesthesia is regarding Malampatti classification. I'm targeting all the parts of anesthesia where questions are asked. Some points I'll be discussing, and anyways, all of you have the workbook as well. So the first thing is Malampatti classification. Malampatti classification is one of the most important topics that comes from anesthesia. And Malampatti, first they'll ask you how do you do it. As you can see in the image, the patient has to open the mouth, extend the tongue, and do not phonate. 3 points, right? So many times it comes as a question where they'll ask you the following image is there and what is it. So you can identify by the patient having the mouth open, extending the tongue. The tongue has to be completely extended, and do not phonate. Patient is not supposed to say ah. All right, so do not phonate. These are the 3 points for Malampatti classification. Based on that, you are looking at the posterior pharyngeal structures. So posterior pharyngeal structures means all the structures which are on the back of the pharynx. Here the most important structure that you should see, all of you have studied well anyways, is uvula. First and foremost, if you can see the uvula completely, it is Malampatti 1. If the uvula is completely visible, if the tip of the uvula is not visible, it becomes Malampatti 2. If only the base of the uvula is seen, that is Malampatti 3, and uvula not visible at all, that's Malampatti 4. This is for the exam purposes. But otherwise, when you will say Malampatti 1, you can see complete posterior pharyngeal structures, which is the soft palate, the hard palate, the pillars and the fauces, all the 5 structures are clearly visible. The hard palate, soft palate, fauces and pillars. When you speak about मलम पट्टी class 2, उसमें जो uvula होता है उसका tip, the tip is the only one which is obscured, but soft palate and hard palate are visible and fauces and pillars are half. On the other hand, in मलम पट्टी 3, when you say मलम पट्टी 3, in this case the base of the uvula is the only one visible, base of the uvula, right? Soft palate and hard palate. But apart from that, you can't see the fauces and pillars. They are not visible. And Malam Patti 4 only hard palate is visible. What's the importance of Malam Patti? It correlates with the next grading. The next grading that you see over here, this is called as 𝐒𝐿𝐴 grading, or it is also called as the laryngoscopic grading. That once you put a laryngoscope, whether you're able to see the vocal cords or not. In Malam Patti 1 and 2, when you do laryngoscopy, vocal cords are normally seen. In Malam Patti 3 and 4, when you do laryngoscopy, the vocal cords are not seen. In that case, Malam Patti 1 and 2 becomes relatively easy intubation, and Malam Patti 3 and 4 becomes difficult. That's the most important point. Take home message of Malam Patti. Basically, Malam Patti classification tells you the ease of intubation, whether the intubation can be done easily or not. And this is based on the 𝐒𝐿𝐴 grading or the laryngoscope grading. That's it. Okay. Hopefully this point is good. Right? All of you are clear with this. Malam Patti classification done. The most important thing here you should know is how to identify. And second thing is what is the importance of Malam Patti. That is to see the ease of intubation, and it is based upon the laryngoscopic grading. Means if you can see the uvula, you can see the vocal cords. You don't see the uvula, you don't see the vocal cords. Simple. Right? Next point. Then we go to the next one, and that is, as you can see in the workbook also that you have, we go to the machine, anesthesia machine. So when we discuss the anesthesia machine, guys, so remember anesthesia machine, we're not studying everything completely. Here what we need to know in the anesthesia machine is just about the fact that what are the important questions asked here. So all of you are already aware the most important questions that come on the anesthesia machine are basically from each system. They'll ask you some questions. So from the high pressure system, they basically ask you about the cylinders, right? That is what is the most important point. They normally target here the questions regarding cylinders. In the intermediate pressure system, you are aware that they are asking about pipelines. So basically various pipelines are where the question comes. Pipelines. You're supposed to know about the pipelines, which becomes a part of intermediate pressure system, as well as oxygen flush valve. That's one important thing that I'll just show to you right now. And in the low pressure system, what is important is regarding the flow indicators. More than the flow indicators is the flow valve. So flow valve will come over here, the knobs which are there, and indicators go on to the low pressure system. So the knobs are here and the indicators are in the low pressure system. Apart from that, the vaporizer is what they ask you. This is what we will revise from the anesthesia machine. The cylinders, the pipelines, the knobs, and the vaporizer. This is what we need to know. So when you speak about the oxygen flush, I'll first go to oxygen flush. Remember, oxygen flush is a small device, not device, but a small part in the device over here, right? Let's think somewhere over here. Oxygen flush comes from the intermediate pressure system. This, if you press oxygen flush in case of an emergency, in case of emergency, if we choose to press this valve, this oxygen flush, this button, this delivers 35 liters of oxygen to the patient, but at little high pressure, right? It delivers it at around 60 pound per square inch pressure, and therefore the side effect can be barotrauma. But this is the only point important when you're speaking about the oxygen flush valve. Apart from that, you don't need to know anything because it's coming from the intermediate pressure system. Done. After this, let's go to the common questions that you people are already aware of. We'll first discuss the cylinders, and after that we'll discuss about the vaporizer, pipelines, and the knobs. These are the colors where they ask you maximum. When you speak about the cylinders, guys, two questions come on the cylinders with three are more important. One is they ask you about the cylinder colors. Second is regarding the pin index, and third is the pin index numbers. So you need to know three things: color of the cylinder, the individual pin index numbers, and the third thing is what is the function of the pin index. So remember, pin index is something which prevents the wrong attachment of cylinders. For example, if you will see over here, this is in case this is your oxygen cylinder and this is my nitrous oxide cylinder. So I cannot interchange. I can't put oxygen here. I can't put nitrous here. That is because of the pin index safety system. So every gas has been given a different number and the color is also different. So remember, the three most important gases are air, oxygen, and nitrous. For them, the last digit is 5 And these are the three most important gases: air, oxygen, nitrous. The number is 15, 25, and 35. Regarding the colors, air is gray body, black and white shoulder. Regarding oxygen, it is black body with white shoulder. Nitrous oxide starts with N. N means Neela, Neeli, Neelam, whatever you call it, completely blue in color. So these are the three most important that you people need to know, right? These three are the most important that you need to know. Apart from that, carbon dioxide, the number is 16 and 26. That depends on the percentage of carbon dioxide in the cylinder, and the color of the cylinder is gray. So this is another one which is important. Carbon dioxide cylinder is important because it is used in laparoscopy, right? Cyclopropane is an old cylinder. If you don't remember, it's okay, right? This probably won't be asked in the exam, but because it's a colored orange colored cylinder, right? And always we study about it. So this is one of them. Cyclopropane pin index is 36, right? The ones you saw air, oxygen, nitrous 15, 25, 35. Similarly, carbon dioxide and cyclopropane 16, 26, and 36. That's a way to remember. That's why we have included all of them. So cyclopropane color is orange, number is 36. Anyways, for exam purposes, cyclopropane not that important, but yes, the next one, Antonox, it becomes important. Here is the last digit 7, right? It does not have any first number over here. It's only one single digit 7. So 5, 6, and 7. Air, oxygen, nitrous, and last numbers were 5. Carbon dioxide 2, and one cyclopropane, last digit was 6. Antonox, the last digit is 7. And then 1, 2, 3, 1, 2, 3, you have your answers in front of you. Antonox, the color is blue with white. That is Antonox. Another one is there, that is helium. Helium is normally brown in color. So normally what we use is heliox gas. So brown with white, right? This becomes heliox, and the number here is heliox. They say right now is no pin index. Some people say nowadays there is no pin index for the helium. But in the old times, helium gas has a number that is 2, 4, and 4, 6. Again, this is a question that you should not think so much about it. But yes, cylinder colors and pin indexes are important. What does the pin index do? Remember, pin index, it prevents the wrong attachment of cylinder. It prevents wrong attachment of cylinder. So we are done with the colors. We are done with the pin index numbers. Let's go to the knobs. When you speak of knobs, what are the knobs? Guys, knobs are these points. These, right? These are the flow control valve or the knobs. This is the flow control valve or the knob. So what is the color of that? Remember, oxygen is always white in color and nitrous is always blue. As you can see, same thing for the knob also you can see from here. If we speak about a knob, let me put the color of the knob here itself. You can see white. So oxygen knob is going to be white in color and nitrous knob is going to be blue in color. That takes care of that also, the knobs. Then let's go to the vaporizers. What are vaporizers, guys? Vaporizers is what is here. These are the vaporizers, right? So cylinders were over here. That's one important thing. This is the high pressure system. Then after that, I told you about the oxygen flush and I told you about the pipelines. Pipelines will be over in the part of the intermediate pressure system. And then there are these knobs over there. Beyond the knobs, then becomes these rotameter and the vaporizer. Point is to discuss about the vaporizer now. So vaporizer colors become important. Halothane is red in color. Enfluorane, this is orange in color. Isoflurane, it is purple in color. Desflurane, this is blue in color. And sevoflurane, this is yellow in color. Right? When you speak about desflurane, you'll find that desflurane looks different from all of them, and that's an important MCQ question asked in the exam. Desflurane vaporizer looks different from all of them. It is basically a special vaporizer. Desflurane has a special vaporizer. This vaporizer is electrically heated. Reason: desflurane is an inhalational agent that boils at 23 degree or room temperature. It's got the highest saturated vapor pressure. This is the reason why we have a special vaporizer for desflurane. So remember, this is one of the most important questions that comes over here in terms of identification as well as in terms of color also, like in image based plus the color. Both of them are asked in the exam. Thumbs up, guys. Is that okay? So we are done with the vaporizer also. The last part that we'll see from the anesthesia machine, again the important one in terms of color. Everyone okay, guys? Any questions and doubts, you can drop in the comments. I'll go through them and let you know. All okay, guys? बीच में मैसेज आना बंद हो जाता है. Okay. I can see people watching, but I can't see any messages. Okay, let me go forward. Let's talk about the pipelines. So pipelines, guys, again, as I said, pipelines are nowadays used. Okay, Dr. Rishabh, Dr. Rishabh. Okay, thank you, Dr. Rishabh. Thank you for the comment. At least I know that the people are around, right? I could see people, but once the messages come, then I'm sure about it. Okay, fatafat, let's go to the pipelines. Pipelines, guys, remember, pipeline, again, colors are asked. So pipeline becomes a part of intermediate pressure system, and pipelines are spread all throughout the hospital. Again, oxygen is always white in color. Nitrous is always blue in color. Air, this is going to be always black in color. Vacuum or suctioning, this is always yellow in color, right? These are the color of pipelines. That is again important. And again, just like pin index safety system, which prevents the wrong cylinder attachment, here you have diametric index system, which is based on diameters, that prevents the wrong attachment of pipeline. So again, this is an important question. What is a diametric index safety system? So diametric index safety system, this prevents the wrong attachment of pipelines. This prevents diametric index safety system. It prevents the wrong pipeline connection. Okay, let's go forward. Dr. Aim High says dis. Correct. इसको dis बोलते हैं. Correct. इसको dis बोलते हैं और पिन इंडेक्स सेफ्टी सिस्टम को पिस बोलते हैं. Correct. Pin index safety system is called PIS. Correct. I'm serious, sir. Some of you will keep on laughing over there. तुमको लग रहा है पका रहा हूं मैं. पिन इंडेक्स सेफ्टी सिस्टम ऐसा होता है PIS. डायमेट्रिक इंडेक्स सेफ्टी सिस्टम होता है DIS. Clear? Okay. So here we are done with the anesthesia machine. When we have spoken about the anesthesia machine, guys, remember, beyond the anesthesia machine, so we discussed about the cylinders. One of the most important question. Pin index हो गया हमारा. Pin index is the attachment to the anesthesia machine. Then we discussed about the knob colors. We discussed about the vaporizers. We discussed about the pipeline supply and the oxygen flush, right? The important questions are done. After that, the connection between the anesthesia machine to the patient, this is what is called as the breathing circuit. This part is the breathing circuit. So this is a breathing circuit which is used nowadays. But in the past, we did not have a breathing circuit. So breathing circuits are basically classified into 3 types. No, 4 types, but at your level, we should take it 3 types. Breathing circuits. Okay, so breathing circuits are the ones which are classified into 3 types. In the old times, we used to use the open drop method for ether and chloroform, which is not used anymore. Nowadays, the one that you see in front of you, this is basically a semi-open or a semi-closed circuit. At your level, as I said, we should think that semi-open or semi-closed are the same, right? We should think the same thing. Some books have mentioned semi-closed, some will say semi-open. These are the Mapleson circuits. Mapleson A12. And then there is something called as a closed circuit. Remember, closed circuit is something which is also called as circle system. Circle system is what contains soda lime. So this contains soda lime. And remember, what is soda lime? Soda lime is basically something that absorbs carbon dioxide. So therefore, what happens in a circle system is patient is rebreathing his own gases that include inhalationals also, but removal of carbon dioxide. So in circle system, patient is rebreathing own gases. Own gases means inhalationals that have come out, but after removal of carbon dioxide, right? After removal of carbon dioxide. And that carbon dioxide is removed because of the soda lime. Okay, so this is our closed circuit or circle system. Remember, closed circuit will always have soda lime. There's another one called barrelime also, but barrelime is normally not used nowadays. Amsorb is also there, but soda lime. So closed circuit circle system is the one that contains soda lime. This is important for exam, where patient is rebreathing own gases, but after removal of carbon dioxide. Then the next part is semi-open circuit, Mapleson circuit. So Mapleson circuit is this one, the one that you see from the end of the anesthesia machine to the patient. This is what is called as a Mapleson circuit. Mapleson circuit is made up normally of 5 things. As you can see, at one point is the mask which connects to the patient. Here is the APL valve. You can also call it as the expiratory valve, from where the carbon dioxide moves out. So the basic function of breathing circuit is to carry these gases from the anesthesia machine to the patient, but at the same time, the presence of the expiratory valve helps the carbon dioxide of the patient to come out. So that's the importance of a breathing circuit. It not only delivers the gases to the patient, but it also helps in removal of carbon dioxide out, right? And that is exactly, if you could put soda lime over here, so carbon dioxide gets absorbed and the rest gases can be sent back to the patient again, because of which it is called circle system. But in Mapleson, this is not done, because in Mapleson, all the gases come out into the atmosphere, right? But in circle system, the same gases which came out of the expiratory valve, the same thing after removal of carbon dioxide can be sent back to the patient, and that is why it is called as the circle system. Okay, guys? Now, circle system, we have already discussed. Mapleson circuits, I told you, one point is the mask, the next is the APL or the expiratory valve. Then you have this connecting tube. This, what you see, is the connecting tube or the corrugated tube that connects to the patient. Here is the bag from where you give positive pressure ventilation, and the end of the machine is the common gas outlet from where fresh gas flow comes to the patient. These 5 things, fresh gas flow, the bag, tube, valve and mask, make the various types of Mapleson circuits. You need to know the names of the Mapleson circuit. You need to know where they are used. According to me, yes, when we teach, we definitely tell you how to identify, but for exam purposes and for rapid revision, I don't think you should be thinking so much as to how to identify in the exam. Another point, before we discuss about which are the ones that you need to know, what are the functions of each of them, remember you have to concentrate only on 3 of them. One is Mapleson A, other is Mapleson D, and last is Mapleson F. Okay, this is the place where maximum questions are going to come, because B and C, both of them are obsolete, right? They are not used anyways nowadays. So B and C are out. A, D and F is what you need to know. And now A and D. So Mapleson A is McGill circuit, and then there is LAC circuit. LAC is a modification which is called as coaxial. Coaxial means one tube inside the other, and beyond that we don't need to know. So coaxial is LAC circuit, and here you can find Bain circuit, that is again called coaxial, one tube inside the other, right? Mapleson A is basically used for a spontaneously breathing adult, an adult who's breathing on his or her own. On the other hand, Bain circuit is now used for controlled ventilation in adult, right? If you have to give controlled ventilation to someone, by controlled ventilation I mean positive pressure ventilation, IPPV. If you're giving it to an adult, you will be using Mapleson D, because it is more efficient for that. On the other hand, Mapleson A is more efficient for spontaneous breathing. Okay, so these are the uses. I told you the names and the coaxial as well. Mapleson E is called Ayer's TPs. If you will see, it looks like a T. Can you see this? It looks like a T-shaped device. It's called Ayer TPs. It was made for neonates ventilation, but it is not commonly used for neonates now. At the same time, it is used in ICU patients to wean the patient off ventilator. Okay, the last one is Jackson-Ree. This is the one which is used in pediatric patients. Jackson-Ree, JR means junior, used for pediatric patient. Pediatric patient less than 6 years of age. Pediatric patient less than 20 kg of weight. If the baby is more than 6 years and 20 kg, in that case we will use the Bain circuit. And that is why you will find Bain circuit is to be the most common circuit that is used out of all of them. Thumbs up, guys. Is that okay? So we discussed this point also. And as I said, A, D and F are more important. So you can remember Mapleson F. This is the only one that is normally used for pediatric patients. Though E is said for neonates, but usko use nahi karte. Practically speaking, it is Mapleson F which is used and not Mapleson E, even for neonates. On the other hand, if someone is an adult, so Mapleson A can be used and Mapleson D can be used. Thumbs up, guys. All okay? Yes? Okay. So we finished off the Mapleson circuits also. And even as I said, remember Mapleson B, C, anyways, they're not going to ask you. Mapleson A, D, and F is what you need to concentrate upon, right? Okay. Let's go forward. Then we'll discuss few of the monitors where questions come in the exam. So remember the first monitor that you need to know, specialized. I mean, this is especially about anesthesia. This is the bispectral index. Okay, bispectral index or the BIS monitor. So bispectral index is basically depth of anesthesia monitor. It is based on electroencephalogram, EEG, and EEG means brain activity. So it is based on brain activity, telling you whether how deep is the anesthesia of the patient. So this EEG measures the brain activity of the patient, and based on the brain activity, it will give you a number. This does not do anything. It does not tell you what's the reason behind it. It just gives you a number, whether the brain is active or not active. So if the patient is awake, you get a number 100. If the patient is in coma, if there is a flat line EEG, right, or coma, this is 0. A value of 40 to 60 is said to be kept for general anesthesia. 60 to 80 is set for sedation, which means if you give general anesthesia, this value of 91 is wrong. It should be around 40 to 60. It means patient has an adequate depth of anesthesia. So this monitor helps you based on the brain activity, it gives you a number, and based on that, it helps you to maintain optimal depth of anesthesia. It tells you if the patient is awake or anesthetized during the surgery, right? Anesthetized or sleeping. So maintain optimal depth during anesthesia, right? It is based on electroencephalogram. And remember, there's another monitor called entropy, which is supposed to be better than bispectral index also. It is EEG plus EMG combined together. So an entropy monitor is better than bispectral index, right? Both of them are almost the same thing, just that entropy has EMG combined into it. Clear? So this is your bispectral index, the depth of anesthesia monitor. All right. It maintains the optimal depth during anesthesia. Next. Okay, let's go to the most important monitor on which questions come. Last year they asked many questions. I mean, 2 questions on NEET PG also. No, NEET PG INI-CET. Right. So this is your capnography. Capnography is a monitor that measures carbon dioxide. It gives you a graph of carbon dioxide. It is measuring basically carbon dioxide, right? It measures the carbon dioxide during the respiratory cycle. So the respiratory cycle is going to have 2 things, right? Respiratory cycle, during the respiratory cycle, it will measure only CO2. But respiratory cycle does not have CO2 alone, right? A respiratory cycle is going to have inspiration as well as expiration. So this monitor can detect only carbon dioxide, which means this monitor can detect only the carbon dioxide coming out in expiration. During inspiration, it is not going to detect carbon dioxide. So remember, whenever it detects carbon dioxide, the graph goes up. It does not detect carbon dioxide, the graph goes down. So therefore, initially, when we keep the monitor and a patient is breathing, when the patient is breathing during inspiration, there is only oxygen going inside, right? The patient is not exhaling carbon dioxide, right? So in that case, it's a flat. Same thing when expiration starts, it's a dead space which comes out initially, dead space gas. So it is still, or it's still at the 0 level. So if I'm drawing a graph which looks like this, the initial part of the graph is down, right? Because of inspiration, baseline what we call, and then the dead space gas coming out. After that, there's a combination of dead space and alveolar carbon dioxide coming, and then max, it's the only alveolar carbon dioxide comes out, only alveolar. So it becomes much more stable. At one point, maximum alveolar carbon dioxide comes out, and then suddenly the patient goes into inspiration. So this is the graph which comes, and this keeps on regularly with every cycle. So this part that you see from here to here is the one that talks about expiration, and the part that you see from here to here, this is basically talking about inspiration. So therefore, this graph gives you expiration and inspiration. Whenever the graph is going down, it means there is inspiration that takes place. A graph, whenever it's going up, it means expiration is taking place, right? So therefore, the initial part here that you find is baseline. This is dead baseline, dead space gas. This is a mixture of dead space and alveolar gas. This is alveolar gas proper, and here is the maximum alveolar carbon dioxide. This was asked last year in NEET PG. This is point A, this is point B, this is point C, here is point D, and this is point E. All right. So maximum alveolar carbon dioxide is around 30 to 35, which is approximately the same as PCO2. So therefore, the EtCO2, this maximum alveolar carbon dioxide, is called as EtCO2, end tidal carbon dioxide. So this gives you slight idea about the PCO2 of the patient also. The maximum alveolar CO2, it gives you slight idea about the PCO2, and that is why this graph is so important. It is almost giving you parameters like a ABG. I mean, the carbon dioxide parameter of ABG you come to know from here only. Okay. So therefore, these are the various waveforms that you might get. Instead of taking this as a reference, I'll just draw my own, right? Because in that case, I can just discuss with you immediately. Otherwise, these are few of them, which you already have seen in the workbook that you have. Now, this graph that you see is what is talking about IPPV, expiration, inspiration, expiration, inspiration. This talks about IPPV, which means there is correct intubation done or correct ventilation. Correct intubation, correct ventilation going on, right? If you get a graph like this, this shows again expiration, inspiration regularly. This is seen in spontaneously breathing patient, someone who's breathing spontaneously, expiration, inspiration. During IPPV, if suddenly you get a dip, it means a patient has tried to breathe in between IPPV, which means the patient is out of muscle relaxant effect. This is the 𝐒𝐿, right? Patient has tried to breathe in between IPPV. So this point is called 𝐒𝐿. This is also called as return of spontaneous breathing. All right. So these are three graphs, major ones initially. Another graph, when you get a graph like this, some CO2 coming and suddenly there is zero CO2 for quite some time. It means there is no carbon dioxide detected at all. Something was seen, but after that, nothing is seen. What was the reason behind it? The reason behind it is that there is no carbon dioxide production. The reason, patient is dead. So cardiac arrest, you will get it. There is no metabolism happening. You will get it in embolism. Maybe the tube has gone in esophagus, so it can happen in esophageal intubation. It can happen with disconnection of the circuit. Accidentally, the patient has got extubated. Or in case there's a complete obstruction of the tube because of which it is not picking up carbon dioxide. These are the basic things. Remember here, embolism, a question is asked many a times, where they give you a patient undergoing laparoscopy, where the EtCO2, if you can see, this is a sudden drop in EtCO2, and then it is not coming. There is a sudden drop of EtCO2. So this normally is seen in laparoscopy, accompanied by decrease in EtCO2 and decrease in SpO2. This is the hallmark of embolism. This question is asked many a times. So remember this, if they have given you clinical question regarding laparoscopy going on and a patient's saturation is falling with EtCO2 decreasing, remember it may be embolism. Of course, you have 3 other things also, but if these 2-3 points are mentioned, it is probably going to be embolism, right? The next one. So let's see. These were 3 graphs that we saw. Then you get a graph where you get more carbon dioxide. This means more CO2 production. A more CO2 production means when will that happen? In case if metabolism is increased, malignant hyperthermia, that can be seen in fever, it can be seen in sepsis, it can be seen in thyrotoxicosis, thyroid storm. Right? In laparoscopy, we use carbon dioxide gas. It can be seen in that. Use of soda bicarb, the end product is carbon dioxide. All these things are going to increase the CO2 of the patient. You may get another graph. Remember, we have discussed circle system where soda lime was used, where rebreathing takes place. What if soda lime canister becomes full? In that case, patient starts to rebreathe his own carbon dioxide and it keeps on increasing, step ladder pattern. This is seen with rebreathing own carbon dioxide, which increases the CO2. It is called as a step ladder pattern. And then you get a graph like this. This graph basically is talking about obstruction, bronchial asthma, COPD, obstruction. There's something that you see in inspiration, and this graph is normally seen in a pediatric patient or someone with a thin chest wall. This is called cardiac oscillations. So this is about the capnography, guys. We've covered most of the graphs, the important ones. We've done all of them, right? Correct intubation, esophageal intubation, all of them we finished over here. And remember, there are two other monitors that you need to know about. Pulse oximeter. In pulse oximeter, you need to know what information does it give. Yes, Dr. Shagupta, sharp fin appearance, absolutely correct. Oh, I did not mention, so you want me to mention that? Absolutely correct. This is called a sharp fin appearance, absolutely correct. So I did not write it, but Dr. Shagupta has pointed out. So thank you, Dr. Shagupta. This is called as a sharp fin appearance. Okay. Correct. Thank you for that, reminding me for that. Pulse oximeter. So when you speak of pulse oximeter, the information that you get about on a pulse oximeter, all of you have a pulse oximeter at home, so you're aware of it. Okay. So the pulse oximeter tells you about the SpO2. It tells you about the pulse rate. It talks about the perfusion index. And it talks about the plethysmography graph. You get a graph like this. That is called plethysmography. Right? That is the information that you get. When do you get a wrong reading? That is more important. In pulse oximeter, you get a wrong reading in case there is a dysfunctional hemoglobin. Dysfunctional means the hemoglobin has got damaged, like, or it has got replaced. Methemoglobinemia, carboxyhemoglobin, sickle cell. In case of sickle cell also you get a wrong reading. Any problem with the blood supply, because it depends on the blood supply to the periphery, right? So if the blood supply to the periphery becomes compromised, you get a wrong reading. In case of vasoconstrictors being used, you get a wrong reading. In case of vasoconstrictor due to drug. In case of vasoconstriction due to any other cause like hypothermia, shivering, all that leads to a wrong reading. Raynaud's disease, all these conditions like Raynaud's disease, right? They are going to give you a wrong reading. All right. Apart from that, in case a patient is in severe shock, severe hypotension, severe hypovolemia, you get a wrong readings. Apart from that, nail paint and all, whichever is there, all you know, all those time pass causes, nail paint, nail polish, dyes, varnish, right? Some books have mentioned dark skin and ambient light also. These are the reasons for a wrong reading on a pulse oximeter. Finger, toes, ear, nose, wrist and sole is where you would use the pulse oximeter. Talking about temperature monitoring. When you speak of temperature monitoring, it's important because in anesthesia, hypothermia, hyperthermia both can occur. Most common is hypothermia, not hyper. Most common is hypothermia. So you need to, especially under GA, patient lose temperature, core temperature decreases. So they ask you what is the most common site to measure core temperature. No, not most common. First, what is the most ideal site? The most ideal site for core temperature, if I have to measure core temperature, the most ideal site is basically myocardial or pulmonary artery. But that's not possible routinely. Therefore, the most common site is distal esophagus. For brain temperature, tympanic membrane or nasopharynx. Okay. Apart from that, remember rectum and bladder can also be used. These are close to core temperature, but the ideal is myocardial or pulmonary artery. So this finishes off the pulse oximeter, temperature monitoring. We finished off the capnography and the bispectral index. Let's go to individual agents. Any questions or doubts till now, guys? Anything till now? Anyone? No one? Okay. So let me go forward. Let's discuss the individual drugs, right? Let's discuss the individual drugs. So I'm going to talk about the general anesthetics first. So when you're talking about drugs in anesthesia, before I discuss this point, uh, remember when we speak about the drugs in anesthesia, we need to know which are the drugs that are most important. So when you speak of general anesthesia, the important drug here are the induction agents. In the induction agents, important questions are regarding inhalationals and regarding IV. Okay. After the induction agents, the muscle relaxants become very important. When you speak of muscle relaxant, the reversal agent becomes very important. Okay, these drugs become very important. And after that, local anesthesia drugs, they are important. So this is what we will study in short and try to revise the drugs as fast as we can. Okay, so let's start. The first one, let's go and talk about the inhalational agents. Once again, let's talk about the inhalational and IV agents. The first one we are talking about is the inhalationals. So all these inhalationals, guys, remember these inhalationals, they are all working. First of all, let's see where they work. The general anesthetic drugs, all these drugs which are there, they work, most of them, induction agents, they work on the GABA receptor, right? Most of them. Inhalationals, all of them mostly work at GABA receptors, except few like nitrous, which works on NMDA. On the other hand, IV drugs also work on GABA receptor. So if you will see barbiturates, they also are working at GABA receptor. You will find benzodiazepines again working at GABA receptor, right? Drugs like 𝐒𝐿 and propofol also working at GABA receptor. Fentanyl is an opioid, so these opioids are going to work on opioid receptors, right? Ketamine, that's a different drug. This works on NMDA receptor. Okay, this works on NMDA receptor. That has been an exam question. So you find out of all of them, ketamine is different, working on NMDA, and many gases, out of the many gases, remember nitrous oxide also works on NMDA receptor, and even Entonox. So when you speak of gases, guys, these gases are the ones which get stored in cylinders, and the volatile liquids like halothane, they are stored in vaporizer. So the gases that get stored in cylinder are nitrous oxide, which I told you works at NMDA. Then there is Entonox. Entonox is a combination of oxygen and nitrous, and because it contains oxygen, it is said to be safest. Where is Entonox used? Labor, analgesia, and dental. In the past, there was that cyclopropane, and nowadays there is a new research on xenon. So these are gases stored in cylinders. But cyclopropane is not used anymore. Drugs that are kept in vaporizer, or the volatiles that are there in vaporizer, is ether, outdated drug. Chloroform, not used anymore. Trilene, not used anymore. And methoxyflurane, not used anymore. In fact, halothane and N-fluorane are also not used anymore. So what is used? What are used are basically isoflurane, desflurane, and sevoflurane. And that is why you'll find most of the answers coming in the exam are going to be basically nitrous, Entonox, and xenon. Xenon are still under research. Otherwise, it is isoflurane, desflurane, and sevo. Rarely you'll find some question about halothane, but this is where the questions come in the exam, right? Nitrous, Entonox, and xenon. On the other hand, isoflurane, desflurane, sevoflurane. Rarely something will come about halothane. Again, they don't ask you about N-fluorine also. That's also outdated drug. Okay, so these are the inhalationals. When we speak about the IV drugs, okay, IV drugs. So you can see in IV drugs, thiopentone is a barbiturate, right? So benzodiazepine, midazolam is a benzodiazepine. That's the structure of the drug. So in that case, what is ketamine? So ketamine drug is phencyclidine. What is etomidate? It is a imidazole by structure. And propofol is basically a phenol. Let's go to these drugs. Okay, let's go to these drugs. Let's start with the inhalational agents. When you speak of inhalational agents, there's one important question that comes regarding minimum alveolar concentration. Remember, it is inversely proportional to potency. It is inversely proportional to potency. You need to know about the sequence. So the most potent is methoxyfluorine. After methoxyfluorine, the next is halothane, then is isoflurane, then is sevoflurane, tresflurane, and nitrous oxide. This is a sequence regarding most potent to least potent. So methoxyfluorine is basically most potent to nitrous oxide, that is least potent. This is that sequence, minimum alveolar concentration. So when inhalationals have gone into the alveoli, that concept of minimum alveolar concentration tells you about the potency. From the alveoli, the inhalationals go into the bloodstream, and the inhalationals then become soluble in the blood. But not all of them will be soluble. Some will be soluble, some will not be soluble. That concept is called as blood gas solubility. It's called blood gas solubility or blood gas solubility, which is indicated by a number, blood gas solubility coefficient. All right. So this basically tells you onset of action. So again, this is inversely proportional to onset of action and recovery. Now, we're kind of using the same sequence which was there before, but we are just twisting it slightly. Okay, the same sequence. So methoxyfluorine, halothane, isoflurane, sevoflurane. Till here it is the same, but now we'll just make one change, and that is nitrous, which was in the end, is what we'll write down now, and then we'll write desflurane in the end. Right? If you want to add one more, there's another drug called xenon, which comes over here, and now the sequence becomes like this. And this sequence is about the slowest onset to the fastest one. Slowest onset to the fastest onset. This sequence is very important. You don't need to know individual numbers regarding potency as well as in onset and recovery. That's according to me. Numbers you can't by heart so easily. And here you will find the two of them, desflurane and nitrous, to be having similar numbers regarding the blood gas coefficient or solubility, similar properties. Thumbs up, guys. All of you okay? These were two important properties regarding all the inhalationals and a sequence that comes in the exam. Then we'll discuss about the individual agents. And we'll start with nitrous oxide. Okay? Thumbs up, guys. All okay, everyone? Okay. So let's discuss about the nitrous oxide. So nitrous oxide, guys, has three. I'll take it the next page. So nitrous oxide has three important effects. One is concentration effect. It increases its own concentration. The other one is second gas effect, where it increases concentration of other agents also. And this property is the reason why nitrous is called as a carrier of inhalational. That's again an important question. And the last is basically called the Fink effect or diffusion hypoxia. These three properties are common only to nitrous and not to any other gas. Right? So if there's an hypoxia, the treatment is going to be oxygen. So treatment is 100% oxygen for 3 to 5 minutes. After extubation of the patient, important point, concentration and second gas effect takes place during induction when we are putting someone to sleep. And Fink effect and diffusion hypoxia happen during recovery when you are waking up a patient from sleep. This is a difference between them. Okay. The first two properties, concentration and second gas effect, took place during induction when you're putting someone to sleep, while Fink effect and diffusion hypoxia are during recovery when you're waking someone up. Okay, so these were the important properties. This is not seen with any other gas. The only one is xenon that comes close to it. Okay, the reason is xenon also works on the same receptor. So if I go to the same classification that we were talking about, so remember I told you that nitrous also works on GABA. So sorry, NMDA receptor. So we were discussing all those receptors. So I told you it was ketamine that worked on NMDA receptor. Apart from that, in inhalationals, it is said that nitrous, Entonox, and xenon, all these three also work at NMDA receptor. They also have some effect, some action on NMDA receptor, right? From the inhalationals. Otherwise, all other inhalationals, all these, ether, chloroform, trilene, halothane, all of them are all working on GABA receptor. All of them are working on GABA. But ketamine Nitrous, Antonox, and xenon are said to be working at NMDA. Okay, so this is about the place that they work. All right, the site of action, the receptors. Nitrous, I've discussed with you this concentration effect, second gas effect, and diffusion hypoxia, 3 properties that it has. Apart from that, nitrous is known to cause maximum nausea, vomiting in a patient. All right, maximum nausea, vomiting out of all the inhalational agents. There's another one called out of all of them, others also have, but maximum is seen with nitrous. Maximum. No other will produce as much nausea, vomiting as much as nitrous oxide. Next property apart from that in nitrous oxide is that it has got many contraindications. Nitrous oxide has got many contraindications. This was a side effect, nausea, vomiting. It's also teratogenic. Right? Contraindications. Contraindications are that it should not be used for laser surgery as it can catch fire. Apart from that, it is not supposed to be, it expands the closed air spaces. So any air-filled cavity in the body, you're not going to use nitrous oxide. So nitrous oxide is contraindicated in laparoscopic surgery where we use the gas, right? Carbon dioxide. We don't use it in any GI surgery like intestinal obstruction or volvulus. It can cause embolism or increase it. So in that case, neurosurgery becomes a contraindication. In case of an embolism, we don't prefer to use it. Respiratory, right? If patient has pneumothorax, we don't use it. ENT, middle ear surgery, cochlear implant, tympanoplasty, we don't use it. Even opthal, vitreoretinal surgery, we don't use it. These are contraindications where you will not be using nitrous oxide. Okay, nitrous is not supposed to be used. Apart from that, I was discussing with you the side effects also, and I told you maximum nausea, vomiting. It is teratogenic. It affects the fetus basically, environmental pollution, and vitamin B12 deficiency, megaloblastic anemia, and all that it can be caused because with nitrous oxide. Okay, so these are the properties of nitrous oxide in short that we have covered all of them, right? Talking about the individual agents. So rather than talking other individual agents, what I will do is I'll discuss them in such a way that we'll discuss the drugs that I feel are the best based on various systems, right? Because what happens is every book has given a separate answer, and from what we read and from what we know is what we are telling you. And I'm not saying I'm the perfect person to give you all the answers, because some people might not agree with me, may differ with me. It depends what books they have referred, right? Of course, the standard book is Miller for everyone, but still everyone may refer a different book, okay, according to me, and no book says this is the drug of choice. Let's start one by one. When we speak about the cardiovascular system, in the CVS system, out of all the inhalationals, according to me, the best drug that suits is isoflurane because it maintains cardiac output. There is no other inhalational that maintains cardiac output as much as isoflurane. All right. And therefore, according to me, isoflurane is a better drug to be used in CVS rather than sevoflurane or desflurane. But people say both of them can be used. They are not wrong. They are not wrong either. I'm not denying. Right. CVS, you will not use. CVS, isoflurane, according to me, is the best. Now, when you speak of a kidney patient, if you keep an obese patient or a patient who is in shock, in these 2-3 conditions, the ideal drug of choice is desflurane, right? Desflurane. Here you will be using desflurane as one of the drugs, okay? Which are the nephrotoxic drugs? So there are 3 nephrotoxic drugs you need to know. Nephrotoxic drugs are 3: methoxyflurane, enflurane, and methoxyflurane, enflurane, and sevoflurane. Sevoflurane actually is not nephrotoxic. It becomes nephrotoxic only when you use it with soda lime. If you use it with soda lime, it forms compound A that can be nephrotoxic. Otherwise, it is not nephrotoxic. All right. So we discussed kidney, obese, and patients of shock. We will prefer to use desflurane above other drugs. Okay. Next, we'll talk about CNS. In a patient of CNS, right? In a patient of CNS, we will prefer to use sevoflurane over isoflurane. Now, here both the answers are correct. Both sevo and iso can be used. What does sevoflurane do? It causes the least increase in cerebral blood flow. Isoflurane, it causes the least increase in intracranial pressure. So if it is related to intracranial pressure, the answer would become isoflurane. If it is related to cerebral blood flow, the answer becomes sevoflurane. So we are done with CVS, kidney, CNS. Let's talk about liver. In case of liver, one of the best drug to use is sevoflurane. It is non-hepatotoxic, but you can use isoflurane, desflurane both, and especially both of them maintain the hepatic blood flow. So these two drugs both can be used as a very good drug for liver transplant. But otherwise, for liver, one of the best drugs is sevoflurane. As it is non-hepatotoxic. So we have done with the CVS, kidney, CNS, liver. In case of a daycare surgery, now both sevoflurane and desflurane can be used, but sevoflurane being a better agent, I will consider them, both are considered same, but I will prefer to use sevo above des, right? For a daycare surgery, some books have mentioned des above sevo. I'm not denying, even this has been mentioned. Okay, and the last that we will see, in case a patient is a respiratory patient, all right, respiratory patient or bronchial asthma, or if you get a pediatric patient and inhalational induction to be done in that patient, here again the drug of choice is sevoflurane, sweet smelling drug, and better than halothane, which can also be used because halothane is more potent. Remember, in potency it is more, but sevoflurane being a newer agent, less complications, it is preferred. Sevoflurane is a good skeletal muscle relaxant. So if you want to use a single agent, if I want to use a single agent for intubation and induction, right? For intubation and induction, for that the answer is sevoflurane. It's a good skeletal muscle relaxant. On the other hand, halothane has good uterine muscle relaxant properties, because of which it can be used for manual removal of placenta, but the side effect can be postpartum hemorrhage, right? Halothane has some other problems also. Halothane is one drug that you need to know because halothane is a drug which can cause arrhythmias in the patient. It is known to cause hepatitis in the patient, right? Arrhythmias, hepatitis. It is also known to produce malignant hyperthermia. Okay, so arrhythmias, hepatitis, malignant hyperthermia, these are all properties that halothane can produce. Thumbs up, guys. Is that okay? One point which we did not mention over here, that which one is the bronchial irritant. Here we have seen these two drugs are good for the respiratory system, but which drug is bad for the respiratory system? That is desflurane. Desflurane has maximum bronchial irritation out of all the drugs. Out of all the drugs, this is not to be used in the respiratory system. So we have seen the nephrotoxic drugs. We saw the drugs which are not supposed to be used in the heart. So apart from halothane, even enflurane can cause, arrhythmias and hepatitis. Even enflurane is known to cause it. All right. So we have seen about the heart rate. We have seen about the CNS also, and we have seen about the respiratory parameters as well. Thumbs up, guys. Everyone okay? Yes, guys. All okay, everyone? Okay. एक छोटा सा पॉइंट है, and that is in isoflurane, it maintains cardiac output. It is good for the cardiac system. लेकिन books have mentioned that it is known to produce a phenomena which does not make a lot of impact, but it is known to produce coronary steel. Coronary steel. Okay, so everyone okay? I was just asking all of you. Okay, so let me go forward and discuss about the IV drugs then. Let's talk about the IV drugs. Okay, so when we are discussing the classification of IV drugs over here, so IV drugs, I told you, they are basically short acting and long. Short and long is what we will say in terms of onset, not duration. Let's not talk about the duration. Let's talk about the onset. What is more important for these drugs is that we need drugs which are fast acting. You will find barbiturates, ketamine, etomidate, and propofol. These drugs that you will find over here, these ones, okay, these drugs that we have written here, okay, these drugs that we find over here, So these drugs are basically fast onset of action and also short duration of action, right? Fast onset means they will start to have their effect within 10 to 15 seconds, and short duration means they'll work for maybe 10, 15 or at the maximum 20 minutes, not more than that. Thank you, Dr. Shagupta. I got a message from you. Thank you. All right. Other drugs, benzodiazepine and opioids, no doubt they have also fast onset, but compared to propofol, ketamine, thiopentone, their onset is relatively slower, right? So these are relatively slower compared to thiopentone, propofol, and ketamine, the opioids and benzodiazepines, and these two normally are used as pre-medication drugs. They are not used as a normal induction agent. So these other four drugs that you see, they are used as induction agents. Right? And benzodiazepine and opioids are more commonly used as pre-medication. Pre-medication means before we start anesthesia, and they are used as co-induction agents. All right. So we are done with the inhalational agents. We are coming to the IV. So let me discuss with you the IV drugs. Okay, IV drugs. So when we speak about the IV drugs, every drug has some property, first physiochemical and then individual properties. So when we speak of the physiochemical properties, remember thiopentone. This drug is yellow powder. It comes as yellow powder. It contains sulfur. Okay, it comes as yellow powder. It contains sulfur. So you have to mix it with something. So you will always going to mix ideally with normal saline. You can also use 5% dextrose or distilled water. Okay, 5% dextrose or distilled water can be used. Yellow powder has to be mixed with something. The pH of thiopentone is 10.8 to 11. All right, 10.8 to 11, which means it's a highly basic pH, and therefore this drug is a highly painful drug. It's very painful. So this drug has some problems that it can cause histamine release, because of which there may be problems, right? The high pH that the drug has, that is a problem. Being a powder, it can known to precipitate, that is a problem. Okay, so these are the points where problems can take place with thiopentone. Okay, so it has a high pH, it has caused histamine release, and it is known to precipitate. So these are 2-3 things. Contraindications of thiopentone are very important. This drug is not supposed to be used in thyroid. It's not supposed to be used in porphyria, right? Not supposed to be used in someone having allergy to sulfur drugs or thiopentone. Not to be used ideally in the cubital fossa, and because it releases histamine in respiratory patients, you should avoid. Okay, respiratory patients avoid because it is causing histamine release. All right, as well as cubital fossa. Why? In cubital fossa, there are high chances that in case the drug goes intra-arterial, it is known to cause gangrene. Right, so this drug is known to cause thrombosis, venous thrombosis, as well as gangrene. So thrombosis in the vein, gangrene in the artery. Okay, so these are 2-3 important points regarding thiopentone which are asked in the exam. Regarding porphyria, regarding thyroid, regarding gangrene. So important points, remember, the appearance of the drug, histamine release, porphyria, gangrene, and these are 3-4 points that you need to concentrate upon that they ask you, right? That's about thiopentone. Let's talk about propofol. When you speak about propofol, it comes as a milky white emulsion. It comes as a milky white emulsion. Propofol is basically containing egg lecithin, glycerol, and soybean oil, because of which it is a good culture medium. It's a good culture medium. It means if it's a good culture medium, it can grow nosocomial infections, because of which you need to discard an open vial or a used vial. You need to discard a used vial within 6 hours. Again, that's an important question. The important properties about the drug is that 70% metabolism in the liver, 30% happens from the lungs. Okay, so it has double metabolism. It's not only going away from the liver, it's also going away from the lungs. So therefore, it leads to a very, very rapid metabolism. This drug has rapid metabolism. It produces a fast and pleasant recovery. And that's the reason it's a drug of choice for daycare surgery. Right? one of the side effects that can take place with propofol is because it is containing all these things, it can cause propofol infusion syndrome, not commonly seen but can be seen in pediatric patients. As the name suggests, it happens with the infusion of propofol. Propofol infusion syndrome, normally seen in a pediatric patient who is admitted in the ICU, on whom we are starting an infusion of propofol for sedation. In that patient, after 2 to 3 days, you will get a failure of free fatty acid metabolism, and that is the one which causes propofol infusion syndrome, metabolic acidosis, acute cardiomyopathy, and skeletal myopathy. Okay, so these are the points of propofol. All right, that's about propofol. Let's talk about etomidate. So I'm discussing these physiochemical properties. I also discussed some part of the pharmacokinetics also, right? In short, as I said, these are all in short. The important points that we should discuss is what I've done. Then is etomidate. Now, etomidate, remember, just like propofol is milky white emulsion. It is milky white emulsion. Etomidate is a milky white emulsion. So milky white emulsion, apart from that, side effect. Etomidate has 3 or 4 side effects which are very important, which are asked in the exam. It causes maximum nausea, vomiting out of all IV agents. Remember, nitrous oxide caused the maximum in inhalational, but in IV, the maximum nausea, vomiting is seen with etomidate. It also causes maximum myoclonus. Myoclonus is jerky movements that take place in a patient. So it is known to cause myoclonus and hiccups. All right, myoclonus and hiccups. It is known to cause myoclonus and hiccups, maximum, that is seen with etomidate. One of the major side effects that it has is adrenal suppression, which decreases the cortisol synthesis. That is the reason we don't use the drug so often. Okay, adrenal suppression. That is one of the major side effects. Otherwise, the drug had one of the best properties. And what's the best property? This drug is the most cardiostable IV anesthetic agent. There's no other agent which is as cardiostable as etomidate. It's the most cardiostable IV anesthetic agent. Of course, we use opioids also at many places. I'm not denying, but etomidate is one of the best for cardiac system. All right. These are 3 drugs that we discussed. So etomidate, it was like propofol. Now, similar to thiopentone, we have a drug in the same group as barbiturate, and that is methohexitol. You must have heard of the name methohexitol or methohexitone. It's a barbiturate just like thiopentone, but contrary to thiopentone, this drug is a proconvulsant drug. Proconvulsant means it causes seizures. So this drug was used as a drug of choice for ECT in psychiatry. Right? Problem, not used anymore. The reason for that is that just like etomidate caused adrenal suppression, this causes HPA axis suppression, hypothalamus pituitary adrenal axis suppression. Okay, you don't need to know much more about this. That's methohexitol. Then we'll talk about ketamine. Ketamine, let me take a new page. Okay, otherwise here it will be less. Let me take a new page. Ketamine. So when we say ketamine, guys, remember ketamine was this time's INICET question. Antidepressant drug, right? Which we've been saying for ages, but they had not asked it like an antidepressant. They'd asked other questions. But the first time they asked about antidepressant property of ketamine. So ketamine is a drug, I told you, that working on NMDA receptor, right? Thiopentone was a powder. Propofol and etomidate, they were liquids, emulsions, and ketamine is a clear liquid. It can be given from all the routes except for subcutaneous. We can give it all routes except for subcute. This is an analgesic drug. Till now, all the drugs were painful, but this is analgesic drug. The special property of ketamine is that it produces dissociative anesthesia. It dissociates the 2 parts of the brain. And because it is producing a dissociative kind of anesthesia, while the patient comes out of anesthesia, it leads to emergence delirium, hallucinations, right? It produces emergence delirium or hallucinations, dreaming. That's one of the reasons why people use it in parties also. What party? Rave party. You will find so many newspaper reports that people say, you know, someone has been caught with ketamine, someone has been caught with ketamine. Why? It's because of this hallucinations. Right? There can be delirium, there can be dreaming. Also remember, auditory hallucinations are more than visual. So it produces emergence, delirium, hallucinations, right? Dreaming. All these are properties produced with ketamine. Of course, analgesic, yeah, Dr. Shagufta said that. Yes. ठीक है, थैंक यू डॉक्टर शगुप्ता. बीच बीच में ऐसा तुम लोग मैसेज किया तो मेरे को आई अंडरस्टैंड दैट यू पीपल आर अराउंड, दो आई कैन सी एवरीवन, द वंस हु हैव जॉइंड, आई कैन सी द नंबर ऑफ पीपल जॉइंड, बट एट द सेम टाइम any small message from all of you makes me realize that you guys are there. All right, thank you for that. Dissociative anesthesia, I said emergence delirium, and apart from that, remember one thing, this drug is known to increase secretions, increase muscle tone. So therefore, whenever we give ketamine to a patient, it also produces amnesia. Apart from analgesia, it produces amnesia and sedation also. So whenever you give ketamine to a patient, guys, remember, ketamine is never given alone. We always combine it with glycopyrrolate to decrease the secretions, right? And we combine it with benzodiazepine to decrease the incidence of emergence delirium, right? So ketamine is never given alone. It's always combined with benzodiazepine and glycopyrrolate. Okay, so that's about ketamine. All right. Next thing that we'll discuss here, guys, is about the painful injection. So painful injection, remember, according to me, the most painful injection is going to be propofol. But some books think no, it is etomidate. So let's put it like this. Propofol is almost the same as etomidate. Both are milky white emulsions. Both are painful in nature. After propofol and etomidate, the next one is methotrexatol. Then is thiopentone. And the last is ketamine. Propofol is so painful that you need to add IV lignocaine to decrease the pain of it. Okay, it is so painful injection. We are already aware, routinely day in and day out when we use propofol, all of us never inject propofol to a patient without giving lignocaine. It is that painful injection. In spite of using lignocaine, the patient complains of burning. That's a practical point I'm telling. Forget about theoretical. It's a practical point. Every day, day in and out, in spite of lignocaine, many patients do complain, you know, especially injected in a small vein. A patient is going to complain of burning and they say something is happening before they go off to sleep. Okay, that's one of the points. Talking about pharmacokinetic properties, just remember, most of these drugs are depressant drugs. They are going to depress everything, right? So thiopentone is going to, you know, decrease everything. So thiopentone is one of the best drugs in the CNS, right? Respiratory system, not much of a only histamine release is there. But in CNS, what it is going to do is thiopentone is decreasing intracranial pressure. It decreases cerebral blood flow, and it is called as a cerebroprotective agent. On the other hand, propofol decreases everything. So propofol again is cerebroprotective, just like thiopentone. And it leads to a major decrease in blood pressure. It causes a decrease in cardiac output, right? In the CVS, it also causes profound, hypotension. And apart from that, apnea, more than thiopentone. So this drug decreases everything. It decreases the respiratory rate. It causes respiratory depression, more respiratory depression than any drug, and can cause apnea. That is much more respiratory depression, more apnea, all that is seen with propofol. Etomidate, we already said most cardiostable drug. And about the CNS properties, myoclonus, hiccups, and focal seizures are seen with etomidate. Methotrexatol, not much to discuss, but ketamine, this drug increases everything. This drug increases, if you talk about ketamine, it increases the heart rate, increases the blood pressure, it increases the myocardial oxygen demand. Apart from that, it increases the intracranial pressure, it increases the cerebral blood flow. Everything is increased. But the only place where ketamine works well is the respiratory system. It's one of the best bronchodilators. Ketamine is one of the best bronchodilators that you will come across ever, right? Patient having an acute bronchospasm, in that patient also we can use ketamine. It is that good a drug. It's a bronchodilator. It kind of maintains the respiration, means it causes the least respiratory depression amongst all the inhalational agents. Sorry, IV agents. Least respiratory depression amongst all the IV agents. So these are the even pharmacokinetic properties that we discussed, right? Same thing as intraocular pressure also. Remember, intracranial pressure and intraocular pressure, you can write the same things. right? Same thing. Similarly for ketamine, where I've written intracranial pressure, we can also write the same as intraocular pressure. All right, so that's about ketamine. It is increasing all the secretions, all the pressures. The only place is bronchodilator. It's one of the good bronchodilators. Then has least respiratory depression effects. Now, if we talk about the IV drugs, and then we are talking about what we call, where are they used as drug of choice. So most of the places you will find propofol as a drug of choice. Most of the places. So what we will do is, rather than talking about propofol, let's talk about those places where other drugs are used as drug of choice, right? So if you talk about CVS, I told you etomidate is the best drug. Apart from that, opioids can be used in CVS as the drug of choice. Opioids are also used. And of course, if a patient is not not a problematic patient, in those patients, some cardiac issues are there, I agree, propofol and thiopentone are also used. Ketamine is not used in a cardiac patient. We try to avoid using ketamine in a cardiac patient. Then where is ketamine used? So for a serious patient, etomidate and opioids are preferred. What about ketamine? Where would you want to use ketamine? So ketamine, remember, is a bronchodilator. So I prefer to use it for a patient who's having status asthmaticus. In the sense that I have a respiratory patient who has intractable bronchospasm or a patient with active bronchospasm. In this patient, I will try to use ketamine. Ketamine is also be used for kids, pediatric patients in whom I can get an IV cannula. I can try to use ketamine there. Good for pediatric patients. Ketamine, again, can be used in a patient. Now it increases the blood pressure, right? It increases the blood pressure. So it can be used in a patient of shock. It can be used in a patient of shunt. It maintains the airway reflexes. It is supposed to be used in a full stomach patient, right? Apart from that, ketamine can also be used for out of OT anesthesia, short procedures, burns, and antidepressant, right? It can be used for out of OT anesthesia, burn dressings, some short procedures, right? And it can also be used as antidepressant. These are the points of ketamine where it is used. Apart from this, guys, everything else, the answer is propofol, right? So here we just mentioned about one patient, respiratory system. Apart from that respiratory system that you see and the cardiac system where you see etomidate, everywhere else the answer is propofol. Everywhere else, you name the system. Let's start the system with CNS. If it is a CNS patient, if it's an ophthal patient, in fact, nowadays, people are not using methotrexate, though methotrexate is a drug of choice for ECT in psychiatry, but because of HPA axis suppression, it is not used, right? So in that patient also we use propofol, or you can use thiopentone. So CNS, ophthal, in fact, even in ECT we use it. Propofol is preferred. Apart from that, if a patient has a liver disorder, patient has a renal disorder, right? Patient is going for a daycare surgery, someone having malignant hyperthermia, someone having porphyria, routine anesthesia, routine sedation, ICU sedation, intubation of a patient, LMA insertion, you name it. I don't even know how many other things to count. Everywhere else, the answer is propofol. Everywhere else, the answer is propofol. Apart from what we have mentioned, everywhere else, the answer should be propofol. Propofol has two important properties. It is anti-emetic and antipruritic also. Anti-emetic, antipruritic. Okay. Similar to that, we haven't discussed thiopentone here, right? Because thiopentone nowadays is not used. But thiopentone has few properties that we are not aware of, right? It can be used not only in anesthesia, it can be used for some other things as well. And that is, thiopentone can be used for treatment of raised intracranial pressure in a head injury ICU patient. It can be used for status epilepticus. It can also be used for narco analysis. प्लेस ही नहीं बचा यार, कहाँ डालूं? Status epilepticus. Let me write down one by one only, right? Treatment of raised intracranial pressure, status epilepticus, and narco analysis. There are other drugs also which are used for narco analysis or truth serum, but you have thiopentone as one of them. Clear? Thumbs up, guys. That takes care of all the IV drugs also. We've discussed all the properties according to me, the important ones. Everyone okay? So I finished off, we finished till now, we finished off complete inhalationals, complete IV discussion. We discussed about the anesthesia machine, the cylinders, right? We discussed about the Malam Patti classification, which was important. We come to the next important drug, and these are skeletal muscle relaxants, right? Skeletal muscle relaxants. Here we are going to discuss about a little bit about the individual agents. Okay, thank you guys. Thank you, Dr. Shigupta. Okay, let me go forward and discuss these skeletal muscle relaxants. So remember, skeletal muscle relaxants, all of them are causing muscle paralysis. This group of drug that we are discussing now, last 1 year, most of the questions, like in every paper, one question has come from this topic, that is skeletal muscle relaxants, and that's about the reversal agents. More than the drugs, they've asked about the reversal agents. This topic is skeletal muscle relaxant, and skeletal muscle relaxants are known basically to cause muscle paralysis. So if they are causing muscle paralysis, means they are preventing muscle contraction. So if they are causing muscle contraction, it means where is muscle contraction caused? Muscle contraction takes place at the neuromuscular junction. So these drugs are basically working at the neuromuscular junction. Where they are working on the neuromuscular junction? Here they are working on the nicotinic receptor, right? Nicotinic receptor. All right. So these drugs, skeletal muscle relaxants, they are working on the nicotinic receptor at the neuromuscular junction. So on the nicotinic receptor, what is the transmitter? What is the one that is taking place, right? On that receptor, what is the functioning one? That is acetylcholine. Those are nicotinic cholinergic receptors, which acetylcholine is the one that is going to pass through that, is going to work upon on that receptor, acetylcholine. These are acetylcholine receptors. So skeletal muscle relaxation, these drugs, skeletal muscle relaxant drugs, they basically, skeletal muscle relaxants, these drugs are causing muscle paralysis. These drugs prevent muscle contraction. Once again, skeletal muscle relaxants. These drugs are producing muscle paralysis. They are preventing muscle contraction by working at the neuromuscular junction at the nicotinic receptors. And these are the nicotinic cholinergic receptors on which acetylcholine works, right? So basically, you are supposed to prevent the muscle contraction. And muscle contraction normally starts when acetylcholine is sitting on the receptor, right? Acetylcholine sits at the receptor. And after that, you're going to get a muscle contraction. Based on that, you get a contraction. So the first thing is, everything starts because of acetylcholine sitting on the receptor. So don't let acetylcholine sit on the receptor. Instead of letting acetylcholine sit on the receptor, make someone else sit on the receptor. If someone else will sit on the receptor, this contraction will not take place. Simple. Okay. Instead of acetylcholine going over there, let me put some other drug in place of acetylcholine, and that is a drug like vecuronium, a drug like atracurium. So if I give vecuronium, atracurium, or any drug like that, they are competing with acetylcholine and they are going to prevent muscle contraction. Okay, I'm discussing in short. I'm not discussing like the complete way that it works. So these drugs, basically, I'm talking of drugs like vecuronium. I'm talking of drugs like atracurium, which I just mentioned. What are they doing? They are a competitive inhibitors. They are competing with acetylcholine, as I told you, right? They are competing with acetylcholine. So these drugs are doing what? They are competitive in nature. They are competing with acetylcholine for what? For the receptor that I was talking about. So these drugs are competing with acetylcholine for that receptor. Whichever drug is strong will sit at the receptor. So if you have given good quantity of vecuronium, the vecuronium will be more in concentration than acetylcholine. And because it is a competitive antagonist, right, it will sit at the receptor. But once it sits on the receptor, it does not let that action potential pass inside, because of which it prevents muscle contraction. So if the action potential doesn't pass inside, which means normal muscle movement is not taking place, and a normal muscle contraction takes place because of depolarization. So therefore, the muscle contraction has two parts, depolarization, and after that, it also has repolarization, right? Depolarization and repolarization. So this drug, if you give vecuronium to someone, this vecuronium, it is competitive to acetylcholine. It's competitive in nature to acetylcholine. It is a competitive antagonist. What does it do? It fights with acetylcholine to sit on the receptor. It will sit on the receptor, and this one prevents the depolarization because it prevents the action potential from going inside. So therefore, you will find it's preventing the depolarization. So if it has prevented depolarization, there's no point about talking about repolarization. So when you speak about non-depolarizing agents, they are competitive antagonists, and these drugs prevent depolarization. Because they prevent depolarization from taking place, that is why they are called non-depolarizing agents. Clear? Exam, all these questions are asked. The meaning of depolarization and competitive antagonist. That is an exam question. So depolarization is what gets prevented when you are giving vecuronium, atracurium, pancuronium, cisatracurium, bivacurium. This is what happens. Okay. It's a competitive antagonist and is preventing depolarization. So till the time vecuronium is sitting on the receptor, there is muscle paralysis, right? But if you want to reverse the paralysis, simple. Why is the paralysis taking place? Because vecuronium was stronger than acetylcholine to sit at the receptor. But if I want to reverse this process, I need to make acetylcholine stronger than vecuronium. How can I make acetylcholine stronger than vecuronium? So always remember, acetylcholine normally gets destroyed by acetylcholinesterase and goes back to synaptic vesicle, right? What was there in the synaptic cleft? You all know this. I'm just saying that in short. So when we give neostigmine, neostigmine blocks acetylcholinesterase and it increases the quantity of acetylcholine. Therefore, the neostigmine will help you to increase acetylcholine more than vecuronium, and that is what is called as the reversal. Clear, everyone? Okay, this is what is called as reversal. So when you give neostigmine to a patient, so when you have given a non-depolarizing agent, when I've given this agent non-depolarizing, here I can give neostigmine. So what happens is neostigmine will block acetylcholinesterase enzyme. Okay, and once it blocks acetylcholinesterase enzyme, it increases the acetylcholine in the cleft, and this becomes more than vecuronium. This process is what is called as the reversal of muscle block. Last year's question, FMGE as well as 𝐼NI-CET, right? Reversal of muscle block is not seen with atropine. Remember this. Reversal is there with neostigmine, not with atropine or glycopyrrolate. That has been given for some other thing. That has been given to take care of the muscarinic side effects. All right. So acetylcholine increases. This is what leads to reversal of muscle block. Right. Now, the increase in acetylcholine at the nicotinic receptor leads to the reversal. But this acetylcholine is also going to increase. Once you've given neostigmine to the patient, this acetylcholine increase is also going to take place at muscarinic receptor, right? So when the acetylcholine increase takes place at the muscarinic receptor, it causes muscarinic side effects, increase in secretions, frothing, sweating, all right, bronchospasm, bradycardia, and to counteract that, you need to add glycopyrrolate. So therefore, in the reversal of muscle block, it's the neostigmine which has the function, but we have added glycopyrrolate to take care of the muscarinic side effects. That is why we add atropine or we add glycopyrrolate to the reversal. Thumbs up, guys. Tell me, all okay? Everyone understood this point? Add atropine or glycopyrrolate, right? This was a question. That's why I'm discussing it slightly. This was last year's. This is a 6 months back question. All this. All right. This was asked in FMG only, and similar question was asked in 𝐼NI-CET. Thumbs up, everyone. Chalo. So we are done with this. Let's go into the next one. Okay. Let's go to the next one. That is about succinylcholine. Thank you, guys. Okay. I think you've understood the point slightly. So we've discussed about the non-depolarizing and the important points. Competitive antagonist and prevents depolarization. I'm talking about the mechanism. Compared to that, when you give succinylcholine, on the other hand, when you give succinylcholine, so succinylcholine sounds like acetylcholine, and remember, succinylcholine mimics acetylcholine. Okay. So when I give succinylcholine to the patient, succinylcholine, it sounds like acetylcholine, it mimics acetylcholine, it works like acetylcholine. So remember, succinylcholine, when it goes and sits at the receptor, it is now becomes non-competitive. Vecuronium was competitive. This becomes non-competitive. So once it is sitting on the receptor, it's going to cause all the thing. It is causing depolarization. That is why succinylcholine is called as a depolarizing muscle relaxant. Point is that once it causes depolarization, after that it persists at the receptor. Means after the depolarization, it will remain at the receptor. It will sit at the receptor, and because it persists at the receptor, it is preventing repolarization. So if it is preventing the repolarization, the receptor does not become normal at all. So how will the next contraction take place? It does not take place, right? So vecuronium atracurium prevented the depolarization, but succinylcholine has caused depolarization but prevented repolarization. Okay, so therefore remember, succinylcholine, like acetylcholine, interacts with the acetylcholine receptor. It causes depolarization, therefore it is called as a depolarizing muscle relaxant. Okay, this prevented depolarization, that's why it is called as a non-depolarizing muscle relaxant. Here what you find, acetylcholine is working like succinylcholine. There's only one drug over here called succinylcholine. Depolarizing is only one drug. So succinylcholine interacts with that acetylcholine just like that receptor. It works like that, and it works as an agonist. So this is agonist at the receptor, basically partial agonist. It is non-competitive in nature, right? And once it sits at the receptor, it has caused depolarization. Because it has caused depolarization, therefore it is called as a depolarizing muscle relaxant. But once it causes depolarization, what after that? After that, it persists at the receptor. It does not go away like acetylcholine goes away. This persists at the receptor, and because it persists of the receptor, that continuous end-plate depolarization is there, and that prevents the repolarization. Okay. Because of that, it leads to the muscle paralysis. How does succinylcholine go away? Right. So this is what is called as a depolarizing block. Succinylcholine goes away when you will find that plasma cholinesterase will come and destroy it. Plasma cholinesterase is the one that destroys succinylcholine, and that happens within 5 to 8 minutes. Hence, succinylcholine, another important point, it is the shortest acting muscle relaxant. It gets destroyed within 5 to 8 minutes. You don't need to give neostigmine. If you give neostigmine, it is going to increase acetylcholine. Doesn't make any sense to give neostigmine for succinylcholine, right? In case if you give the block will become prolonged. It doesn't make sense. Okay, so neostigmine is not given. This succinylcholine ultimately gets destroyed by plasma cholinesterase. It persists and finally gets destroyed by plasma cholinesterase. Question: in case someone has plasma cholinesterase deficiency, in that case, the normal block, the normal muscle paralysis of succinylcholine is called as a phase 1 block. But if someone has this plasma cholinesterase deficiency, the block becomes prolonged, right? It becomes a prolonged block, and that is called as a phase 2 block. That's it. I think I'm done with the discussion regarding the mechanism of action. And I think I've covered up all the points which are asked in the exam, both for non-depolarizing as well as depolarizing. So prolonged effect in case of deficiency, and that is called as a phase 2 block. Remember, it's sort of a dual block. It's called as a dual block also. All right. So this is about the succinylcholine drug. Remember, succinylcholine is an important agent. Now, talking about the non-depolarizing drugs. Succinylcholine properties. If you have to talk about the properties of succinylcholine, remember, it is shortest acting. It is the fastest acting muscle relaxant, right? Succinylcholine is the one which can cause malignant hyperthermia, not to be used in a patient of massive trauma. Apart from that, remember, anything to do with brain, neuro, nerve, opthal, right, burns, all these places, neuromuscular, all these places, succinylcholine is sort of contraindicated. And it's not a complete thing, but in short, these are the places you will not try to use succinylcholine. What does succinylcholine do? It increases potassium. Apart from that, it increases all the pressures. whether it is the intracranial pressure, intraocular pressure, intragastric pressure. Everything is increased, right? That's another property of succinyl coating. So malignant hyperthermia, it can cause massive trauma, or massive trauma means I'm telling you these are the contraindications where not to use it. Malignant hyperthermia, you will not use it. Massive trauma, you will not use it. Brain, neuro, nerves, opthal burns, neuromuscular. And the reason is that the point is it increases potassium. That's a side effect. It increases potassium. It increases potassium. It increases all the pressures. So you're trying to avoid it in all the places that we discussed. Then let's talk about the competitive antagonist. We'll talk about these drugs, non-depolarizing. They are divided into two types. These are aminosteroid compounds and benzyl isoquinolinum compounds. You will see most of the aminosteroid compounds have onium written behind them, and most of the benzyl isoquinolinum have curium written behind them. Yes, that's one of the ways that you can identify an exam, right? Onium and curium. Onium and curium. That's a way to identify. We'll take one or two drugs and discuss them in short. What is important point? Vecuronium. It is the most cardiostable. Okay, let's do system wise first. Let's do the same thing what we did for other points, and we'll discuss the same thing over here. When we speak of the cardiovascular system in CVS, the best drug to use is vecuronium, as it is the most cardiostable. Vecuronium is also the most common used drug. When we speak about daycare surgery, no. When we speak about a respiratory patient, I can use any drug without any histamine release. Any drug without that does not release histamine. Remember, histamine releasing drugs are DTC, atracurium, mivacurium, rapacuronium. Little bit of succinyl coating. These are the drugs that release histamine. For CNS, remember I just told you brain, neuro, not to use succinylcholine, any drug apart from succinylcholine. So in CNS, succinylcholine is contraindicated. Any other drug can be used. Any non-depolarizing muscle relaxant can be used. Right? In a patient of liver disorder, in a patient of renal disorder, right? If it's a pediatric patient or a neonate. Also, you can include neuromuscular disorder or a nerve disorder. We prefer to use cis-atracurium over atracurium. Remember, cis-atracurium and atracurium, they have a special metabolism technique. Both these drugs, they undergo 2/3 Hoffman's elimination. Hoffman's is one of the most important properties. It's a non-enzymatic degradation, means no enzymes are needed. Non-enzymatic degradation, right? Without any enzymes, it just degrades inside when it is given to the patient. You don't have to give any drug. This produces a metabolite called ludanosine, and this is known to cause seizures, right? That is seen with atracurium. The metabolite that it produces is ludanosine, which can cause seizures in the patient, and atracurium also produces histamine, which we just saw. So they made new drug cis-atracurium. This drug cis-atracurium has no histamine release and less incidence of seizures with ludanosine. Okay, so it's a better drug. Cis-atracurium, less ludanosine production and no histamine release. No histamine. Thumbs up, guys. Everyone okay? Daycare is not what I discussed. I'll discuss that. Daycare. When it comes to daycare, I'll be using the shortest acting drugs. So daycare, I'll be using succinylcholine or mivacurium. Remember, mivacurium is shortest acting. It gets destroyed by plasma cholinesterase, just like succinylcholine. Just like plasma cholinesterase was destroying succinylcholine, similarly, mivacurium gets destroyed by plasma cholinesterase. In daycare, we can also use rocuronium. because rocuronium has a new reversal agent, and that is Sugammadex. Sugammadex has been asked recently in NEET PG as well as in INI-CET. Sugammadex is a specific reversal agent which causes fast reversal. It's like a binding agent, specific reversal agent which causes a fast reversal, right? And this Sugammadex basically, this Sugammadex can be used for rocuronium, but remember it can also be used for vecuronium and pancuronium. Though it is made for rocuronium, but it can be also used for vecuronium and pancuronium. I got a thumbs up from Dr. Shivangi as well. Thank you, Dr. Shivangi. All right. So rocuronium, vecuronium, pancuronium. All right. So we've discussed Sugammadex also. We discussed the muscle laxants. We've discussed neostigmine. Right. We've discussed about why it is being added, the muscarinic side effects. All right. So all these points we've covered here itself. Individual drugs also we've taken care of that. All right. Any questions or doubts till here, guys? Any questions or doubts, or should I go forward? So we are done with the muscle relaxants as well. All right. Okay, so let's go to the next one. I think I'm done and no other doubts. Hopefully not. So let me go forward. Then, when we're discussing muscle laxants, one thing very important was there's something called as a neuromuscular monitor. This is what is called as a neuromuscular monitor. Okay, neuromuscular monitor is what monitors the neuromuscular junction. It monitors the neuromuscular function, and this can be used to monitor the neuromuscular function basically. So basically the most common use is the ulnar nerve, and corresponding to that I'm going to see the response in the adductor pollicis muscle. Adductor pollicis muscle. Right? So electromyogram, correct. EMG, guys, EMG is considered better than a neuromuscular monitor. Remember this, huh? Right, Dr. Shagupta, thank you for saying that. Okay, so EMG, electromyogram, is considered better than the neuromuscular monitor. It is considered better. EMG is what is used in physiology, and neuromuscular monitor is what is used clinically. So neuromuscular monitor, remember the most common mode used here is called the train of 4. The most common mode here used is train of 4. Train of 4 means 1, 2, 3, 4. 4 stimuli are given in a span of 2 seconds. Each stimulus is of 2 hertz. So every stimulus is going to come at 0.5 seconds. So you give 4 stimuli, right? A normal response is going to be like this. This is going to be a normal response. If there are no drugs present, this is the normal response. With a non-depolarizing drug, okay, if the non-depolarizing, this is what you get to see, that is fade. This is called fade. This is seen with a non-depolarizing. In succinylcholine phase 1, here you will get to see a decrease height, same height but a decrease amplitude, right? You get to see the same height but decrease amplitude. But in phase 2, remember, in phase 2, when there is plasma cholinesterase deficiency, the prolonged block, right? In that case, succinylcholine in phase 2 shows you the features of non-depolarizing. So you start to get the same fade. That is the MCQ question. Okay. So you get to see fade with succinylcholine phase 2. So fade is seen with non-depolarizing and it is seen with succinylcholine phase 2. This much is sufficient to know. We'll not go into too much details. Clear? This finishes off the neuromuscular monitor and we go to local anesthetics. So local anesthetics, guys, remember the classification is injectable and surface local anesthesia drugs. All right, injectable and surface. The surface local anesthesia drugs are the ones which are applied over the surface, so they are soluble or insoluble. So soluble, you have cocaine, lidocaine or lignocaine, tetracaine or proparacaine. So this question came in exam. Proparacaine, this is the one which is normally used for cataract surgery. A lot of people had made a mistake regarding this, right? Confusing था उस समय because they had given lignocaine also as one of the options. A lot of people had mentioned their lignocaine. I think there was lignocaine given. So cataract, I think proparacaine is a drug which is normally used compared to other local anesthetics. Insoluble, you have benzocaine, butyl aminobenzoate and oxytazine. Right? So benzocaine and all, these are the drugs. Benzocaine is used in oral ulcer gel. Oxytocin is used in antacids. So these are all those surface local anesthesia agents. Right? The more important questions come regarding injectable anesthetics. Injectable means they are injected for infiltration or they are given for blocks. Right? Surface local anesthesia drugs, they are just applied over the skin surface. So you apply them on the skin surface. That is why they are called mucus, and that's why they are mentioned mucous membrane, and that's why they are called as surface local anesthesia drugs. Infiltration and blocks is with the injectable. So this group is classified as less potent and short duration, where you get drugs like procaine and chloroprocaine. Remember, chloroprocaine is the shortest acting and the fastest acting local anesthetic. Okay, chloroprocaine, this is shortest acting and fastest acting. Shortest, fastest. Okay, lignocaine. Lignocaine is the most common used local anesthetic, right? Prilocaine. So prilocaine is the one that is used in EMLA cream and intravenous regional anesthesia, right? So that is the use of prilocaine that we'll discuss later on. Lignocaine, guys, remember, there are few questions that come on lignocaine. I'll take it on the next page, right? I'm not writing it over here. Here I'm going to discuss, so this group of drug is intermediate potency and intermediate duration. These two drugs, even mepivacaine comes here, and highly potent long duration, you get tetracaine, bupivacaine, ropivacaine, dibucaine. Remember, dibucaine, this is the longest acting. Longest acting is dibucaine. Second longest acting is tetracaine. Third longest acting is bupivacaine, right? But bupivacaine has one problem. The problem is that bupivacaine, guys, I'm writing it in red. Bupivacaine is the most cardiotoxic local anesthesia drug. It is the most cardiotoxic local anesthesia drug where your CVS symptoms happen at the same time as CNS symptoms, right? Here you get CVS symptoms at the same time as CNS symptoms, means you will get arrhythmias along with convulsion. All right, most cardiotoxic local anesthesia drug, you get arrhythmias along with convulsion when you're giving bupivacaine. Bupivacaine comes in concentrations of 0.25%, which is normally used for analgesia or pain relief. You get a concentration of 0.5% that is used for motor blocks, spinal anesthesia, epidural or blocks. The difference between them is there, and this is what is produced. It produces something called as differential block. All right. Bupivacaine is most cardiotoxic, so people made a new drug out of it, and that is called ropivacaine. Now, ropivacaine is a S enantiomer. It is less cardiotoxic than bupivacaine, and hence a lot of people are now preferring to use ropivacaine. But it is used more commonly for analgesia rather than anesthesia. Okay, ropivacaine is less cardiotoxic. It is S enantiomer. I told you we'll discuss lignocaine. I'll just discuss it on the next page. Remember, guys, lignocaine, there are 2-3 questions which come that are important. And that is, lignocaine by itself, the maximum dose is around 4 to 5 milligram per kg. And lignocaine plus adrenaline, if you talk about lignocaine plus adrenaline, here the maximum dose goes up to 7 milligram per kg. This is asked in the exam. Another important question that comes regarding another important question that comes regarding lignocaine is that concentration of lignocaine that is available. So what are the concentrations of lignocaine available, guys? 0.5%, 1%, 2%. Remember, 0.5% and 1% are normally used for dental procedures. 2%, there are 2-3 types. Okay, 2-3 types. This comes in a vial. 2% is the one which will, you have seen a jelly. The jelly is basically the surface local anesthesia drug. So the jelly, that gel, all that is local anesthesia drug. Soluble, that is surface local anesthesia drug. Here it comes in a vial, right? And there is even IV use, which is preservative free. One comes with adrenaline and other is preservative free for IV use. So this is 2% which comes like this. You get a 2.5% which is combined with prilocaine, right? That is lignocaine plus prilocaine, which is called the EMLA cream, right? 4%. It comes as a viscous and it comes in a vial, right? It comes in a vial. This is used for anesthesia and ENT, right? The 5% comes as a cream. In the past, it was used for spinal anesthesia. In past, it was used for spinal. Now it's not used. And then you have 10% that comes as a spray. Clear? So these are all the concentrations of lignocaine which are there, which is asked in the exam. So it starts right from 0.5% and up to 10%. These are all the concentrations of lignocaine, right? When you speak of local anesthesia drugs, guys, remember, where do they work? So all of you know, whenever we inject local anesthesia, we inject it inside the tissue, and from the tissue, what happens is the drug gets absorbed in the nerve. So the effect of local anesthesia drug, it takes place at the nerve or the nerve fiber. On the nerve fiber, it's working at the nodes of Ranvier, and there it's working on the sodium channels. So what does it do is, it prevents the generation and conduction of impulse or action potential. It prevents the generation and conduction of impulse or action potential. It prevents the action potential from going forward or propagating forward by working on the sodium channels. What sodium channels, guys? Remember, these are voltage gated, inactivated sodium channels. Maximum effect takes place on them. But because it is blocking action potential, it can work on potassium, calcium, chloride channel also. Another point to remember is, this drug on the sodium channel works from the intracellular area, not outside the cell. It enters the cell. It works intracellularly from the cytosolic side. Okay? Clear, everyone? Okay? All right. Any questions or doubts till here? No? No questions, no doubts till here? Right? So when you're injecting the drug in the tissue, guys, remember, local anesthesia drug is working on the nerve, but it can also get absorbed in the blood vessel. From that is where systemic absorption takes place. So therefore, these local anesthesia drugs have few properties. The first thing is that these are weak bases, right? So therefore, let's discuss in a way that what are the additives that can be used with local anesthesia drugs. What are the additives we can add? The additives to local anesthesia drug. Thank you, Dr. Parul. Okay, thank you. So let's discuss about the additives. What are the additives that you can use? So one of them is soda bicarb. Why will you add soda bicarb? By addition of soda bicarb, it means that normally local anesthesia drugs are weak bases. When you add soda bicarb, it makes the drug more basic. All right. So basically, you're going to have a better effect. Okay. So local anesthesia drugs are weak bases. You add soda bicarb. By addition, we start to get a better effect of the drug. Faster onset and less pain, less subcutaneous pain. That is soda bicarb. We add adrenaline or any vasoconstrictor. Even this is added. Why is vasoconstrictor added? Remember, adrenaline and phenylephrine are two important drugs which are asked from here. Adrenaline and phenylephrine are added because they are vasoconstrictors. Remember, normal local anesthesia drugs are vasodilators. So to counteract that property, we add adrenaline or phenylephrine. Okay, to counteract that property. So local anesthesia drugs are vasodilators except for cocaine. Remember, cocaine is a vasoconstrictor. Apart from that, we can add dextrose. Dextrose is added for spinal anesthesia so that the drug can settle down. Okay, so soda bicarb, vasoconstrictors, dextrose we have seen. Apart from that, ketamine, midazolam, opioids, and alpha-2 agonist. These 3-4 drugs can also be added. Remember, these drugs can be given from all the routes except for subcute. Okay, so this is about the additives that can be added to local anesthesia drugs. All right, additives which are added. Again, I've not gone too much into detail, but I've just discussed just the additives and basic points regarding that. Remember, it's a big topic, even this one. All right. So now that we are discussing these drugs, remember, there's another classification that local anesthetics have, and that is based on structure. and this is what defines the metabolism. So the metabolism of local anesthesia drug, that depends on the structure. Metabolism depends on the structure of the drug. So the structure of local anesthesia drugs is basically an aromatic ring. The aromatic ring is joined to an intermediate chain, and this intermediate chain is joined to an amine part, right? The chain can be of two types. You can have a chain that is ester, you can have a chain that is amide. If the chain is ester, the drug is called amino ester. If the chain is amide, the drug is called amino amide. Again, exam question, how do you identify which of the following drug is amino ester, which is amino amide? Look at double I and single I. Right? Cocaine, single I, procaine, single I, chloroprocaine, single I, tetracaine, single I, lignocaine, double I, bupivacaine, double I, trilocaine, double I, ropivacaine, double I. So all the single I drugs are amino ester, all the double I drugs are amino amides. Amino esters get metabolized in plasma by plasma cholinesterase. In the plasma, by plasma cholinesterase. Remember, plasma cholinesterase, pseudocholinesterase, and butyryl cholinesterase are the same thing. Okay, these are plasma esterases. And you will find lignocaine, bupivacaine, trilocaine, all these drugs are metabolized in the liver. Okay, except for cocaine. This cocaine does not get metabolized by plasma. Cocaine gets metabolized in liver. Clear? So this finishes off regarding the classification of these drugs based on the structure and the metabolism based on the structure that is there. Excretion of all these drugs takes place by the kidney, right? In case you give local anesthesia drug and it leads to local anesthesia systemic toxicity, which is called LAST, right? In that case, what has happened? Local anesthesia systemic toxicity, you're going to get symptoms. Which organ system gets affected first? Remember, CNS symptoms takes place before the CVS symptoms. All right, and CNS symptoms will include right from the prodromal symptoms. Prodromal means circumoral, tongue numbness, eye and ear symptoms, right? You will get oral symptoms, eye and ear symptoms, diplopia, double vision, dizziness, all that will take place. Ultimately, all these prodromal symptoms leads to convulsions, dizziness, muscle twitching, convulsions. After convulsions, there can be respiratory arrest and apnea. There will be cardiac symptoms taking place after that. Changes in the heart rate, blood pressure, cardiovascular collapse, and arrhythmias. These things take place after the convulsions. So your CNS symptoms take place before the severe symptoms. What is the treatment? The treatment is going to be first maintain the ABC, CPR, that has to be done. Give anticonvulsants, and remember, when you're giving anticonvulsants, you have to be ready that there can be arrhythmia, so you have to have antiarrhythmics also ready. The new treatment here is that you're supposed to be giving 20%, not a new treatment, but of course it's been followed for some time, but a question always comes based on this. 20% intralipid. 20% intralipid, the same one that is used for total parenteral nutrition, that is given to the patient, and you will always use small doses of adrenaline. Right? Even this is being given. All right. Intralipid is the same thing that is used for total parenteral nutrition, TPN, what we use. Right. So this is a treatment of local anesthesia systemic toxicity. Next, we'll discuss malignant hyperthermia. All of you okay? Okay till here? I will take about 1 hour more. As we said, I'll be finishing off in 1 hour. Till now we've discussed almost local is done. Then I'm going to take spinal, intubation, and then we'll discuss CPR. And with that, we'll be done till 9. Hopefully till 9:15 we should be over. Right? Any questions or doubts, guys? No one asked me doubts. I can see everyone joined in. But if there are any doubts, please ask me in between. I'm seeing the messages also in between, the chat box as well. Okay. So let me go forward. We're done with the local anesthesia systemic toxicity. I'll come to the next important topic that comes from here, that is malignant hyperthermia. Remember, malignant hyperthermia questions always after 1 or 2 years, they keep on asking. Malignant hyperthermia, guys, it's a genetic disorder. So it is something which does not have an overt expression like some genetic disorders. You know, you can see a patient of Down syndrome or some other syndromes where you can see effects on the face, you know, or maybe in the behavior of someone, of a person. But malignant hyperthermia normally is a genetic disorder which does not have an expression directly, right? I also have seen till now only 1 or 2 patients, not directly malignant hyperthermia, but when I saw their reports, it was written IVAR RYR gene positive, which is ryanodine receptor gene positive. So it's a rare thing. In Indians is extremely rare, right? It's more common abroad, but Indians have this gene very rarely. And anyways, because we saw this, so the patient is normally referred to a higher center. In that case, they will manage it in that way that in case the dantrolene and all those drugs are available. So that's a rare condition seen in India, but you're supposed to know, because in case it happens in the OT, there's no treatment for this condition apart from dantrolene. So everyone is supposed to be knowing about this condition, and hence, right from my time till your time, this question is an important question for the exam. Okay, it has not become an old question or unused question. No, it is still important. So malignant hyperthermia, guys, it's a genetic disorder of what? It's a genetic disorder of sarcoplasmic reticulum, which is present in the muscles. Okay, it's a genetic disorder of sarcoplasmic reticulum having ryanodine receptor gene abnormality. So there is a ryanodine receptor, okay, ryanodine in the sarcoplasmic reticulum. There is this ryanodine receptor. So this has a ryanodine receptor gene abnormality, and ryanodine receptor basically is a calcium release channel. So remember, this disorder is a disorder of the calcium channel. MCQ question. It's a disorder of the calcium release channel. All right, disorder of the calcium release channel. So this patient will be talking, walking, running like all of us, will be normal. But when this patient comes to the OT, otherwise this patient has no abnormality, we have no idea. In OT, if this patient comes into the OT now, I have a patient with genetic disorder. This patient comes inside the OT and I'm not knowing about it. I had no idea. So in OT, what I do, I start using inhalational agents. I can give, this is volatile anesthetic agents, not volume, but volatile. It's not volume, huh? Because I got this question once. I shared it, and one of the students asked me, sir, VOL means volume anesthesia? No, this is volatile anesthesia short form. We become accustomed to writing the short forms. So volatile anesthesia drugs, right? Especially halothane. If you give halothane, or if you give succinylcholine, which we just saw, or even if you give lignocaine, to all these 3 drugs, if you have given in the OT, suddenly what will happen is from the calcium release channel, there is increased calcium release that takes place. There's a calcium release taking place. Suddenly, imagine how much calcium is going to get released, right? That increase in the calcium release that takes place, it increases the metabolism. So the calcium release causes arrhythmia. The increase in metabolism is what increases the temperature. It increases the carbon dioxide production. And if you don't give anything to stop the calcium release, this temperature will keep on increasing till the patient is dead. And that is why this is a dangerous condition, because the only treatment of this condition is that you're supposed to stop this calcium release. If you cannot stop the calcium release, arrhythmias will keep on taking place, hyperthermia will taking place, carbon dioxide will keep on increasing, and that is why this is called as malignant hyperthermia. Okay, the temperature does not decrease and muscles get involved. There may be muscle rigidity and myoglobinuria. So these are the symptoms that you see in the patient. The only treatment of this condition is dantrolene sodium. When you give dantrolene sodium, guys, remember this is the one which stops the calcium release. Apart from that, there is nothing which stops the calcium release, right? And you will have to cool down the patient. And next time this patient comes for surgery, if I have to give him general anesthesia, I will be giving the patient propofol, because remember, where no drug can be given, propofol is given. Remember, everywhere else answer was propofol. And if I have to give local anesthesia, since I can't use lignocaine, I'll be using the drug procaine. Done. So we have discussed malignant hyperthermia. That's an important question. Let's go to the next part. Right? I think all of you already know it, but I just discussed this important point. Next 2 questions were last year's NEET PG question. This was an image based. At once we were thinking that, this question will be stopped being asked because it's an outdated procedure. We don't use it anymore. Hardly it is used. This is what is called as intravenous regional anesthesia, IVRA, or Bayer's block. Bayer's block, nowadays we don't use it. Hardly anyone uses it, right? IVRA is basically intravenous is basically regional anesthesia injected IV. But if you inject regional anesthesia IV, it's going to cause local anesthesia systemic toxicity. Therefore, you are supposed to attach a double cuff tourniquet. A double cuff tourniquet is attached so that the blood does, the local anesthesia given in the bloodstream does not go, right, Dr. Shagufta IVR. Okay. Dr. Parul says Beer's block. Are kahan gaya? Dr. Parul, it was okay. I was about to say something. I said, yes, you people are sitting since morning, so all of you need to have a beer for getting Beer's block, right? I'm sorry, Dr. Parul. Okay, just wanted to add that as soon as you send that message, I really wanted to say this. Okay, but she corrected it immediately. Okay, sorry. Okay, I know you were right. You just had a spelling mistake over there, but I really wanted to say that all of you are sitting since morning. You've gone through so many sessions. So really, it's a time for Beer's block now, right? Not a Bayer's block. It's a Beer's block time, but no, not right now. Have your exams and only then. Till the time the exams are there, guys, please concentrate on studies. And I know all of you will do well. So concentrate on studies and get this exam cleared. It's one of the biggest hurdles that we have, right? And once you're done, trust me, your parents are going to love it. It's a gift for your parents. Do it for your parents. I know with every passing day, it feels as if what is going to happen, what is going to happen. Just think about your parents, pray to the Almighty, and all of you will sail through. Okay? Dr. Parul ने काट दिया, मेरे को बहुत मन था. Sorry, Dr. Parul immediately typed. Like even I'm looking at the comment box in between. Dr. Parul was like beer. बोला हाँ, someone has written beer. Now let me say something. Okay? But immediately correction was made. But that's nice. All right. So let's talk about the Bayer's block. The Bayer's block is regional anesthesia injected IV. It's a double cuff tourniquet that you attach, right? The two drugs that you can use here are lignocaine or prilocaine. Both the drugs have a wide margin of safety, right? They can be used. And remember, because the drug goes IV, the most cardiotoxic drug, bupivacaine, is contraindicated. We don't use it. This was used only for an upper limb or lower limb surgery, but it is not used now, as I said, because you're using a tourniquet that could have been used only for upper limb and lower limb surgery. So this is Bayer's block, guys, which was asked in the exam last year, NEET PG. Next is EMLA cream. EMLA, eutectic mixture of local anesthesia drugs. This was again last year's NEET PG question, which was asked in the second paper. Last year NEET PG was held in 2 sessions. This question was in the second session. EMLA cream. Look at me, I'm also making mistakes here. You people, bichare, have sitting since morning and making a mistake. And for me, it's lack of the beer and making a mistake. Is that so? EMLA cream. So EMLA cream is eutectic mixture of local anesthesia drugs. Eutectic mixture of local anesthesia drugs. Now, just like you saw here, lignocaine and prilocaine, same thing is used over here, but it's a combination of drugs. So here we are using 2.5% lignocaine plus 2.5% prilocaine. Eutectic means lowering the melting point, right? So that the drug can now penetrate inside, right? It's a surface local anesthesia drug basically. It's a cream. EMLA is a cream. Okay, so 2.5% lignocaine and prilocaine are used. This is the one which can anesthetize intact skin, and that is why the mixture is eutectic in nature. It can anesthetize intact skin, right? It is used for needle phobia. And remember, needle phobia, circumcision, skin grafting, these are the uses. With any superficial procedure, basically, what may be the side effects, especially if you use it in neonates in huge quantities. Remember, prilocaine has a side effect that you don't expect from anesthesia, right? So prilocaine and benzocaine, in fact, even benzocaine, if given in high quantities, they can cause methemoglobinemia, and the treatment of methemoglobinemia is IV methylene blue. Clear? So we are finished with this also. Let's go to spinal and epidural. Here, most of the things are already written. Here, already written. This is the point where I was discussing drugs. So we had kept, just the images. Here, most of the points are already written. Remember, when we talk about spinal epidural, they are called neuraxial block. They are working on the central nerves or the spinal nerves of the body. These drugs are working on the spinal nerve. That is why they are called as the neuraxial block, central neuraxial block, not just neuraxial, they are called central neuraxial blocks. All right. The first and foremost thing that you need to know here is anatomy. In anatomy, a question comes, and that is spinal cord exists or goes from where to where? spinal cord basically, guys, remember, ends at L1 or L2 in adult, L3 in child. You need to know about dura. Dura ends at S2 in adult and S4 in child. Okay, this anatomical point is important. 2 points from anat that come over here, right? Spinal cord ends at L1, L2 in adult, L3 in child, and S2 in adult, S4 in child. So this was about adult. All these two are about child. Another important point about anatomy is the presence of Tuffier's line that they ask you. Tuffier's line is the line joining the highest point of iliac crest. Highest point of iliac crest, the line which joins is called Tuffier's line. This corresponds to L3, L4 interspace. This is important because you should be giving spinal anesthesia in such a space where you don't damage the spinal cord. Your spinal anesthesia should be given so that it does not damage the spinal cord. That is why L3, L4 becomes important, and we find it out by the presence of Tuffier's line. Okay, that one point we finished there. What are the structures then? The first structure that you get is always the skin, right? The first structure that you're going to get over here is the skin. And after the skin, the next layer is the subcutaneous tissue. After the subcutaneous tissue, the next layer covers up the spinous process. This is called supraspinous ligament. This one. Then you get a ligament in between the spinous process. This is called interspinous ligament. After that, you reach a ligament which is over here. As you can see this is called ligamentum flavum. This is ligamentum flavum. So till now we got skin, we got subcutaneous tissue, supraspinous ligament, interspinous ligament, and we reached ligamentum flavum. Till now we have not come to any space that I'm using it for anesthesia. But after that, the next place after ligamentum flavum immediately is the epidural space. Immediately after the ligamentum flavum is the epidural space. So MCQ question, the last layer punctured before epidural is the ligamentum flavum, right? After the epidural, then you will find the next layer over here is dura. Can you see this? There is one layer which you see over here. This layer is the dura over here. After the dura, you get the arachnoid. So arachnoid and dura are almost, stuck onto each other here. Arachnoid and dura are stuck onto each other. So the small space that you see in between them, this space between arachnoid and dura, guys, this is what is called as subdural. So therefore, after the epidural, you get dura, and then you get the arachnoid, and the space in between them is called as the subdural space. Okay, between the dura and arachnoid, there's a small space called subdural. After the arachnoid, the next layer that you get, that is subarachnoid. After that, the next layer that I've got here is subarachnoid. Subarachnoid is the one which contains the CSF. So this is the subarachnoid space. It contains the CSF, which is over here. You give spinal anesthesia over. Subarachnoid space is what contains the CSF. So your epidural anesthesia is going to come here, and the spinal anesthesia is going to come here into the subarachnoid. So this is spinal, and here is epidural. So therefore, the last layer that you puncture in epidural is ligamentum flavum, and the last layer that you puncture in spinal or lumbar puncture is arachnoid. That's the MCQ question. Clear, everyone? So these are the various layers, important question that is asked in the exam. All right. Fine. So this is an important question as I discussed. What are the differences between them? The differences is that where will you give spinal anesthesia? As I just discussed with you, spinal anesthesia is given inside CSF. So you should know that the spinal cord ends over here somewhere. Where does the spinal cord end? The spinal cord ends at the lower border of L1, upper border of L2. So you can give spinal anesthesia below that. That is why the most common space is L3, L4. What about epidural? That you can give anywhere, because epidural is outside the dura. So you are not coming in contact with the spinal cord. Had there been a spinal cord over here, then there was a problem. But here in epidural space is outside. If this is the spinal cord that you see, therefore epidural space is over here. So my epidural space is not interfering with the spinal cord. So epidural can be given anywhere. So epidural can be given cervical, thoracic, lumbar, sacral, and sacral epidural is what is called as caudal anesthesia, which you must have heard, used for pediatric patients. Okay. Spinal anesthesia is given below L1, L2, where the spinal cord ends. Therefore, the most common space used is L3, L4. Books have also mentioned L4, L5. That we identify by the presence of the Tuffier's line. Okay. The site of injection for spinal is subarachnoid space, means after the arachnoid. Hence, therefore, you are puncturing the dura for sure. Here, dura is punctured. Of course, ligamentum flavum is also punctured, but dura is also punctured, and arachnoid. The last layer that is punctured is arachnoid. So, arachnoid is also punctured. Puncture of both dura and arachnoid, which means the meninges are punctured. The point about this is that the meninges are punctured. All right. However, when you speak of epidural, you are not puncturing the meninges. Epidural space is a space a space in between ligamentum flavum and dura. So therefore, here meninges are not punctured. The meaning of this is that without the puncture of dura means here the meninges are not punctured. So therefore, the point is that post-dural puncture headache ideally should not be getting with an epidural, because epidural you are not puncturing the dura. Did you understand this, guys? Okay, here what has happened, dura and arachnoid are getting punctured, so therefore the meninges have got, right, meningitis and that meningeal irritation and stretch and post-dural puncture headache, all that can take place dura and arachnoid, right? That's the reason why PDPH is seen in spinal, and here PDPH is not seen. No puncture of dura, post-dural puncture headache is not seen. Here it is not seen, PDPH is not seen. Right? How do you identify the spinal? It's by the presence of CSF. Remember, CSF should be free and clear flow of CSF, only then, right? However, how to identify the epidurals? Remember, epidural space, because it is outside the dura, is also called as extradural. So extradural is the same thing as epidural, and it can also be called as peridural. So these are different names. Same thing has been asked in the exam. Epidural is the same as extradural, outside the dura, or peridural. All right. You identify it by the loss of resistance technique. Since epidural is a huge space outside, you're going to need more drug. The site of action remains the same for both of them. But in epidural, I'm going to use a drug 15 to 20 ml, while in spinal, I'll use 12.5 to 3 ml. Heavy. What is the meaning of heavy? I just told you dextrose is added in spinal. So you add dextrose so that specific gravity of the drug, specific gravity of the drug is more than specific gravity of the CSF, and the drug settles down. That is the meaning of heavy. That is why dextrose is added for spinal, and that is not used for epidural. Onset of action is fast, 2 to 5 minutes, while for epidural it is slow, 15 to 20 minutes. The density of block means how good the block is. So spinal, the block is more dense, hence it is used for anesthesia and getting a surgery done. But on the other hand, the density of block of epidural is less. Basically, it is variable. So when you speak of epidural, it is more commonly used for analgesia or pain relief, or it is used to increase the anesthesia time by combining it with spinal. All right. On the other hand, hypotension is fast seen with spinal and slow seen with epidural. Clear? So these are the points of differentiation between them. Next, the type of needles. Again, important question. Spinal needles are of two types. There are two types of spinal needles. You can take the next page. Everyone okay till here? Right? No doubts? Revision okay till here? Let's go forward. So spinal. Spinal needles are of two types. They are cutting tip and pencil point tip. So the cutting tip needles are basically dura cutting, the same point we were discussing. In spinal, the dura is cut. So this needle, cutting tip needle, is basically dura cutting needle. It is called 𝐒𝐿𝐻. What it does is it causes more damage to the dura, more CSF loss. On the other hand, the pencil tip needles are called dura separating, which are Whitaker and Sprott. Dura separating or dura splitting. So they are basically going to cause a very small hole or rent in the dura. So they cause less damage. Okay, so cutting tip needles and pencil tip needles, pencil point needles. Okay, then we come to the Tuhi needle. This is the epidural needle. The epidural needles are much more thick compared to spinal. Remember last year, this time 𝐼𝐿𝐼 I think they asked Very's needle, and they had given the option of spinal and Tuhi needle in that. Okay, the image was of Very's needle, and the options were given from anesthesia. That's how questions come in the exam. So epidural, guys, remember, is a thicker needle. It has got 1 centimeter markings, right? 1 centimeter marking, so that you know how far you are from the skin towards the epidural space. You will see it has got 1 centimeter marking. That's how you identify epidural, right? One of them has a straight tip, which is Crawford, and the one which has a curved tip, 𝐒𝐻. We prefer to use 𝐒𝐻 needle as the most common because here the tip is curved. So what's the advantage? If the tip is curved, so the tip becomes like this. It goes like this. So if the tip is curved, when we are putting the epidural catheter, it goes here. Plus, it's not damaging the dura also. That is why the curved tip or the 𝐒𝐻 needle is preferred out of the other needles. So 𝐒𝐻 is the most common one which is used, which is a curved tip, right? 𝐒𝐻 needle is a curved tip. So this is the one which is preferred. Clear? So done with this as well. This is the epidural needle. Let's talk about the complications. So first I'm discussing all these which are called as intraoperative complications. These are the intraoperative side effects or complications. First is a vasovagal syncope, which means a collapse of the patient when you are trying to inject. I was trying to inject and suddenly the patient has a vasovagal syncope. He collapses. Here the patient has collapsed because of the fear of the injection, or basically, fear of something. That's called vasovagal syncope. It has happened at the time of injection when I was injecting. But patient has not collapsed then. I've injected the drug and suddenly patient throws up a convulsion and then there is collapse. That is basically intravascular injection. By mistake, my drug has gone in the intravascular injection, leading to local anesthesia systemic toxicity. This would lead to collapse of the patient, and that is going to be accompanied with symptoms of local anesthesia systemic toxicity. This is going to be accompanied with symptoms of local anesthesia systemic toxicity, like convulsions, arrhythmias, and all those things are going to be seen. So that is your intravascular injection. Shivering, again, all types of anesthesia causes shivering. Remember, I told you temperature monitoring. Rarely you will get hyperthermia, like malignant hyperthermia, but all types of anesthesia cause shivering. It's one of the commonest complications. Nausea, vomiting is seen. Again, the reason for that is hypotension. Hypotension, guys, remember, is the most common complication that we see with spinal or epidural. In spinal, it happens fast. In epidural, it is slow. The hypotension means there is a decrease in blood pressure with an increase in heart rate. The body tries to compensate for it. The reason for that is a sympathetic block which causes peripheral pooling of blood, right? If you want to prevent it, co-load with colloids, that is the prevention. Co-loading with colloids. By the time you're giving spinal, co-load with colloids. And the treatment of this condition is again IV fluids or colloids. Vasopressors. Adrenaline can be used. And head low can be given, so that the venous return to the heart increases, right? That's what is given in the books. These are the things that you can do, right? This is happening in a normal anesthesia, like normal spinal. You may get vasovagal, you will get shivering, you'll get nausea, vomiting, and hypotension. This is common. But if the level has gone up, that is what is called as high spinal. The level has gone little up, and this may be accompanied with different symptoms, which are systemic symptoms. What systemic symptoms you're going to get? You may get cardiac symptoms and CNS symptoms, right? Now the level has gone up. So basically, I am getting the cardiac symptom, I am getting the CNS symptom, RS, and the CNS symptom. This is what is called as high spinal anesthesia. And when the level goes completely up, that is called total spinal anesthesia. So this can lead to a collapse of the patient because all these systems basically are getting involved. So this will cause the collapse of the patient, but after 5 to 10 minutes. Not immediately, because now the level is going slightly up. So this causes collapse of the patient, but after 5 to 10 minutes. Not immediate. So it is high spinal anesthesia. By the time it's gone up, you can also call it total spinal anesthesia. Right? Total spinal. So high spinal, total spinal complications when the level has gone up. So it can cause bradycardia. So in this bradycardia, the meaning is that there is going to be hypotension with bradycardia, right? That's the kind of thing which is seen. Hypotension with bradycardia. There may be asystole, respiratory impairment and apnea, and loss of consciousness. So what is the treatment of this condition? Here the treatment is going to be For high spinal or total spinal, you need to manage the CVS, you need to manage the RS, you need to manage the CNS. So basically, I'm just managing the ABC and CPR, right? I'm treating the hypotension which was there. I'm treating the bradycardia. So treatment of hypotension, which means giving IV fluids, all those things. Treatment of bradycardia, right? And of course, ABC, CPR become a part and parcel of it. Clear? So this is all our intraoperative side effects and complications. Let's go to post-op. What happens post-op? In post-operative, guys, the most common in post-operative, the most common that we see is urinary retention. In post-operative, the most common is urinary retention, right? And the most common delayed is post-dural puncture headache complication. All right. Infections can take place because you're close to the meninges. There can be meningitis, arachnoiditis, abscess formation. Apart from that, complications can be damage to any surrounding structure, damage to nerves leading to neuropathy, right? Cordaquina syndrome, damage to the blood vessels leading to hematoma formation, and all of them can lead to paraplegia in the patient. But bothersome complication is going to be the post-dural puncture headache, on which questions are asked. Okay, post-dural puncture headache. When you speak of PDPH, post-dural puncture headache, remember this can be also called as post-spinal headache. It can also be called as post-lumbar puncture headache. Okay. This pain happens later on, not immediate. Later on means it happens 12 to 72 hours after the spinal. It is fronto-occipital in nature. Most important, it has a postural variation. Postural variation means it increases in the sitting position or straining and decreases on lying down. What is the mechanism? Remember, we had punctured the dura. So when you had given spinal, when we gave the spinal, we had punctured the dura, and from dura there was a dural hole or a dural rent, and that dural rent led to a CSF loss. So I gave spinal, right? The dura was punctured. With the puncture of the dura, there was a dural rent or a dural hole. From there, CSF loss was taking place. This leads to the stretch of the meninges causing headache. Right? Stretch of the meninges causing headache. Now, I'm discussing what are the factors responsible, and opposite to that are going to be the prevention. So what are the factors responsible? The best factors responsible are going to be if you have punctured quite a lot, right? If you have punctured means if you have given multiple punctures to the patient, that is one of the factors. More CSF loss will take place. If the dural rent is much bigger in size, if you have used a wide bore needle, if I have used a wide bore needle, that means the dural rent is going to be bigger in size. The same thing can be said if I am using a dura cutting needle. If I use a dura cutting, so if I use a wide bore needle, the dural rent is bigger in size, more CSF loss, more headache. If I use a dura cutting needle, again the same thing. So these are the basic factors that are going to increase the headache. Multiple punctures, wide bore needle, dura cutting needle. Apart from that, in females, in young patients, not older, this was an MCQ question last year only, or I think INICT this question was asked. Female, young patients and pregnant ladies. It is more common in them compared to the other general population. So how to prevent it? Less number of punctures, use a thin gauge needle and use a dura separating needle. All right, clear? So that is your post-dural puncture headache. But what's the treatment of this condition? So the basic treatment of this condition is to maintain hydration. If someone will say what is the basic treatment, the initial treatment, the patient is at home, it's after 2 or 3 days. Initial treatment is to maintain hydration, adequate oral IV, use adequate analgesics that take care of pain. Possible analgesics might not be taking care. We also advise caffeine, cerebral vasoconstrictor or theophylline can be given. Right? Stool softeners are given so that the patient does not strain. right? That during the motion, because this is the thing which increases the pain. Stool softeners, right? Apart from that, you can use steroids, sumatriptan, all these drugs are given, right? All these drugs, many other drugs are also there, but these are there. And the most definite treatment is basically an epidural blood patch. What we do is we take patient's blood and we put it in the epidural space. It seals that clot. Okay. So what it happens is, if there was a dural rent and then I took 10 ml of the patient's blood, right? So what I did was I took 10 ml of the patient's blood and I put it in the epidural space, right? So that will seal that dural rent. The dural rent will become sealed. That's the reason how it prevents the pain, takes care of the pain, the epidural blood patch. Clear? So this is also done. Last is the contraindication. So these are the contraindications for spinal. Remember, skin infection at the site, it can go further inside. Severe hypovolemia or severe shock is going to be a contraindication. Coagulopathy, high chances of bleeding and hematoma formation. Increased intracranial pressure, coning of brain and herniation. Lack of consent or patient refusal is the foremost absolute contraindication, right? Shock, sepsis, severe fixed output lesions like aortic stenosis, mitral stenosis, and allergy to drugs. Relative contraindications are uncooperative patient like pediatric patients, pre-existing cardiac problems or neurological deficits. Even if there's a cardiac issue, you need to be careful, and there can be a relative contraindication. Demyelinating diseases, severe spinal deformity, infection at the site away from the site of insertion, and like there is sepsis, or technical difficulties like obese patients where you don't get the adequate length of the, or you can have patients like kyphosis, scoliosis, lordosis. So these are technical difficulties, right? Next, let's see about the intubation. Any questions, then ask me. I'll take another 10-15 minutes for this and another 15 minutes for CPR. Any questions, guys? Please ask me. Otherwise, I'll go forward. No questions. All okay, everyone? Shall I go forward? Okay. Okay. When we speak of intubation, the position that you need for laryngoscopy is called the sniffing position. Many places we call it McGill position. It's written like this. A lot of people call it barking dog position, and some places it's also been mentioned as Chevalier-Jackson position, and a lot of places I think ENT textbooks have given it as Boyce-Jackson position. Okay, thank you, Dr. Parul, and thank you, Dr. Shivangi. Thank you. Okay, so as I said, thank you for letting me know about that. Thank you. Okay, I was discussing intubation. Remember, intubation, the position that we say is called sniffing position. That's the right name. McGill also, it is said. It's also called Chevalier-Jackson position. And as I said, some ENT books have mentioned Boyce-Jackson position also, because that I got to know from someone. Okay, I am not sure about that, but normally we call it the sniffing position. So don't get confused. Normally it's called the sniffing position for intubation and laryngoscopy. In ENT, they do various other types also, no? They do micro laryngoscopy or other things also. So that position may be for that. But otherwise it is called a sniffing position. Okay. Now, when you do a sniffing position, how do you make it? Guys, remember the difference between sniffing position and rose position is the presence of a pillow. Here you just have a pillow under the head, not below the shoulder. In rose position, it is present below the shoulder also. So here you keep 8 to 10 centimeter pillow under the occiput, which causes head extension at the atlanto-occipital joint. It causes neck flexion at the lower cervical spine. Because of this reason, which is already mentioned, extension at the atlanto-occipital joint and neck flexion at the lower cervical spine, it leads to 3 axes coming in one line. The oral axis, tracheal axis, pharyngeal axis, they come in one line. All the axes are in one line, and because of that, it eases the laryngoscopic view. This position eases the laryngoscopic view. All right, it eases the laryngoscopic view. Then when you're talking of laryngoscopy, okay, so we're discussing laryngoscopy right now. Intubation, the first step before intubation is to discuss laryngoscopy. So we'll discuss laryngoscopy. First we'll discuss the position. What happens in the position? The next step is what are the types of laryngoscope blade. So remember the laryngoscope blade normally that are used are basically Macintosh. The Macintosh blade is basically a curved blade that is used in adults. Why? Because in adults the epiglottis is free. It is not included. Because the tip lies at the vallecula. This point where it lies is called the vallecula. Tip of the laryngoscope in adults lies at the vallecula. However, when you speak of a Miller blade, the Miller blade is basically a straight blade which is used in pediatric patients. Alright, and here if you will see, the epiglottis is included. Right, it includes the epiglottis. Because in pediatric patients, the epiglottis is long, floppy, right? That is why it is included, and that's why we use a straight blade for pediatric patient. We use a curved blade for the adult. Okay, that's the reason. There's another blade that is there, which is called 𝐒𝐿𝐻𝐿. 𝐒𝐿𝐻𝐿 is used in anesthesia. It's a hinge tip blade which has a lever. It's a hinge tip blade which has a lever. It is used in difficult intubation. In anesthesia, we use it for difficult intubation or difficult airway. Clear? So this is about the different types of laryngoscopic blade. When you speak of laryngoscopy, remember the complications can be trauma to any structures, including vertebral column. Even the neck can be damaged, atlanto-occipital joint. Okay, there can be trauma to any structure, including vertebral column. There can be bleeding, obstruction, all those things, damage to teeth and all the surrounding structures, leading to inflammation. All that is there. Then, more important is that it also causes something called as a hemodynamic response, which is increasing in the heart rate, increasing in blood pressure, changes in that. There can be myocardial infarction also. So this is one of the important complications that can take place with laryngoscopy, which is hemodynamic response. When do you want to intubate someone? The point is we intubate someone whenever we want to maintain a patent airway or an open airway for gas exchange. Why? To remove airway obstruction. Whenever you want to remove the airway obstruction, the best thing is to intubate the patient. Right? I am discussing the indications of endotracheal intubation. What are the indications? Why do you want to intubate someone? To remove the airway obstruction, to prevent the secretions from getting aspirated, to prevent the blood from getting aspirated, therefore to prevent aspiration of gastric contents also. Then whenever you want to give positive pressure ventilation or mechanical ventilation to a patient, for how long can you give ambu bag? So whether it's anesthesia or it is casualty or ICU, whenever you want to institute mechanical ventilation or give ventilation for a longer duration of time, better to put endotracheal tube. It can be one of the ways or routes of administration for drugs. One of the routes of administration of drugs in emergency, anesthesia drugs like inhalation agents, surfactant is given from there. And pulmonary lavage. This was an exam question last year. Pulmonary lavage or pulmonary toilet. Okay, so these are the basic indications for putting an endotracheal tube in a patient. All right. Next, the way you put an oral endotracheal tube, similarly you put a nasal endotracheal tube. All right, so nasal endotracheal tube. Nasal endotracheal tube, more important are the complications where you will not insert. So nasal endotracheal tube not to be inserted in fracture base of skull, CSF rhinorrhea, it can go to the brain. Of course, there are other things like coagulopathy and nasal problems as well. But three most important things are coagulopathy, high chances of bleeding, fracture base of skull, CSF rhinorrhea. Okay, this finishes off the indications for intubation, and these are the contraindications of nasal endotracheal tube. These are indications of all types of intubation. All right. talking about the endotracheal tube, since we are discussing it, we need to know about the endotracheal tube also. So remember, the endotracheal tube at one end has the connector. This connector is attached to the umbu bag or the machine or the breathing circuit. This is what gets attached to the breathing circuit, or it gets attached to the umbu. This is basically called the machine end. The bevel is what is said to be the patient end, right? Murphy's eye is a small opening that you see over here. This Murphy's eye is an additional port for oxygenation. Remember, Murphy's eye is not ophthal, it is not ENT, it is not head injury. Murphy's eye is endotracheal tube. Remember this. Murphy's eye is an additional port for ventilation. For oxygenation and ventilation. The cuff. Remember, nowadays the cuff is what prevents aspiration, and the cuff that we use nowadays is called high volume, low pressure cuff, right? This cuff is inflated with 5 to 10 ml of air or saline. And remember, the cuff pressure should be less than 25 to 30 centimeter of water. It should be less than 25 to 30 centimeter of water, right? The level of vocal cords, you get a black line. This is called as the vocal cord guide or the vocal cord marker. This is supposed to lie at the vocal cords. All right. Internal diameter. This internal diameter basically tells you the size of endotracheal tube. So when we speak of endotracheal diameter, internal diameter, this is basically the size of the endotracheal tube. Also, one more point is that the resistance of endotracheal tube, is inversely proportional to its diameter. There are other properties also involved, but the most important there is diameter, right? The cuff I was talking about gets inflated from the pilot balloon. When you push air from here, it passes through the inflation line and goes over here, right? Depth marker. Depth marker is basically telling you how deep you have to keep the endotracheal tube. So normally in a male patient, we keep 21 to 23 at the teeth. In a female patient, 19 to 21. All these tubes have a radio-opaque line that can be seen on the X-ray. Radio-opaque line. Fine. Done with this endotracheal tube also. Okay, what is the best sign for confirmation? What is the best sign for confirmation? Remember, capnography. If you want to confirm the presence of endotracheal tube is correct or not, the best thing is capnography. And remember, better than capnography can even be fiber optic, because there is direct visualization. Whenever there is direct visualization, it is always better than any other monitor. So remember, direct visualization is always better than otherwise, right? So capnography is the best, but if they have given you fiber optic or direct visualization, that is better. Okay. Apart from that, there are indirect methods. Chest rise is there, fogging or moisture mist is there. You can also see it on the X-ray, ultrasound. Okay, auscultation is there. So many other methods are there, but I'm talking the best ones. Fine. Next, in case of a full stomach patient, risk of aspiration condition, which you must be seeing, where bag mask ventilation is contraindicated, what do you do? That is what is called as cricoid pressure. So if someone is risk of aspiration, any patient or any condition with risk of aspiration coming for a surgery where bag mask ventilation is contraindicated, you're not supposed to do bag mask ventilation. In those patients, what we do is Silix maneuver. Okay, the first step is to pre-oxygenate the patient with 100% oxygen. This increases the FRC. It increases the, you're giving it for 3 to 5 minutes. Ask the patient to breathe spontaneously or take 8 vital capacity breaths, right? This basically increases the oxygen presence in the lungs, right? Prevents desaturation and increases the PaO2 and FRC, all right? After that, the next step is, once these 3 to 5 minutes are done, you protect the airway by doing Silix maneuver, where you manually are occluding the esophagus. Silix maneuver. Right? What you're doing in Silix maneuver is cricoid pressure. Remember, cricoid pressure is given by assistant. How much? you are giving about 30 Newton of required pressure. Then you are going to give the induction drugs, which is ketamine, propofol, or thiopentone. Plus, immediately you will add succinylcholine or rocuronium, the drug of choice. After that, you intubate the patient, inflate the cuff, right? Do the laryngoscopy. Point is confirm the position, and remember, only then release cricoid pressure. Once you have confirmed, only then release cricoid pressure. So cricoid pressure is done when there's a patient coming with risk of aspiration for surgery, okay, or where bag mask ventilation is contraindicated. So congenital diaphragmatic hernia, all right, these are contraindications for bag mask ventilation, all right, all those conditions. Pregnancy, full stomach patients, these are risk of aspiration. Bag mask contraindicated is congenital diaphragmatic hernia, tracheoesophageal fistula, all right, risk of aspiration, full stomach patients, pregnancy, right, intestinal obstruction, volvulus, hiatus hernia, all those conditions. Clear? So this is about the cricoid pressure. Next, laryngeal mask airway. Remember, LMA is one of the best devices which is a good alternative to intubation. It's a very good alternative to intubation. Laryngeal mask airway, it looks like intubation, but the difference is that laryngeal mask airway lies in the larynx, outside the glottis, because of which it is called as supraglottic airway. Outside the glottis, supraglottic. Okay, the tip of laryngeal mask airway, it lies at the esophagus. So you will see the tip of the laryngeal mask airway lies at the esophagus. It is lying outside the glottis, right? Outside the glottis. It is lying in the larynx. That is the laryngeal mask airway. Laryngeal mask airway. Advantage. The biggest advantage is that you don't need to have training, no muscle relaxation, no laryngoscope needed. It is an alternative to intubation, and it can be used in emergency. It can be used during CPR. It can be used for difficult airway. Everything is good about it except for one thing, and that is it does not prevent aspiration. If you give it for IPPV, it's very good for emergency, right? It's a use in emergency, CPR, and difficult airway. It's absolutely wonderful to be used here, right? These are the uses. So we try to use it for anesthesia, but it is contraindicated for IPPV since it can cause gastric distension and aspiration. It does not prevent aspiration. It can cause aspiration. Of course, even laryngospasm is there, but aspiration. That's one of the bigger things that can take place. So therefore, gastric distension, aspiration can take place in this patient. So what they did was we put another tube from here into the stomach, and we can do a suctioning from there. In that case, we can use it for IPPV also. So they combine the two together to make a second generation LMA. So remember, all the first generation LMA have only one tube or one tube, intubating tubes or ventilating tube that you see. On the second generation, we'll have two of them. So therefore, they are classified as first generation and second generation. Nowadays, even a third generation is available. First generation you get to see is the classic LMA. One tube. This is an intubating LMA. Here you get to see again one tube, flexible LMA. Again you get to see one tube. This is called unique LMA. Right? These are the first generation. Then we see the second generation. Second generation LMA. Second generation means two tubes. One tube, two tube. Right? One tube, two tube. One tube and two tube. What's the point of the second tube? Insert a Ryle's tube that goes in the stomach from where you can do a suction. All these also have a presence of bite block. There are three things. These have a drain tube. The second generation, all of them are going to have a drain tube, which is a second tube, right? All of them have a presence of a bite block. All of them have a better seal compared to the previous one. These are the three differences. The first airway tube is there in everywhere, right? That airway tube is definitely there, but along with that, they have a drain tube also. This drain tube helps you to suction the stomach through the right tube, inserted from there. The first one that we see is called Pro-Seal LMA. Again, I asked in the exam. The second is called as Supreme LMA, used for difficult airway. The third one is called 𝐼-GEL. 𝐼-GEL has no cuff, no inflation of the cuff also. It's the most common used nowadays. Okay, 𝐼-GEL has no cuff. It is called cuffless LMA. There's another one which comes in this, which is called AMBU Aura Gain. Of all the AMBU LMAs, only this is second generation. Apart from that, all AMBU LMAs are first generation. Most of the AMBU LMAs are first generation. All right, only this one is a AMBU Aura Gain is second generation. Right, third generation is the Baska tube, which is not used in India. We are not using it, but I think it's already come. It's already there. It's beyond research now. Next, we'll talk about these airways. We'll discuss the laryngeal mask airway. Now I'm discussing the other airways. So this is what is called as the oropharyngeal airway. Oropharyngeal airway. All these two, or even this one I'm talking, this is the nasopharyngeal airway. Both of them, they do what? They prevent the backfall of tongue on posterior pharyngeal wall. They prevent the backfall of tongue. Both of them. The only difference is that oropharyngeal airway is going from the mouth. So therefore, the oropharyngeal airway, it can stimulate the gag reflex in awake patient. So this is contraindicated in awake patient as it can stimulate the gag reflex. And stimulation of the gag reflex can lead to laryngospasm, vomiting, and aspiration. And nasopharyngeal airway bypasses the gag reflex, therefore can be used in awake patients. Right? It can be used in awake patients. It bypasses the gag reflex. Clear? Sizing. The size of oropharyngeal airway is from the corner of mouth. Therefore, corner of the mouth to the angle of the mandible. यहाँ से लेके यहाँ तक, from here to here. So this is the angle of mandible. That is the size. On the other hand, the nasopharyngeal airway is from the tip of the nose to the tragus of the ear. So normally we will measure from here to here, to the tragus of the ear. That is the size. The contraindication of nasopharyngeal airway is the same as the nasal endotracheal tube. Okay, so we discussed the oropharyngeal and nasopharyngeal, and remember, nasopharyngeal airway looks like a uncuffed endotracheal tube. Last year they asked in the NEET PG, a lot of students made that mistake. Remember, a nasopharyngeal airway does not have the Murphy's eye. Uncuffed tube will have a Murphy's eye. Uncuffed tube will have a vocal cord guide. Uncuffed tube is going to have these markings, depth marker. Uncuffed tube is going to have this radio opaque line. Uncuffed tube is going to have a connector over here. These things are missing, which we just discussed. Uncuffed tube is going to have all of them: the connector, radio opaque line, the depth marker, vocal cord guide, and Murphy's eye. And a nasopharyngeal airway, these 5 things are missing. Thumbs up, guys. Is that okay? That's why it's not an uncuffed tube. It is a nasopharyngeal airway, which was asked last year in the NEET PG exam. Okay. Thanks, Dr. Pravneet. Dr. Pravneet, thank you so much. You said no, so hopefully you have understood things till now. All right. All right. Next, we come to the bag mask ventilation. So, bag mask ventilation maintains the seal for positive pressure ventilation. All right. This is held by a C+E technique. Right. What does the little finger do? It elevates the jaw. Right. So the E technique means it is elevating the jaw. That's the most important thing here. It elevates the jaw. And the biggest problem with a bag mask ventilation is that it increases dead space. Any area that contains oxygen not taking part in gas exchange, right? It increases dead space. So the next question is, what decreases dead space? Dead space is decreased by tracheostomy. Dead space is decreased by endotracheal intubation in an adult. Right? These are the devices that help you decrease the dead space. All right. So bag mask ventilation ka side effect is that it increases the dead space. And the next question I just discussed over here, what decreases the dead space is tracheostomy and endotracheal intubation in adults. Okay, that is about the dead space. Important question. Next, Ambu bag. Normally, Ambu bag we never used to discuss so much, apart from the fact that it is used in adults, it is used in pediatric, it is used in neonates. What are the sizes? 1.5 liters, 500 ml, 250 ml. Apart from that, you should discuss there are 3 valves in the front plus 2 valves in the back. Right? 3 plus 2. इस बार का क्वेश्चन पूछा था, at what pressure does this valve, pop-off valve, give way? Right? This was asked in NEET PG. I mean, we did not expect these questions to come, but yes, because it has come already, so we should discuss it out. The pop-off valve gives way at 30 to 40 centimeter of water in an adult. In a child, normally it is said to be 10 to 20 centimeter of water. In fact, some books have also mentioned as 50 to 60, right? But exam question had mentioned 30 to 40, so let's stick to that. This is for adult, this is for a child. Okay, so this is the time, this is the pressure at which the pop-off valve gives way or moves away. Right? Fat jata pop-off valve. That is Ambu bag. Let's go to the oxygen delivery devices. So first I'm discussing these ones which are called as the low flow. I'm discussing the oxygen delivery devices. What is the last part now? Okay. CPR was baki after this. Oxygen delivery devices. So this is again important question. All of you are already aware. So oxygen delivery devices presently that you see, these are low flow. Low flow, you have nasal cannula. Maximum FiO2 is 40%. Right? Nasal cannula is also called nasal prongs. A normal face mask is also called a simple face mask. It is also called as a Hudson face mask. At 10 liters, it gives 60% maximum FiO2. Then a face mask containing reservoir and a valve. This is a non-rebreathing mask called NRBM. There's also partial rebreathing, but this one is the one that gives 95%. Maximum FiO2 out of all low flow devices. Okay, maximum FiO2 out of all the low flow devices, that is by the non-rebreathing mask. Okay, and then you have, so these are the low flow devices. Classification. So one was the low flow. These are the low flow which you have seen in the wards. All of you must have seen it normally. In fact, COVID mein maximum what was used was NRBM. That's why NRBM was maximum used during COVID. Non-rebreathing mask. And this question was very common asked 2-3 years back when COVID was at the peak. This was a very common question then. Every exam they were asking this question, NRBM. All right. And when patients of COVID were not improving with NRBM, then you should put them, clinically, you're putting them on high flow nasal cannula. This high flow nasal cannula is not a low flow device. Now this becomes a high flow device. Okay. These are high flow devices. So high flow devices, you have high flow nasal cannula and you have the Venturi mask, right? The high flow nasal cannula, it is identified. I don't have the image, the one that I have given the workbook to you, but it is identified, guys, remember, by presence of humidifier. It has a separate humidifier by which you can identify, right? And the presence of the humidifier gives it a warm and humidified oxygen to the patient. Even the flow meter is different because it can give flow up to 60 liters. So it has got a very different flow meter, right? It tells you about the FiO2 and the maximum FiO2 that can go is 100%. So when patients of COVID were not improving, we used to put them on high flow nasal cannula, and this was the maximum, again, apart from NRBM, high flow nasal cannula. It is called HFNC. This was also very commonly used during COVID, right? Another high flow device is the Venturi mask. Remember, Venturi mask is what is based on Venturi principle or Bernoulli's law. The point is that this is a different out of all other masks. This looks like a normal mask only. This is what is a fixed output device. It's a fixed output device. Based on that principle, it tells you exactly how much is being delivered to the patient, right? How much exactly FiO2 means, how much exact oxygen is going. Flow is what? Flow meter is what you start on the flow meter. FiO2 is what? FiO2 is what the patient is receiving. So Venturi mask is a fixed output device. So if you put a green one, there are different types available. Color coded bhi hota hai. If you put a green one, so like a green one is going to give 60%. A red one is supposed to give 40%. The yellow one is supposed to give 35. The orange one, or maybe the orange is 31, right? This is 31. Then you have the blue 28, and then you have the white giving 24. Okay, so this is the percentage. But if you use the individual colored ones, so this is how the percentage of FiO2 will go. So this is a fixed output device. Whenever you want to give a fixed output to a patient where you want to be sure, for example, in nasal cannula, in how normal face mask and NRBM, you are saying maximum is this much, but you can't be sure. But here you can be sure that you are giving 60% or 40% or 35% of the patient based on which color you're using. That's why it's called precisely controlled or fixed output device, but the maximum is only 60%. Remember this? This was the question asked. So non-rebreathing mask gives you more oxygen than a Venturi mask. Remember this point. Non-rebreathing mask gives higher percentage of oxygen than a Venturi mask. Remember this. Okay. So this is about the oxygen delivery devices. And here remember, with the patients don't improve here with this high flow nasal cannula, the next step was to go to non-invasive ventilation. Non-invasive ventilation, guys, is when we are using CPAP and BiPAP. Continuous positive airway pressure, bilevel positive airway pressure. And remember, this is contraindicated in a patient having facial fracture or a patient who is unconscious or sedated. Because non-invasive ventilation is given by a face mask. It's given by a tight face mask, a different face mask. So here the patient has to be spontaneously breathing. So if the patient is not breathing, you cannot be giving non-invasive ventilation like CPAP or BiPAP. So this was the next step in COVID. And after the non-invasive, the next step, of course, is invasive ventilation. If the patient is not improving, you will put a endotracheal tube, tracheostomy, and put the patient on ventilator. Right? That is what is done in the ICU. Endotracheal tube, tracheostomy, ventilator. Clear? Everyone okay? Okay till here? So we are done with the oxygen delivery devices also. All of them are done. Here is what the BiPAP looks, which I was telling you, the tight face mask. Okay, this is the tight different face mask which is attached to the patient. That is the BiPAP, right? Contraindicated in facial fracture, unconscious patient and sedated patients, right? Remember CPAP, BiPAP nowadays, you must have studied in medicine also. It is used in patients of obstructive sleep apnea as well. It is used. OSA. It is used in obstructive sleep apnea. It helps to increase oxygenation and decrease the carbon dioxide of the patient, right? I think I got it. Dr. Parul, thank you so much for saying that. Yes. Okay. Let me go to the last part week here. The last part actually is ASA grading, which I have left as a very small one, which you must be seeing. And before that, I'm discussing the CPR with you. So another 10-15 minutes, I'll do the CPR and then we should be done. CPR, guys, the first step always is verify scene safety. The scene is safe for the victim, rescuer, and standard precautions. For example, someone is collapsed on the road. Don't start CPR on the mid road. Take the patient onto the side so that you are safe and the victim is safe. So safety for yourself as well as for the victim. That is called scene safety. The next step, remember, scene safety always comes first. The next step is check for response. If the patient is responding, leave the patient. If the patient is not responding, then call for help. Right? That is my third step. Call for help. Call for help means you can ask from a mobile also. It doesn't mean you have to call, shout over there. You can use your mobile also and call for help. Not necessarily you just are shouting. You can use your mobile and you can call for help. Okay. And then you're calling for help so that people can come with emergency equipment or automated external, defibrillator and all, and they can help you out. That is the third step. Till now, you've not checked the patient. The fourth step now is that you're checking the patient. I just saw the response, nothing else. Now I'm checking the breath, I'm checking the pulse. Both are done simultaneously within 10 seconds. How do you check for the breath? Look for a visible chest rise. Look for a visible chest rise. Where do you check for the pulse? The normal pulse that is checked is carotid, right? But you can also check for femoral. But this is more commonly checked in pediatrics. But if you ask me, pediatrics, the best one to check is brachial. So carotid, femoral and brachial, all the three are used. But femoral and brachial more so in a pediatric patient. All right. This is step number 4. So when you are checking for breath and pulse simultaneously in 10 seconds, I'm looking at the chest rise and checking for the pulse together. If I find that the patient's breath is also present and pulse is also present, both of them are present. That is my scenario number A. Both of them are present, pulse as well as breath. I will do nothing, just monitor the patient and keep the patient in a recovery position. Okay, keep the patient in recovery position. Breath and pulse both are felt. Now, the next step I may get is breath absent and pulse present. So what is absent here is the breath, what is present is the pulse. So if breath is absent, what is missing? Breath. So what you need to do? Give breath. How many breaths? 10 breaths per minute, right? How do you give a breath to the patient? That you already know. You can give the breath mouth to mouth, mouth to nose, mouth to mask and bag mask. Okay. The breath can be given mouth to mouth. It can be given mouth to nose, mouth to mask. It can also be given bag mask. Bag mask means ambu. In case you manage to get ambu from somewhere, bag mask. Remember, the best one is bag mask with oxygen with reservoir, right? And if you find signs of opioid overdose, you can give naloxone to the patient if you find, right? That's one of the points. So this is my scenario number B. So this was my scenario number A. This became my scenario number B. Scenario number C. So I had checked pulse and breath together. Remember, at one step both were present. Second time breath was absent, pulse was present. Scenario number C. What's my scenario number C? Both of them are not there. This patient now has no pulse and no BP. I mean, no breath and no pulse. Sorry. No breath and no pulse. Both are missing. So my fifth step is start CPR. My fifth step is start CPR and do it chest compression, airway, breathing, right? Chest compression, airway, breathing. So when you're giving chest compression, remember you're giving it at the lower 1/3 of the sternum. It's basically the center of the intermammary line. Midpoint of the line joining the intermammary line, basically intermammary line. Lower 1/3 of the sternum. The rate is 100 to 120 per minute. The depth that you have to give is around 2 to 2.4 inches or 5 to 6 centimeter. Remember, it's 1/3 the depth of the chest. It's 1/3 the depth of the chest, and always allow for chest recoil. Let the chest come back. Okay. Then when you're doing airway, airway means the maneuver for the airway means you need to open up the airway, and that is done by doing head tilt and chin lift. Head tilt, chin lift. But head tilt and chin lift should not be done in fractured cervical spine. So therefore, fractured cervical spine, the best thing to do is jaw thrust. In case there is vomitus or foreign body, you need to remove that also out over here, because you're checking the airway. The next step is to give a breath. When you give a breath, it's always 2 breaths at one time, inspiration over 1 second, right? No excessive ventilation, expiration over 1 second, right? Give 2 breaths, 1 second for inspiration, 1 for expiration, and no excessive ventilation. This is how you are supposed to do the chest compression, airway, breathing, and then you have to mix them together. How do you mix them together? That is given over here. Okay. So basically you're supposed to be doing, this was my step number 5, to do chest compression, airway and breathing. I've discussed how you do that. So we are doing cycles of 30:2. You're supposed to do the cycles continuously. In between, after 2 minutes, you will checking the pulse as well. And then use AED when it available. So when the AED comes, that's my step number 6. As soon as it comes, I will need to attach the pads, right side below the clavicle, left side mid axillary or anterior posterior. And then I check for the rhythm. right? If the rhythm is shockable, the monitor will say, the AED will say, yes, shockable. So after that, once I've checked the rhythm, immediately give the shock. Most important, after the shock, no pulse check. After the shock, there is no pulse check. Resume CPR for 2 minutes. That was I was saying. After 2 minutes, this is the point when you can check for pulse. If the pulse is present, patient is fine. If the pulse is absent, go back and do the same thing again. So like do it for 2 minutes, and after that 2 minutes, here you can check for the pulse, right? If the pulse is present, patient is okay. And if the pulse is absent, you need to start the same thing again, right? The same thing will go on. Now, I will again check for the rhythm. If the rhythm is shockable, I will give a shock. No pulse check after that. I will resume CPR for 2 minutes, and then again, I will, in case there are 2 people, I will need to rotate the compressor also here. Okay, that is what is to be done. If the rhythm is non-shockable, means you're not supposed to give the shock. In this case, anyways, point is to resume CPR. The only thing is that if you give a shock, after the shock, resume CPR. If there's no shock, immediately resume CPR. The point is no pulse check in between. The pulse check is after the 2 minutes, right? Here, what you're doing. So resume CPR for 2 minutes. After that, if the patient is not revived, you go back and check for the rhythm again. This is what is done and continued for 30 to 40 minutes, or till the time advanced life support people come, or if the patient is revived. Okay, this is your basic life support, BLS, right? Then how is a ALS different from BLS? What's the difference in advanced life support? This again I've given in the what you call in our workbook. You have this also. This is advanced life support. So advanced life support, guys, you must have seen there's a chart over here. All this is the same thing what we have discussed. It just tells you what are the rhythms. So now if I have to put the rhythms, so remember the shockable rhythms are 2. There are 2 rhythms where you can give shock. One is pulseless ventricular tachycardia, and the other one is ventricular fibrillation. The non-shockable rhythms are 2, which is pulseless electrical activity and asystole. Okay, asystole. Now, when you speak of advanced life support, now you have people. Remember, you had called up someone for help. In step number 2, no, step number 3, we had called someone for help. For what? Get the AED, get emergency equipment, send someone to get it. So we have done that. We had activated the emergency response. Now they have come. That is advanced life support. Once these people have come, this is what is called as advanced life support. This is called as advanced life support. Right? They have come now. So you've got help, you've got people, you've got instruments, you've got monitors, you've got LMA, you've got endotracheal tube, you've got laryngoscope, you've got IV line, you've got drugs. It means everyone has come to help you now. So therefore, remember what are the points for a high quality CPR. Remember, it has to be 2 to 2.4 inches or 5 to 6 centimeter. Maintain that. 100 to 120 per minute. Complete chest recoil. We mentioned that, right? Avoid interruption in chest compression. Avoid excessive ventilation. And remember, I told you rotate the compressor every 2 minutes. When you were checking that, rotate the compressor. So these are the points for high quality CPR. They are asked in the exam. Right? These are the points which are used for high quality CPR, right? This will improve the quality of CPR. The one that you're doing for the patient, this is going to improve the quality of CPR that you're giving for the patient. All right. The next is when you give a shock. Now you have a defibrillator, not a AED, defibrillator. So a biphasic defibrillator, 120 to 200 joules of shock. In monophasic, 360 joules of shock. Okay. Then you also get an IV access or intraosseous access. Can you see IV or intraosseous both is present? What other drugs you can give? You can use adrenaline. Epinephrine is the same as adrenaline. We can use amiodarone, lignocaine, and magnesium. Remember, other drugs are not used nowadays. Other drugs are not used apart from adrenaline, amiodarone, lignocaine, and magnesium. Other drugs like vasopressin, atropine are not used nowadays. Okay. So drug therapy means I have taken an IV access, intraosseous access, and I can use these drugs. Remember, no using atropine, no dextrose solutions, and no using vasopressin. It's not mentioned in the guidelines. All right, next, continuing with the advanced part. Remember, now you've got people who have got laryngoscope, they've got endotracheal tube and LMA. So you put an endotracheal tube or put a supraglottic airway device, which means I put an endotracheal tube in the patient, I put a laryngeal mask airway. How will I confirm it? By end-tidal carbon dioxide. EtCO2 is one of the best methods. And once advanced airway is in place, remember, the chest compression will go 100 to 120 and the breath will go at 10 breaths per minute. Okay, it's continuous chest compression. This is how it will go. Right, this is what is done with the advanced airway. How will you monitor? Look at the pulse or BP. Now you have got things which will help you out. EtCO2 can be seen, and intra-arterial monitoring. Right, so spontaneous arterial pressure waves in the intra-arterial monitoring. Intra-arterial monitoring. It means about the arterial line. Remember, we used to be discussing Allen's test and all. You put in the radial artery, all right, all that is there. Now, reversible causes, you have to keep on thinking what must be either of the 5H or the 5T that has happened. This is your advanced life support, all right, advanced life support. Apart from that, there are a few other things that you need to know. If there is a maternal patient, maternal CPR, in maternal CPR, always remember that the IV line is above the diaphragm. But in emergency, do a cesarean section in 5 minutes to take the baby out. Pediatric patient with 2 rescuers. Pediatric patient with 2 rescuers is 15:2. Remember, neonates is 3:1. Right? All right. That is in pediatric patients. Also, in young patients less than 1 year of age, you are going to do that, thumb encircling technique and the 2-finger technique for the chest compression. Also, choking has maneuvers, which is Heimlich maneuver and 5 back slaps, 5 chest thrust. All that is done. So remember, Heimlich's maneuver is also there. Right? And for a pediatric patient, 5 back slaps, 5 chest thrust. Right? Now, always remember, when CPR, questions come regarding tachyarrhythmias and if the patient is stable or unstable, where you have to see, right, where we did discuss about synchronized cardioversion, that is asked in the exam, presence, use of adenosine, use of amiodarone, all these drugs are used, right? Remember all that. They ask you about, in case bradyarrhythmias, you got treatment for that also. So remember, this has to be studied, or if it's a bradyarrhythmia, right? Same thing, stable or unstable patient for tachyarrhythmias or bradyarrhythmias. So you need to see that even this is a part that is important, which comes mixed with other, and this comes with an ECG diagnosis also. So please pay attention to this also when you are, not as a part of anesthesia also, it's a part of anesthesia as well. But just remember कि ये एक important topic है जो normally medicine में cover होता है. It's covered in medicine. So please pay attention to this as well. Right? This was a point on which 𝐼𝐿 and FMGE in January they asked a question. This is chain of survival. These are the sequence of events that you do to improve a survival of a patient. It is intra-hospital cardiac arrest and out-of-hospital cardiac arrest. 2 things. If you will find the adult link of survival, the 5th and the 6th point remain the same for both, and these are the points which were asked in the exam. The first point, the second point, third and fourth are slightly different. Intra-hospital, the first is early recognition of arrest, activate the emergency response, do a high quality CPR as I discussed, and defibrillate as early as you can if needed. Next is that what is out of hospital? Immediately call someone for help, right? As you can see from the mobile, do a high quality CPR, defibrillate if possible, and shift to the hospital advanced resuscitation. That is for out of hospital. But the 5th and the 6th link remain the same for both of them. The 5th link in this is post cardiac arrest care. In post cardiac arrest care, this was a 𝐼𝐿 question. You're basically taking care of the blood sugar of the patient, you're taking care of the SpO2 of the patient, because now the patient has revived. You're taking care of the BP, You take care of the temperature. Remember, temperature is kept between 32 to 36 degree. Hypothermia is given to the patient. A neurological assessment is done, right? And if the patient, if it is needed, you shift the patient to a cardiac cath lab, right? For angiography, angioplasty, they'll be checking angiography, they'll be doing over there if need be, and if you think like that. And the sixth link is basically recovery. This was asked in FMGE. These two are common for both in hospital and out of hospital cardiac arrest. So post cardiac arrest care and recovery are common for both of them, and this was asked in the exam. Clear? So we are done with this part. The last part I'll discuss is ASA grading. So ASA grading again is your part of the pre-anesthetic checkup where questions are asked. ASA grading means it is talking about the physical status of the patient or the medical status of the patient, right? It tells you about the medical condition of the patient and the risk associated with that, right? So based on that, a normal patient is called ASA grade 1. If there's a mild systemic problem, that is called ASA grade 2, mild problem, not a major one, mild. But if the disease becomes severe, that becomes ASA grade 3. All these are asked in the exam. Normal patient is 1, mild is 2, severe is 3. A severe disease that becomes threat to life is 4. A moribund patient not expected to survive before surgery, without surgery, is 5, right? Not expected to survive without surgery is 5, and a brain dead patient is ASA 6. This is for organ transplant. Clear, guys? So this is your ASA grading. Remember, ASA, normally they say ASA 1 and 2 are the ones they go for daycare surgery, right? ASA 1 and 2 are the ones that go for daycare surgery, and apart from that, 3 and 4 are the ones who are not going to go for the daycare surgery. So basically it tells you about the medical status of the patient, the risk of the patient. Based on that, you can take the consent of the patient, plan investigations, right? So this is ASA grading, which tells you the physical status or medical status. When we speak about daycare surgery, guys, remember, in daycare surgery, we need to use short-acting drugs, and the short-acting drugs that we use for daycare normally is propofol, which is the drug of choice. Apart from that, we will also be using, in case of a muscle laxant, succinylcholine, 𝐒𝐿-𝐶urium, or rocuronium can be used, because now rocuronium has sugammadex as a reversal agent. So this is the muscle laxant of choice. Fentanyl or any derivative of fentanyl can be used. Remember, opioids are an important topic. Alfentanyl, sufentanil, or remifentanil can be used. Midazolam is one of the agents which is used for amnesia. And in case of an inhalational agent, normally inhalationals many times we will avoid, but in case you want to use an inhalational agent for daycare surgery, I will be using sevoflurane, which is almost the same as desflurane. What are the most common complications that can take place in a daycare surgery? Remember, the most common cause can be post-operative nausea, vomiting, and that's the cause for admission as well. There can be pain, again it's another common one, and both of them can lead to admission to the hospital, right? Apart of that, there can be respiratory depression, there can be sedation, there can be drowsiness, right? And another important complication can be a surgical complication or bleeding, for which a patient may have to be readmitted after going home, right? So surgical complications and bleeding. So this is also another point which is important. So remember, 3 things: post-operative nausea, vomiting, most common, then pain and bleeding. These are 3 parts where they ask you the questions. Right, guys? So I've taken at 3.5 hours. Hopefully you people have understood something from anesthesia. My Instagram ID is Dr. Vinish. So I'll share that with you. Any questions and doubts, you can ask me directly. If there are any doubts right now, you can ask me as well presently. Okay. So I'll just share. Any questions and doubts, guys, please ask me. That is from my side. Insta ID is dr.viinish. So you can follow me and ask me questions directly on the Instagram. Okay, that's one. And second is Telegram. Here also you can ask me questions directly. Telegram ID is Dr. Vinish. So thank you guys for joining me at this session. All of you have sat all throughout. So hopefully the session was helpful for all of you. All the best. Do well. I tried to revise everything from anesthesia, right? Whatever I felt is important. Most of the topics I've covered, right? Still, it was very short time to cover up everything, but hopefully it will be going to be beneficial to all of you. Thank you, Dr. Shivangi. Any other questions, guys? If there's a question, so you can please ask me. Otherwise, you can send the questions to me on Instagram or Telegram. Okay. And I will share the PDF later on. So this PDF also will be available. Thank you, Dr. Parul. So thank you all of you for joining. Okay, so I'll take the leave and all the best, guys. Do well and don't worry. Believe in yourself. Stay motivated in the sense that you have to do it for your parents. Don't think that you're doing this exam for yourself. You have to do it for your parents. Think always like that and you will be able to do it. Right? And once you people clear, so please message me on Instagram or Telegram. I'd love to see your messages that all of you have cleared. Okay? I want to see those messages. It makes us feel good. Right? So all the best. Do well. Bye-bye. Good night. Take care. No questions, I think. Right? Thanks, guys.